The CV. 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 The backend team can show the CV, please. CV. You had fun yesterday? Say yes or no. Depending upon the time. Sorry? Late night was a party. But the sessions were on time yesterday, except for the ILD workshop, which I think just dragged on a little longer because of too much of enthusiasm and too many people in that. But the party you enjoyed? Good. That's good. That's good. Sorry? Both parts were very well taken care of by you people. You enjoyed the party and you enjoyed the day. I think it was a very tiring day. You started very early at 8 in the morning and went off to almost like 8 o'clock in the evening. So 12 hours and then very little time. It was worth it? Good. Thank you very much. Excellent feedback. I know that there are people who are coming in. They are setting the stage. Bronchiectasis, what you do. And the speaker for this topic is Professor Michael Labinger. And he's, of course, as it is written here, everybody can read, Professor of Practice of Respiratory Medicine from Imperial College London. And he's also at Royal Brompton and Hartford Hospitals in UK. He specializes in bronchiectasis. So I think none other than him to give us a talk on when things get worse, what to do in bronchiectasis. So this session will be moderated by Dr. Saurabh Mittal, and I invite him to the stage and take the proceedings of this session. Thank you, Saurabh.
Good morning, everyone. So I welcome you all to this session. So I would like to invite all the expert panelists for the session. Dr. Rajesh Yadav, Dr. Ved Prakash, Dr. P.K. Thomas, and Dr. Sunny. All, please. Also, I would like to invite the chairpersons for the session, Dr. Kumar Utsav, Dr. Javed Malik, Dr. Sanjay, and Dr. Mazhar Maqsood. I would request Dr. Utsav to invite the speaker as well. Thank you.
Professor.
Okay, I presume I should start. So look, it's a real privilege to be here. Thank you very much indeed for the invitation. It's my first time in India, so I'm really looking forward to the next few days. So thanks very much. I presume we start a little bit late, but I can see I've got my timer there, so I'll just keep to that. So I've been asked to talk about what to do if things get worse in bronchiectasis. As per the introduction, I work at the Brompton. We probably look after the most global patients in bronchiectasis there. We have about 3,000 patients. And what I'll do in this talk is I will have a few case histories illustrating what I want to talk about when things get worse, talk a little bit about guidelines, but also talk about some new concepts within the management of bronchiectasis and new clinical trials. So bronchiectasis, we all know what that is. It's irreversible dilatation of the airways, leading to lots of sputum production on a daily basis, cough, and also recurrent chest infections. It used to be demarcated and diagnosed by bronchograms, but now obviously by HRCT scan, with the diagnosis made with a few criteria, such as when you have airway dilatation greater than the surrounding vessels. Over the last few years, it's been clear that actually the prevalence is much higher than previously thought. When I first started, it was put at 50 per 100,000. Now it's at least 500 per 100,000, so 0.5% of the population, which makes it a significant diagnosis and disease. And the general assessment for bronchiectasis and the general treatment surrounds trying to work out what the underlying cause is. Of course, bronchiectasis is just a description of the airway dilatation on a CT scan, and there's lots of different causes for that. So finding the underlying cause and then looking at the vicious vortex and trying to work that out, which I'll go through in a little bit more detail later, with regards to treating inflammation, infection, and airway clearance. So let's get straight into the case histories to really look at how I deal with bronchiectasis patients when they are getting worse. And what does getting worse mean? Well, I'm talking about significant and prolonged deterioration of symptoms, worse exacerbations, maybe perhaps going to hospital, relapsing after treatment, or declining in some objective measures. So the first case is a 20-year-old female who, as well as a child, cough and sputum at the age of 14, referred to a local hospital at 17, had the CT, as you can see, with lingular left lower lobe bronchiectasis, and she had those lobes actually taken out. In the workshop, we discussed a little bit about indications for surgery, and this came up. So she actually had surgery. And she was well, but then relapsed a few months later and started coughing up again, more infections. And you can see that, unfortunately, the bronchiectasis had now progressed to alternative lobes that she hadn't had removed. She was referred to the Brompton and had a whole range of investigations, and was actually, as part of her host defense screen, was found to have low immunoglobulins and was diagnosed with common variable immunodeficiency. She was started with azithromycin and then started on intravenous immunoglobulin, with the azithromycin being discontinued. So this is case one. This is a patient who is deteriorating, but actually the issue here is the underlying diagnosis, the underlying cause of the bronchiectasis that wasn't previously determined, in this case CVID. Case two, 63-year-old female, asthma as a child, cough and sputum in the late 40s. She did have a full host defense screen looking for the cause of bronchiectasis when she first presented and did not find one, so she was idiopathic bronchiectasis. Pseudomonas colonization was doing okay, but then again starts deteriorating. More sputum, more shortness of breath, more infections, less effective antibiotics. And she had a full screen or a full analysis again, and you can see here that her IgE, which when first tested, when she had bronchiectasis, was normal, raises quite significantly towards the latter years, almost up to 8,000. So she had ABPA, and she was treated with steroids, made a significant recovery, was much better. So this is case number two, a deteriorating patient, not the etiology of the bronchiectasis, but deteriorating because she had an additional comorbidity, an additional diagnosis, which was the cause of her deterioration. Case three, this is a 78-year-old female, all females so far, child, young adult, 8-year history of a productive cough, 6 infections per year, widespread bronchiectasis. Again, the host defense screen looking for etiologies was unremarkable, and significant bronchiectasis, as you can see on that scan. She had some reflux symptoms, was given a PPI, had a full physiotherapy review, and had all that optimized. And with optimization, she made a significant improvement both radiologically but also symptomatically. So this is case 3, somebody doing less well with the treatment being optimization. And the final quick case, and then I'll show you how I've tried to illustrate these things, was a lady with primary ciliary dyskinesia doing quite badly, lots of infections, Pseudomonas, was already on colomicin nebulized, in stabilization for a bit, had increased physiotherapy, addition of long-term azithromycin, but doing actually quite badly and really severe changes on her scan. And what we did with her is we started to give her cyclical intravenous antibiotics. So this just gave a little bit of structure to her life, and every 8 to 10 weeks she would come in, have 2 weeks of antibiotics, and get better for a few weeks before deteriorating, before coming back in again. So this is case 4, showing all of the additional therapies that you can use for deteriorating bronchiectasis. Okay, so what am I trying to illustrate with these cases? So like when you first see a patient with bronchiectasis and you're trying to assess the underlying cause and severity, if a patient starts deteriorating or gets worse, it's important to redo that assessment. And for that, you need various objective assessment tools. You should repeat the HRCT, repeat the lung function, consider other things such as an echocardiogram. And the reason for this are you are updating the baseline tests, you're looking, as well as the description of deterioration, for objective deterioration in these measures, and you also want to correlate the changes that you see in these with the symptoms to try and work out what's going on. It's also important to do bloods and sputum. Again, have you actually determined the underlying etiology properly, and is there something new that you were missing? So, for example, ABPA in the second case. In the first case, actually the underlying etiology of CVID hadn't been already determined. And these are really important things to do because we know that actually with the underlying etiology, several of the underlying etiologies make a very, very different change to management. All those ones that I've starred, immune deficiency, ABPA, like I mentioned, but other things, ulcerative colitis, mycobacterial infection, aspiration, cystic fibrosis, all have very, very specific treatments. And so it is very important to see the underlying etiology. And I showed that before. That's from the EMBARC registry of about 15,000 bronchiectasis patients. And then with those tests, you want to try and determine, why is this patient deteriorating? Is there something new? Is there a new microbe? So particularly is there new Pseudomonas, nontuberculous mycobacteria, Aspergillus? Is there a new comorbidity or an alternative diagnosis? I've mentioned ABPA, I've mentioned aspiration, but there's other things that you may want to look for. Pulmonary embolus, pulmonary hypertension, or completely alternative diagnosis. That's the reason for this structured assessment of patients. After that, it's important to then ensure that you've optimized everything. And this goes through to the last couple of patients that I mentioned in the case histories. So, is physiotherapy properly optimized? Is the baseline therapy optimized, and are they compliant with it, and is it appropriate? And importantly, are they having exacerbation treatment correctly? Do they have a suitable antibiotic when they get an infection? Are they having a suitable dose of that antibiotic? And most importantly, are they getting it for long enough? So lots of our patients are having multiple infections, but when you actually interrogate them, they're given 3 days of azithromycin for their infection or 5 days of amoxicillin. Whereas for patients with bronchiectasis, the standard of care would be 14 days of antibiotics. And then you have the additional therapies. So I flashed this slide up before. It is basically straight from the recent ERS guidelines that were published at the end of 2025. And it utilizes the vicious vortex, which used to be the vicious circle, to actually determine the different treatments that are available. So the vicious vortex really describes the pathophysiology of bronchiectasis, the interlinking between infection, causing inflammation and interacting with the inflammation, causing that damage to the airways, which also leads to impairment of mucociliary clearance, and all of those things together leading to bronchiectasis. As well as describing the pathophysiology, it's also a really good tool to actually think about etiologies of bronchiectasis, but then also, as I'm describing it here, for the therapies that you can use. So for impaired mucociliary clearance, you can see there airway clearance, mucoactive drugs with the evidence that was found within the guidelines. For infection, particularly if you have Pseudomonas, for long-term inhaled antibiotics. And then the use of macrolide antibiotics actually fits in that inflammation section, which I've used here, but obviously has crossover between infection and inflammation. Now, since those guidelines came out, there's also been the phase 3 trial of DPP1 inhibitors, which I will also go on to speak to. Within those clinical guidelines, both on the left and on the right, the left is from the BTS guidelines from 2019, the right from the ERS guidelines of 2025. This isn't to read what's on the screen, but it's just to show that there are stepwise guidelines for the deteriorating patient. And they are very similar to the stepwise assessment that I have mentioned, both with the case histories, but also in the last few slides. Okay, so in the last sort of half of this talk, I just want to talk about a few different concepts that have really come out with regards to the management of these difficult patients in bronchiectasis over the last year or last couple of years. The first is when to intervene and the concept of disease activity. And certainly in the past, management of bronchiectasis has been predominantly based on severity. All of the work has been on severity assessments, the bronchiectasis severity index, and certainly the last couple of cases were patients that really had quite severe disease. Indeed, the guidelines, both the BTS guidelines but also the ERS guidelines from 2017, concentrated on treatment with long-term antibiotics for patients with 3 or more exacerbations per year. But the dial is shifting a little bit over the last year or so, and this concept of disease activity is important. So what I was talking about with the management of severe disease is quite nicely illustrated, I suppose, right on the left-hand side with that really severe scan, illustrated by a house on fire. And you could see, I suppose, the normal scan is a normal house. The really severe disease is a house having been on fire and been destroyed. But where the interest is over the last couple of years is the house in the middle. Not necessarily severe damage or severe disease, but activity. So is this the area that we really should be trying to treat patients? And you can see the distinction between activity with sputum pollens, frequency of exacerbations, and symptoms, importantly, which is very different to severity, where you can have extensive radiological disease, spirometry changes, emphysema, and things like that. And there really is a sort of move to treat in the middle, I suppose akin to things like asthma, where you're really trying to treat the patient when they're active, as opposed to waiting for them to have multiple exacerbations per year before you intervene. And this concept of disease activity has entered into the new guidelines. So whereas I mentioned before that treatment was 3 or more exacerbations, if you look at the remarks on the bottom here in the last guidelines, it's for patients at high risk of exacerbations, which includes patients with 2 or more exacerbations or 1 severe exacerbation, or importantly, 1 exacerbation plus severe daily symptoms. So symptoms really has taken front stage now in determining when we treat patients and when we start with these long-term therapies. Some of that has come from this study on the right-hand side, which was published just at the end of last year in Lancet Respiratory Medicine. And that was a study looking both at the EMBARK registry, 15,000, 20,000 patients longitudinally, but also looking at the 3 well-known macrolide studies in bronchiectasis in a post-hoc fashion, and using both of those to use symptom scores to help determine the risk of future exacerbations. And what they found was the risk of future exacerbations was just as high with symptoms as it was with past exacerbations, which is used previously to determine when to treat patients. So because of these concepts and this evidence, we also have these high-risk groups where, again, you should have a much lower threshold for treatment, They include some diagnoses, such as primary ciliary dyskinesia, that I'm going to talk about tomorrow, some infection states, such as Pseudomonas, but again, you've got severe symptoms there, directing treatment. And then the other concept within this therapy is the use of anti-inflammatory treatment. And the last year, again, has seen a lot of focus on that. Neutrophils have always been known to be important in bronchiectasis, but previous attempts at trying to reduce neutrophils as a treatment for bronchiectasis had failed. They had looked at things such as chemotactic inhibitors, which reduced the number of neutrophils in the airways, which led to more infections. But we have more tools now, and one of those main tools is DPP1 inhibition. How does that work? Well, one of the main issues with neutrophils is that when they get to the sites in the airways, they release neutrophil nets, so neutrophil extracellular traps, but they also release these proteases, neutrophil elastase, cathepsin G, proteinase 3, which can cause damage to the airways. Now, these proteases actually are in inactive form when they are packaged within neutrophils, and they are activated by cleaving of peptide bonds by DPP1. So if you have DPP1 inhibition, the neutrophils still get to the airway, so they can still phagocytose and have other actions, but they do not have active proteases to cause the damage. So this was an interesting concept, and it's led to multiple trials over the last year. It's led to the phase 3 trial, which I'll mention in a little bit more detail, that was published in the New England Journal of Medicine. And also there's a couple of similar studies in phase 2, but it's the phase 3 that has the most data. So just a couple of minutes on this. This was a very large study. It was 1,600 patients globally over multiple sites, and it was patients that were split into either 10 milligrams of brensocatib, 25 milligrams of brensocatib, which is the DPP1 inhibitor, or placebo. The inclusion criteria were 2 exacerbations and mucopurulent or purulent sputum, and it met its primary endpoint. The primary endpoint was a reduction in exacerbation rate over a year, and you can see here that the reduction in exacerbation rate was about 20% with both doses, with similar effects in time to first pulmonary exacerbation. It had a statistical hierarchy, whereby if the top-level hierarchy was statistically significant, you could move to the next layer, and these were also statistically significant, so the number of patients that remained exacerbation-free over the treatment period. And also, intriguingly, for the higher dose, the 25 milligram brensocatib, there was a reduction in the decline in spirometry, both FEV1 and pulmonary function over the year. So a reduction in decline of about 40 mils over that period of time. So this has led to the first licensed drug in bronchiectasis. So this is now licensed both with the FDA, which has quite a broad license, either drug dose for bronchiectasis generally. Also in my area, in the EMA and MHRA, it's also been licensed, but there, according to where the evidence is, for 2 or more exacerbations in the prior 12 months. It's also opened up this whole area as the importance of inflammation for other targets. I can't get the pointer to work, but you can see kind of right in the middle the DPP1 and CATC inhibitors, which are where you can see the neutrophils, but there's a lot of other industry interested in areas, and I'm involved in antibodies for some of these other drugs as well. So it really has opened the field here. But finally, we shouldn't forget infection. We know from that vicious vortex that infection is definitely a component, and whereas there's been a lot of interest in inflammation over the last year, we know that most of our patients grow bugs, that about 20-30% have Pseudomonas, which can lead to increased morbidity, increased mortality, and we also know that the greater the bacterial load, the higher the inflammation, and so all of these things are very much interlinked. The most recent study looking at this was a study looking at premixin, which is colomycin through the INEB. There were 2 big studies, PROMISE 1 and PROMISE 2. PROMISE 1 met its endpoint well, with a statistically significant 40% reduction in annual exacerbation rate, with even greater improvements in severe exacerbations. Unfortunately, PROMISE 2 did not reach the endpoint, but had a lot of problems with COVID at the time. Other interest in other clinical trials going on also is looking at phages as an antimicrobial treatment, and particular monoclonal antibodies against Pseudomonas virulence factors. So again, a lot of interest. So if I was doing this talk a few years ago, the bronchiectasis pipeline would be pretty empty, but there has been a real lot of development in this area to really help our patients. So I've mentioned a lot about inflammation. The first 3 trials are all DPP-1 inhibitors, but the other ones, areas again that I showed you on the cartoon earlier, there's also been significant movements in infection and mucociliary clearance. So I hope that gives a kind of whistle-stop tour around bronchiectasis. I've started really with the deteriorating patient, talking about how to assess them, the importance of HRCT, spirometry, bloods and sputum in the reassessment of etiology. I've talked about the importance of optimization of baseline therapies, and then I've moved more into when to treat some of these patients and maybe intervening earlier in this whole concept of disease activity. And then I've wrapped that together with the further therapies in bronchiectasis, the real interest in inflammation over the last year and how increased inflammatory and anti-inflammatory tools together with increased anti-infective tools can really change the landscape, hopefully, for some of these patients over the next few years. So I hope that was useful and fits into the program well. Thank you.
So thank you, Professor Michael, for a very nice illustration on the bronchiectasis. So I have one question. So do you routinely use mucoactive drugs for all bronchiectasis?
Mucoactive drugs,
yes,
you say?
Means N-acetylcysteine or adocysteine?
Yeah, so no. I utilise mucoactive drugs really on the advice of our physiotherapists, actually. So, and I know that not everybody has the same access to physiotherapy that we do in the UK. We discussed that in the workshop yesterday. But normally, the physiotherapy would train the patient in a kind of bespoke manner to airway clear, and they would base the need of these mucoactive therapies essentially depending on what they were like. Now, clearly, we also have a look at CT scans, etc. So if people are doing physiotherapy, but they still have loads of mucus down there, then irrespective, we might use it. There have, interestingly, been a recent New England Journal paper of medicine looking at some mucoactive therapies, which I was involved in, which was a crossover study looking at both carbocysteine and hypertonic saline. And the data was unclear, actually. There wasn't a clear benefit from it. We use a lot of hypertonic saline, less so, actually, carbocysteine.
Okay, thank you. Another question is role of bronchodilators. Means, do most of these patients or some of these patients need inhaled bronchodilators routinely or? Yeah,
so the guideline looked at this, and they are advised for patients with some obstruction, essentially. So I definitely don't give bronchodilators to all of them. I would base it on spirometry. If they have some obstruction, I might get them to try it. I also base it on symptoms. If somebody feels short of breath and wheezy, I would often get them to trial it. But I don't often stick patients on it and leave them on it, ad infinitum, unless there's a clear symptomatic or spirometric benefit.
Thank you.
Sir,
Now the floor is open for comments and questions.
Yes, sir, your experience do you routinely vaccinate all your patients?
Do I what, sorry?
Routinely vaccinate for pneumonia, influenza?
Yeah. So as part of their standard care, all of these patients would have yearly COVID vaccine. Well, actually not COVID anymore, yearly flu vaccine, certainly. And as part of their analysis with regards to etiology, we do an immunological screen which includes pneumococcal antibody level. So if their pneumococcal antibody level is low, they would all get another pneumococcal antibody.
Again, cholesterol is a bit costly in India. So I wanted to know, were you part of PROMISE trial or not?
Were we part of PROMISE trial? Yeah.
Yes, you were. So what about your experience with tobramycin?
So, so funnily enough, tobramycin is more expensive in the UK. So we have access to colomycin. We don't always use it in the premixin form. In fact, at the moment, that's not available. So the colomycin we use is just standard colomycin that we put in a nebulizer, standard nebulizer, 1 or 2 mega units twice a day. Tobramycin, we also use 300 milligrams twice a day via a nebulizer in Toby form.
Any patients where you have used both of them together?
I've never used both Toby and colomycin together at the same time, but I have sometimes flicked between them.
And how often do you find blood culture useful in bronchiectasis patients?
How often do I find?
Blood culture to be useful.
Hardly ever. They rarely get septic, in my opinion.
Can I? Sir, can I ask you one question?
Yes.
Yes,
sorry.
sir. It was an excellent talk on the bronchiectasis. In Indian context, I just want to know, as we have seen the Klebsiella pneumoniae, it is being isolated and it is associated with the mortality higher than the Pseudomonas aeruginosa. So, is there any different strategy if we come across the Klebsiella pneumoniae?
So I don't think the evidence is quite as strong with regards to Pseudomonas, with regards to things like eradication and impact on mortality or morbidity. Obviously, the body of evidence from a Pseudomonas point of view is very strong, not just in bronchiectasis, but obviously in other conditions like cystic fibrosis as well. From an eradication point of view, again, looking at the guidelines, which based on the evidence, the only real evidence from a guideline basis for Pseudomonas eradication. So we don't routinely, and the guidelines don't stipulate routinely eradicating Klebsiella. I think it all depends a bit on how the patient is. So if a patient's completely well and Klebsiella is one of the things that they regularly isolate, then other than treat exacerbations with antimicrobials that would cover it, I don't think I'd do anything specific. Clearly, if a patient gets Klebsiella and that causes a deterioration similar to what we've described, then I would be much more actively treating it. And I think that goes with all gram-negatives and with all of the colonizing microbes.
Sir, I would like to ask about the options of surgeries, right? So we see a typical profile of patient. The most common patients are the chunk which come in our OPDs post-tubercular bronchiectasis. Sometimes most of them will have a localized disease and bronchiectasis would be in a particular lobe, right? So it's not a progressive reason, not a systemic reason. So if patient is having repeated set of infections or some massive hemopsis, so which are those patients which can be considered for surgery in such subset of patients?
Yeah.
So I just have the answers.
So I think you've described the subset quite well. I think for considering surgery, it's important to realise that it's a big operation and there are complications of surgery. And obviously, if you remove some good lung as well, there can be complications with regards to longer term symptoms following that as well. Having said that, the other thing to just be aware of is if the first case I showed you, somebody had quite bad bronchiectasis that was localized, that was removed, but actually had a driving underlying disease that would cause bronchiectasis in other lobes further on. So I think it is very important that you ensure that you've removed the driver for the bronchiectasis, you've ensured that you've done the etiological screen and there's nothing else driving it. But then you're right, if you're struggling with a patient from a symptomatic point of view, they have localized bronchiectasis, it's causing them lots of problems such as hemoptysis or recurrent infections, and you don't have very good working lung within that lobe, then surgery, and post-TB is a perfect example, then surgery is definitely an option. We don't use it that much because we often have other drivers and multi-lobers, so we don't have the same etiology, but we do sometimes use it.
So Dr. Nagarjun, please.
Yes, so thank you so much. An excellent talk, Professor Michael. So I have two questions. One is on the use of airway clearance devices. In one of the last slides, you have listed all the devices which are there. So in India, as of today, we have access to Simeox, Byways, the West, and the oscillatory PEP devices. So if a patient comes to you, how do you devise which is the best device for him for airway clearance?
My answer is quite similar to the previous question. We're very lucky in the UK to have really specialist physiotherapists, and so a lot of the assessment of these kind of devices with airway clearance is taken away from me as the physician and put into the realms of the physiotherapist. Having said that, the devices that we most commonly use are the Arabica and the Acapella. So these are two essentially flutter type devices. We very, very rarely actually use any of those other kind of things that you've mentioned. We very rarely use the vest. We sometimes have patients that have come, particularly from the US, etc., that use the vest, but we don't feel, and I'm talking as a physiotherapist, that is as useful as proper airway clearance. So those are the main two that we use.
The second question was, we do have a subset of patients where we fail to eradicate Pseudomonas, which is what you had said in one of your cases also. So how would you go about managing this subset of patients where you fail to eradicate Pseudomonas?
So sorry, the question is, do I eradicate Pseudomonas?
No. If you fail to eradicate Pseudomonas.
If I fail?
Yes.
So if I fail to eradicate Pseudomonas, which happens in about 20% of the cohort that we have, so we've got 20% of 3,000 patients with Pseudomonas, then I would treat them depending on how they are. So if they are unwell and they are having several exacerbations a year, I would probably put them on a colomycin nebulizer or azithromycin. If they're doing badly on one of those two prophylactic management plans, I would put them on both. So the same kind, I don't think I'd treat them any differently to the way that I've kind of laid out in the talk.
Thank you, Professor Michael. So I think we'll stop here because time is up. So rest of the questions you can ask Dr. Michael on the floor. Thank you for a very nice talk and discussion.
Thank you.
I'm sorry that we had to stop in the middle of the discussions, but since the program started 15 minutes late, we really need to catch it up. The next master class. Actually, yes. If you have any questions with the speaker, actually you can take it outside the hall and they are available. So there's no problem about it. We are moving on to the second master class by Professor Richard Gisley Jenkins. Biologicals in ILD. Yeah. He's a consultant respiratory physician and lead in the ILD unit at Royal Brompton in London, UK. He is also Margaret Turner Warwick Chair of Thoracic Medicine and Head Center for Fibrosing Lung Disease in UK. For this, the moderator is Professor Mir Ilyas, and I invite him on the stage to get other people on board.
Thank you very much, sir. Good morning, ladies and gentlemen. Hello and welcome. It gives me immense pleasure and honor to welcome you all to this important session, Biologicals in ILD. Actually, we have seen a lot of progress being made in the field of interstitial lung disease, where we are moving from diagnosis simply to molecular and biological phenotyping. And wherever there is biological phenotyping, there is biological targeting. And for this, we have the best possible person with us. We are honored and pleased that Professor Richard Gisley Jenkins is with us. He is the chair of thoracic medicine at the MTW chair at the Imperial College of London. We have read his papers in the profile series, the injustice trial, and among all others. He's the best possible person that we can have for this subject. I would request our expert panelists, Dr. A.K. Mahapatra, Dr. Renis Davis, Dr. Komal Deep Kaur, Dr. Aditya Sharma to take their seats over there. And I would also request Dr. Atri Gangopadhyay, Dr. Priyajit Jana, Dr. Sagar Gandhi, and Dr. Shivkant Sharma to take their respective seats. Over to Professor Jenkins. We hope we get some minutes for discussion after the talk. We're all ears, sir. Please go ahead.
So thank you. It's a real honor and pleasure to be here on what I gather is a very important day, so thank you very much. So yeah, I'm going to talk about biologicals in interstitial lung disease. So just to set the scene, it's worth remembering what a biological therapy is, not least because we've had lots of new therapies tried and introduced in the field of ILD. But a biological therapy uses substances that are made from living organisms, like human cells, proteins, or tissues, to treat disease. And so this is essentially an antibody-based therapy. Now, there are different types of antibody-based therapies, but in the broadest terms, these are antibody-based therapies. So the question is, what is the role of antibody-based therapy in ILD? So I'm going to consider three areas. I'm going to focus, obviously, on the lung, because I'm a pulmonologist, and this is a pulmonary conference. We're going to talk about the role of antibody therapies in idiopathic pulmonary fibrosis before moving on to connective tissue disease, or SARD ILD, and then a final word on sarcoid. So, in a way, it's really easy to describe the role of antibody and biologics in IPF because there is no indication at the current time for the use of biologics in IPF. So I could stop there. But this has not been for the want of trying. There have been 11 different biologicals tried in IPF, but none have worked. And this slide was produced by Theo Karamtikos over 5 years ago now, describing the different trials and the different mechanisms that had been assessed in idiopathic pulmonary fibrosis. And you can see that there's a large number of negative trials. In that list of 11, 7 are negative and 4 were yet to report. Now, of those, and this was obviously a while ago, 3 out of those 4 trials have now reported, and 2 were negative. So the pamrevlumab, which was the anti-CTGF antibody, which everyone thought was going to work on the basis of its excellent phase 2b data, sadly, that was negative. And if you looked at the share price at the time that reported, it was astonishing. It dropped like a stone. And sadly, also, the STX-100, the humanized monoclonal antibody against the beta-6 integrin, was also negative. And the BAFF receptor, that was terminated by Novartis. There was no publication, there was just a press release, and it was for lack of efficacy after only 26 patients. We still don't know about the rituximab and acute exacerbations. That is still pending, and that's a study that's still ongoing. So I think the real question for biologics in IPF is, will they ever work? Now, the reason I say that is, and I do a fair bit of consulting for biotechs and pharmaceutical companies, is that one of the problems is that antibodies are big molecules. They're big molecules, and they have to penetrate the fibrotic tissue. So if you see here, see if this works. So the pointer's not working. So on the right of your screen, you'll see a Masson's trichrome of a fibrotic lesion, and that blue stuff is fibronectin-rich matrix. And the alveolar structure has been destroyed, and it's been replaced by this matrix. And if you look at the figure in the middle there, that's our spatial transcriptomics data. And what you can see, so the green dots are cells are the epithelial lining of the honeycomb cysts. And the red and the purple dots are fibroblasts and B cells. And you'll see that the fibroblasts and the B cells are deep within the fibronectin-rich matrix. And I am concerned that if you're going to try and target the fibroblast with a biological, it's not going to get in, it's not going to penetrate the matrix. So even if the target is good, and many of the targets that have been tried in IPF have been good targets, it's not going to work because the antibodies are too big to actually get in to where they're needed. So I'm concerned that they will ever work. And another pragmatic consideration is that most biologics require either subcutaneous or intravenous infusion once a week, once every 2 weeks, unless they're like rituximab and they have a 6-month half-life. And so you're asking your patients who have a disease which limits their ability to move to come from their home to the interstitial lung disease unit, which can be, even in the UK, that can be a long way. I don't imagine what it's like in a country the size of India. But you're asking them to come to the hospital every 2 weeks, every week, for an intravenous therapy. So I have a certain skepticism that biologics will ever be of use in IPF. I could well be wrong. Where there is clear evidence for their use is in SARD-related ILD. And these are taken from the guidelines that were published a couple of years ago. And these are the different CTDs, so systemic sclerosis, myositis, mixed connective tissue disease, rheumatoid arthritis, and Sjogren's. And it describes the preferred first-line therapy for all of these conditions. And what you will see is that the number one is mycophenolate. So that's not a biologic. That's a standard chemical inhibitor of lymphocyte function, which has been around for decades. We've all had considerable experience with it. But you'll see that for all of these subgroups of SARD, rituximab is recommended. So I'll show you the data on which that recommendation is made. Note, it's recommended, but it's a conditional recommendation. And you'll understand why when you see the data. And likewise, tocilizumab, which is an anti-IL-6, is also recommended specifically for systemic sclerosis. And again, I'll show you the data for that. And these are conditional recommendations, and again, you'll see why. And of course, systemic sclerosis, there is a strong recommendation against glucocorticoids, obviously not a biologic, but that's because of the risk of renal crisis. It's also worth noting that the SARD guidelines also tell you what to do if you have progressive pulmonary fibrosis in connective tissue disease in SARD. And you'll notice that there, and this is something I discussed at an earlier talk, is that if you have a connective tissue disease which is progressing, do you escalate the immunosuppression or do you add in an antifibrotic? And that's a nuanced discussion, but the recommendations say you can do either. So you can either add in rituximab, tocilizumab, or nintedanib. And it really depends whether you think the progression is due to worsening fibrosis or worsening inflammation. And the treatment for rapidly progressive ILD, and this is the one thing that I think we're all terrified of because the clinical presentation is quite dramatic and the risk of poor outcomes is so high. What you'll notice is that the suggestion is whether the first decision point in the algorithm is do you think it's anti-MDA5 or not? Because we know that the anti-MDA5 CTDs have a particularly bad prognosis. But actually, the treatment algorithm is largely the same. You give them IV glucocorticoids, and then you throw the biological book at them effectively. So you can either give a standard immunosuppression plus a biologic, depending on how severe it is. So now let's look at the data. So rituximab is an anti-CD20, which is an adhesion marker which identifies B cells. It's worth remembering, and this may explain why it's not so good in IPF, despite the presence of a lot of plasma cells in fibrotic lung tissue, is that the B cell penetration of rituximab into tissues is not great, which is why in MS, they don't use it for MS. They have different anti-B cell therapies in MS. Very good at reducing your B cells in your peripheral blood, not so great at reducing B cells in the tissues. This is the EVER-ILD study. It was performed in France. It randomized 126 patients in a 1-to-1 ratio of placebo versus rituximab. Rituximab was given 1,000 milligrams IV on day 1 and at week 2, and it was given on top of standard of care, which was mycophenolate. The primary endpoint was the change in FVC at 26 weeks. And unfortunately, you won't be able to read much of what's on that baseline panel, but this just shows that the patients were well matched for age and sex across both groups and baseline FVC. And it also shows that they had a lot of non-specific ILD. So there was IPAF and idiopathic non-specific interstitial pneumonitis. It wasn't all classical connective tissue disease. And so this is the headline figure. This is the result of the primary endpoint. And what you will see is that in the placebo group, there was a steady reduction in FVC to about a drop in just under 2% of FVC after 6 months, which was protected by the rituximab group. So there was a 2% difference in their FVC, percent predicted after 6 months. The question is that a worthwhile return on the patient's investment in time and risk and the healthcare institution's investment in the money? That I will leave people to discuss. There was also an important secondary endpoint, which was a statistically significant reduction in, or an increase, a statistically significant increase in progression-free survival. It's important to note that their progression-free survival included stopping mycophenolate. So if they had to stop mycophenolate because we thought it was not working, then that was called a progression event. What they don't tell us is how many of these progression events were due to the change in therapy. But clearly that's part of the intervention. So it's difficult to interpret progression-free survival in that context. So the headline summary of the EVER-ILD study was that rituximab does lead to a 2% improvement in FVC at 6 months. Rituximab leads to an improvement in progression-free survival. There were 9 infections in the rituximab group versus 4 severe infections in the placebo group. There were 3 deaths in the rituximab group and 4 in the placebo group. So then we come on to the recital study, and this was a study performed by Toby Mayer out of the Brompton. And this was not a placebo-controlled trial. This was a rituximab versus cyclophosphamide phase 2b superiority study. And this is important because when you power a superiority study, the numbers are small. This was not a non-inferiority study, which is when you need much bigger numbers for a non-inferiority study. The primary endpoint was delta FVC at 24 weeks, which is actually the commonest time point for many of these studies. And the power calculation suggested 104 patients were needed. And unfortunately, like many studies, COVID made it difficult, and 101 patients were randomized. So already, the study is underpowered. And these are the baseline characteristics, and again, you can see that they were well matched for age, sex, ethnicity, and lung function. But just worth remembering in this study that there was a big recruitment of patients with inflammatory myositis. So whereas in the EVER-ILD, it was a lot of IPAF and idiopathic NSIP, in this study, there was a lot of myositis. So here's the headline data, and you can see that the difference in FVC at 24 weeks was 40 mils better for cyclophosphamide. So rituximab did not show superiority to cyclophosphamide. That is all we can interpret. This doesn't mean that rituximab and cyclophosphamide are equivalent, because this is not a non-inferiority study. What it did show also, and you see that in the bottom part of that figure, is that the FVC improved for both patients receiving cyclophosphamide and rituximab over the 24 weeks of the study, and this was maintained in both groups for nearly a year. With no difference in any secondary endpoints. There was a slight reduction in corticosteroid dose use in patients on rituximab, is about 4 milligrams, and I think the difference was between 40 and 36 milligrams. There were 50 infections in the cyclophosphamide group and 46 in the rituximab group. There were 2 deaths in the cyclophosphamide group and 3 in rituximab. And the conclusion of the paper, which is 100% correct, is that rituximab was not superior to cyclophosphamide to treat patients with CTD-ILD. There were other statements about effect on FVC, but this was not placebo-controlled, so it's very difficult to make any comment of how the drugs are working, not compared with each other. And the statement that that rituximab is a potentially useful alternative to cyclophosphamide also needs to be taken with a grain of salt, because this wasn't a non-inferiority study. So it was neither placebo-controlled and it was not non-inferiority, so really all we can say is it's not better than cyclophosphamide. Finally, in the rituximab is the CTD Desires study, and this is a phase 2b safety and efficacy study of rituximab versus placebo in systemic sclerosis. And this was 54 patients randomized, 48 of them had ILD. Like many of these studies, the primary endpoint was a change in Rodman skin score. These patients had a different routine of rituximab. These patients had it every week for 4 weeks, as opposed to every 2 weeks. And in this study, the secondary endpoint was change in FVC predicted at 24 weeks. So you're seeing a theme here. We wait for 6 months to look at the FVC. And again, these are the headline figures. So the top graph is the change in Rodman skin score, but the bottom graph is change in FVC. And again, you will see a statistically significant difference in the change between patients treated with rituximab and placebo. This is a secondary endpoint, though. This is not a primary endpoint, and it's at best exploratory. But you will see that there's a 2.5% difference in FVC at 6 months, or just short of 6 months. So, like the other 2 studies, we're seeing a 2% difference in FVC. There were no infusion reactions, no difference in SAEs, and no deaths in either group. What about tocilizumab? So this was a phase 3A trial in systemic sclerosis, randomized 212 patients. Again, because it was a systemic sclerosis study, the primary endpoint was change in modified Rodman skin score. And again, exploratory secondary endpoints included delta FVC and delta QCT. This is the headline figure, and what I want you to notice particularly is one, if you look at the figure A in the top right-hand corner as you look at it, these are patients without ILD. These are all comers. So it improves FVC even in patients who don't have an ILD. something weird's going on with anti-IL-6. But that effect is enhanced in panel B in patients who just had ILD. And again, you will see that in the bottom figures where they map the FVC, the effect is sustained over 48 weeks. So at 24 weeks, the difference was about 2% of FVC, which had increased to close to 6% after 12 months. And we see this in trials. If you're on a drug continuously, the progression is stopped, the difference is magnified over time. And these are the other secondary endpoints. So there was 77% adverse effects, but in both groups, 50% of them were severe. There were quite a few reactions at the injection sites. But importantly, there were fewer infections in the tocilizumab group compared with placebo, similar number of severe effects, and fewer deaths. But again, there weren't many deaths in each group. So to summarize tocilizumab, there was a 6% difference in FVC at 48 weeks, but this was about 3% at 6 months, very similar to what we see in rituximab. This was only an exploratory endpoint. It was generally safe and well tolerated, and this study led to the approval of tocilizumab for the treatment of ILD by the FDA. So finally, final slide, infliximab in sarcoid. This was a phase 2b placebo-controlled randomized trial in 2006. There has been nothing since, as far as I could tell. 138 patients randomized, and again, the primary endpoint was delta FVC at 24 weeks. And you can see this average age was 47, males 57% white, 67%, 68% FVC at baseline. So these were pretty bad sarcoid patients, and they were equally randomized. And what we saw with this was pretty much the same. So at 6 months, 24 weeks, patients receiving infliction, so the effect was not sustained in the higher dosing group. So to summarize, in infliximab, again, there was a 2% difference in FVC at 24 weeks. There was no dose-response effect. Effect was not sustained. They did see a reduction in steroid dose, and it was generally well tolerated, although there was an increase in pneumonia in patients treated with infliximab, with 4 patients getting infections compared with 0 in placebo. The question was, why wasn't there any take-up? And apparently, at the time, it was considered that a 2% improvement in FVC in patients with sarcoid at 6 months was not considered sufficient to be exciting. So I'm going to finish there. And just to summarize, there is no evidence to support the use of biologics in IPF at the current time. The SARD ILD guidelines recommend the use of rituximab and tocilizumab based entirely on phase 2b studies or secondary endpoints in clinical trials for systemic sclerosis. And the evidence for the use of infliximab in sarcoid is very similar to the evidence for the use of tocilizumab and rituximab. So I'll stop there, and I'm happy to take any questions.
Thank you very much, Professor Jenkins. I think it was a very ruthless and honest dissection of these famous studies. We would agree that the evidence is very weak, to say the best. We should expect a maximum of 4% change in FVC even at full dose. I'm sorry, I said we should expect a maximum of 6% change in IVC in the best of circumstances. That is the situation in 2026. My question would be hypothetical. After 5 years, say we are doing the same meeting, which areas do you see where there would be a proven or an increased role of biologics in these subsets?
So, sorry, I don't quite understand. In which area of?
Like CTD, ILDs, hypersensitivity, pneumonitis.
Okay. So I think,
so
there is no data on hypersensitivity pneumonitis at the moment. And I think if you think about it mechanistically, biologics are targeting largely inflammation. So I think where inflammation is playing a big role, then that's where we are going to see further approvals. Now, my challenge is But, and I guess this is and the question is the when. The inflammation in hypersensitivity pneumonitis, the inflammation in idiopathic pulmonary fibrosis is early on in the course of the disease. And we probably have pretty good anti-inflammatory agents just with mycophenolate, actually, and methotrexate. You know, we probably have pretty good drugs for the inflammatory phase. We have very bad drugs for the fibrotic phase. And as I said, I'm not convinced that an antibody therapy will ever work in the fibrotic phase, of whether it's hypersensitivity pneumonitis or idiopathic pulmonary fibrosis or CTD. Now, it might do if it can penetrate. So now they're developing smaller sort of chimeric antibodies, so they're much easier to penetrate. So there may be modifications we can make to biologics so they can get into the matrix. But until such time that we see a biologic work in IPF, I'm very hesitant to think that we'll ever get something to work in the broader range unless there's inflammation. And certainly with hypersensitivity pneumonitis, the inflammation is early on. And by the time, and we see this in Justice, we didn't show the data, but in the patients with hypersensitivity pneumonitis with unknown antigen, they're behaving very much like IPF.
We can take one or two questions from our expert panelists. Anybody?
Yeah, excellent presentation by Professor Richard. And may I ask you the time to give the antifibrotics, whether it should be upfront or you watch for the progression, or whenever you feel that there is a progressive pulmonary fibrosis, you add?
So that's a really good question. So the question was, in terms of antifibrotics, when should you give it? Should you give it up front or wait for progression? And certainly in IPF, the answer is give it up front. In CTD or hypersensitivity, the recommendation is to wait until you have progression, and progression is defined as 2 out of 3 things. So worsening symptoms, worsening lung function, or worsening radiology, and you can argue about the precise numbers. The question is, in my heart, the answer is, in my heart, I know that most of these patients, certainly with hypersensitivity pneumonitis, are going to progress. So why should we wait? Now, the other challenge we have is that we don't know how long antifibrotics work for. And we're seeing this a lot now in the new trials coming through. The patients on background nintedanib, background pirfenidone, are progressing at the same rate as placebo. Now, a letter was published in JAMA after the Isabella studies. Yeah, and it looks as though the treatment effect is wearing off. Now, we don't know why that is. Is it some patients just never respond because no patient responds the same to all drugs, and so there's a positive selection bias of people into these trials who are not responding? Or are the drugs wearing off? We don't know. So the timing could be very important. If these antifibrotics don't work forever, and you give antifibrotics to a patient who is stable, are you losing your opportunity? And we see this with the anti-tumor drugs. You know, there is resistance to the new anti-tumor therapies, and so I have a slight concern that we might be developing, patients with fibrosis might be developing resistance. Their myofibroblasts might be developing resistance, and so then we may have to think very carefully about when we start antifibrotics. And so you might want to wait until there is some evidence of progression, maybe not a formal 6 months, but if a patient says to you, I've actually been feeling fine for the last 2 years and I feel fine now, you may want to wait. If someone comes to you and says, well, actually, 6 months ago I couldn't walk up a flight of, I could walk up a flight of stairs and now I can't, that's the time to start the antifibrotic. And I don't think it matters whether it's IPF or progressive fibrotic lung disease at that point.
Thank you very much, sir.
Dr.
I think...
Dr. Mir, I have a question.
Yes, quick one. Just we have 20 seconds.
Yeah. Professor Richard, thank you for your talk actually. My question is about probable UAP versus NSAP. There are a lot of times the CT pattern is either probable UAP versus NSAP and the autoimmune serologies are negative. There are many who would actually biopsy the patient, but there are a lot of people who would give a steroid trial and see whether the patient is responding and then decide about alternative immunosuppression. Would doing lung biopsy earlier help us in choosing a steroid sparing agent early, and also consider rituximab in cases who are failing on MMF? Because you have shown in your studies that EverILD and other places, other studies in NSAP, when the patient is not responding, to give rituximab. So would an early biopsy in these patients help?
A controversial question. I'm going to say no. I'm not a big fan of biopsies. I think we make too many assumptions, and there's no data to back up our assumptions. So if you have, in my mind, I'm a very simple physician. If you have probable UIP in the right, on CT scan, in the right clinical scenario, so in an elderly patient who has evidence of ischemic heart disease and cardiovascular disease, it's going to be IPF, whether you do this. So don't waste your time trying to give drugs which are going to make their cardiovascular disease worse and kill them with a heart attack and diabetes, i.e. steroids. Just go straight to the antifibrotic. A biopsy has a 1 in 50, an open lung biopsy has a 1 in 50 chance of killing the patient. Now, I asked this question in Australia. I said, would you get, in Australia everyone flies all the time, and in India I guess people fly a lot. Would you get on an airplane if your risk of dying was 1 in 50? And if the answer is no, you've got to be very clear that doing a biopsy is the right thing to do. And I don't think there's any evidence anywhere that what you see on a biopsy predicts your response to treatment. Now, it helps us refine our diagnosis, but it doesn't tell us that even when you see a bunch of lymphocytes on the biopsy, or a bunch of eosinophils, which are the only cells which are going to respond to any of the treatments that we have, the biopsy still doesn't predict response to treatment. And that's what we really need in our field. And that's why we're working so hard on biomarkers, is something that we can measure anywhere in a patient which says, you're going to respond to this drug. If we had an IgE level or an IL-5 level or something which we could say, like they do in asthma, you're going to respond to this drug, then I'd agree with you. But at the moment, not. So I tend to say if it looks like IPF, it smells like IPF, it is IPF.
Yeah,
thank you very much. Thank you very much, everybody. Thank you very much, Professor Jenkins. It was such a lucid presentation, and we are already in the red zone. Thank you very much, panelists, and thank you very much, chairpersons. Bye. Over to organizers.
So for the next session, we have Professor Shamila Vitana with us. She will talk about the clinical phenotypes of OSA. And Professor Shamila Vitana, she's a known, renowned faculty from London, and she's a consultant respiratory physician specialist in respiratory medicine, sleep and ventilation, and allergy at Hayfield Hospital and Brompton NHS Trust, UK. So to moderate this session, we have Dr. S.N. Gupta with us. And we have expert panelists of this session, Dr. Syamal Sarkar, Dr. Varsha Vishwanath, Dr. Gaurav Singhal, Dr. Sonali Saini, and Dr. Pallavi Periwal. And we have chairpersons for this session, Dr. Dilbag Singh Randhawa, Dr. Sanjeev Singhal, and Dr. Vidya Nair. So please be on the dais. And now I request our moderators to start the proceedings. Dr. S.N. Gupta, please.
So good morning, everybody. At the outset, I'm thankful to my close friend, Dr. Deepak Talwar, who has given me the opportunity. Rather, he is giving every year this opportunity to meet all my old and good friends. So this morning, we will see the OSA, the topic on OSA. So most of us consider the OSA as a single disease. When we consider this diagnosis or treatment point, we think that it is a single disease. But actually, this is a heterogeneous disease with different phenotypes and endotypes. Not only that the response to the treatment is also different in those group of patients. So one size fits all doesn't fit to this OSA care. So Dr. Shrimla is here, who will be clearing all the points on different phenotypes and endotypes. Thank you, and I request Dr. Shrimla to start with the lecture.
Thank you very much. And thank you for all, after last night, not having much sleep. All of us are here to understand sleep a bit more in detail. And this is a topic that is very close to my heart, so thank you, Deepak, for this. I hope you can hear me at the back. Thank you so much for choosing this topic. Clinical phenotypes in OSA. I have turned it into more clinical phenotype in sleep disordered breathing. And how do you practice precision personalized medicine, and what more can be done? Simple changes, but you will find you can do a lot more within your practice. So I will be I'm going to skip the summary, but I will be going through the spectrum of phenotypes and the latest evidence based on how we classify different phenotypes with a lot of input in cardiovascular medicine, different types of phenotypes which matches different treatment pathways, and CPAP is not going to be the only effective treatment modality available. So for you to know a bit more about the rest of the modalities apart from CPAP, and of course the future of digitalizing, the future of making your patients more smart and making your sleep clinics more smart, and getting cloud-based telemonitoring into your practices, and also making your patient care more personalized. No two patients with any disorder, for that matter, will behave in the same way, and that applies to sleep medicine. So you can clearly see this is a very abundant disease in the world, and India is within the top 10. And these patients actually exist in your everyday practice. They exist within your ILD, within your asthma, within your COPD. So I think it's about understanding that they don't present to you just as sleep disordered breathing. They exist within your day-to-day practice, and it's about identifying them and classifying their treatment according to their phenotype. So sleep disordered breathing is a spectrum, and right at the top is your OSA, but there is increasing interest in identifying I don't think this is the pointer is working, but identifying subgroups within OSA itself, such as persistent sleep apnea and REM dominant sleep apnea. So be more vigilant when you look at your sleep study to identify all these subgroups. There is increasing interest in central sleep apnea, which I will talk a bit more on my tomorrow's talk. And of course, obesity hypoventilation syndrome, the relevance is becoming more and more in your day-to-day practice. Nocturnal hypoventilation, which exists in all of the spectrum of conditions that you treat, particularly if you're giving anyone steroids, watch out for it because of steroid-related obesity, sarcopenia, osteoporosis. These issues kick in over chronology, over time. And as you monitor your patients over time, particularly if you've treated them for 10 years, then start being vigilant about sleep-disordered breathing. I will speak a little bit on upper airway resistance. These are tired patients who do not score in the traditional way on AHI scoring that we do. Then there is nocturnal hypoxia and there is overlap syndromes. So sleep-disordered breathing is identified through polygraphy or polysomnography or simple oximetry, the level 4 study. Based on airflow obstruction, hypoxia, and hypoventilation, we classify them into severity indices. One of the most important messages for me, for you for today is actually to screen your patients with a very simple tool, and I quote it from the Stop Bang tool that is worldwide known. But the Stop Bang BMI thresholds, as we know, it's not really very applicable for our part of the world. So modified Stop Bang should be a way forward for us to think, and there is emerging research looking into this in the South Asian cohort, and these are some of the points. And the BMI threshold, as per NICE last year, should be 27.5 for us. The age cutoff should be possibly around 40, and the neck circumference for females should be around 35 centimeters, and males should be about 40 centimeters. So there is emerging evidence, but one of the key things is the stop question, which you can ask, because I think in your busy, flooded clinics, it's very difficult to do all of these neck circumferences, and even to measure BMI in height is not that easy. But the STOP questionnaire, which is snoring, tiredness, observed apneas, and hypertension. Very easy 4 questions, 2 out of 4. You have a suspected sleep disordered patient in front of you, and that is going to be very common in your practice. So I think this is one key message for all of you. Start asking these questions, particularly when your patients are tired, and tiredness is very common in your day-to-day practice. And think about sleep disordered breathing as a comorbid condition, and the rest of the talk will tell you why it is important. So sleep disordered breathing, as you traditionally know it, we go by the classifications based on apnea, hypopnea indexes, and this more than 5 event threshold, the 3% desaturation thresholds. If you look at obesity, hypoventilation, again, the BMI threshold, we need to know it's 27.5 for our patient group. And the PCO2 thresholds for any patient with suspected muscle dysfunction or suspected chest wall disorders, such as kyphoscoliosis with osteoporosis. These cutoff values are dropping, and the PCO2 for such groups is 45. And the other cutoff value to know is that a baseline to overnight, next day morning increase of PCO2 more than 10. So 2 blood gases done before and after sleep, more than 10 millimeter mercury jump can diagnose hypoventilation syndromes. And this means if you have a patient with a PCO2 at 30 in the evening and the next day morning it jumps up to 40, 41, 42, that will classify as nocturnal hypoventilation. So I think, be aware that these thresholds are changing and dropping, so that you pick these patients early in their disease spectrum, and you identify how each individual behavior can be improved. Excessive daytime somnolence is the key. So tiredness is a very relevant and an important question to ask. And a lot of the cardiovascular morbidities, a lot of the responsiveness to CPAP is based on excessive daytime somnolence. And it's not that easy to apply Epworth sleepiness score to our cohort of patients, and I know this with the work we do in Sri Lanka, that patients, one, do not understand these questions in the same way, two, the clinical behaviors are different, and of course all the validation tools aren't that robust, and you do not have time to go through this in your day-to-day practice often. So I think it's, again, measuring tiredness as a tool is not that difficult, but not that easy using the standard prompts that we use, but have a way of measuring it in a clinical sense. But if the patient is tired, definitely they will respond better for the gold standard CPAP treatment. So the tiredness cohort will respond very well, and they also will mount a better cardiovascular improvement with the gold standard PAP-based treatment. And yesterday's workshop, we went through all these CPAP, auto CPAP, BiPAP, VAPS modes in detail. I think you are all familiar with the modes of treatment, but what you need to understand is just a set standard approach to give the machine and forget about the patients is not going to be useful. These patients' clinical behavior, it progresses over time, changes over time. Patients add on additional comorbidities over time. So you need to be following these patients, even if they're on CPAP treatment, even if they're on BiPAP treatment, their treatment response will change. They may not respond, after another couple of years. Then you have to reassess and re-prescribe and look into other comorbidities. So pick the correct patients to prescribe PAP therapies. However, that doesn't end there. You need to follow these patients over time and adjust the treatment over time and think of other comorbid conditions. Bit on nocturnal hypoventilation syndromes. This is again fairly common in your day-to-day practice. You need to be vigilant to pick it up, and these sort of threshold values that I told you about, PCO2 measurements, be aware of it, and simple blood gas tools will do. And yesterday we talked a bit about a TOSCA device, O2 CO2 study, that will be a real game changer if you are going to improve your sleep service, which helps in acute and chronic as well. So another entity that I wanted to speak a little bit is on upper airway resistance syndrome. You will come across your practice where patients do not behave in the same traditional way. They will be excessively tired, they'll be snoring. However, there's traditional HI polygraphy tool does not pick these patients up. Currently, the best way to pick it up is polysomnography. However, there are increasing tools coming available to look into the respiratory disturbance index and arousal thresholds by alternative means. These patients are tired, so they will respond to CPAP, and they do have cardiovascular comorbidities. So polygraphy sleep study should be seen as a cardiopulmonary risk assessment tool, and this is increasingly being relevant in cardiovascular health. So I think it is important that we as respiratory physicians make more awareness about the fact that this is a tool that the cardiologist needs to be aware of. There is an increasing trend towards trying to identify cardiometabolic benefits in sleep medicine, and so far the research evidence says HI is not the best way of measuring this risk, which is why there is so much going on to identify what other tools should we be using instead of AHI as a tool to measure the cardiovascular risk, and that is where precision phenotyping is coming into play. You can see on the graph that there is so much data that you can measure from a simple polygraphy. You can see that this patient has obstructive sleep apnea, hypopnea syndrome. You will be able to see these patients whether they are having central sleep apnea or mixed sleep apnea at the onset or not. You will be able to see whether the patient has supine dominant sleep apnea or REM dominant sleep apnea. And these subclassifications do matter when you actually look at their treatment options. Then you will be able to see whether they have predominant obesity hypoventilation, or if they do not have, if their BMI is normal, if you see these sort of dips, then think about overlap with your COPD-ILD group, for example, nocturnal hypoventilation syndromes, check on their diaphragms, look at their muscle function. Then you have nocturnal hypoxemia. You will have a flat line, and it will be more desaturation, it will be more the hypoxic burden. So it will be a measure of hypoxic burden, which is also a cardiovascular risk assessment. It's particularly relevant to pulmonary hypertension and heart failure. And of course, you can look at tachyarrhythmias and atrial fibrillation. And so in terms of cardiovascular importance, particularly that there is increasing tendency for cardiologists to now refer patients who are having resistant hypertension, poorly controlled atrial fibrillation, and cardiac failure. So I think the place for the polygraphy sleep study is increasingly becoming a cardiopulmonary risk assessment. So I think that is the mindset that we need to use these tools, not just as a sleep study, but as a more of a risk assessment tool for all of these reasons. So there is increasing evidence that excessive sleepiness is a key thing to look out for. So yes, the focus is on AHI as a diagnostic tool. However, the patient group that have excessive sleepiness, they have a higher cardiometabolic risk, but they too respond really well to CPAP. So if you were to select this group of patients, then your CPAP adherence is going to be better, and that group actually really benefit from cardiovascular improvement. Obese males with cardiovascular and metabolic disease is where, and those who are having excessive sleepiness are the ones who would benefit more from CPAP. And this is another couple of studies to prove that this group of patients actually have better, a higher cardiovascular risk burden. Particularly, you can see, rather than AHI, they have used sleepiness as a way of phenotyping higher cardiovascular risk burden group. So having excessive sleepiness as a phenotype, regardless of the patient's AHI. So change your mindset from these patients, the bottom group with excessive sleepiness might have an AHI of 5, and the top group with minimum sleepiness might come with an AHI of 30. So ignore the AHI and look at the excessive sleepiness as a phenotype, and that is an important message. And this sort of phenotypic classification is further supported by these evidences coming from Europe and from USA, where they're looking into why the underlying disease behaves this way. And the 4 main factors is the pharyngeal muscle tone, the arousal threshold of the patient, and here, if the patients are having a low arousal threshold, you need to know that these patients may not tolerate CPAP that well. So it's important to know that the arousal threshold is an important factor. That's the group that if you have to choose between a CPAP or an alternative treatment, then choose the alternative treatment option first. The O2-CO2 sensitivity drives loop gain, and the high loop gain patients actually respond fairly better to CPAP therapy. The patients with pharyngeal muscle tone will have a high AHI, and that group of patients who are, you can see on that red box, they tend to have a lot more anatomical impairment and their need for a higher CPAP pressure. So this group of patients do respond a lot better for CPAP. So this is another approach looking, breaking down your sleep study, ignoring the AHI to decide on CPAP. I think I had my timing wrong for this study talk, I must say, so I probably will have to steal some time. This is an important...
Excuse me, Dr. Sharmila.
Yes.
Actually, we are running short of time. The organizers, they are requesting you to finish it fast.
Yes. So this is a couple of studies that I had to run through to show you that the cardiovascular risk burden is important. And of course, this is a study to say that sleep apnea, CPAP is not just the only treatment option. There are other treatment modalities such as mouth guards and drugs, medication that is coming to play, and all sorts of devices that are coming to play, this is a very important slide. So I will probably show you this slide as my last slide to tell you how much alternative treatment options are actually available. It is important that you assess these patients for lifestyle measures, and GLPs are coming into the market. Precision sleep devices that are increasingly being available. Mandibular devices have increasingly more and more supportive evidence to support cardiovascular benefit as well. But there are other devices that are FDA approved and NICE approved, such as ENT interventions, such as hypoglossal nerve stimulation, and e-sprite, INAP type devices, tongue and genioglossus, and submental stimulation or TENS devices. So these are for your non-PAP-based treatment options that are growing across the world. And I think you need to be aware of these treatment options, particularly as PAP intolerance is going to be, there will be that group of patients with PAP intolerance. So I think it's very much to tell you that sleep disordered breathing is not just one defined all fit, one stop fit all fit type situation. It's evolving over time, it's changing over time. Cardiovascular risk burden is becoming an important aspect, and it's not just CPAP, so many other treatment modalities are there, and I think you need to be more and more aware of how to select the right patient for these right tools. And I will leave you with this slide for your thoughts.
So thank you, Dr. Sharmila, for the excellent talk. You see, actually, nowadays, because still recently, all of us, rather most of us, were considering the AHI as a standard, and it was just not a measure of the severity, but we would consider it for the planning of the treatment. But after the exposure to the different phenotypes and endotypes, now the AHI is not left. I think it should be used as a complementary while we're planning to and see the what is the symptom burdens and what are the other for the cardiopulmonary risk factors, and we should plan for the treatment. And that I think the last slide was depicting very well to go for the combination of therapies, because we can start with the combination of therapies in subgroup of patients. Thank you so much, and I'll request my chairpersons and the expert panelists to ask questions if they have.
Thank you, Madam, for the excellent lecture here. I have two questions. First one is, in spite of having same age, BMI, and AHI criteria of severity of OSA, some patient has excessive daytime sleepiness, yes. Some don't have. What the underlying cause of non-sleepy OSAs? Yes. And second question is, I feel the very trouble in diagnosing and treating women with OSA.
I didn't catch the second one, sorry.
Yes. Women with OSA is very trouble for the diagnosis because their presentation is different, and the standard questionnaire which we are used, yes, are not acting in that cases. Yeah. And their polysomnography criteria is different, so home sleep apnea test is not proper for the diagnosing them.
Yes.
And the auto-titrating CPAP is also not enough for the treating of this patient because they are very much poor tolerance of this, yes, not using CPAPs. What's your comment on this?
So the first question was very much, I think the focus of the study is the fact that there are high AHI burden patients with no sleepiness and there are low AHI burden patients with high sleepiness. And that's exactly the essence of today's talk, is to ignore, not to ignore the AHI, but to know about the AHI, because that's the only way we right now know how to classify this disease, and all the guidelines are still based on the AHI as a criteria to tell you how to decide on the severity. But however, the severity is the severity of sleep fragmentation. It is not a severity of disease burden, and particularly cardiovascular disease burden or clinical behavior. So yes, you have to take AHI into account, but you as clinicians, and you are, generally day-to-day clinics are absolutely flooded with patients. So you have to go by your clinical judgment, and which is why I said about the stop tool. And if you are having a patient who's snoring with tiredness, take that as a marker and then look at the AHI, but you can use that as a tool to decide on CPAP responsiveness. So in other words, you could ignore that AHI and look at your tiredness as a tool to decide on CPAP responsiveness. So I think that hopefully answered one question. Because if you go by mild AHI or do we give CPAP, I think that mindset is increasingly changing, is what I'm saying. Second question was also an excellent question, which is, home sleep studies versus polysomnographies. How do we, set about, did you say it's more about identifying the right kind of patients using these tools? So again, I do have, can I have one slide of there's a last slide in there which I would really like to show the audience. It's the one before the last slide, actually, if you can just show that slide. So the world is changing in how we do sleep studies. And there is a lot of wireless kit coming around, and I actually wanted to allude you to the fact that there is so much digital technology coming around. This is the slide. We are moving out of standard level 1, 2 studies into doing this in a more digitalized manner. And this technology is the future, and wireless technology in sleep medicine is going to be the future, and India has to be part of this. So you need to start thinking smart and moving your patients into smart ways of managing these patients. All of your patients have smartphones, and I think the cloud capacity is coming so that all these devices, every single device that will come into the market will have a telemonitoring facility. So I think the traditional ways of testing sleep disordered patients is changing. We are moving more wireless. And even the EEG, that ear probe is actually an EEG probe. Right now it's very much for epilepsy, but this will move forward into a sleep arousal detecting tool of some sort. The rest of the tools that you see are sleep studies, polygraphies that are also like pretty good indicator of cardiovascular burden, some of them. And the patients are increasingly being able to monitor their sleep using the smart apps, and they will most likely come to your clinic even right now to say, my smart app is saying, I have sleep disordered breathing. So I think it is important that you use these tools in your day-to-day practice, particularly in follow-up and particularly in personalizing the care for your patients. I hope that...
yes, Dr. Gaurav wants to ask some question.
Another question, ma'am. When a patient who has a moderate obstructive sleep apnea comes to you with a AHI of around 30 to 35, so with the coming up of GLP-1, would you like to give the patient time to lose weight with GLP-1 agonist before going on to CPAP, or would you prescribe both the therapies concurrently and then decide on the further management?
Just a simple answer to that is yes. Generally, of course, it depends on if you have a patient with very excessive daytime somnolence, then the GLP alone is not going to cut it. So you will probably have to prescribe CPAP. And if the patient is PAP intolerant, and alternative treatment. But certainly GLP is increasingly, it's into the guidelines now that it does have the ability to help the patients to lose weight in the correct area. So you saw the pharyngeal area, and patients with on GLPs versus no GLP who will lose 10 kilos with the same AHI. The patients with on a GLP will improve their AHI a lot better because the GLPs do have the ability to improve the weight loss in the areas that matter. So yes, GLPs are increasingly going to be part and parcel of your sleep apnea treatment. And of course, the decision of whether to start it with CPAP or without, I suppose in the NHS, everything's free, so we give everything together for our patients. And of course here, you could argue patients could try the GLPs and then use the PAP-based treatment as the next step.
Two more questions. One is, do you screen all your heart failure patients with polysomnography, or only those who are not optimized with therapy? Number one. Number two is, what are the ideal candidates for the myofunctional therapy and the mandibular advancement devices? Whether you do a radiological screen on all these patients, you're suspecting that they'll improve with mandibular advancement devices?
Good question. So I will break it down. So polysomnography, as I mentioned here, is increasingly becoming a third line test for us. A lot of the cardiovascular, so I come from a advanced heart lung center, as you know, Harefield Hospital. And you will be pleased to know the majority of our screening is actually polygraphy. And there is, as I said, polygraphy is a cardiovascular risk assessment tool. And the amount of data, if you know how to get the data out, is such that you actually do not need polysomnography. It's only a very small proportion of these patients will end up needing polysomnography, and that is usually when you're in trouble, when their excessive sleepiness is not improved by everything you throw at them, then you have to subclassify them. And of course, in a comprehensive sleep service, you will have neurologists, ENT surgeons, psychologists. So then you sit together, do the polysomnography, and we generally do a PhD MDT. That is the service structure over there. But that's a very small proportion. So having simple polygraphy is good enough as a cardiovascular screening marker. The second one is also very important. A comprehensive sleep clinic also have PACS, has dentists or orthodontists who are specializing in sleep medicine. And our general consensus is if we think a patient is better off going into that mode of treatment before considering sleep, and this is the non-sleepy group, we generally refer to our orthodontal team, and they actually do not use radiological parameters. They use fairly a structural functional assessment. If they are going into maxillomandibular surgery, then they go into MRIs and radiological interventions, but that is the surgical group. But the actual OMF group, the dental group, and you need to encourage this dentistry in your industry. No sleep service should function without an orthodontal sleep service. You need an orthodontal sleep service because increasingly there is evidence to support MAD devices or mandibular advancement devices, even improving cardiovascular comorbidity. And the dentist would love to hear this, that a device such as simple as a MAD device can improve cardiovascular comorbidity. So I think it will be music to their ears. So get them involved in your service. I hope that answered your question.
Thank you. Thank you, Dr. Sharmila. And I think the take-home message today may be that in practice, now onwards, the AHI, we will move beyond the AHI, yes, and we'll consider all those risk factors and the symptoms scoring also while we are formulating the treatment, along with the whatever phenotype-guided approach. We'll take that into considerations too. Yes. Thank you very much.
Thank you.
Thank you, Sharmila.
Thank you, Professor Sharmila Vitana, for comprehensive talk on OSA. Now, the next talk will be on changing landscape of COPD in 2026. Will triple move with any single exacerbation in last year? So to present this talk, we have Professor Richard Russell with us. So Professor Richard Russell, he's a consultant chest physician, professor of respiratory medicine, King's College London, and he's head of the department at Peter George Department of Immunobiology. So to moderate this session, we have Dr. Rajesh Chawla with us. So Dr. Rajesh Chawla, he's a senior consultant at Department of Respiratory Medicine, Critical Care and Sleep Medicine at Indraprastha Apollo Hospital, New Delhi. And the expert panelist for this session is Dr. Ajay Kumar Verma, Dr. Pradyut Wagre, Dr. Pooja Aneja, Dr. Vaibhav Chachra, and Dr. Sonia Goel. So all the panelists will join on this side. And the chairperson for this session are Dr. S. Selva Kumaran, Dr. B.K. Chaudhary, Dr. Lalit Mishra, and Dr. Sonisha Gupta. So I hand over to proceedings to Dr. Rajesh Chawla, sir, please.
Morning, and thank you, Deepak, for invitation. So we are going to discuss a very, very important topic, which is practically a bread and butter of our routine practice. And one exacerbation matters, and that is the goal which we are going to discuss 2026 has proposed. And does it automatically means you escalate to triple therapy? So that's what we are going to listen from you. Changing landscape of COPD in 2026. Will triple move with any single exacerbation last year? So the time for this is 25 minutes. I would request you to finish in time so that we can have some question later. Thank you very much.
Thank you very much indeed. Good morning, everybody. Happy National Day today. I hope we have a wonderful day together celebrating this very important day in India's history. Thank you, Shamila, for a wonderful last talk and the clarity you brought to a difficult subject. She didn't get a chance to say how important sleep apnea is in COPD, which I would give a quick plug to. I'm going to unpack for you why exacerbations are important, the impact of exacerbations, and the role of triple therapy. How important this is, and how, and this is the important thing to think about, how I want you to change your mindset. We've heard various talks this morning about some treatments which work, some which don't work. Well, our treatments do work. Our treatments do change lives, but do we believe it? Do we really believe it? And I'm going to push you a little bit on this. This is me. You've heard a little bit about me already. And I'm going to unpack very briefly the problem of COPD. Is COPD a problem globally? Yes. At least 400 million people. Did you know probably nearly 300 million people with COPD live in China? Just think about that. China is now taking COPD seriously because they realize with an aging population, they are going to hit a massive wall of problems. COPD is now the fourth leading cause of death in the world, in every country, including the United Kingdom, including India, including China. It is estimated that over half our patients are undiagnosed. So they're out there suffering, having symptoms, having exacerbations, and that's the most important thing. And in the UK, in the winter, COPD exacerbations are the second most important cause of admission to hospital. That is where the cost is. And so COPD is important to patients, to us as doctors, and to our payers, our funders as well. But COPD patients don't just die of respiratory failure, some do, but they also die of cardiovascular disease. And this is maybe how we can change our mindset. So forgive me. I'm going to ask you to think a little bit more like a cardiologist. That may be uncomfortable, but I want you to do that a little bit for me. It is increasing globally. The prevalence is around 13%, and there is a particular problem in Asia. I think it's important to say. Asia has particularly unique features, which may include parasitic infection, bronchiectasis coexisting with it, biomass smoking, air pollution, but of course, still cigarette smoking as well, which is the biggest global cause of COPD. And I think it's important to understand that and push back and push down on cigarette companies at every single opportunity. So it's worth thinking about these things. Of course, COPD has various aspects to it, which include the bronchitis, the sputum production, the bronchitic element of it, as well as airways inflammation. Previously, we thought COPD was not an inflammatory condition. This is not the case. It is desperately inflammatory, with beginning understandings about T lymphocytes, how lymphocytes affect COPD airway function, the loss of small airways, the damage which occurs, the neutrophil infiltration, which then causes progressive damage in the lungs. COPD patients have symptoms, and this is a schematic to try and understand the integration of symptoms with events. If you have cough, if you have sputum, you do worse. And you have more exacerbations, you have more cardiovascular events, and this can lead to premature death. So I'm going to ask you a question. Do you believe that we can stop patients with COPD dying? Can we stop them dying prematurely? Because the answer actually is yes. Did you know 25% of people admitted to hospital in the UK with COPD exacerbations are under the age of 65, which in the UK is a working age. Pensions don't start till 68 now. And so we really need to understand the impact of this on our patients. Exacerbations are the hallmark of COPD, with an increase in breathlessness, sputum production. My patients tell me they just can't walk as far. The definition is poor. It doesn't include physiology. It doesn't include inflammation. It doesn't include an understanding of the underpinnings of the immunology and the cause even. But we know much of the causes are driven by viral infections, which then cause loss of lung function, which is never recovered. So each exacerbation chips away. One of my good friends, Bart Celli from Harvard, Bart says in an editorial, and he says this now very widely, that the COPD exacerbation, think about this, is the heart attack of the lung. If you're admitted to hospital in the UK, any hospital, with a myocardial infarction, heart attack, full thickness myocardial infarction, not just a bit of troponin, your mortality rate is around 4.5%. If you're admitted to a hospital with an exacerbation of COPD, which we consider to be trivial very often, your mortality rate is 14%. So these events are important. These events are significant, and we don't take them seriously. That's my point. Can you predict who's going to have an exacerbation? Well, yes. People who are more severe have more exacerbations. People who've had previous exacerbations have exacerbations. But look at this. This is some work done by John Hurst in the ECLIPSE study, basically showing that people who had no exacerbations, 25% in the next year had an exacerbation. Can I say, therefore, that any of my patients are not going to have an exacerbation? No, I can't. So who is at risk? Everybody is at risk of an exacerbation. Would a cardiologist be happy if 25% of their patients who had not previously had an event were going to have a myocardial infarction? The answer is no. Exacerbations also go unreported by patients, up to 80% in some studies. And these are from clinical trials. And so we need to understand that patients have these events which are often, I'm not going to say silent, but we don't ask the right questions. And it's really important when you see a COPD patient that you ask, have you had an exacerbation? Have you had a worsening? Did a cold or respiratory tract infection go to your chest? And were you therefore more breathless? Because if you have, you've had one of these attacks. So I'm making the case these attacks are important. These attacks are frequent. These attacks are uncommon, and they happen all of the time for our patients. This is a nice analysis study done from a Swedish cohort by a chap called Louis van Vletteren from Holland. And Louis took the gold classification, A, B, E, and then added to it one if you've had one moderate exacerbation. And the question I've been asked today is there a risk of one moderate exacerbation? Well, this is the future of having exacerbations if you've had one. If you've had no exacerbations, 17%. If you had one exacerbation, 43%. So one exacerbation strongly drives the next event. It's not a benign thing in any way at all. This is moderate exacerbations. And the same, if you're even more symptomatic, is up to 50%, with a doubling of risk which occurs driven by one exacerbation. So we need to be very aware. We need to be very critical and ask the right questions at all the time. So these events are common. These events have an impact. But look at the mortality associated. This is work done by Sami Suisa. Sami from Canada, from Montreal, I think one of the best respiratory epidemiologists in the world. And Sami took the UK data and looked at survival. My patients admitted to hospital with COPD, 50% are dead in under 4 years. 50%. So we must take this seriously. My national societies and my national medicines body, NICE, did not believe this data when it came to talking about new therapies for COPD. And I had to show them and explain to them, this is what is happening to my patients. And if you've had one moderate exacerbation, your risk of mortality is increased by 17%. Mortality. If you've had one moderate exacerbation, your risk of cardiac mortality is increased by 23%. Remember, exacerbations do not just cause respiratory problems, they cause cardiovascular problems. This has been shown very clearly in this real-world study, the EXACOS CV study, now done in I think 9 different countries throughout the world, demonstrating that if you've had a hospital admission, your risk of myocardial infarction, stroke, heart failure, arrhythmia, death is increased by a factor of 20 in the first week, and this effect is persistent up to 6 months. At least. And if you've had a moderate exacerbation, one exacerbation which, forgive me, in the UK we consider to be trivial, we treat at home, because that's the definition of moderate exacerbation, often by a GP on their own, or maybe supported by respiratory nurses, the impact on cardiovascular comorbidity is enormous, with over doubling of an effect of mortality, myocardial infarction, atrial fibrillation, heart failure, COPD exacerbation, and death. So this is really important. These events, even the ones we consider mild, are significant. Do we have treatments which work? And I'm going to pull some data, and this is about triple therapy. So some of our most latest data is from the ETHOS study and the Kronos study, just because they're some of the biggest that we've done, with similar data shown by other treatments, but showing that triple therapy reduces the rate of moderate and severe exacerbations by 24% versus versus LABA-LAMA, and 13% versus LABA-ICS. So our treatments really do work. This is a randomized controlled trial. This is, in many ways, less effect, I think, than we see in real life, because these patients are particularly included in the trial with particular inclusion criteria. But the number needed to treat to prevent one exacerbation is 3. This is not against placebo. This is against active comparator. Very powerful data. And this is from the Kronos study, and I'm going to unpack this because I think this is important. People don't talk about this. This is an important thing to change your mindset. The Kronos study was a lung function study. And so the people included in the Kronos study did not have a prior exacerbation. Exacerbations were a secondary endpoint. But if you therefore looked, and only 25% of patients in the Kronos study had ever had a previous exacerbation, if you then looked at exacerbation rates and compared those who had a previous exacerbation with those that hadn't, the treatments were still extremely effective, showing, number one, everybody is at risk of an exacerbation, and that our treatments are particularly powerful in preventing exacerbations in this, what we would consider, milder population, with a 58% reduction versus LABA-LAMA in prior exacerbators, and a 48% reduction in those that hadn't had exacerbation. Strong evidence for me, to answer your question, that actually we should be taking a preventative, proactive approach to our patients. And this further data looks at cardiopulmonary events with cardiac disease, showing again further reductions in those cardiac disease and a reduction in mortality as well, which is really important to pick up. Showing us data from ETHOS, but also we have data from our other studies of triple therapies, again showing similar effects on mortality as well. But what was killing our patients? And what was the difference? Well, the difference was cardiovascular disease. And those mortality reduction was because the patients were preventing exacerbations and therefore preventing the consequence of exacerbations, which is cardiovascular mortality. Why am I telling you this? I'm telling you this to make us maybe think more like a cardiologist, to maybe think we need to be preventing, we need to be proactive, and saying that if we don't, well, this is what happens. Are my patients at home more worried about their lungs or their heart? If you take this room and I said to you, can you rank your worries about your health from 20 different items, including cardiovascular disease, neurological disease, respiratory disease, skin disease, dementia, you will rank just like everyone does. Number 1, actually progressive neurological disease. Number 2, cardiovascular disease. Do you know where COPD comes or respiratory disease comes? It comes number 16 out of 20. So I'm using this data to make people actually a little bit worried, to make you think, you know, we need to be more proactive with our COPD treatment because we have consequence. And if we don't take the respiratory consequence seriously, perhaps we'll take the cardiovascular consequence seriously. So the next question is, when do we act? How should we act? When should we treat these exacerbations? Well, this is again obvious. Would a cardiologist say, oh, you've had a heart attack. I'm not going to treat you now, I'm going to wait. I'm going to wait until you have a second heart attack before I give you an aspirin. No, that's crazy. If you come to hospital in India, in the UK, anywhere in the world with a heart problem, you come out now with 5, 6, 7 treatments, all given straight away. But in this study performed in America, looking at delays in treatment, if you delay treatment, all you're doing is exposing your patients to future risk. By 6-month delay, an increase of 24% risk. A 1-year delay, 34% increase in risk. Because the treatments work. And that's something we must really grasp. So what's GOLD saying? Now be careful. GOLD is not a guideline. Please don't say that. GOLD is a strategy. I'll be very careful here. No one from GOLD is in the room. GOLD is a group of old, white, middle-class men sitting in a room with 2 women out of 22. Not acceptable. Really bad, okay? But they come up with some good ideas. And there's a strategy. It's really useful. But they don't always get it right. But they've changed the world of COPD in a good way. When I started COPD was defined, and some of you will remember this, as a disease that was caused by cigarette smoke. That was relentlessly progressive. That was unresponsive to treatment, that led to death. So is it a surprise that we're negative about COPD? No. GOLD changed that. GOLD has now said COPD is an inflammatory disease which is responsive to treatment, which is caused by noxious substances and genetic factors as well, that actually we can treat and get better outcomes. So GOLD is good in that way. Everyone always focuses on this. It's an important thing because GOLD has changed our mindset into risk. And if you want to reduce risk and impact, you need to optimize therapy. They've also picked up on the work, the sentinel work that was driven by Professor Baffadal, who we have in the room, who has worked tirelessly through her career to push the idea that eosinophils are important in COPD and demonstrate through evidence that this is significant. Every single study in COPD, when you use inhaled corticosteroids, shows that eosinophils as a phenotype are important to predict risk, to predict response. So they say, if you have low symptoms, not no symptoms, and no exacerbations, you can be treated with bronchodilators. In the UK, we only have 2 treatments, LABA-LAMA and triple. And so we treat everybody with LABA-LAMA to start with. And if you've had 1 exacerbation now, moderate or severe, you should now be considered for dual bronchodilators, or if you have a raised eosinophil count, triple therapy. Now remember, this is initial treatment. So if you have a subsequent exacerbation, you need to be on triple therapy, and I'll show you why that is in a second. The eosinophil count, in my local guidelines, we consider a primary preventative approach. If someone comes with COPD, we ask the first question, what's your eosinophil count? If your eosinophil count is greater than 300, you go straight on triple therapy. Just like somebody with a raised cholesterol, just like somebody with high blood pressure, just like somebody with a high glucose would go on treatment to reduce future risk. And we then say, if your eosinophil count's less than 100, you don't go on inhaled corticosteroids, you go on LABA/LAMA. And then we ask the second question, have you had an exacerbation? And if you had an exacerbation, you go on triple therapy. And if you haven't had an exacerbation, you may stay on dual, maybe until you've had one exacerbation of COPD. And this is important to therefore understand. GOLD has translated that we now use the blood eosinophil count and the risk of exacerbation to then give triple therapy. So in clarity, to answer the question, should everyone who's had a moderate exacerbation get triple therapy? No. But if your eosinophil count is greater than 100 and you've had a moderate exacerbation, yes, you should. If you haven't got the blood eosinophil count raised, look for other phenotypes. And we heard yesterday very much about the role of sputum, looking for neutrophils, looking for hemophilus, which may predict macrolide azithromycin response. Roflumilast is another therapy, and of course, we're now moving into a biological age with both dupilumab and mepolizumab now available in the United Kingdom for my patients with persistent exacerbations. So GOLD is helping us by giving us clear guidance about who should get inhaled steroids. People say, well, what about pneumonia? Yeah, sure, what about pneumonia? Well, there is a signal that we see of pneumonia in inhaled steroids, and I've written about this in the past. If your eosinophil count is greater than 100, your risk of pneumonia is low, but your risk of response to steroid is high. If your blood eosinophil count is less than 100, your risk of pneumonia is higher, and your response to inhaled corticosteroids is not there. So what I'm saying is we must use the steroids in the right people, in the right phenotype. And of course, if you're on LABA/ICS, what do? There's nothing wrong with LABA/ICS. It's just you're missing the benefits of the LABA/LAMA or the LAMA component. If you had no exacerbations and you're well, there's an argument to say continue. If you've had exacerbations, you certainly should be on triple therapy. I would argue that we don't always ask the right questions. Do I believe there's such a thing as a low symptom COPD patient? No. Have I ever cured a patient with COPD? No. So do I need to ask more questions about their exercise tolerance, what they want to achieve, and how they want to be active in their lives? And therefore, LAMA has a particular role to play in deflation, and exercise capacity. So GOLD has also picked up on this cardiovascular risk and is very much driving it and using it as almost a false flag to say, you know what? Increased cardiovascular risk following exacerbation is a strong argument for exacerbation prevention. In some ways, yeah, we should always be trying to prevent exacerbations, but we should be using this cardiovascular problem as a way of driving that discussion. Proactive, risk-driven, to reduce symptoms, to make our patients feel better, to improve exercise tolerance, to improve health status and quality of life, as well as to reduce risk. I'm sorry, we in secondary care, we in academia, we don't see risk. We see consequence. We see the things when they go wrong. But we need to be much more risk-driven, with understanding that risk leads to consequence, leads to exacerbations, then leads to mortality. And we have to therefore act to stop that. So do you believe we can reduce the mortality in COPD? That's the question. I think we can. We have to believe that. And how we define mortality? Well, hey, pick a number. But if people are dying under 65, 67, 68 of COPD, that is premature. Of course, many of my older patients with more progressive disease or more advanced disease will die of respiratory disease. But those others, we need to intervene to stop these events happening. But what we're doing at the moment is wrong. This is a figure drawn by Mark Dransfield from America, who said, you know what? What we do is crazy. Patients come with an exacerbation and we give them bronchodilator. Then we say, go away and wait. And they have another event, and then we add an extra treatment. And then we say, go away and wait. And they have a third event and come back. And eventually we will put them on maximum therapy. Does a cardiologist do that? Does a cardiologist say, you've had a heart attack, here's some aspirin. Come back and see me if it happens again. Oh, I'm sorry. You've had another heart attack. Maybe I'll add a beta blocker to your treatment. So now you've got 2. Oh no, you've had 3 heart attacks. Maybe I'll add an ACE inhibitor or spironolactone or other treatments. No, that makes no sense. So why do we accept that in COPD? And we mustn't. Exacerbations have consequence, and we understand the risk, and therefore we need to treat. Of course, in Asia, there are specific things to focus on, which is also helpful, particularly in India, the post-tuberculosis work. And we're doing some work with St. John's at the moment on this, and I want to take this very much further forwards to understand this particularly. But air pollution, biomass smoke, tuberculosis, bronchiectasis, smoking. I'm sorry to say that the trends in smoke are increasing. It's something which I hope will not happen in India, and particularly in our young people. 55% of men in China smoke. Only 7% of women smoke. Does that mean women are smarter? I hope so. But it also means that as you become financially independent, you might increase the risk of smoking. So we must stop people smoking. Really important. And you'd be very proud to say that the United Kingdom has moved forward to banning smoking in our children now. And going forward, we are banning smoking. And of course, there are other issues in China, specifically about access and vaccination, in India as well. So the key points to this talk. COPD is a major burden, especially in the Asia-Pacific region. We have an increased risk of exacerbation with increased cardiopulmonary events. We need to assess that and manage that. Do we do that by being part cardiologists? Maybe. But we need to take a cardiological approach to risk management. There is no doubt for me that an early initiation of triple therapy in the right people, driven by the eosinophil phenotype, reduces the risk of future exacerbations, causes better lung function, better exacerbations, better quality of life. If a cardiologist gives you a beta blocker, do you feel better? No, but you reduce your risk. Our drugs make you feel better as well as reducing risk. So to finish, and all you need to know is this. If you recognize someone with COPD, you recognize their risk. Look at the eosinophil and you can then risk stratify. You understand, therefore, the consequences if they have an exacerbation of COPD exacerbation, further events, further cardiovascular problems. And then we need to act. Because if we understand risk, we understand consequence, that leads to action. Thank you very much for listening.
Thank you. Spot on, and you've answered most of my questions actually. So, the COPD management in 2026 is moving simply from counting exacerbation to recognize disease activity early. That's what he highlighted in his. So we have panelists, so we'll ask Dr. Pooja Aneja, and you can intervene anytime you want. You are our expert. So a patient is already on LABA and LAMA, has been stable, and then one outpatient exacerbation treated with steroid plus antibiotic. Would you add ICS immediately or wait for another event?
So if a person who comes with one exacerbation, I should first know what has caused that exacerbation. So is it whether he was adherence with his therapy was there, whether the technique was good, was there some associated comorbidities which was not taken into account, and were there any asthma co-features or any overlap? Then we'll of course take eosinophil count into this account, and if after that, if all my above questions has been answered and there's a no for that, of course I can add a ICS in that.
Yes. So it's a very important point to just raise, and data that we know from globally. What happened during the COVID pandemic? During the COVID pandemic, 80% of exacerbations stopped. Why? Partly they were happening at home and patients didn't want to come to hospital, but mainly because the respiratory transmissible viruses stopped. And so the avoidance of triggers, making sure people have vaccinations. I still encourage my patients to wear face masks and avoid confined spaces. And that also leads to benefits for patients. But I would very much say, quite correct, looking at what's going on, optimizing everything we can, but also looking very much early at the eosinophil count, because the higher numbers are highly predictive of future risk, but also strongly predictive of benefit of inhaled steroids.
Thank you. You know, Dr. Pradyut, you see all moderate exacerbation equivalent, like a patient who's an outpatient steroid course carry the same weight as an emergency patient who comes with an acute exacerbation?
Good morning. Thank you so much, Professor, for the excellent presentation. I think in India, in our day-to-day practice, it is very difficult actually to document an exacerbation, because most of the patients, they take treatment either on their own or they go to the GP and take some steroids. So unless they land up in the hospital or emergency department, only then it is technically labeled as exacerbation. So in reality, we really don't know when they come to us. And in fact, I was also having that question in my mind, because practically what we see in day-to-day life is patients present to us with group B or group P, highly symptomatic, and whether they have a documented exacerbation or not, very difficult to extract from the history. So is it in this group, why not we start the triple therapy immediately? And again, most of our patients have associated comorbidities like diabetes, hypertension, and other things, and they are not completely possible to be evaluated for cardiovascular disease. So why not treat early and treat with triple therapy in this condition?
Sure, I would absolutely agree. And I think there is an argument, if we're going to take a purely, very preventive approach, of absolutely risk-benefit of treating everyone very early indeed. I think the very important point made there was about how to assess that exacerbation. Had people have them in their home? And actually, we need to be structured with our questions. We need to ask the right questions about impact of, again, as I mentioned, viral infections going to the chest, increasing breathlessness, cough, and sputum. And I would also we have to remember that exacerbations are defined by that, but also by where we treat the patient. And where we treat the patient is based upon, do you live near the hospital? Or can you get access to the hospital? Or have you got health insurance to enable you to use the hospital, perhaps more than the severity of your condition? So I think we need to be very proactive with our questions. And I think there's important research to be done in those definitions of those early events to enable us to systematically ask our patients. It is also very important, that picks up on the missed events, but also very important when someone's had an event. We need to check, particularly because in the UK, we give people rescue packs. So they have at home steroids and antibiotics. And my patients tell me, I just wasn't feeling very well today, so I started my steroids. That's wrong, terrible, stop. So we have to then use every opportunity to interrogate in a systematic way what happened. And we've still got a lot of way to understand that, I think, but then we can help.
So, Dr. Sonia, see, I'll ask you a question. Suppose a patient has eosinophil count of less than 100 and has pneumonia risk. Would you just stay with LABA-LAMA?
Dr. Sonia, is there?
If a patient eosinophil count, COPD, eosinophil count is less than 100 and has pneumonia risk, he has a history of recurrent pneumonia, you may say.
Definitely,
and
sir.
would you just stay with LABA-LAMA or you go to triple therapy?
So we will go to a triple therapy in this case. Yeah. Because there is a risk of pneumonia, so we will definitely go for the triple therapy.
I wouldn't agree with that, only because all of the data on inhaled steroids shows when you treat COPD with inhaled steroids, if your eosinophil count is less than 100, there is no benefit on exacerbations, because there's no eosinophilic drive there to treat those diseases. And it's very important also to understand, I think, that dual broncholators are effective, but also there are other causes of exacerbations or other drivers. So, for example, I mentioned Haemophilus, a neutrophilic disease. And if you look in the sputum and you find Haemophilus, that's a highly predictive factor for benefits from macrolide therapy. So I would consider, in my patients with low eosinophils who have on dual bronchodilators, I would certainly consider macrolide therapy to be a very effective therapy in those patients going forward. So it's one of those things we have to balance up and obviously keep an eye on the eosinophil count and see where it goes over time. Remember, when we test the eosinophils, and this may be a problem that we see, the patients must not be taking oral steroids, because oral steroids will suppress the eosinophils so quickly that you'll get a false negative result, which is important. A great question to ask, perhaps simply, is do patients benefit from oral steroids? Do you feel better?
What would be your next alternative in a chronic bronchitis, frequent excessive Tom-Level-Last, or macrolide, or ensifentrine, or another strategy?
Sure. So ensifentrine is not quite available in the UK yet. We're doing some clinical trials at the moment on ensifentrine, but I think it has some potential important benefits as a bronchodilator as well as maybe an anti-inflammatory agent. So we shall see. There's some good data already there from the enhanced studies. I would reach, for someone who's having exacerbations with a low eosinophil count, I would do a trial of macrolide therapy, azithromycin.
Let me put another question. A patient has FEV1 of 35%, one exacerbation. Another patient, 75% FEV1. Will you treat them same?
Would I?
Or differently?
I would treat them the same. I would absolutely treat them the same. Exacerbations have the same consequence for those patients, particularly of cardiovascular risk. Of course, the patient with the worst lung function is more susceptible to respiratory failure, more susceptible to future events because they've got less resilience in their lungs, less physiological reserve in their lungs. But absolutely, I would optimally bronchodilate them, both, and I would look at their eosinophil count to choose triple therapy.
So we are moving toward hit early rather than a step-up therapy. Yeah. So, you are moving towards COPD philosophy of achieving zero exacerbation rather than waiting for the events. Do you agree with that?
I think that's not realistic. Patients have many, as has been said, many causes of exacerbations. Viral causes, eosinophilic-driven inflammation causes, pollution causes, temperature changes. Can we stop those events fully? No, we can't. But what I'm saying is, rather than I'm trying to push down to zero, I would want us to have a zero tolerance of exacerbations. We should always, like the cardiologist, try and make the second event a never event. So when someone's had one hospital admission, one exacerbation, we need to critically appraise and optimize their therapy to reduce as much as possible the chance of the second event.
So I have a last question. We have just 1 minute and 28 seconds. So you suppose a patient has been stable. It's 1 year, 1.5 years. How do you step down this patient?
So this is a great question. We get asked this question about many treatments in many diseases, particularly when it comes to, for example, biologics. The question you have to ask is not should you step down, but has your treatment changed the underlying biology? Have you changed the underlying pathophysiological drivers which you're treating? And if you haven't, you cannot step down because it is illogical and will not work. I believe, for example, macrolide therapy, and you're looking to change the microbiome, over time does change the microbiome. And I've had patients who've gone from 3 or 4 exacerbations to none. I treat for a 3 or 4 year period, I stop the treatment, and they don't have another attack for maybe 4 or 5 years. Fantastic. I've changed things. Does triple therapy change the biology? No. It treats the biology. Do biologic treatments change the biology? No, not as far as we know yet. They treat the biology. And so we must not get confused with that. Would a cardiologist, in someone who's had a heart attack, who's got a raised cholesterol, stop the statin? The answer is no. So why are we even thinking about it?
So he remains on triple therapy?
Absolutely.
So, even one exacerbation does not mean that reflexly you go on to triple therapy. It means that you need to reassess patients. You look at the eosinophils, look at the phenotype. Is it really COPD exacerbation? Remember, patient of COPD, they have risk factor for cardio. It could be a failure, it could be pulmonary embolism, it could be something else. If you really feel it is exacerbation, then I think you should move to triple therapy. And with that, thank you very much, Russell, for a wonderful, all the chairperson and
I just-
panelists for a wonderful discussion.
Just wanted to
Thank you
have
very
one
much.
last quick question, if the time allows us, Professor.
No, the Dr. Deepak has
Excellent
to answer.
lecture, sir.
Dr. Deepak, will you allow?
Sir, just one quick question. So, one exacerbation, FE, the eosinophil counts around 100. How do you take a dual LAMA-LABA plus a biological versus inhaled corticosteroid introduction?
Sure. We can't answer that question because at the moment biologic treatments are being given in people who are on triple therapy as a baseline and also with high eosinophils greater than 100, usually around 150 to 150 plus. So we do not know. There are treatments coming, and we hope we get some data from tozoracimab soon that may show that we do see effects on people on dual bronchodilators or maybe triple therapies with lower eosinophil counts than we have at the moment. But dupilumab and mepolizumab are given to those on triple therapy with higher eosinophil counts. So we can't answer, but it's an exciting question.
Thank you. Thank you, sir.
I think it deserves much louder applause. What a session. And I think I have taken home the message very, very clear and loud out here. One exacerbation means cardiovascular death. And that's a very important thing because these patients will be shunting across between cardiology and pulmonology, and always pulmonologists get the blame that this is dying because of that. They are dying cardiac death. They are not dying respiratory death. I think that is what, if it is in our mind, we will understand that. We are always battling around the pneumonias. Anyways, thank you very much, Professor Russell. Thank you very much. It was an excellent presentation. And we have many more exciting sessions to come. And one of them is now going to start, the first one, which is fireside chat. So this is a new format where we have two speakers and they are going to focus on small airway disease and its importance. One is going to talk about airway diseases and another one is going to talk about interstitial lung diseases. And there is going to be a hot seat as well as we are going to have a moderator to break the fight. For this, first of all, I would like to invite on the hot seat, Dr. Khurshid Ahmad Dar. When he is there, I can very well assure you that this will be the hottest seat. So which is the hot seat, Deepak? I think you... Moderator of this panel will be, or this session will be Dr. Basanta Hazarika. And that's the seat for you, sir. There are people who are going to look at and support their speaker. Team A, which is going to support Professor Morris Pradella, who is going to be on small airway disease and interstitial lung disease. And the team A has Karan Singla, Thamna Siri Devi, and Govind Desai on that side. We have two chairpersons, Dr. Ravindranath and Dr. Sejal Day, also on that side. Team B is Dr. Kalpesh Panchal, Dr. Mandeep Kaur Sodhi, and Dr. Prince James on this side. And the chairs, Dr. Sanjay Sareen and Adnan Hamza on this side. I hope you remember who's going which sides. But anyways, you can break the rules, but please don't do that. Now I invite our expert, Professor Morris Pradella, who is going to be on small airway disease, interstitial lung disease, because he is the one who is going to pick it up on the CT scans. And he is Associate Director of Interstitial Lung Diseases, Thoracic Imaging, and everything at the University of Basel. So one of the podium goes to him, and of course the second one is Professor Mona Bafidal. We have already been introduced to her yesterday. And Yeah. So I think the entire team has come. We are ready? Yeah. So you can both have one podium. You can have your own discussion and points, and it can come on later. There was a question here. Small airway disease is the hidden driver in lung diseases, which was distributed to all of you in this hall. And this was the response. So 85% of the people say that they are driver of diseases and very, very important. I'm sure oscillometry has done good in India to make this point so clear. But yes, 15% are not sure that whether the evidence is good enough to tell us that it is an important thing when it comes to two main diseases in the lung, that is airway and interstitial lung disease. So we can start this, and of course the first one will be Professor Predella from that side.
Hello everyone. I'm Maurice Predella from Basel, Switzerland. It's a great honor to be here to speak in front of all of you. And actually you will see me quite a bit on stage today. This fireside chat is also a new format for me. So I'm a cardiothoracic radiologist, as I said, and maybe you can start my few slides I presented for this, because I think we all, when we talk about small airway disease, I think we have to talk about how we measure it. And there is obviously CT, which plays a big role there. Hello, hello. Yeah, thank you. The PowerPoint is here, so I had to move. And just very quick recap. So we are talking about like these distal airways no one can really see on CT, and typically what are we looking for basically in the imaging? We are looking for indirect signs. We're looking for signs of air trapping. And this is not a new concept. It's kind of established in these like asthma and COPD, but it's not established in ILDs. However, I was very surprised to see the voting results, which I find very interesting, that so many people of you believe that it's such an important topic. And what do we do in imaging? And I'll have an example on the next slide. Like we do the in and expiratory CT, but basically what you typically ask me is, okay, we'll look for air trapping, look for these relatively darker, hypodenser areas, and we've done that. We've done that for quite a while. We've done that at my hospital in a COPD cohort, and we're also like a hematologic center. Patients who get stem cell transplantation, they get a lot of CTs. And while we do not do lung transplants at my hospital, we also see some patients there. But what I basically am doing on my colleagues, we are looking qualitatively at the images. We're looking for these mosaic changes, the air trapping, which is the hypodense areas, maybe 3 density pattern. But how can we be really objective doing that? And it leads to the question, how can we measure small airway disease? And it's been like more than 10 years ago, a group from the US, they have established a method on in and expiratory CT. It's an example from one of our publications here. And basically, you have on A, B, you have the inspiratory, or basically the entire top row is the inspiratory CT. And what the group from Michigan did was they did a segmentation of the lung on the inspiratory scan, and they quantified the emphysema first, right? And I think this is a well-established method. You have like a cutoff of 950 a cutoff lower than minus 950 Hounsfield units, and then you can, automatically quantify the voxels. This example here, you get a volume 112 milliliters of voxels lower than minus 950, And relative to the entire volume of the lung, you can say there's 2% emphysema. I think we all know that. I think that's well established. The novel part, what the group did was they tried to establish, or they established a cutoff on the expiratory CT, which you see down at the bottom. And in blue you see the lung segmentation, and in red you see what was identified as air trapping. And so they had they did a study where they compared it to histology, and they came up with a cutoff of minus 856 Hounsfield units for air trapping on an expiratory CT. But this was not an ILD cohort, but we use it at my hospital. So basically when we get in an expiratory CT scans, like in this case, we don't just look at the images. And I'm not sure how well you can see it on the screen, but I think if you look at the coronal expiratory scan, which is G, you can actually see right above the diaphragm and the lower lobes, you can see these very, very hypodense areas. And I think, yeah, you can qualitatively tell, okay, there's air trapping there, but actually this quantification method allows me to be more confident about it, right? However, this method cannot one-on-one be transferred to interstitial lung disease because it has not been validated there. It's maybe there, the cutoff, the minus 856 is wrong. This is something, I guess we just have to do more research to find out about it, right? But how else can we measure it? How do you measure like small airway disease in your practice? Like on just conventional pulmonary function tests? How well does it work? I mean, you know probably better than I do. Do you use oscillometry to measure it? Is this like the way to go? Because I think we have to kind of have a definition of how we can quantify it. I think relying on the image and just saying it's air trapping is a little difficult. And then the other question is, and what about like, is there maybe the idea to do relative measurements to, for example, have like a baseline scan and then follow up the patient over time, but with like in an expiratory CT, you would have to consider the radiation dose and things like that. So, I think it all comes down then in the end, like if we even get to the point where we agree on something like what we can measure, is it actually then a real independent and then ultimately treatable disease, or is what we see just a manifestation of the fibrosis? And with these, let's say, sparks, I would like to, I'm not sure if Mona, if you will be presenting next, or we will start the discussion. I think Dr. Talwa said you can maybe come to the podium. The microphone, please. On the other side.
Perfect. Thank you very much. So if we switch over to my slides, please. Thank you. So we've had a brief overview about small airways disease in ILD. I'll focus about small airways disease in COPD mainly and airways disease. These are my disclosures. So we've heard a little bit about why they really are important, and perhaps in clinical practice we don't think about them as much, and certainly in the public space no one is talking about small airways disease, let alone some of our other chronic lung diseases. For obstructive lung disease, particularly COPD, we'll have seen that the small airway disease is really much more, occurs much earlier than we are able to make diagnoses. And perhaps it's starting to be more framed as a potential treatable trait, and we've heard about that today within GOLD, and we have to think about prioritizing the detection of small airways disease in airways disease too. The one question we still haven't really answered is, could we be adding newer therapies like biologics therapies, which we heard about yesterday, to become an emergent target for the small airway? We've seen from the GOLD strategy documents that there's a highlight here that small airways disease is indeed early physiological abnormalities or structural abnormalities. And these can definitely be preceding measurable FEV1 decline. There's some thoughts that actually you have to lose a significant proportion of your small airways before you will be diagnosed with obstructive spirometry. And in COPD, what is driving the small airways disease? Well, there's a lot of inflammation that happens in COPD. It's not going to be targeting only one airway, it's going to be targeting the majority of the airways. And here really is a highlight of how the different steps of small airways can occur from the start of inflammation all the way through to a structural, remodeled, and unchangeable airway. So we have epithelial injuries, we have innate and adaptive inflammation, and this leads to mucus plugging, wall thickening and fibrosis, lumen narrowing, and of course the end product being obstruction on spirometry. What is important to note, of course, for COPD is that the small airway damage can very much precede the emphysema that we see by many, many years. What do we have in our toolkits? We have impulse oscillometry, so forced oscillation techniques. Many of us may be using this in clinical practice. I would say in the UK, in our clinical practice, this is not available in our routine clinical labs or clinical physiology labs. We don't use this in clinical practice, and perhaps it'd be interesting to hear about what the experience is from India here and the clinicians on the stage with forced oscillometry techniques. We can see how it detects resistance, reactance, and of course how much dysfunction there is within that airway. There is some evidence about forced oscillation techniques for diagnostic accuracy, for its association with early biomarkers, particularly inflammatory profiles. And there's also some evidence that it's a reproducible test. As we know, for our patients with COPD who have a huge amount of early airway collapse, using this test in tidal breath may be a different way to be able to actually estimate the degree of dysfunction that occurs in patients. There's also some data that have shown that small airways disease may be a predictor of exacerbations. We've heard a little bit about imaging, and of course we can see air trapping, we can map parametric response. I'm not a radiology expert or an imaging expert, but these are tools that many of our patients with COPD, for example, may have far earlier than they have spirometry or full physiological assessments. So this again may be an opportunity to add in forced oscillation to our diagnostic toolkit. And finally, I mentioned the small airway as a disease, as a treatable trait. Perhaps it can tell us a little bit about the phenotype, where we know that there may be a lot of mucus plugging and therefore the chronic bronchitic type clinical phenotype within the small airway. Perhaps it can also tell us about prognostic indicators, where we find that there might be accelerated lung function decline or exacerbation frequency. And unlike when the damage is fixed, and I know we've got some talks tomorrow on emphysema and whether that is a fixed or a reversible problem, we know that in some small airways they don't become fixed immediately, so there's an element of time, potential time, where we can impact on inflammation and prevent that irreversible damage. And from a biologics potential, there's not much going on in COPD from looking at the small airway, but in asthma, we have learned that there is some data sets and some clinical trials that have been looking to see how small airway changes may be occurring with targeted pathways along the Vestige program, which looked at dupilumab, along some real-world data sets, looking at multiple biologics, but mainly in dupilumab, and some dupilumab studies that are currently in open-label follow-up to see that we may be able to see if there's a signal in COPD also. Thank you very much.
Yes. Small airway disease is a very neglected part of respiratory medicine. Most of our standard textbook even not include the chapters of small airway diseases. Various type of lung diseases involve small airway disease, and it has some prognostic and therapeutic importance also. I have some questions to Dr. Machines. What is the impact of small airway diseases in ILD? And what is the prognosis if it is small airway involved in ILD?
Like, is the microphone? Oh, yeah, thank you.
You can come to the stage. You can come to the podium. Oh, yeah.
Yeah, I think, I'm not sure if I really know a good answer to your question. I think, for example, it was mentioned about the lung function tests and how you can measure on lung function tests small airway disease. I'm not sure if you can just take it, what we know from like COPD, for example, take it to ILDs and say that is small airway disease. Because it's not, as far as I understand, we cannot really differentiate if it's caused by the fibrosis which is going on, right? Or if it's like a second, or it's a second small airway disease present. So for me, this question is really hard. I look at my team. I'm not sure what.
Anybody panelists can give an answer?
Yeah. So good morning, everyone. So one thing we need to know is the small airway disease in ILD is a true fact. It's not that it's just been seen on the FEF 2575 or the iOS or on an HRCT. So in an explanted lungs in IPF, there is a definite proof that small airway disease occurs. The point is that we need to know that the bronchiolar inflammation, what actually happens in a small airway disease like in chronic bronchitis, asthma, is very different from what small airway disease occurs in ILD. In ILD, it's basically it's the fibrotic architectural distortion of the terminal bronchioles which are happening with the alveoli. And that's why the disease may be a small airway, but the pathology, what is causing it, is definitely different.
But in some ILD, like RB ILD, it's involved the small airway. It starts with bronchiolitis, then ILD. And BOOP, cryptogenic organizing pneumonia or bronchiolitis obstructive pneumonia, it's also involved alveoli as well as in the respiratory bronchioles. But as such in IPF, there is no direct involvement of small airway, but when there is distortions in the alveoli, there is traction bronchiectasis or honeycombing is there, due to involvement of the dilatations of the bronchus and bronchioles.
Coming to the investigative modalities for the involvement of the small airway disease in the various ILDs, basically there can be a bundle of investigations which will be including the spirometry, pulmonary function test, spirometry, DLCO, where in the ILDs the DLCO will be reduced. Other investigations will be like body plethysmography technique, and in the small airway involvement conditions, the RV by TLC ratios and all will be increased, and impulse oscillometric techniques also can be done. In this, the R5 minus R20 has to be evaluated, and along with the impedance and even the bronchodilator reversibility can also be assessed in this scenario. And the other scenarios like nitrogen washout techniques, multiple breath washout techniques by LCI indices and helium oxygen flow volume curves can be helpful, and another best modality is the HRCT. So the important key point is the involvement of the small airways in the HRCT is like showing the air trapping, central lobular nodules and mosaic attenuation. These are very much helpful for us. And if you are going to consider regarding the advanced modalities and all, even in future the HR micro-CT techniques, endobronchial OCT techniques, and it's like xenon MRI techniques, all these can also be very much helpful in this. So that's it.
I have a question to Professor Mona. Since we are clinicians here, So I just want to know that if we are treating a patient of interstitial lung disease, IPF, or maybe a connective tissue disease related, so at what point in our clinical practice we should suspect that we should evaluate this patient for small airway dysfunction? Clinically, at what point during the treatment we should suspect that we should evaluate this patient for SAD in an ILD patient?
Yeah, so I'm not an expert in ILD, but what we do know is many lung diseases are driven by a lot of inflammation as a start. You know, we breathe lots, we have lots of epithelial injury going on very early. And so I would say perhaps across interstitial lung diseases and airway diseases, actually the first moment that you're getting injury and inflammation is likely when you're going to get small airway dysfunction. So this is always happening anyway, right? It's just that we're not using the tests or appreciating what they mean, perhaps, to understand how long is it going to be before they get a disease? What can I do to intervene? Because we just don't have the evidence, really.
I have a question to Mona, Professor. Is small airway involvement in asthma is a different phenotypes, or it is a disease process all asthmatic question?
Yeah, that's a really good question, actually. What we know is the end result of small airways disease, so defined, is often airflow obstruction. That's the end product from a spirometric evaluation. Fortunately, many of our asthma patients do not get fixed airflow obstruction. So it is likely in those with very severe asthma, they will have that proportion of small airway disease, but many have dysfunction before disease. Whereas in COPD, it's likely that it's going to be much more disease starting off with dysfunction leading to small airway disease. I think what I'm learning from your discussions and hearing as well earlier is actually this is an area that we should probably be incorporating to our clinical practice to be able to learn more about what it means. I'm interested to hear how many of you measure or use impulse oscillometry or diagnostics from imaging to define small airways disease in clinical practice.
Actually, small airway involvement in bronchial asthma is very late stages. It should be a different phenotype of bronchial asthma.
Yeah. Anyone from the audience using the iOS or
maybe if you put your hand
tech?
up, if you're using forced oscillometry as a routine test in clinical practice. You see, this is very different. So if I was presenting at in the British meeting, I would say no one's hand is going up. So the fact that you are doing it is it would be really important for you to share your knowledge and to the rest of the societies, because we don't know, we don't have this knowledge. And actually it is a very easy test to do. I mean, we use it in research setting. It's very easy. Maybe we haven't understood how to interpret it as well as we could do, but I think longitudinally it's likely to be very much more helpful.
And can I quickly jump in and ask the audience, do you do, like, for example, in asthma, do you do CT, inspiratory CT? Can you maybe raise up hands if you do? Not so many. So my follow-up question would have been in an expiratory CT, or is anyone doing on a regular basis in any patients in an expiratory CT at the moment?
So I just wanted to make a point on this. I mean, HRCT, when we are talking about small airway disease in ILD, there are so many things that we can pick up, like mosaic attenuation, centrilobular ground glass nodules, tree in bud opacities. Tree in bud basically points towards infectious bronchiolitis. When we are talking about CTD ILDs, there we have follicular bronchiolitis and RA, which is most often seen. In fact, even in Sjogren's disease, we see small airway disease, the centrilobular nodules and the cyst, which is very, very characteristic. HP, I mean, pathological as well as the radiological findings match. And the new classification also mentions that it is bronchiolocentric interstitial pneumonia, which is the inflammation and the fibrosis is centered around the small airways. So when we see the pathology, we see the same thing and same we see in HP and CTD. So I just wanted to make a point that small airway involvement is most often seen in HP, CTD, ILDs. Asthma, COPD, we all by now are aware. And yeah, I think for now, no, there's no question, there's just a point.
I have a query to Professor Morris. What radiological features, when you do a CT in a case of ILD, what are the radiological features that you will suggest to us as a clinicians, or you will write down in the report that this ILD patient has more of a small airway involvement rather than a simple fibrotic involvement?
Let me maybe answer the question more in general, or let me first talk about general CT and then I go into ILD. Because what I basically do first is I look, is there anything, is there something obviously wrong? You know, is there some extensive ground glass? Like just was mentioned, a lot of fibrosis going on. Because if that's going on, the whole assessment of air trapping is going to be very different and a lot more difficult than if you have a rather unspectacular lung on the inspiratory scan, and then you have an expiratory scan, and then the air trapping comes out, right? And yeah, so the reason why we did all this, we invented our workflow in the way to get an automatic assessment was basically because I didn't want to be my colleagues or me being the ones with like thumbs up, thumbs down. Okay, I call this qualitatively air trapping in this patient, and in the other patient I'm not calling it, you know, because I think this gets very vague. So in ILD, I do not have really a lot of experience with the expiratory scan. I would be very cautious to apply the cutoff I've just mentioned, just in general to ILD. And one thing I haven't mentioned, with the expiratory scan or the whole CT-based assessment, we read in the guidelines about so much, it really depends on the form of the patient. This means first, is the patient at the moment, is the patient symptomatic? If the patient's symptomatic, the whole maneuvers will be different, right? And then just in general, to understand, especially the expiratory scan, this is tricky. In my hospital, we do it the way that our technicians, they train with the patient before the scan. They tell the patient, do the maneuver for inspiration, also for expiration, right? Because if you don't have a proper expiratory scan, you can basically not assess it at all, right? You cannot assess it quantitatively, but also not really qualitatively. And when we spot it, we might repeat it, but sometimes the patient might be too sick to really do it, right? And they still, even if it's just for a few seconds, they still have to hold their breath. So there are a lot of difficult things when you look in detail at the imaging.
One question from the audience.
My comment, sir, I want to make a small comment, if you allow. This is out of my experience of published and unpublished and rejected efforts. The published effort is that if you take FEF 2575, in your consideration, the frequency of small airway involvement goes up in ILD from say 26% from FEV1 by FVC ratio to 43 to 46%. That's one. Second, if you look seriously at FEF 2575, and if you see the percentage predicted, if it's more than 100%, to my experience, the risk of having ILD is much higher. And one abstract has been published on it. Second, third, if you come to iOS, in resistance arena, if you further subdivide the resistance into say R10 to 15, R5 to 10, like that, R5 to 10 is much, much sensitive for ILD to pick up small airway disease. So, and what Dr. Mona said, the X5 is also very important. So I would say the small airway is a heterogeneous structure. It's like a whole airway.
I have a request to the audience. Please ask questions if you have. Please don't give comments. Otherwise, we won't be able to finish in time.
I have a question.
Only
question. This is for Dr. Mona. So you were talking about damage yesterday, and that same applies to small airways. And in the morning, we had a session where, severity and activity are different. Now, we've been talking about assessing severity of small airways. We're not even talking about active inflammation in the small airways. And there is no parameter which defines active inflammation going on in the small airways. So do you think picking up just severity or damage to the small airway is equivalent to treating the small airway when we don't have evidence of inflammation going on?
Yeah, no, that's a very good question, actually. I would say perhaps we need to change our mindsets, and it shouldn't be about severity of small airways disease. It should be about activity of small airways dysfunction leading to disease. I don't think we've been able to really define how much what the severity of small airways disease is, apart from the fact that we know that when you're obstructed, it means there's a lot, right? But that's all we know. We don't know what mild means. We don't know what moderate means. But we could take the word out, severity, and apply for the small airways. We apply activity, because the one thing is that if we do intervene earlier, they may be able to change things.
So what happens is, in a childhood respiratory illness, you have scarring in the lung, and they end up having bronchiolitis. I see the patient as an adult. I see extensive small airway disease, but it is not active.
Yes.
So should I be even addressing that?
Yes, there may be, though, if we tested it across after they'd had their bronchiolitis as a child and we knew that there was activity, we would have intervened before they got to see you as an adult.
One more question from the audience, then we will.
What is your take about the ACE values in FOT regarding small airway disease in COPD, asthma and ILD? Is there a difference?
Yeah.
ACE values.
Yeah, I mean, I think, listen, this has been really enlightening to me, because I didn't really, it's an understanding how much small airways disease there is across all lung diseases. And actually, maybe it's not about if there's a difference. Could we use it to diagnose diseases earlier? May be relevant, because then it's important to know if this is IPF, this is asthma, if this is COPD. But having an understanding of how much dysfunction and activity there is may be a different, almost trait. It's like another form of endotyping. So yesterday I talked about biological endotyping, but this is more about physiological endotyping. And that's something that we've probably not been talking about in the community, across the respiratory community or the scientific community. And maybe this is where we need to start thinking about from a small airway function point of view.
Dr. Kaplish.
I want to comment in one aspect of oscillometry. So is there any advantage of adding oscillometry in our diagnostic tool for any COPD, asthma or ILD? Is there any advantage of adding oscillometry? Is there any changes in our treatment protocols by adding oscillometry in ILD versus oscillometry in obstructive airway disease? Because we cannot discriminate disease with the oscillometry, whether this is obstructive lung disease or whether it is a restrictive lung disease.
No,
yes.
I mean, I agree. So I think, listen, not all of our tools are perfect, okay? But the more tools we have, the better we become. And as we know, within the lung, it's really hard to take samples. Like if we were dermatologists, we'd just take a sample. Even cardiologists can get to the heart and understand physiology much better. We can't get into the lung as well as we could do. But this is a test that's available. It's easy to do, easy to perform. And actually, if we did it longitudinally, we may be able to evaluate epidemiologically what happens over time with one person who develops IPF in 20 years versus one person who develops asthma as a child to asthma as an adult, and one person who doesn't smoke who then develops COPD. I think this might be where we go. We heard Richard present, 30-year data about the epidemiology of lung function and cardiovascular risk. Do we have that for small airways disease? No.
So the reason for that, I think, when we talk about the small airway, we are talking about the less than 2 millimeter diameter of the small airways. So that is very difficult to pick, even on the CT scan also, if it is not done properly. So how can we pick that small airway on just oscillometry? Because for that we need to do with the frequency of 1 Hertz and 2 Hertz. And right now we are doing in the frequency of 5 Hertz to 20 Hertz. So less than 5 Hertz of frequency is required to actually assess the small airway if we want to assess the small airway with the help of
Then we need
oscillometry.
to talk to our colleagues who make the machines and
Yes.
say, make the
So
hertz
that
lower.
is the limitation. That is the limitation of oscillometry. Even R5 to R20 includes large airway. It is not exclusively includes small airway.
Yeah.
Even it is includes large airways also.
Yeah.
So R5 to R20 is not exclusively truly gold standard indicator for small airway disease. It is also includes large airway.
Okay, thank you, Professor
Thank you
Mori,
very
and
much.
thank you, Professor Mona. We have a nice discussion. The take-home message is that we as clinicians should keep in mind that SAD exists in ILD and in the other airway disease. We should think whenever the clinical need arises to investigate for these. Thank you for
Thank
all
you
the
very
people.
much. Thank you. Thank you.
Sorry for that, because already we have delayed the session. I would request the panelists to be very, very brief in asking the question and making the comments. It becomes like little difficult, but I think we can ask how many are actually feeling that small airway disease has become treatable target by raise of hands. I think our
The
hot
audience
seat guy-
pool, how many of you that we should evaluate for small airway disease in ILD patients? I think it's more than 60%. That's a good.
Two-third.
Good two-third.
in
And
airway
and the
diseases-
winner is audience.
And in airway diseases?
And airway disease?
Oh God.
More than that.
So I think
As
Mona
per
and-
literature, the hands are raised as per literature evidence.
Correct. So I think lot of us believe it's significant, but yes, we do not know how much it will be translating into practice. And as you said, no evidence. I think Richard must go back with one more idea to work on, that can this damage be also a driver for a cardiovascular event or not? Thank you very much. Thank you very much. So thank you. I hope you liked this session, which was a chat, fireside chat. And I now request the next one, which is this next signature session, Lungs on Fire. So we have clubbed 2 cases. So we will start with the case 1, which will be by Dr. Richa Gupta. And we have subject experts, Dr. Niranjan Desyanke and Dr. Bhattacharya. Dr. Niranjan? Oh, we have been missing you since morning, right? Thank you. Our panel is radiologist, Professor Padela. Yes, requesting you to, this is very new in Lungs on Fire, that we have a radiologist who is the international faculty. Yeah, please, you can take the chair. Dr. Charul Debral, who's the pathologist, everybody knows her now in India. Then we have Dr. Israrul Haq, who's our rheumatologist on board. And since we have written all names together, this is the first case. In the chairpersons, I will invite Dr. Vivekan Pillai, Dr. Mir Fazal, and Dr. Jogesh Sharma on that side. We'll have expert panelists, Dr. Sourvik Sarkar, Amit Gupta, Nirvan Bashya. So the other names will come in the second case. This is the first case which is going to go on. And over to you, Richa. Fire the stage.
Thank you so much, sir. And a very, very warm good morning and a very... we have the voting pads as well, so I would ask you... Okay. So I would like you to interact with us as we go through this Lungs on Fire session 1. And before even I start, can I have a very loud cheer? Vande Mataram, today is 80th Independence Day. Come on, all of you. All right. Here we go.
So you have on the
pads.
tables, you have a voting pad, so all of you can vote during the poll sessions.
Okay. We have a 67-year-old female, a hookah smoker, housewife, known diabetic, who was symptomatic for a month with hoarseness of voice, weight loss of 2 kg, loss of appetite, but there was no other symptoms. On examination, general examination was normal, her vitals were okay. She had no clubbing, no peripheral palpable lymphadenopathy. Systemic examination showed she has some decreased breath sound on the left side of the chest. Other systemic examination was normal, and this was the chest X-ray. So this is a poll question to the audience. Name 3 radiological signs. No, it can't be poll question. Is it? Okay, what are the 3 radiological signs applicable on a chest X-ray? Very quick, anyone from the audience. Hilum overlay. Second, quickly, we have to finish on time. Sorry? I didn't get it. Extra pleural sign. Okay, I'm not sure about that. More? Hilum overlay is done, which is the second one and the third one. Silhouette sign, very good. Third one more is there. Okay, we'll ask our radiologists to talk about, we are talking about what are the 3 radiological signs we can see on this chest X-ray.
Yeah, thank you very much for having me again here on stage. I don't know the cases, just a disclaimer. So what I see here, and maybe talk about the case first a little, if that's okay. Yeah. So on this chest X-ray, we have like the 2 planes. I think the quality is very nice. First thing is we see this mass in projection of the left hilum, and we don't see any vasculature there. So we can also see on the lateral scan it's a little more anteriorly located. That's the one thing which caught my eye. And we also see that the left lung, the volume is reduced, right? We see the diaphragm is elevated, and in general. Also, if you look on the left, on the lateral view, you can also see that. Can I use the mouse here? Does it work?
Yeah.
So you see where the mouse is pointing now. That is like the lowest point on the left diaphragm. So the lung has significantly reduced in size. And also, what I see. I'm kind of in between. I see a little bit of a nodular pattern going on around the entire lung and or a little reticulation here at the bottom. But yeah, in general, I think this is definitely, there's a need for a CT, right?
Yeah, so I think in the interest of the PGs who are sitting here, we were talking about what are the radiological signs. So probably they are what they have said is hilum overlay sign. Do we agree on that?
Yeah, we agree on that.
We agree on that. And what is hilum overlay sign? Very quickly, someone? Do you want to say what is hilum overlay sign?
That you basically cannot identify the structures of the left hilum because of this mass.
Yeah. So if you could see the vessels through the mass lesion which is at the hilum, or whether you cannot see it, right? If you can see it, then it is not at the hilum, it is either in the mediastinum. And then second sign was Silhouette sign. Silhouette, yeah?
Yeah, for example, you can see it in relation to the aorta of the mass. You can see the lateral wall of the descending aorta there. Thank you very much for pointing that out. And this tells us that the lesion, if we had no lateral view, that the lesion is not next to the aorta, it's more anteriorly to the aorta.
She's saying, can it be cervicothoracic sign?
Cervicothoracic sign? I think not. No.
How about hilum convergence sign? The vessels.
Yeah, I think it's a little tricky. Yeah, I think it could be. Yeah, I agree. Yeah.
So hilum convergence sign. Someone very quickly. Can somebody say? I think nobody picked up the third sign. Only 2 signs they were able to pick up.
So there are prizes, so if you answer the questions, you will get a prize. So maybe this motivates everyone to get a little prize to... Oh, there's someone, thank you.
If we see this X-ray, what we see first, if we say hilum, overlay sign, that means it's in the anterior part. But we see cardiac, say aorta anteriority, because we can make it different. So it is between, in the middle mediastinum, not in the anterior. That's one sign there. And second, there is some pleural effusion and there's slot sign, left level collapse possible.
No. So we are not talking about is it anterior or posterior. We are just saying whether hilum overlay sign is positive, is there or not, which differentiate between whether the tumor is hilar tumor or it is not hilar. That's the only thing. Let's move on to next slide. The lab investigations and the workup, as you can see, is all normal. The 2D echo was done with the normal ejection fraction. And we move on to next. So now this is a poll question. What would you recommend next? HRCT thorax, contrast enhanced CT thorax, bronchoscopy or PACS scan? Very quickly. The poll question. Vote please.
Ten seconds.
Can we have the answers, please? Contrast enhanced CT thorax. Do you agree, Professor?
Yes, I think that's a very good choice.
And we'll do the mediastinal window first. And here's the lung window as well. Shall I move on to next slide? Or you want me to run again?
I think I'm good.
Okay. Do you want me to run again the mediastinal window or we can go? Okay. So what is it? Again, a poll question quickly. Is it a thymic tumor? It's a mediastinal lymphoma, a germ cell tumor, or tuberculosis? Can we make it out on a CT scan alone? A very quick one.
So if anyone is going to answer it, you get the coupon. Any one of you?
Anyone want to answer to get the
Germ
coupon?
cell? Germ cell? Okay.
What do you feel?
It's interesting. Yeah. Thank you. I think it's a very interesting choice. So I agree that the lesion is primarily in the anterior mediastinum, right? It doesn't look like the typical bronchial carcinoma. These are basically all the differentials of a mediastinal mass, right?
True.
The one thing, if you look at this picture there, the way it compresses the left pulmonary artery, I think for lymphomas are from the tissue, they are softer in tissue. The pathologists probably will agree with that.
Yeah, but sometimes lymphomas, they can involve the vasculature as well.
Yeah, but I think it's less likely lymphoma because of that. For like a germ cell cancer, I mean, typically teratoma, we see like fatty parts, we see maybe like a little tooth in it. It doesn't look like it. So while I picked up that maybe tuberculosis might be the right answer, I think I would have actually gone, from my experience, I would have gone with like a thymic tumor. However, I think in India it's probably a lot more likely to have a... Okay.
Answer will come.
Okay. But I would go actually for A in this case. And also for the tuberculosis, I mean, it could be, but the way it grows, it looks like it's one mass growing into the mediastinum. I would go more for like the malignancy here.
So we agree it's a mediastinal tumor and we are looking into what it could be. So whether it is mediastinal or lung or pleural effusion or a pleural lesion, there was a small effusion as well, right? So we know we are a radiologist and Morris has confirmed that it is a mediastinal lesion and all of us agree on that. Let's move. The poll question please. What would you recommend next? Do a bronchoscopy, EBIS, CT guided biopsy, or you want to now further characterize and do a PAT scan for the patient? Very quickly.
So all the participants
So any one of you
who
can
win
answer
the coupons, they can redeem it from the souvenir counter. So maximum coupons if you get, you will get more
So, any one of you, any guess?
precious gift from the souvenir counter.
Yes, please. So, PET CT,
So I
PET
think
CT, different answer?
40% are going for EBIS.
Okay.
The second is 28%. So let's look at the answers. Who has answered what? Anybody for PET?
No, I
How
think
many?
we can hold on here because we don't have time. What would you say? I mean, I'll ask my chairpersons to please intervene on that.
Yeah.
What would you suggest, sir?
So what I saw that there's a mask-like structure which is getting into the aortopulmonary window area, and that's where it is compressing possibly the left recurrent laryngeal nerve. I don't know about hoarseness of voice. Maybe phrenic nerve is also involved, but the left diaphragm is up. So I think it's more likely a lymphoma kind of thing.
No, sir, what-
And I can see also subcarinal lymph nodes very easily seen. It will be very easy for a transbronchial needle aspiration from that tissue, and the tissue textures-wise is almost same. I would rather go for a EVAS.
What's your opinion, sir?
Right. So I'm thinking about the resources as well. So in my country, I'm from Sri Lanka, so EBUS is not truly available. So,
Okay.
and in this patient, I think the most likely diagnosis is tuberculosis.
Okay.
When you look at the clinical picture, as well as the lung windows, which showed some nodularity with some what you call train bud appearances as well. I think you might agree with that. And so I'd go for FOB first.
Okay.
And if I get a gene expert positivity,
Okay.
then I think we have a diagnosis, yeah?
Sure.
And then probably treat him. Then if the patient is not responding, go for that. Or else maybe go for the basic EBUS again if there is no conclusive diagnosis.
Sure. A very quick one from our panelists sitting on the right side.
So FOB.
Who all for FOB? Just raise your hands, you get a coupon.
It's a plural based mass. Why not go for a CT guide biopsy? It's a plural based, Dr. Richa. It's a plural based mass. Why not go for a CT guide biopsy?
So we agree, Dr. Pillai, that it is a mediastinal lesion. The radiologist has confirmed. If we have anything else, okay, let me just move forward. PET CT was done actually for this patient to further characterize what exactly we are looking at. And if we look at the PET CT, just see. Do you want me to run once more or it's okay? Once more?
I think it's okay. Like
It's
if
okay?
they're like, if you promise that there's nothing going on in the pelvis, you can.
No, it is nothing going on the pelvis. So again, now the poll question comes, what you get to do the diagnosis, bronchoscopy, EBIS, CT biopsy, ultrasound guided pleural aspiration, very quickly.
Please poll and win the prizes.
That's really different.
So now I would ask our experts as well, while the question answers are coming, what do you feel now with the PET scan, what we should do?
Yeah, I've seen it's, I do not know the SUV max value, but it is PET positive. And one small part is more positive. And that part seems quite a bit away from the left main bronchus. The subcarinal lymph node is not that strongly PET positive. So to access that mass, I think the tissue which is most hot is the deepest, and CT-guided biopsy would be a little difficult, but I will decide between EBUS and CT-guided biopsy. If you can pinpoint that site in my biopsy procedure, be it through EBUS or CT-guided, it will be the best. So I'm in dilemma, maybe I'll try with EBUS, but I'm not sure how far I'll be successful to get a tissue
That's
diagnosis.
fine, sir. We are just looking at anyone from the panelist side.
Thank you, ma'am. Wonderful question.
Ma'am, in the same setting, can we plan for A and B together, same setting?
I'm sorry, I didn't get
In
it.
the same setting, can we do a screening bronchoscopy plus EBUS in the same setting?
Okay. So we are looking at CT guided biopsy. A very quick one, very quick one.
Can you go to the microphone,
Very good.
please?
So he's saying there are areas of necrosis on the PET scan, so we have to be careful about that. Dr. Rennis, very quickly, few seconds.
Yeah, since we have done the PET, we can do a PET-CT guided biopsy to get the more tissue for further IHC markers and all the stuff. So that
Okay.
would be better, I think. And if you give me a coupon, I can go for others.
Yeah, like I think generally these masses behind the sternum, they are not so easily accessible for the CT guided biopsies. However, I also think, like my colleague, that from like transbronchial will be difficult, right? So I think I would ask my colleagues from intervention if they can do it, and they always say yes.
Okay. So this patient went into MDT. It was discussed and advised to do bronchoscopy, BAL and EBIS for the reasons because MDT consensus was that on a PET CT there were many areas of necrosis. So we are doing CT guided biopsy. Probably we may hit them. And so a biopsy was done, EBIS FNAC was done for this patient. And this is histopathology. So now, Charu. We have station 7 and we have the mass which was at upper paratracheal position.
Yeah, so this was the mass 2L and you can see it is showing a monotonous population of small round cells with some prominent nuclei. And the station 7 is showing some ill-formed granulomas and again these small round cells with extensive crush artifact. And in higher magnification, you can appreciate that it is a mitotically active lesion. This is atypical mitosis. And these are small round cells with hyperchromatic nuclei and prominent nuclei.
So what would your differential on this?
So my differential would be thymoma versus a lymphoma.
Okay. And we have some IHCs for you.
So yeah, then in this case, LCA is negative. So obviously LCA is a leukocyte common antigen, so it is negative, so lymphoma is ruled out. And then we did B cell markers also, which are CD19 and 20. So this is also negative. And CD3 is also negative. CD3 is for T lymphocytes and 1920 are for B lymphocytes. And CK is showing patchy positivity. So patchy positivity is seen generally in thymomas and thymic carcinomas, and LCA is negative in thymomas. So we are seeing patchy positivity with CK, and we are seeing strong positivity with CD68, which is a histocytic marker, and synaptochromo and NSE, these are neuroendocrine markers which are negative. TTF1 is also negative, CK7 is negative, these are for adenocarcinoma lung.
So we are kind of in a mix or in a mess because few markers are positive, few are
No,
not.
so
So we really
I'll just make a gist. So
Right.
it's an anterior mediastinal mass.
Right.
So so it's an anterior mediastinal mass. So the differential is whether we are dealing with the thymoma, whether we are dealing with the lymphoma, or whether we are dealing with some germ cell tumors.
Right. So at this point of time, Charu, I would ask you, would you suggest us to get more sample because things are not very clear.
Yes,
It's not very
yes,
clear cut on
yes,
this.
yes.
Okay. So as Charu has already said, there were lots of differentials at this point of time and they advised that we need more tissue, a better tissue. That was only FNAC. So now a poll question again very quickly. Can we give only 10 seconds please? VETS biopsy, repeat EBUS, CT guided biopsy, or again, shall we do ultrasound guided pleural aspiration? Huh? Or PET guided biopsy? Yeah. So CT guided biopsy, it's PET guided biopsy. Very quickly. And we ask our experts to tell us what do we think we would need now? Because tissue is an issue now.
Yep. So there's a high probability of having some mixed diagnoses as well here in this patient because, we might have a lymphoma where immune suppression would have caused a secondary infection, maybe a malignancy with obstruction causing a secondary infection. So we have multiple possible diagnoses, and I completely agree that with the pathologist that we need a larger tissue sample so that we can analyze this tumor better. So in this instance, I would go for a guided CT biopsy. Yeah.
Guided biopsy. All of us agree on that now? Guided biopsy. Okay,
There's
sure.
3% who is voting, who has voted for EBIS.
So
Repeat.
anyone who has
Can we
voted for
know
the
that
EBIS,
Dr. Vijay Kumar will get a
the coupon for him.
gift from us.
Vijay, you want to say something?
So,
Sorry? Crionodal biopsy, but only thing is, yeah, okay, I agree on that. So this was
But the question is, let's go back. Let's go back. Everybody wants to use instruments to do it. Why not simple PET has been done? You know where to put in the needle, where the needle will reach directly to the tissue and get
Why
you the
don't we have
tissue. Is that
guided
right or
biopsy?
wrong?
Yes.
Why not? Why crionodals and why all those things are required? You need a tissue when it is a lymphoma under diagnosis. You need big tissue, chunk of tissue. And can anybody say crionodal can give bigger tissue than a CT guided true cut biopsy? No. Then why so? That is the question actually. And I think Sonia wants to bring the point, why PET scan? So I think you show the PET scan and ask Morris that you have seen the CT scan. Can you really tell which place to hit the needle, or with a PET scan you know where your needle should go?
Yeah, I think with the PET scan, I think it was also mentioned before.
That's
in
the
audience,
answer.
You see the highly metabolic areas, and you can differentiate where necrosis is, where there will be a vital tissue,
Exactly.
and you can actually target that quite well with a CT-guided biopsy. But I guess if you would ask the question in a at a radiology conference, everyone would go for CT-guided biopsy.
True,
It's, I think, a little bit of this bias here.
Okay. So we'll ask from the audience very quickly, what is the diagnosis before Charu tell us what is the diagnosis
Yes, this
on
is the
this.
prize question for the audience.
Somebody
Prize
wants to-
question.
I'll give 2 coupons for the answer.
You can give 4. Yeah, speak. Lymphoma, thymoma. Sorry? Thymic tumor.
Yes, sir. What is?
Anybody
Sorry?
to say tuberculosis? Nobody? You want to say tuberculosis? you
So we'll ask
So, no
Charu.
right answer.
Yeah, we'll ask Charu to give us the
After
right
that,
answer.
prizes will be given.
So yeah, this is a CT guided biopsy. So what we can see in a CT guided biopsy is that there is a highly undifferentiated hypercellular tumor composed of round to oval to now some spindle cells with hyperchromatic nuclei. And at places we can see there is some molding also in the nuclei. So it's a highly undifferentiated tumor. Lymphoma comes low down now in the probability. So whether we are dealing with a thymic carcinoma or maybe some sarcoma.
Okay.
So we need IHC for that.
And with this now, Charu, does it helps you?
So now, see, we have already ruled out lymphoma because LCA was negative, PAN B markers were negative, and T cell markers were negative, and thymoma was also ruled out. So now in this case, we are seeing vimentin, which is very strongly positive. So vimentin comes positive in a sarcoma. And the other markers which were coming positive was CD34. CD34 generally highlights the vasculature, but it comes positive in sarcomas, and CD99. So we are dealing with a sarcoma, most probably a synovial sarcoma.
So one right answer from the audience. Ladies and gentlemen, give him a big hand. Dr. Hanif. So please stand up.
He must have done this CRP. But anyways,
Okay.
Pratibha had said synovial, actually the germ cell synovial carcinoma right in the beginning itself. So 2 coupons to you.
Okay, so let me finish with this, with the key learning points. Synovial sarcoma is highly aggressive mesenchymal tumor, rarely appears in the mediastinum, and that is why we were not looking that as a differential when we were talking about. Seen in younger patient, though our lady was 67 years old. Clinical manifestations are non-specific. Diagnosis mainly rely on pathological, immunohistochemical, and molecular genetic analysis. And the key point takeaway is that don't use instruments when you can do it with a simple guided biopsy. My last comments from all the panelists and from the expert panelists. Just one-liner from everyone before we finish. So.
All right, okay. So when I look at this in my context, I would always think whether there is a mixture of diagnosis here, because you know, I'm not very sure whether you might be able to enlighten whether the pleural reaction is also in keeping with the diagnosis of sarcoma only, or whether there's a coexisting other pathology going on in the context of our you know, geography. And anyway, I think it's a very good case, and congratulations for presenting it in a very nice way and the clear images, and we learned a lot. Thank you.
Thank you.
Truly, I didn't think of sarcoma, and I was a little taken aback as the diagnosis has come. Lymphoma was a possibility, but I was not that sure. I was a little hesitant to put that needle through CT-guided biopsy close to the mediastinum. That's why I was hesitant. Yeah. But I think that's the choice in such a cornered situation.
Any, Charu?
I just wanted to say one thing, that the approach for an anterior mediastinal mass is very important, because you know the area is such that we cannot biopsy it many times, and so the approach is very important.
Yeah.
So basically the diagnosis was debatable, but if you see the cost effectivity as far as the modality of diagnosis is concerned, CT-guided true-cut biopsy and the size of tissue obtainable was way superior, and it didn't had any diagnosis as compared to the EBUS or any other sophisticated modalities.
Right.
I think tissue is always the issue, so we should go for that modality where we have lot of tissue.
Agree
That's
completely.
what we get from this
yes.
case.
The Charu needs to be fully satisfied so that she gives a good diagnosis to us. Anyone else before we close?
Integrated through biopsy is the most important to get the most of the tissues actually.
Rightly said, sir.
In our hospital, we usually have little poorer patients, so I think we would have gone directly for CT guided after plain CCT thorax itself, and avoided PET CT also probably.
PET CT probably would be, because we are looking at something very highly aggressive on a CT scan when we are considering malignancy. I think rather than going for a CT scan, you can just go directly for PET CT scan. That would give you more characteristic of the lesion, plus it will tell you about the metastasis as well. So thank you so much, everyone. Thank you so much for participating, and again wishing you a happy Independence Day.
Thank you, Richa, and please go home with an idea. First plain CT, then contrast CT, then PET CT. What are we doing? Why are we doing? It's such an aggressive tumor. You can see that it is a tumor. Why not to go right away, and if you want to know whether it is metastasized, if it is metastasized in liver or in lymph nodes elsewhere, that's a better place to do a biopsy than to do at lung. Just because we have a bronchoscope and an EBUS with us, that does not mean everything is a whole which can be pierced with these instruments. You get the appropriate one. Appropriate, the most appropriate, because patient loses confidence if first biopsy does not give you the diagnosis. Remember that.
Thank you so much.
Okay, go. Beginning the second case, Deepak.
So for the second case, we have Dr. Pratibha Singhal with us, and I request this side of panel please be with us. And I would like to invite the experts for this. Yeah, the previous case experts can leave now. So the expert panelists for this second case of lungs on fire are Dr. Muniza Bhai, Dr. Sonam Solanki, Dr. Kunal Wagre, and Dr. Vijay Kumar Chenam Chetty. So please join us on the stage. And I would like to invite our chairpersons for this session, Dr. Mandeep Singh from Amritsar, and Dr. Sameer Gami, and Dr. Arshad Ijazi. So I think we'll start.
Yeah. Thank you. So slight change. Sushmita was supposed to be doing the second case, but I'm doing the case instead. So moving on right away, and as you all know, please, it's an interactive thing. Please use your voting pads, and it's not always a wrong answer gets a prize or the coupon, so it's always a googly. So don't head for the wrong answers now, since you all have figured out that only the wrong answers are getting the prizes. So 79-year-old male, retired accountant, non-smoker, BMI of 21, having shortness of breath for 2 years, gradually worsening, and it is worsened more over 2 days. Cough with scanty expectoration over 2 years, again worsening over 2 days. Previous 2 admissions with similar complaints treated as acute exacerbations of COPD elsewhere. Hypertensive on clindipine, no past history of tuberculosis, history of PTCA in June 2025, epistaxis in Jan 25, underwent an endoscopic cauterization. In 2022, had right-sided empyema with an ICD insertion. And at that point, his pleural fluid reports are available with high sugars, with the high proteins, low sugars, very high LDH, and high ADA, high counts, obviously suggestive of a empyema. But at that time, a pyogenic culture and TB cultures were all negative, treated with antibiotics. Currently, vitals are stable, no clubbing, saturation is 95% on room air, bilateral rhonchi, and the other systemic examinations are normal. And this is what the X-ray chest looks like. Do we have Maurice here? I think we need Maurice back. Yeah.
Thank you.
No giving away the diagnosis.
All right, now we only have like one. I think it looks probably like AP projection of the chest, which always, you know, we have to consider everything is a little different because the heart typically appears larger because of the different technique. If I look at the, and I have to say, all the rules we know about X-ray in general, they are typically applied to the standing PA X-ray, where you also have the lateral, and so you have to be careful with like the interpretation. And I'm wondering why it wasn't, because typically you see these only in patients doing not so well, right? Otherwise, when everything's normal, they should not be getting the X-ray in AP projection. So I got some time, to be honest, something which really, like, there's nothing really striking my mind. What I was looking at the left hilum again a little bit. There could be some calcifications, maybe in lymph nodes going on around there, because there's also a little dot on the right. But yeah.
So there's increased bronchovascular markings, there's no loss of lung volumes,
no
preserved lung volumes, right? There's no
agree.
hyperinflation, obviously, on this X-ray. Maybe what we would describe as maybe hyaloprominence and some increased bronchovascular markings when we don't know what to report it as, right?
Yeah, but with the bronchovascular markings, that could be just the technique.
Yes, correct. So moving on, nothing specific here. On investigations, the WBC counts are raised. Urea is 52, creat is normal, CRP is 44, NT-proBNP is mildly elevated, D-dimer is borderline. IgE is 3730, which is increased. Previously, there is an IgE report of 9637, which is very high. Absolute eosinophil count is 10 at present. Aspergillus IgG is normal. IgE is also normal. And echo is showing pulmonary artery pressures of 25, EF is 55, USG is showing grade 1 fatty liver and raised echogenicity in the bilateral kidneys. Managed on the lines of airway disease with an acute exacerbation with antibiotics, bronchodilators, but he still continues to be breathless. We have a prize question here now. What infection is common with hyper IgE syndromes? Anybody?
So anyone? Sorry?
Giardiasis.
Strongyloidosis.
Yes, anybody from there? No.
Which infection is common with hyper IgE?
Maybe stronger.
Interesting. Nobody? Yes? Some more audience? Sorry? Aspergillus, okay. Staph aureus, the commonest thing. Yes, somebody who said Staph aureus? Yes. What infections is with Staph aureus? Skin, boils, right? Patient, yes. Job syndromes, they come classically repeated boils with staphylococcal infection, cold abscesses. Okay, so somebody from there gets that answer, great. Moving on. What would you recommend next? This is going to be a polling question. Please take your voting pads. Spirometry with a pre and post bronchodilator, complete lung functions, oscillometry with a pheno or a CT, PA. Can we start the polling, please? I can see some people are not voting. Please take your voting pads to make it interesting. Okay, so interesting. An equal percentage of people feel that we need to do a spirometry, and an equal percentage of people think we need a CT pulmonary angiography. Can we have your opinion on this? CTPA right away.
Like from the X-ray, I don't see a real reason for that actually, but we get a lot of CTs requested. So.
I think this is because people know that the wrong answer gets the coupons. That is why people are purposely voting for the incorrect answer. Is that what it is? I'm telling you all, it's not going to be the same in each case. So please don't vote for the wrong answers purposely. Yes. What would you all do?
There's a tie between A and D.
Left pulmonary artery was slightly prominent. So can it be vascular prominence of the left pulmonary artery?
But for that, you don't really need to do a CTPA, right? I mean, just for the caliber of the pulmonary artery.
Maybe a clot or thrombus is there in that.
The D-dimer is just 690. We don't have any symptoms to suggest any thrombosis.
There is no desaturation, no pulmonary, pressures are normal. So
yes.
It's a low risk one.
Okay, probably you'll get an answer. Panelist.
Yes. Sir.
Sir?
So it's very difficult and intriguing. If
so
I
you
am
get an
given the
answer
option,
for
I'll
that.
go for
Probably there's a
complete lung
thrombus
function
we do not
test
know.
first.
So please.
And I will try to get clues of where to go next.
Okay. So we've
2 years. 2 years.
breathless. Rule out a thrombotic episode that's happening. Okay. Fine. Yes. It is normal. Yes. So, Indu, just give Sir the mic now.
I think that answer can be left for you people to ponder actually. So if the patient has a strong clinical suspicion of pulmonary embolism and D-dimer is not high, will you not do CTPA? I think we have Professor Bunela out here.
It depends also, of course, on the clinical status of the patient. So I will go for it, I have to say.
Thank you very much. I think that makes the point out here. But somebody got it out here for the prize also for that. And I think we can go ahead actually. You know, somebody said oscillometry and pheno. Actually, they're going for an airway disease which is becoming worse. That is also an answer which should deserve some kind of a...
I think Jyoti has...
So we are doing oscillometry with pheno right away before doing a baseline spirometry.
So I think somebody is thinking on the lines of airway disease getting complicated and getting worse. So they may get coupons. I'm very, very free.
So moving on, we have a lung function test.
Keep your hands raised so that you get coupon, right? Yeah.
So we have a lung function test which is showing a decreased FEV1 by FVC with an FEV1 of 1.37, 59%, not much bronchodilator reversibility, but remember the patient is already on bronchodilators. FVC is maintained, the diffusion is mildly reduced, and the residual volume is also reasonably normal, it's just borderline elevated. You have a flow volume loop which is looking like a scooped out loop, so probably a obstructive loop. So at this point in time, the lung functions are showing an obstructive defect. So now what would you do? Again, a polling question, would you do a HRCT chest with a CTPNS? Would you do a CTPA? Would you do a coronary angiography? Or would you do a bronchoprovocation test because there is no post-bronchodilator reversibility?
Now CTPA
Can
will
we
not
have
get
the
prize.
polls? Can we have the poll? Yes.
Somebody wants.
Okay, so 83% have gone with HRCT chest with a CTPNS, and only 14% still want to do a CTPA. About 2% want to do a bronchoprovocation test. Can I see those hands up, please?
That should.
Prize.
Yes,
prize.
please.
Prize.
You all get prizes.
Prize.
Okay.
Not for that
So,
it is right, but
coming
still
back-
it will get a prize because somebody is thinking on the lines of asthma reversibility, not seen,
Dr.
broncho-provocating,
elevated
look for
IgE,
EGDA, perhaps you are driving
elevated
towards that side.
eosinophils.
Gets price.
Okay, so can I come back to our experts and our panelists? What would you do?
So previous question, we didn't have the option of doing a plain CT. That's why I think majority people said CT-PA. Right now, of course, HRCT chest with a PNS. I would.
Okay, why will you do a CT-PNS?
Very high IgE. You also want to see if you have upper airways involvement, sinusitis, polyposis. Everything.
So if we are looking at hyper IgE, then you do need to look at the CT-PNS because of recurrent sinusitis and sinus
I just want to add the
obstruction.
previous question. If the patient is hypoxic, sir, even with a low D-dimer, you can still clinically go for a CT-PA. Like
Thank you,
the
Sonam.
discussion
Thank
here.
you. Please make this point to clear.
So Dr. Sonal gets a prize for that.
So
Plus
moving
CT
on,
PNS.
this is what the CT showed. And we can get Maurice's input on that.
I think I'll request even Professor Bonella to be
Yes,
there on the
yes,
dais.
yes.
We have a case where we would have
Francisco,
his
we
inputs
need your
also.
inputs on this case. Please join us on the dais, please. Yeah.
Yeah, there's a lot going on in this CT. There's definitely cystic lung disease. There, like for us, the cutoff is like 10 cysts. So this is the one thing. But in addition, there is also like some like mild reticulation, if you see like there anteriorly, and you also see there in these areas of like, I would probably call it fine reticular pattern with like affecting the bronchi, so signs of fibrosis there as well. And also a little bit of like infection going on. I saw a little nodule also in the left upper lobe, I think.
There.
Yeah, this one, but can you go down? But it's in continuation of a bronchus. So that's probably some post-infectious thing. Maybe
Yeah, the
some,
WBC counts are also high right now. So a lot of cysts are there. Any characteristic to these? Anything you would like to?
Professor Bonella, your comment
Yes,
on...
it's not emphysema, so I don't see the white dot in the cysts. The wall is thick, so I think around 2 to 4 millimeters. And the form of the cyst is pretty round and diffuse, no prevalence. So I see in every lobe cysts. They are not bizarre.
And
Okay.
maybe also a little in the basal parts more than the upper parts.
Yeah, a little more on the basal parts than the upper parts, correct. So this is the mediastinal cuts. Maurice, if you can just, sorry.
The
come
one
in.
lesion was calcified there in the left upper lobe, which was now more clear, so probably some
Some old infection,
old
old granuloma.
calcified granuloma. We see also some calcified lymph nodes, axillary lymph nodes on both sides, also some mediastinal lymph nodes.
I don't see nodules.
She's asking for an autoimmune profile.
We will come to that, Sonia. All right, so nothing else specific other than calcification.
I just want to add, at my hospital, we would just do the HRCT as a PE study. So we would do, like A and B would be one answer, if you will, in this case.
So you would do a angio CTPA along with.
But the parameters for the lungs, while there is a little...
Coronary angio or pulmonary angio?
Pulmonary
Or
angio.
combined, both of them?
No, we do one scan with contrast, and you can then...
Reformat it.
And then you can look at the lung, and you can also look at the pulmonary arteries.
Exactly.
Pulmonary arteries.
This was also my idea, to do one CT with all the contrasts, and then you get it. Yeah.
Okay. So moving on, what's your diagnosis based on the CT scan? Can we have, is voting pads please? Is it LCH? Is it BHD? Is it LIP? Is it emphysema? Or are these incidental cysts? Interesting. So majority people feel it is LCH.
So radiologists made it very clear it is not emphysema. Maybe we should have posted the question prior to an imaging opinion on that. Maybe people might have even thought like that, but yes. Incidental cysts, raise your hands. Go ahead.
Too many
all
cysts.
get the prizes.
Too many cysts.
Yeah.
Please keep
Yeah, too many.
your hands raised.
It's too many,
So
it's more than
It's
10.
too many cysts to be incidental, guys. So it cannot be incidental cysts.
No.
But I'm sure 50% of people have voted for incidental cysts just to get the coupons.
Is that so? No.
Incidental cysts.
So I think the take-home message is that you don't get so many cysts which are incidental.
Yes.
I think that is what it is. They are too profuse to be incidental. I think that's the message
But
coming.
sorry, may I ask something? I missed the autoantibody status of this
I have
patient.
not yet come to it.
Ah, okay, sorry.
We were waiting for the radiologist opinion as to what does this look like. Actually, it was reported initially as emphysema only.
So
Like, I think Professor Bonella nicely put it that there was no central vessel
We don't have
sign
that.
in the, so emphysema is ruled out. The LCH, you also mentioned it, they are very round, very oval. In LCH, you typically see these cysts like more like irregular. So actually, I would probably not have thought it's LCH.
So we have
honestly.
2 scans now of 2025 and 2026 if there is
Yes, so
any
there are
change
comparison
or
of two
comparison
scans
of
are
2
there.
scans. Do you want me to run it again?
Is there any increase in number, size, or anything else, new findings, anything in between 25 and 26?
Some merging of cysts, I guess. Some merging. Yeah. It could also be LIP in advanced stage. No. No.
No.
They are asking about the smoking history.
No smoke, non-smoker.
Non-smoker, it was mentioned in the beginning.
Yeah.
Hello? Sir, I have a comment. Hello?
She says, why are you keeping everything in a suspense? That's what lungs and fire is. All suspense, full suspense. If you know the diagnosis on the first slide itself, believe me, it won't be here.
Sir, I feel it is not LCH the primary diagnosis. LIP is more likely in this case because they are more round. Well defined.
You justify once the answer comes. Please have a seat.
So there is slight increase in the cysts, some merging of the cysts, right? That's what we're seeing in 2026. Is there a change in your diagnosis now?
HIV status negative.
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 So now is there a change in your diagnosis?
Somebody is asking, is there a follicular?
We are coming to it, Sonia. I would suggest you hold your horses. So any change in diagnosis? Polling question, please. LCH, BHD, LIP, emphysema, or is it LAM in a male patient?
Oh my God.
Okay, so 22% people think it's male lamb. Yes, so Madhukar is not giving the prize for that, so too bad. 40% of people have changed their mind and think now it is BHD.
Yes.
And 22% feel it is LIP. 14% still feel it is LCH. And yes, we can have some comments from
you can have
the
a comment
experts.
from Professor Bunela. LCH. People still want to say non-smoker LCH.
Of course, smoking is a trigger, but if you have mutations like MAP kinase mutation of BRAF mutations, you can also have PLCH in non-smokers. So it's not mandatory in 100% of cases. And for BHD, I'm missing skin lesions, I'm missing the age of onset and so on.
Yeah, it's a more elderly patient.
A renal carcinoma in the family of the patient?
No,
the anamnesis?
no. Okay. So moving on, what would you recommend next?
We'll leave this question. Go to the
Okay. So let's look at the autoimmune profile. Everybody has been asking for the autoimmune profile. The only thing that was positive was Joe 1. Everything else was negative. ACE was a little high. Yes. Can I have your opinion now based on this autoimmune profile which everybody has been waiting for?
Come here, come.
Thank you. So what we see is that we have patient, we are evaluating for basically cystic lung disease. Yes. And with that, the autoimmune cause that we think of is primary Sjogren disease, that is called as Sjogren disease nowadays. So we have a specific myositis specific antibody, anti-synthetase antibodies Jo1 positive here. So now we have a very, now the class project had defined how we define the anti-synthetase, because our serological diagnosis and clinical diagnosis both are differing in this case. As per the CT, our differential was Sjogren, but we have a positive myositis specific antibody. So to say a patient having anti-synthetase, patient must have out of 3 one core feature, either arthritis, either interstitial lung disease, or patient should have Raynaud's phenomena. So out of these, patient has a cystic lung disease, and now we have JOAN antibody is positive. So this needs evaluation for underlying subclinical myositis in this patient, because the titers are high. This is not borderline. Anything less than 15 is negative. Anything more than 15 is positive. So we need to evaluate if the patient has underlying ILD.
So we're not happy with labeling the patient. We need to investigate further.
Yes.
I think Professor Bonilla wants to make a comment.
Yes, before thinking to a biopsy, do you have a BAL?
No, it's not.
No.
We haven't reached there yet.
We haven't reached there
We
yet.
haven't reached there.
Yes.
But I
Okay.
think one provoking question was that CPK and CK, everything is normal. So still you do muscle workup. Would you still recommend muscle workup?
Yes, I'm thinking about that because maybe a clinical, so I don't know if I would go for biopsy. That's the point.
Okay, go ahead.
Sir, can I add one point?
No, you only advise the next biopsy
Okay,
which has
so
been
you
done.
have advised the biopsy and we've gone ahead and done.
So
Charu.
since we were suspecting Sjogren's, so we did a lip biopsy. But the lip biopsy unfortunately was negative because all you can see is seromucinous units. So in Sjogren's you have to see lymphoid follicles, which should be at least more than 2 lymphoid follicles. So we give a focal score. So focal score is negative in this case. So this is a non-specific lip biopsy.
All right.
So no evidence of Sjogren's.
No evidence of Sjogren's
But
yet.
why did we think about Sjogren's? Because I mean SSA, SSB was negative.
Because of the cysts. Yeah. And now the diagnosis, so we then incidentally noted patient came back to us with this skin lesion. Would you now look at something else? Would you look at LCH, BHD again? So now you were coming back and asking us about skin lesions, Francisco, and then there was a
You
skin
wanted at
biopsy
first
done.
place.
Yes. So Charu, skin biopsy?
Yeah, so skin biopsy also ruled out the other differential because the skin biopsy is basically a non-specific dermatitis. And in BHD, you see fibrofolliculomas. Basically, you see hair follicles with keratin plugging, which is not there. So basically, it's a non-specific dermatitis.
Okay. So we still don't have a diagnosis. So we are still not sure whether it is BHD. There was an isolated skin lesion. So what was done subsequently after an MDD discussion was a lung biopsy. Yes.
So the skin lesion is basically a wart. It's not follicular nodular, and normally you will have it on the face near the nose, and this way. This does not look like that of a.
You can get it on the chest and the
but not-
neck as well.
This is a wart. This is a
Axilla,
neck
neck, chest can also be there.
But classically it didn't look like
Yes.
what you see in BHD.
In
It didn't
BHD.
classically look like that.
It's just that because it was pigmented.
But it's
Yes,
generic,
there was a single
exactly.
lesion, so it does not conform to the line. Correct. It's okay.
Generally, it's on the
Don't
face.
ask whys, because if you put that why in the chat GPT, it will tell you still possible. Go ahead and do it.
All right. So since we don't have any answers still, patient underwent a rigid bronchoscopy and a cryo lung biopsy, and this is what the cryo lung biopsy shows. Charu.
So I think this is a prize question. If anybody can,
So can we
give the
I know
answer
it's-
here,
anybody-
we'll get the prize.
Anybody can guess?
Anybody quickly?
Quick. Answer
One
is
answer.
only one word.
One answer quickly. Nobody?
Eh.
Nobody? Okay, fine. People giving out prizes are not allowed to answer the questions.
Just speak out loud. What you can see? Anthracotic pigment.
Anthracotic
Good.
pigmentation.
Give-
Okay, fine.
Give him.
Please give him 10 coupons.
Anything
If a pulmonologist can see the biopsy and even this much of it deserves actually 2 coupons, not 1.
2 coupons, not more, sir.
2 coupons, 2. Yeah.
Charu, please go ahead.
Yeah, so this biopsy was very good because we can reach to 2 diagnoses in this biopsy. So in the upper left, you can see there are a lot of cystic air spaces, like the cystic It's a cystic lung disease. And yes, there is obviously a lot of anthracosis, but I would like to focus on, these lymphoid follicles which are present in the interstitium. And this is an ill-formed granuloma which was also there in the interstitium. So all these favor a lymphoid interstitial pneumonia, which is there in Sjogren's. But the other interesting feature which we could appreciate in this biopsy was that there was this pale pink homogeneous material around the blood vessels and also in the alveolar septa. And then we went ahead.
Next.
So we were suspecting amyloidosis, so we did a Congo red staining and it came beautifully bright red positive in this pale pink homogeneous material.
We wanted to ask which stain it is, but she has already said it is Congo red, so that question goes out actually. Nobody gets a prize on that.
So what we are seeing is amyloid deposits.
So we have two diagnoses on this small piece of tissue. One is lymphoid interstitial pneumonia and associated with amyloidosis.
Okay. All right. So what next now? What are we going to do? Are we going to do a serum electrophoresis? Are we going to do a bone marrow biopsy, abdominal fat pad biopsy, or a serum immunofixation studies?
This is really tough. So I would have chosen the most difficult topic, the one which I do not know anything about.
Okay. So 42% want to do an abdominal fat pad biopsy, 28% electrophoresis, 17% bone marrow, and serum immunofixation, 11%. Yes, Francisco?
Everybody wants to do something.
Something, yes.
They don't want to stop here. That itself is a prize.
Yes, Francisco. Is there a correct answer or they are in all priority?
But I think maybe also serum immune fixation could be correct. Yeah.
Primary or secondary?
Okay. So this is what the... Can we stop the poll please and go ahead to the PPT? Yeah. So this is what the immune fixation assay showed. It showed a positive kappa lambda, and we also went ahead and did an abdominal fat pad biopsy.
Yes, ma'am.
So since immunofixation is negative and kappa and lambda both are positive, so it's a polyclonal infiltrate. And then we did the abdominal fat pad biopsy, which was quite diagnostic. You can see again in the abdominal fat also there are these pale pink homogeneous acellular material, which was again positive for Congo red. So obviously it is an amyloidosis, which is a systemic amyloidosis.
And there was also a bone marrow biopsy done.
So yeah, so bone marrow biopsy was quite cellular, but there was no increase in eosinophilic infiltrate like we were suspecting HES. And in the marrow, there was no amyloid deposition. But we went ahead and did, because there were a lot of plasma cells, so we did kappa and lambda staining and both were coming positive. So it was a polyclonal infiltrate in the marrow.
So there is a prize question.
Which organ should be screened? We get a prize here, please, to Rushali.
Thyroid, heart, liver, kidney.
Rushali has said heart.
Kidney. Okay, so this time I think we have to give it only those who are correct.
Yes, so we've already given it to Rushali.
Okay.
All right. So the key learnings from our case here was that this was a case of AA amyloidosis with mass clonality. Multiple comorbidities confused the presentation. Cystic looking lungs which were not emphysema. Jo1 antibody which was making us lead towards, initially based on the scan we were looking at Sjogren's, and then based on the Jo1 antibody we were looking at myositis, but we did not have any systemic manifestations. We need to monitor the kidney. Remember, hyper IgE can lead to AA amyloidosis, not primarily, but because of chronic systemic inflammation and secondary infections recurrently. Yes, Francisco?
Yes, I'm still convinced that this is a secondary amyloidosis to autoimmune disease, which is maybe undifferentiated.
Correct. So this is what we are looking at, secondary amyloidosis to the autoimmune disease, which is Jo1 positive, and they are going to die of kidney. So kidney people will all also get the coupons because whatever is going to happen, the death has to be from cardiac or kidney. And the cardiac already is showing mid-cardial fibrosis on a late gadolinium scan. So kidney people will also get the coupon on that.
So the interesting thing in this case was that we had a primary cystic manifestation, very subtle. Maurice has told us there were subtle reticular shadows on the CT scans as well, right, in the initial presentation. But the primary presentation on CT was cystic, which is unusual for our JO1 myositis presentation. So that is why you can see, that's why the obvious reason why this case is here.
Correct. So I think the nodules were interpreted as LCH also by one radiologist. So there was always a question that, but then patient was having infection. So
Yes.
nodules were because of
That Maurice had already said.
Yes,
looking
he already
infective,
said it
yeah.
is infection.
Yeah.
So just wanted to make one point in that. There are basically two things. One is
No, you make the points later now. We are already much over the time. You can let the message go to people later on. We need to
Yes.
wind it up.
So with that, we wind up this case and we thank everybody on our panelists and our chairpersons, our experts, and of course Maurice, who gave away some of the diagnoses initially.
I would say thank you from the core of my heart. The entire hall is full. There's not even a single seat available here to be a part of Lungs on Fire. And we are happy to announce the Lungs on Fire will be online session with multiple satellite centers taking forward after the PACS, because we have got the feedback. We don't want once a year Lungs on Fire. We want Lungs on Fire throughout the year. So every month there will be Lungs on Fire.
You have to go to the souvenir counter and redeem it. So there are prizes on the souvenir counter.
So up next, hi, I'm Dr. Dwivedi, professor in JIPMER, and I really, from the bottom of my heart, thanks PACS, which made me really pulmonologist, and especially to Dr. Talwar. So I have privilege to call upon Professor Francisco Bonella for his state-of-art lecture on pulmonary alveolar proteinosis, and we have expert panels. Kindly come to the dais, Dr. Rahul Jalan, Dr. Banani Jaina, Dr. Pradyut, Dr. Vishal Raj, Dr. V.N. Agrawal, and chairpersons for this topic is Dr. Tom Kamgo, Dr. Anupam Prakash, Dr. Gayatri Devi, and Dr. Naresh Batla. Please come, sir.
So we have next Lungs on Fire session will be after the lunch.
So thank you so much for your kind invitation and a happy Independence Day. It's a pleasure to me to present the state of the art of pulmonary alveolar proteinosis. This is my conflict of interest disclosure. Let's start with the definition. So PAP is not a single disease, it's a syndrome associated with alveolar filling and accumulation of phospholipids and proteins in alveoli and distal airways. The incidence is around 0.5 to 1 case per million, and the prevalence is around 7 to 10 per million. Over 90% of PAP patients has the primary autoimmune form. Hereditary and secondary PAP are infrequent. And age, smoking, and HLI loci are recognized as risk factors for this syndrome. This is a comparison of clinical characteristics and treatment worldwide. And as you can see, there is really some consistency in terms of most frequent PAP form, spontaneous remission, which is ranges between 6 and 10%, and also treatment with Hulan lavage and dust exposure, which is seen in around 40 to 60% of our patients. First, big news from the last years, does autoimmune PAP exist in children? We were really convinced as PAP experts that children can only have genetic associated PAP, but it was the wrong answer. So they can have also autoimmune PAP, resembling autoimmune PAP in adults in terms of clinical manifestations, chest X-ray, or HRCT presentation, but also clinical course, which is very variable. But it look like the levels of serum GM-CSF autoantibodies is lower than in adults. And the outcome can be extremely variable, as well as the clinical answer to Hulan lavage in these patients. So now we know that PAP phenotypes are determined by pathogenesis. The pathogenesis is a multi-pathway associated, and as you can see here, in congenital PAP, you have mutation in surfactant coding genes, as well as other genes which have which are involved in systemic syndromes. And in the primary PAP, you have a disruption of GM-CSF signaling with impairment of clearance of surfactant within the alveoli, and in secondary PAP, you have conditions which reduce the macrophage numbers and function. And now we know that there is a clear link between GM-CSF signaling and cholesterol homeostasis. So this signal, the binding of GM-CSF to its receptor, which has two chains, chain alpha and beta, through the JAK2 molecular pathway, can induce PPAR gamma and cholesterol transporters, but also activate the STAT5 pathway. At the end of the day, you have a cholesterol efflux from the cells if this pathway is preserved. This is not preserved, as you can see here. The time after withdrawal of GM-CSF in a mice model, you see that the accumulation of cholesterol at intracellular level in bone marrow-derived alveolar macrophages rise up, and if you add GM-CSF to the culture, you have an efflux of cholesterol from the cells. So now we know the clear link between the GM-CSF signalings and cholesterol accumulation. So again, the classification, the primary PAP can be autoimmune due to the presence of autoantibodies against GM-CSF, hereditary due to receptor mutations in GM-CSF chain alpha or beta. Secondary PAP is associated with infections, hematological disorders, immune deficiency, and inhalation, but the list of causes will be even longer every year. And congenital PAP especially associated with surfactant mutation, ABCA3 cholesterol transporter mutations, and other specific diseases like Niemann-Pick disease or methionine deficiency associated disease. But the dilemmas on classification, so we have essentially two groups in the world, the American European researchers which approve this classification, and the Japanese groups which tend to move the hereditary PAP into the genetic PAP. This is quite academical, but maybe in the future we will have some rearrangements of the current classification. Can pulmonary alveolar proteinosis be an occupational disease? The answer is yes. There are some cases, these were published in 2020 by Cummings and then commented by Costabel and Nakata, cases so two patients which worked in indium thin oxide facilities which had alveolar proteinosis, but only the one with GM-CSF autoantibody developed clinical manifest disease and the other one not. So maybe like in other autoimmune diseases, inhalational, occupational exposure can trigger autoimmunity. What about primary PAP? So we know that serum antibodies against GM-CSF are polyclonal and non-monoclonal, so primarily IgG1 and IgG2, and recognize human GM-CSF with high avidity and specificity and can neutralize far more GM-CSF than physiologically present. This is a crucial concept for augmentation treatment. So you have late responders, you have no responders because they have really aggressive antibodies with a high avidity, able to neutralize also the exogenous GM-CSF you administer to correct the defect. And GM-CSF autoantibody titer is essential to know in these patients, just to have an idea if the patients have clearly associated condition to high level of GM-CSF antibodies or not, because there are also these antibodies in normal individuals up to 7.5 microgram per ml in titer in serum. So it's really essential to know the concentration. In terms of GM-CSF receptor mutations, we have here a clear presentation of the published mutation, and you see the majority of mutation under the chain alpha of GM-CSF receptor and are diagnosed in adulthood. The beta mutations are really rare and are also associated with a worse clinical outcome. Here again we have some list of NOx, so inhalational agents, dusts, organic dust, fumes, and others associated with secondary PAP, infection, and we have some new entry, COVID-19, of course, and also in terms of hematological disorders, myelodysplastic syndrome is the most frequent condition associated with secondary PAP, but also GATA2 deficiency, and also new entries in the group of immune deficiency syndromes like the OPI, the polymorphic autoinflammatory immune deficiency, but also some conditions like sarcoidosis and HP can be associated with PAP. Secondary PAP can be really challenging. This was a 64-year-old patient from our hospital which had a chronic myeloid leukemia, and you can see after 6 years, it developed really patchy infiltrates in HRCT. This was pulmonary alveolar proteinosis. We performed also whole lung lavage with 20 liters per side, but at the end of the day, the same year of diagnosis of PAP, the patients died to renal and respiratory insufficiency. And in the GATA2 deficiency group, you have also heterogeneous clinical manifestation from skin abscesses, PAP, and also recurrent NTM infections. Congenital PAP is also a very tricky group of diseases. You see here the classical mutation we know which are associated with congenital PAP, the mutations in the transcription factor gene NKX2-1 associated with brain thyroid lung syndrome, the Niemann-Pick disease, the methionine tRNA synthetase, mostly in Réunion Island and in France, because it is a cluster of patients, phenylalanine tRNA synthetase, and also the OPID, the autoinflammatory genetic induced disease. But there are, of course, other phenotypes, and we know from these nice case reports from the Royal Brompton Hospital, case series from the Royal Brompton Hospital, that there is an association with HP, especially with positive precipitins to birds. And it was really, in this case, it was really histology confirmed. And there are possible explanations, of course, related to accumulation of PAP-like material in the alveolar spaces due to some common mechanism between HP and autoimmune alveolar proteinosis, so maybe a misfunctioning of alveolar macrophages, but also, of course, related to the immune system. And we published a case of overlap of PAP with sarcoidosis some years ago. Now we have guidelines guiding us in the diagnosis or diagnostic flowchart for PAP. So the clinical presentation is not specific. We have dyspnea on exertion, cough, but also systemic signs like fever, fatigue, chest pain, and only clubbing inspiratory crackles in advanced phase. And this is the algorithm from the guidelines. So at first you have to confirm, the first decision level is to confirm PAP syndrome, and the second is the serum GM-CSF antibodies test, and then if the test is positive, you have the diagnosis of autoimmune PAP, and if it's negative, you can assess the GM-CSF signal, which is very complicated, or go for NGS panel in these patients. And the biopsy is only mandatory when you have discordant findings or GM-CSF negative test and NGS panel indeterminate. So these are the HRCT features for diagnosis PAP syndrome. You have the crazy paving pattern, which is pathognomonic for the disease. You have geographic distribution. And you have a patchy, sometimes a patchy distribution, and a clear intra and interocular septal thickening, overlapping ground glass opacities. One of the questions is there a different distribution in autoimmune PAP versus secondary PAP? The answer is yes, according to the Japanese data, which were published some year ago, but I have to say now I don't have such experience at my center with a clearly different distribution of secondary PAP compared to the autoimmune PAP. So this craniocaudal distribution seen in Japanese patients in 62% of cases is not seen at my center. So I have around 200 cases of PAP. And then there are some similarities with lung manifestation in acid-sphingomyelin deficiency or Niemann-Pick disease, and also in methionine deficiency disease. You can see sometimes there is also development of cysts within the crazy paving pattern, or more ground glass, or even intraparenchymal nodules. So the differential diagnosis of crazy paving pattern can be really complicated, and then don't forget lymphangitic carcinomatosis, for example, and also, of course, some mixed connective tissue disease, hemorrhagic syndrome, but also sometimes pulmonary edema can also give a crazy paving pattern. And in younger patients, pneumocystis jirovecii pneumonia associated with immune deficiency should be always considered. So my suggestion is to perform the BAL with specific staining for PLP. The BAL findings are characteristic. You have foamy macrophages surrounded by PAS-positive acellular globules, and pink rain staining in the background with cell debris. And BAL received a positive, strong recommendation from the guidelines, although all the recommendations in the guideline had a very low certainty of evidence. But it was also preferred by the patients compared to the lung biopsy. In terms of biomarkers with potential clinical application, of course, we have GM-CSF autoantibodies, which are necessary for diagnosis, for better classifying the PAP. KL6 can be used to stratify patients for the risk of progression. And we have also other established biomarkers like LDH, surfactant protein D, but also tumor tissue antigens like SIA and CFRA21, which are routinely used in Japan, but also YKL-40. Antibody testing, positive recommendation, strong recommendation in the guidelines. You see here the comparison of the titer of antibodies between pulmonary alveolar proteinosis and normal individuals. The sensitivity and specificity is around 98 to 100%, but you need the titer, and we have stressed a lot at this point the guideline, and we have also provided a list of laboratories providing the not only positivity and negativity to the test, but also the concentration. And this is one of the biggest news from 2025. At the end of the year, Professor Nakata has published the rapid serologic detection test for anti-GM-CSF antibodies. So like a COVID test, you can see here. This is commercially available now. They had validation time around 6 months to 1 year. And then you can see this is a semi-quantitative test. So if the line is positive, also weak positive, you are in a field of concentration, a concentration range which is surely associated with autoimmune PAP, so over a certain threshold. Nevertheless, we perform the rapid test, and then if the rapid test is weak positive or clearly positive, we tend to confirm at my center by ELISA to get the concentration. The GM-CSF signaling test is complicated, can be done in blood neutrophils and monocytes, and is essentially done by flow cytometry, is expensive. It's only few centers worldwide. I'm aware of 5 centers worldwide provide this center to measure essentially the GM-CSF serum concentration and also the stat phosphorylation in these cells, because also neutrophils express the GM-CSF receptor, and these neutrophils are also bad functioning in PAP, in secondary PAP, and the genetic testing is, of course, also pretty expensive and should include, we have only one NGS panel for ILD and for alveolar proteinosis, including all the most frequent mutations associated with alveolar proteinosis, so we can get the answer in unclassified ILD or PAP patients about both mutations. What about the treatment? First, you have to assess disease activity. Secondly, Hulan lavage is the preferred test because is the preferred treatment because it's the treatment of the syndrome and not of the disease. Not a disease-modifying syndrome. Modifying treatment is a treatment which can relieve patient symptoms. Really, after 24 hours, the patients are able to walk and, without oxygen, and they don't have any symptoms. And of course, in case of treatment failure, you can treat with inhaled GM-CSF, or in case of refractory to treatment patients, use rituximab plasmapheresis or lung transplantation. No hierarchy of treatment is possible for other forms of PAP due to the lack of data. Disease severity assessment, you need lung function tests, you need blood gas analysis, and you need a CT. And there is a disease severity score which has been developed in Japan. And essentially, you have 5 classes, and it is based on PaO2 with a threshold of 70 mmHg, and the symptoms. If you have respiratory insufficiency in calm and symptoms, you have different classes, and also in the clinical trials, DSS score has been used to stratify the patients and to include or exclude the patient from the trial. You can see a clear example of progression. So in these 50-year-old females, so sometimes you have a worsening of the same infiltrates, but sometimes you have rearrangement of the infiltrates. We don't know why, in terms of number and shape in the HRCT. And this is the disease severity score with the 5 groups. So early patients have DSS-1, and a severe patient have DSS-5, and there is a good correlation with the LCO % predicted. But further scores have been developed and proposed, including HRCT findings, including biomarkers like KS6, for example. There is no sure correlation between GM-CSF antibody titer and disease activity, whereas a new international initiative collecting all the GM-CSF antibody titer and correlating with lung function tests and so on showed some clear worse outcome in patients with very, very high levels, so over 60, 70, or even 100 microgram per ml. But there are other circulating biomarkers which are more used for research purposes, which really correlate with disease activity. And also, of course, AI-based quantification CT tools like the Caliper system, but there are also other companies like Coreline offering such systems to quantify the crazy paving infiltrates in the lung of patients with PAP. Now let's move forward to treatment of PAP. In the guidelines, all the available treatment were addressed with a recommendation. Hull and lavage received a strong recommendation, although the level of certainty was very low. And it was only recommended for autoimmune PAP, and this is not because it doesn't work for other forms of PAP, it's just because of the available evidence. It's always the difference between evidence and clinical practice. The patient is intubated with a Carlen's double lumen tube, and then there is a cycle of instillation of saline volume of around, so between 700 and 1 liter, and then this fluid is drained by gravity. And you see the clinical effect of Hull and lavage before and after 1 month. You see a clear resolution of the infiltrates. Complete radiological remission is really, really rare. I think in my life I never seen a complete radiological remission in pulmonary alveolar proteinosis. And in this retrospective analysis of more than 200 cases of PAP patients receiving Hull and lavage, you can see a clinical significant improvement in blood gas analysis and DSC on more than 84% of cases, and a long-lasting effect over 15 months. And you can monitor the turbidity also by using spectrophotometry, which is very simple and cheap method, because we made some correlation in the past. Even when the fluid is clear, you have a protein concentration with this, which is clearly higher than normal in the BAL fluid. And you can also apply some methods like manual ventilation after a certain amounts of protein have been removed, or every 10 liters or 15 liters, or thoracic percussion, or you can also do Trendelenburg and move the patient. So you can do whatever you want, but really the aim of the Hull and lavage is to remove the largest quantity of protein as possible. And this was the second study published, 8 years after my study, confirming that the use of manual ventilation, they did it every 3 washes, but we did every 10 washes, was really effective in removing even more proteins from the lung. So based on the meta-analysis we performed for the guidelines, you can see the diamond in the forest plot were really long-lasting effects in terms of blood gas analysis and DLCO over several months. So this is a really safe and also a safe procedures in the hands of experienced people. But the problem we have is the indication of Hull and lavage, because some patients comes to lavage too early and some patients too late. So we are working on that, and of course we need better biomarkers and better indicators of disease progression and disease activity. Because these, we have to remember, these are younger patients and they can compensate very well even if they have respiratory insufficiency or huge infiltrates at HRCT. Careful application of Hull and lavage in patients with secondary PAP, especially those with infection and hematological malignancies, and in those with fibrosis and in children is mandatory. GM-CSF augmentation, positive, strong recommendation in the guidelines with a very low certainty of evidence. There were a lot of observational studies before the first Japanese trial, the PACS trial, have been published in 2020. You can see this was also a patient treated off-label from my center over 9 months, a clear resolution of the infiltrates, but not a complete resolution of the infiltrates, and a clinical benefit. And this was the trial published at the end of 2019 by Professor Tazawa and Professor Nakata. This was a trial with inhalational sargramostin, 125 microgram twice daily with the so-called Japanese protocol, 1 day off and 1 week off and 1 week on, matched with placebo, and the primary endpoint was ADO2 change from baseline at week 25. And you see there was a significant difference in terms of ADO2 between placebo and GM-CSF. a decrease in the ADO2. But they also published very nice data on ground glass opacifications. You see that the ground glass opacifications over time from baseline to week 25 clearly improved in the patients, and this was also quantified in terms of Hounsfield units. The second trial was published 1 year later with inhaled molgramostim in autoimmune alveolar proteinosis. The primary endpoint was also ADO2, but there were some quality problem in terms of blood gas analysis. So the primary endpoint was positive for the intermittent and continuous administration versus placebo after correction. And this was the reason why the FDA required a confirmatory trial by using DLCO as a primary endpoint because of better standardization in their opinion compared to ADO2. This was the reason why we had to perform a second clinical trials. In this meta-analysis, not including the Impala-2 trial, so only considering data up to 2020 or 2021, you can see here that the diamond in the forest plots for ADO2 and DLCO was clearly in favor of GM-CSF treatment with a lasting effect approximately 6 months. And here is the comparison between Impala versus Impala-2 trial, where the primary endpoint was DLCO assessed at week 24 and secondary endpoint at week 48, with a number of secondary endpoints like St. George's Respiratory Questionnaire. And for the first time, the exercise capacity measured by treadmill test at week 24 and 48. And you can see here, primary endpoint met, a huge increase of DLCO at week 24, long-lasting to week 48 in the patients with who received molgramostim, so around, so they were 81 patients, and also a positive response in terms of respiratory symptoms and exercise capacity measured by peak METs, metabolic units. But also, as a secondary endpoint, less patients require Hulan lavage in the treatment group compared to the placebo group. And the tolerability was very good. Only a few patients had some adverse events, but they were mostly related to the cleaning of the nebulizer. Open questions remain around the treatment or the best treatment for autoimmune PAP. Should we now try to skip Hulan lavage in these patients with high, especially those with higher GM-CSF autoantibody titer, and try really to avoid this invasive procedure? Should we combine Hulan lavage with GM-CSF augmentation in these patients? Or should we consider Hulan lavage only a rescue treatment? A lot of questions. Ilaria Campo and Bruce Trapner tried to answer the first question about the combination of Hulan lavage with GM-CSF augmentation, and you can see in this trial, unfortunately only with 9 patients per group, you have practically only rescue Hulan lavage in those patients not receiving inhalative GM-CSF. And these were all patients with a disease severity score between 2 and 4. Second-line treatment, rituximab. Personally, I don't believe in the efficacy of rituximab, so I'm very convinced that the data published by the French colleagues some years ago were true. So you can have really different clinical response in these patients, and there is also a risk of infection. So we don't have to forget that these patients are prone to opportunistic infection due to the malfunctioning of alveolar macrophages and neutrophils. And you can see here very heterogeneous response. Some patients are really improving, the other remain stable, and the other worsen over time. Plasmapheresis is a good method, but it's of course pretty invasive, and it received a conditional recommendation with a very low certainty of evidence in the guideline. Lung transplantation is tricky because the disease can recur, and this is from my center case series of 4 patients which we compare to the literature. And you can see that the time to representation of PAP or recurrence of PAP after lung transplantation is variable between 1 month and 1 year and a half after transplantation. And recently, I think 3 to 4 weeks ago, the biggest international study monitoring lung transplantation in PAP patients has really confirmed this data. So high variability and also variable clinical course of these patients. Outcome and prognosis, it is known that the secondary PAP has a worse prognosis compared to autoimmune PAP with a mortality over 5 years around 50%. It's very high mortality. And the spontaneous remitters are between 5 to 10%. And if you carefully observe in this graphic regarding the primary endpoint of the IMPALA-2 trial, you can also see that the placebo patients improve over time. And why? Because these patients are included in the clinical trial. They quit smoking, they quit inhalational exposure, and this is the reason why maybe they have a spontaneous improvement. One of the pressing questions is whether PAP phenotypes can explain spontaneous remission versus worse outcome, responsiveness to Hull and lavage, responsiveness to GM-CSF, different susceptibility to inhalational exposures, and also different rate of complications like infections and fibrosis. And fibrosis is the new issue we are all facing in our patients because they live longer, they have a treatment, and in 10 to 20% of patients, they have really these fibrotic changes. We were all convinced that there was a predominance of lung fibrosis in those with genetic associated PAP, but it's not true. Also in those with autoimmune PAP. And there are also some concerns about GM-CSF inhalational because if you prime the alveolar macrophages over time or too long, maybe they can start to release pro-fibrotic cytokines and, of course, stimulate fibroblast to myofibroblast transition and, at the end of the day, fibrosis. And we are submitted a manuscript now from my center. You can see that fibrosis patients has a worse outcome compared to non-fibrotic PAP patients. And there are also, of course, some exciting new perspectives. We have some studies going on with statins and PPAR gamma agonists. And the mechanism I have mentioned at the beginning, the reason why is that the disruption of GM-CSF signaling can disrupt all the pathway of cholesterol clearance. So pioglitazone as well as statins can increase the efflux of esterified cholesterol from the cells, therefore improving the alveolar space. There are these two trials. Until now, we have only data on mice. And also we have some examples of targeted treatment, like in methionine deficiency-associated autoimmune alveolar proteinosis, where the administration of methionine in these patients led to a complete restitutio ad integrum or reversal of autoimmune of PAP-associated HRCT findings and BAL findings. But maybe one of the most important things is the transplantation of gene-corrected macrophages in hereditary PAP. The first in human clinical trial for patients with CSF2RA gene mutation with transplant macrophages has been concluded, and the results will be announced at the ATS conference next year. But there are also other ongoing clinical trials and anecdotal reports which are encouraging when you have exhausted all your therapeutic possibilities. One of the most intriguing one is the use of daratumumab, which is an approved drug from myeloma in this 51-year-old patient with severe treatment refractory APAP, where all the possibilities were tried, so Hull and lavage, GM-CSF augmentation, rituximab, plasmapheresis, and then they administered daratumumab, which is a CD38 monoclonal antibodies with a really long-lasting remission in these patients of all APAP features.
Summarizing, disease severity assessment and clinical evolution guide the treatment indication. The classification of PAP remains driven by pathogenesis, and then based on this differentiation of PAP forms, you can then choose the best treatment for your patients. Hula lavage is effective in improving symptoms, lung function and hypoxemia, but it's not a disease-modifying treatment. Inhalation on GM-CSF is the first approved treatment in Japan, so sagramostin, and then the approval is going on for morgamostin in US and in Europe. We expect the approval at the end of 2026 in US and in spring 2027 in Europe. We have a compassionate use program or early access program going on. Lung fibrosis is the new enemy in PAP, limiting PAP prognosis, and should be really closely monitored in these patients with HRCT scan at least every year. And don't forget that autoimmune PAP can recur after transplantation, so please refer your patients with autoimmune PAP to centers with experience on that. And novel approaches, including targeted treatments, are ongoing. And I think PAP is one of the ILDs where we can really get lessons in terms of targeted advanced or precision diagnosis and targeted treatment. And a little bit of advertising, sorry, this is the monograph I have published this year together with Professor Manali from Greece. Is the first book entirely dedicated to PAP, covering the history, the definition, the classification based on pathogenesis, and providing a beautiful overview of current diagnostic and therapeutic strategies. And all the PAP experts involved in the guideline are included as authors in this very nice monograph. Thank you very much for your attention.
Thank you, sir. This was really, I don't think any questions will be there after the review, but we have a hand.
So, thank you, sir, for the brilliant deliberation on this PAP. So I had a patient a few years back. He was having the insult of silica, and he presented to us with 2 years of this breathlessness and dry cough. And when we investigated, we found this PAP in that. So my query is that he is, of course, not willing to go for a lung transplant. So how often we should do the whole lung lavage so that his symptoms remain under control?
I can only tell you the statistics we have in our hand. So hula lavage will be is performed every 220 days on average in patients with autoimmune PAP or secondary PAP. But the kinetic of the hula lavage is really depending on the inhalational exposure. If the patients don't quit smoking, don't quit inhalational exposure, they even can receive 1 hula lavage per month. I had a patient with really 1 hula lavage every 25 days. Can you imagine? So the range is variable. On average, 200 days, every 200 days.
Thank you.
Can I ask one question?
Before we take one question from audience,
one basic question for the young pulmonologist. Are there any clues in the clinical history or physical examination which should make him think this could be PAP and proceed accordingly for the investigations? Any clues in the history or physical examination which tells us this patient could be having PAP and we can proceed in those directions?
I have to delude you, there are no specific clinical manifestation of PAP, but I have to say, compared to other ILDs, I have a higher rate of chest pain in these patients. So when you have unclassifiable ILD and chest pain and fever sometimes, so this triad, you can think to something special like PAP.
Right, sir.
Thank you for a very nice talk. I have about 10 patients, and 1 or 2 patients are really troubling. Can I ask you, one patient I have been doing lavage almost every year. I have given rituximab. We've done plasmapheresis. How successful is the lung transplant in these patients, in PAP?
So this patient with autoimmune PAP or secondary PAP?
Autoimmune, yes.
Autoimmune PAP.
GM-CSF more than 20. has got tested?
The transplant is successful, but the problem is the recurrence of PAP after lung transplant. But also, I have to say now we have a longer survival of these patients after transplant. The overlap between autoimmune recurrent alveolar proteinosis and CLAD. And it's a very complicated situation because performing a whole lung lavage again in the patients after transplantation can be tricky because you have the anastomosis, you have the infectious complication due to immunosuppressants, so they have really to be followed by a reference center with experience in that. Yeah.
And the other thing is, do you extubate the same day or the next day after the lavage?
Sorry, can you repeat?
Do you extubate these patients, take off the ventilator, the same day or the next day?
Whether after home lung lavage,
Sir. Regarding extubation,
when you do?
After the whole lung lavage.
After whole lung lavage.
Yeah. But you mean in transplant patient or in general?
No. I'm saying after you've done a lavage.
Yes.
You know, if you used something like 20-25 liters, do you extubate, take out the tube the same day or the next day?
Yes, the same day. After 40 minutes.
And have you done
lavage.
both the lungs together? Because a lot of people are doing
Only in 3 patients.
No.
Only in 3 patients was a disaster. So all the patients ended in intensive care units. To be very careful, you have to be very careful because the issue is that you have to wait 1 hour and a half up to 2 hours between one side and the other side. You have to be a big team of people, experienced people. And then really these 3 patients remained in intensive care units over 3 days because they have some problems of desaturation and bad compliance and so on, extubation problems. So I don't suggest to do both lungs in one session. So generally we have 5 days to 7 days delay from one side to the other side.
Just last one line. If you do a one lung lavage, the other one, after how many days do you do it? A week or 2 days, 3 days?
Yes, 5 days to 7 days.
Yeah, that's what we also think.
So one last comment.
And we tend to start with the most severe side. Yeah.
Can you use GCSF, granulocyte CSF? We don't have GM-CSF.
Yes, I mentioned. So we have a compassionate use program or early access program where we receive the drug from US, from the company, and then we can provide to the patients without any costs. Yes. Or off-label, you can try with sagramostin, Partner Therapeutics. They have so they are applying for an extension of the indication. So the drug is commercially available, but the cost is around 44,000 euro per patient per year.
Thank you.
Off-label.
So with this, thank you, Dr. Bonella, and our chairpersons, panelists, for this wonderful session. And we conclude this session. Thank you.
Thank you, sir. It was a very nice talk, and I don't think it could be better for pulmonary alveolar proteinosis better than this. So now we move to cardiology topic. It is an early suspicion of PH. In whom, when, and how. It will be taken by Professor Gary Coughlin. I invite him on the stage. For this, as a moderator, Dr. Vishwanath Gela, Dr. P.S. Bhattacharya. I welcome them. As a panelist, Dr. Sandeep Katiyar, Dr. Harjeet Dumra, Dr. P.K. Sinha, and Dr. Sonali Trivedi. And chairpersons would be Dr. S. A. Rafi, Dr. Sudhintra, Dr. Deepak Tayal, and Dr. Ritisha Bhatt, Dr. Amit Kumar also. Thank you. So stage is yours.
Hello.
So very, very good morning, everyone. So I, Dr. P.K. Sinha, bring you love and blessings from the land of Holy Land, Gaya and Bodh Gaya, and wish you all a happy Republic Day. Now, please take your topic.
Okay, thank you very much. So good to be here on Independence Day. So I work in the UK, but I'm actually Irish. And we have an Independence Day as well, which is the 6th of December 1921. But being Irish, we do not celebrate it because we complain and argue about whether or not it was an adequate independence rather than celebrating what we achieved. So I'd like to take home from you how to celebrate things. Okay, for those who are anxious for lunch, what I'd say to you is I can summarize the situation with regard to early suspicion of PH. We are unable to do it. So, end of talk. But we do have some ideas. So let's have a think about early diagnosis of pulmonary hypertension. The first problem we have is that the pulmonary pressures do not increase until more than 50% of the vasculature is obstructed. You take out a lung, the pulmonary pressures do not rise. So unless we had some method of looking at the pulmonary vessels directly, we're always going to struggle. Our second problem is that the conditions for which we have therapy, which are pulmonary arterial hypertension and chronic thromboembolic disease, are both rare. And you can't create a generic bespoke solution handed out to the GPs and to secondary care for something that's incredibly rare. You need something common in order to do that kind of bespoke assessments. We can look at people during exercise, so how the pressures and the flow change during exercise, and that would be one way of identifying people early. But to do that, we have to catheterize patients and then exercise them. So that's not really a practical solution for a rare disease. And then finally, we are looking at AI algorithms to see if they can help us with this, and they've been looked at by looking at ECGs to see are there ECG changes early that would point to pulmonary hypertension, exchanged gas analysis, healthcare utilization. The problem with all of these AI algorithms is that they're developed by comparing a normal population with those who have got extremely severe pulmonary hypertension. But that's not telling you about early pulmonary hypertension. So these tests will simply say, if the diagnosis was obvious you've got severe disease, is it easier to identify them if you're supported by an AI algorithm rather than taking you towards an early diagnosis? So what would an early diagnosis population look like and how easy would they be to find? We've done this analysis of the early patients, or relatively early patients, those with the mean pulmonary artery pressure 21 to 24. Summarizing all the patients who had this diagnosis in the UK, the 8 centres that look at pulmonary hypertension, over a period of 10 years, we found 700 patients. So it's not that many, and therefore creating a decent study is difficult. But what we did find was that as the pulmonary vascular resistance increases, your prognosis deteriorates, independent of your age, your sex, or whether or not you have comorbidity. But the impact of comorbidity is very impressive. So if you have no comorbidity and your mean pulmonary artery pressure is elevated, then your prognosis does not change until about 7 years after identification. So it's a long time to wait. However, if you've got lung disease as well, you've got 40% mortality at 5 years. So it's very mild pulmonary hypertension from our current definitions. CT, however, may be a way forward. We've tried to educate people to diagnose as early as possible. We've talked to echocardiographers, to respiratory physicians, rheumatologists. It really has made no difference at all. However, we have made progress with the radiologists. And if you educate radiologists to look at the CT, not just at the lungs, but also to look at the vessels, then you do make progress. And you can see that the pulmonary artery is a good sign. 50%, if your pulmonary artery is larger than your aorta, there's a 50-50 chance you will have pulmonary hypertension. If they look at the right heart, that is obviously a signal. Teaching them to look for vessels that are missing on the CT is very useful when you compare one side to the other, and then looking for webs and for missing vessels. So we are able to train radiologists to do that. But going forward, AI is probably the answer here, because you can train an AI algorithm to track out the pulmonary arteries and the pulmonary veins. And from that, you can see that if the surface volume ratio is abnormal in the veins more than the arteries, that's post-capillary pulmonary hypertension. Whereas if it's abnormal in the arteries only and not the veins, that's pre-capillary pulmonary hypertension. So that has legs, but we need to test it in large enough populations to find out if it's true. So in real practice, what should we be doing? Obviously, patients who are breathless on effort, that's the key finding in pulmonary hypertension. If there's no clear cardiopulmonary cause, one should think about pulmonary arterial hypertension or chronic thromboembolic pulmonary hypertension. About 4% of people who have had pulmonary emboli will develop chronic thromboembolic disease. And if you look at the people 3 months afterwards, about 1 in 3 have not recovered back to normal. If you investigate within that 1 in 3, you'll find the patients who've got pulmonary hypertension post-pulmonary embolism. Obviously, disproportionate breathlessness in people with heart and lung disease is a clue that they may have secondary pulmonary hypertension. And you can also look at the risk factor populations, those who have an increased likelihood of pulmonary arterial hypertension, and there we can consider screening. So there are populations in whom we can look. So I'll just show you a little case to show you just how difficult it is to diagnose early. So this is a lady who was born in 1972, who went to her GP in 2018 with a 6-month history of breathlessness on effort. The GP decided she was a bit too fat and recommended she lose some weight. 6 months later, she goes back to the GP. She's still breathless, so he goes a little bit further, does some spirometry, and says, well, spirometry is pretty normal, but we'll try some serotype. A few months later, she goes back. She's still breathless, so eventually decides, okay, maybe I should send you to a respiratory physician. And the respiratory physician, who's now seeing somebody with a 17-month history of progressive breathlessness, says, I can't find anything wrong with your lungs. And that's the end of the investigations. So she's sent to a cardiologist. She's now had breathlessness progressively worsening for 20 months. And he says, I can't find anything wrong with your heart. So does an echo, does an ECG, does a coronary angiogram. And as far as he's concerned, there is nothing going on. So this is the echo that he did. And what I'd point out to you is that this is a technically normal echo in terms of the report. The right ventricle is not big, the right atrium is not big, the TAPSE is normal, there's no tricuspid velocity to be obtained, pulmonary acceleration time is normal, there's no septal flattening. If you are an expert in pulmonary hypertension, you will note that the apex of the right ventricle does not triangulate. So I know that that's abnormal, but the report is normal. And this is a lady who's been breathless for 20 months. Nothing major was spotted on the ECG, but again, if we had looked very carefully, there is right axis deviation. So there are subtle changes, but they're pretty subtle. She was then landed into hospital in September, so 27 months later. She's now got syncope on effort. She's breathless, walking room to room. Her blood pressure is maintained, her heart rate is not particularly elevated, but she's in right heart failure. No ankle edema at this stage, pro-BNP is significantly elevated, and her VQ scan is negative. Her ECG has evolved somewhat, so in 7 months, it's gone from a minimal change to a proper right ventricular hypertrophy, right ventricular strain pattern, and her heart has progressed. She's now got a grossly dilated right heart, flattened septum, severe pulmonary hypertension. So that's all happened over a period of 27 months, but at 20 months, this was incredibly subtle. So this is the difficulty. The progression of the disease is not easy to pick up. So what about screening? Is that a way forward? And that the problem with screening is couple-fold. First of all, you've got to have a treatment. So one should only screen for conditions you can treat. And secondly, you've got to have a very accurate test. If your specificity of your test is low, then you're going to have lots of false positives. If lots of false positives, you're going to have to do lots of catheters on people that do not have pulmonary hypertension. Is that acceptable? Can you repeat it? So here's the recommendations presently, that one should do multiparametric testing in systemic sclerosis and echo in all the others. So the question is, how accurate is echo? Will that solve this problem? Is it applicable to these populations? You'll notice that lung diseases are not included. And the question is, of course, if you don't have a treatment, you don't screen. So why don't we screen for lung pH? So we obviously have very little data, and that's where the problem is. So if we take COPD, there's some registry data from Compara and from the Go Deep studies that kind of suggests that maybe PDE5 inhibitors are of some benefit. We have no randomized controlled trial to confirm that's true, and actually we do have some randomized controlled trials which are negative, so it's not particularly helpful. We have inhaled treprostinil, which works for advanced ILD-associated pulmonary hypertension. If the PVR is high enough, if the PVR is over 4, it seems to have a benefit in terms of 6-minute walk test. But does that translate into a prognostic benefit? And if we don't know that, it's difficult to screen. The perfect study says that we should not use inhaled iloprost in COPD. There was an adverse outcome. The more interesting problem we have is that the ILD trial, the Teton trial, showed that inhaled iloprost works perfectly well in ILD whether or not you have pulmonary hypertension. So do we need to know whether or not you've got pulmonary hypertension? If you've got pulmonary hypertension and you've got access to inhaled treprostinil, you can just use it. So we don't really have a clear mandate to screen at present. So what about echo? How useful is it? So the problem with echo is obviously when somebody has severe pulmonary hypertension, it's great. If your pulmonary artery pressure is above 50-55, then the tricuspid velocity tends to be positive. It tends to be fairly easy diagnosis, and you tend to see secondary changes in the right ventricle with that. The problem with early is that it's below that point, and that's where echo begins to struggle. So we've got all these sort of parameters we can use, such as the right ventricular size, the eccentricity index. We can look at the TAPC over SPAP ratio, so whether or not you've got a coupling abnormality. We can look at the flows in the pulmonary vessels to see whether or not there's rapid acceleration, whether there's notching because of high pressures, whether there's severe elevation of pulmonary regurgitation pressures, and how big the pulmonary artery is. And finally, we can look at the right side of the heart, the right atrium, and the IVC. The question you have to ask is how useful are all of these in patients with pulmonary hypertension? So this has been looked at in two ways. The first study here is the CIPHER study, which is a multinational study looking at echo in people with severe pulmonary hypertension, so not people with mild pulmonary hypertension. So the mean pulmonary artery pressure was about 45 there. Sleg from Bath did another study where we looked at patients with mean pulmonary artery pressure about 35, so a bit earlier pulmonary hypertension. And we see differences in how the performance is in these populations. So if you've got severe PH, your eccentricity, dilated right ventricle, systolic notching turn up positive. So anything above 10, you've increased the likelihood that you're going to find pulmonary hypertension by about 50%. When it comes to milder disease, it's actually pulmonary regurgitation velocity and the tricuspid velocity are the only two positives. None of these characteristics exclude pH. So to exclude pH, you need a negative likelihood ratio of less than 0.1. So none of them excluded. So echo cannot exclude pulmonary hypertension. It's poor at diagnosing early pulmonary hypertension. It's okay for severe pulmonary hypertension would be the message. I'll just labor that point a little bit further. If you try to use a screening tool for idiopathic pulmonary hypertension, unless you can get to a test specificity of 99.9%, you are not going to be able to find IPH in 5% of the population you have just screened. So you would have to do 20 catheters if you had a test that was that specific. If, on the other hand, you go to, let's follow up somebody who's got a female, she's had a BMPR2 thing, we know that she's got a 5% chance of having pulmonary hypertension. I don't need to do any test if I want a 1 in 20 ratio. But if I then follow up a year later, the chances of arterial pulmonary hypertension is only 1% per year. I now need a test with an 87% sensitivity. But we know from the DETECT study where we catheterized 450 patients and compared echo to the catheter in patients with scleroderma and a mean pulmonary artery pressure 32, that actually the specificity of echo is less than 70%. So echo just doesn't have the accuracy that we need for early diagnosis. And here's why. This is from the DETECT study. You can see that if we take our tricuspid velocity at 2.8, which is quite low, mean pulmonary artery pressure of about 35, we can see that we would catheterize 51 patients that do not have pulmonary hypertension, and we would miss 35 of 87 patients that do have pulmonary hypertension. So it has too much of an overlap to be useful. And this is the best we've got. All the others are less good. What about TAPSE over SPAP? We've looked at that in the population from the UK registry. It does separate better than tricuspid velocity. You can see the curves, the density curves here, where there's better separation of the curves for TAPSE over SPAP. But if you say we will exclude people in whom we've already made the diagnosis of pulmonary hypertension, a tricuspid velocity of above 3.4, it adds no value. So again, tricuspid velocity remains the standalone best best estimate. It has its faults, and nothing else adds very much to it in mild pulmonary hypertension. Severe pulmonary hypertension, different ballgame. Okay, so what have we done to get around this problem? What we've done is to try and enrich the populations. So if you presented with a population of scleroderma, the prevalence of PAH is about 3%. But if you say we will use DLCO to select those patients who are more likely to pulmonary hypertension, we actually substantially increase the percentage of patients within the population that might have pulmonary hypertension. And if you then move the goalposts, saying I won't screen you early, I'll screen you later when you're more likely to have pulmonary hypertension, you can actually increase the prevalence significantly. So that's how we do things. What we do is we increase the pre-test probability before we do the echo. We don't rely on the echo to diagnose early. And when we did that, we found 8 criteria that actually helped us to say who's more likely to have pulmonary hypertension than not. And this has got an ability to increase the prevalence to about 25-30%. So you're now only doing 1 catheter or 3 catheters for every patient to diagnose. So we've moved from a situation where we've had to do about 30 catheters to diagnose 1 patient to a situation where we can just do 3 catheters to diagnose 1 patient. But it's because we increase the pre-test probability. Now, I know there's a lot of desire that we should start screening in lung disease-associated pulmonary hypertension, in particular ILD. And therefore, my question is, can we use the same approach here? The prevalence of pulmonary hypertension has been estimated at about 40% in ILD, but these are patients who are clinically catheterized. If you really want to know what's going on, you should take a full population and just catheterize the whole lot and find out what's really going on. So we don't know if that's quite true. But let's assume that there's some truth to that. What we then need to know is these criteria that have been suggested from retrospective registries as potentially telling you who has got pulmonary hypertension, are they true in reality? So what we actually need is a study where we take a large number of people, 200-300 patients with ILD, catheterize them all, do all these tests and say which ones actually add value. Because at the moment, we're assuming they add value based on poor quality data. So, we can summarize where we are. So, echocardiography obviously has a pivotal role in pulmonary hypertension. What I would do is say to you that it's great if you want to pick up very severe pulmonary hypertension. If somebody is really sick, it's very useful. But when it comes to patients who have a sudden suggestion of pulmonary hypertension on echo, we think this is an intermediate probability, then you need to know what the pre-test probability was. If the pre-test probability was low, the post-test probability is still low. So the echo has not told you this person has pulmonary hypertension and needs a catheter. It's told you, go back and look at your patient. Second point is it's not a diagnostic test. I don't mind what the echo shows. I still need to do a catheter, with one exception, Eisenmenger's. If I see Eisenmenger's, I don't need a catheter. After that, the echo, while it can show you what's going on in the left heart, it is not necessarily accurate. I will show you any number of patients who have normal-sized left atriums and have got severely elevated filling pressures, because you can get a stiff left atrium that causes elevated filling pressures. So it's not inaccurate. Wedge pressures aren't accurate either. Everything has its faults. But all these things need to be taken into consideration. So echo, as I say, shouldn't use it for diagnosis, should only use it for probability. Unless, of course, it tells you that somebody's got a poor left ventricle or severe mitral regurgitation or something of the kind. Echocardiography cannot exclude either PH or PAH. Okay? You can have severe PH with completely normal echo. That lady I showed you with that echo would have had severe pulmonary hypertension at the time of that first normal echo. Echocardiography obviously is highly operator dependent. I will look at echoes time and time again. They'll have reported a tricuspid velocity of 3.5 or 4. I look at the quality of the tracing and say, I have no idea what the tricuspid velocity is. They will not look at the pulmonary regurgitation velocity. They won't make sure the jet is properly aligned. So there are all sorts of mistakes that are made. And unless you look at the echo, you don't really know what the report means. We've all mentioned that it should be consistent. Exercise echo has been studied, and it sort of has a kind of a role, but actually it produces more false positives than anything else. So if I was to say, if I'm looking for early diagnosis, where is my best hope? And my best hope is AI evaluation of the CT vasculature. Thank you very much.
Yeah, thank you so much, Professor Gary. Actually, yesterday we had an enlightening talk on evolving landscape of treatment. Actually, you spoke about multiple things. Actually, and today you spoke about early PH. Unless we have an early suspicion of PH and then we diagnose it early, whatever treatment options come, probably they'll all fail because we are going to make a diagnosis in the later stage. Actually. Please be seated. Yeah. So I think Professor Jerry has clearly shown that diagnosing PH is very, very important at an early stage. Actually, we all know that if you diagnose a patient in class 3 and class 4 state compared to when you diagnose a patient in class 1 or class 2 functional status, the mortality is significantly increased. And even when you see the treatment options, when you see a patient who is presenting in class 3 or class 4, probably we'll have to upfront start triple therapy, or even now sotatercept is available. That has to be available. That has to be considered. But if you see a patient who is coming in class 2, you can start with an simultaneous combination therapy in class 2. So it's very, very important to catch the disease in early stage so that we identify the pulmonary vascular remodeling at an early stage. So if we are able to identify the pulmonary vascular remodeling at an early stage, the RV hypertrophy does not happen, dilatation does not happen, and RV failure becomes lesser, because RV failure is the most important determinant of mortality in patients with pulmonary hypertension. With these few comments, I would like to open the session for audience question and also interaction with the panelists.
May I make a small comment? My question is, where are we left with after your talk? If it is AI to diagnose early pulmonary hypertension, till it has been available to us, we have to go in be a wilderness. So I think we should discuss how we can improve our pre-test probability for echocardiography in our day-to-day practice. And on that line, I would like to ask questions to my extreme panelists. How do they think about it? How to increase the pre-test probability for echocardiography in our clinical practice?
I'll jump in before people do, but essentially, you're absolutely right. First things first, divide early into early clinical versus early pathogenic. So early pathogenic is where I was talking, it's very difficult. I don't think we have the technology yet. Early clinical, in terms of functional class 1, functional class 2, as you say, it's pre-test probability, and that really is around, has the person had a pulmonary embolism? Is there a clotting disorder? Is there a condition that drives pulmonary hypertension? Is one of the things. And then, to me, the other big group is breathlessness, so exertional breathlessness that is progressive and is not associated with very clear lung or heart disease. So if you don't have a lung or heart disease diagnosis, then all progressive breathlessness or all breathless in exertion deserves evaluation. That's where your pretest probability comes. BNP helps a bit.
Well, even then, the evaluation algorithm should start at a certain point. And I think in our ground reality, it should start with a good echocardiography. Although I understand the limitations that you have already elaborated. So may I request my panelists to give their personal opinions, because this area is a gray area and everyone understands the limitations of ours. So can any of you make a comment on this?
In my practice, generally, I am able to pick up pulmonary artery hypertension based on the CTs, the diameter of the pulmonary artery, and the ratio it shares with the aorta. So that is one of a definitive indicator that the patient is having PH, because the quality of echoes keeps on changing at every place, and the echo is definitely not a gold standard for it. So the first thing all of us can get good quality CT scan. Even in a basic CT scan also, you can make note of the pulmonary artery diameter. So pulmonary artery diameter more than 30 mm and a ratio of your pulmonary artery to the aorta of more than 0.9 is very much suggestive of your pH in these patients.
So you are meaning radiological clues. If I go back to 70s and 80s, last century, Japanese people have elaborated that right pulmonary artery diameter and other diameters and ratios are very, very good predictor of having pulmonary hypertensions. CT, aorta pulmonary artery difference, multiple lobar pulmonary artery branch dilatation as good as the aortic diameter, or the bronchial diameter, these are also good predictor. But sometimes we find that even the pulmonary artery is dilated, the pH is not there. What is your take?
So if you've got dilated pulmonary artery, there's a 50-50 chance you will find elevated pulmonary pressures and a 50-50 chance you won't. So it certainly has increased your pretest probability for your echo. But again, your problem then is echo doesn't exclude pulmonary hypertension. So you now do your echo and it's normal. What do you do?
And once it gets dilated, the pulmonary artery trunk, it's maybe already late. When we see these patients, the projections, these patients must have a very high pH. But in day-to-day practice, we are bothered with our COPD patients who have got severe reduction in the lung functions with mild to moderate pH. And they are the majority. I think diagnosing pH in them has got different significance. How do you take it?
COPD patients?
COPD patients with severe lung function worsening and mild to moderate pH with very poor functional status.
So our policy is that we will consider off-label therapy if the PVR is above 5. But we will warn the patient that we could make them worse and that we have no evidence that what we're doing is useful. So it's a very difficult position. We need proper trials to actually know whether or not we should treat that population. If the PVR is less than 5, we know that the evidence is currently non-existent.
Well, Professor, I would like to put it in a different angle. We need to go for early diagnosis of pulmonary hypertension whenever we can come across a patient of unexplained dyspnea or unexplained fatigue, right? But the second point is there. Similarly, we have to look for heart failure or preserved ejection fraction at the same time. And both the echo have got many similarities for the preserved ejection fraction failure and pH. So how to go for that with echocardiography? That's the question.
Well, so our policy is that certainly if the left atrium is dilated, we're going to start heading down the left heart route. Less certain about E prime and EA ratios. We're not quite sure what they mean. If there's good going left ventricular hypertrophy. So what we tend to do is, again, go back to pretest probability. Elderly patients above 55, female patients, hypertension, atrial fibrillation, diabetes, that pushes you very much towards the HFpEF end of the spectrum. And we've got reasonable treatments for that, so we tend to go for that.
LSI will be helping us probably, distinguishing between the two. LSI, left atrial size and the mitral inflow pattern will be helping us.
Certainly left atrial size, yes.
So there is a question from the floor. Before that, yes.
So what I was interested in knowing was on the treatment aspects from Sir. So most of the trials have been done at functional class 2 with a mean pulmonary artery pressure of greater than 25. And when we're talking about early PH, we talk about a mean pulmonary artery between 21 and 24 now. So in your practice, what I would like to understand is, in patients with functional class 2, what is the possibility that these patients will still have mild pulmonary hypertension? Because we are only going to treat them after functional class 2. We've not started treating functional class 1 as yet. So is this entire debate of picking up early pulmonary hypertension relevant only from the screening perspective, or does it have a therapeutic benefit as well?
I have a, please comment, then I'll come.
So I think that functional class 2 have been included in the trials and the efficacy is similar in functional class 2 and functional class 3. So I'm not worried about the drug efficacy in functional class 2. You're right, functional class 1 has not been included and that's a problem for us. But actually, the reality is that by the time people are functional class 2, they have got severe pulmonary hypertension. If we go back to the early trial, which was in the 1990s, early 2000s, that was a functional class 2 effectively study, but the mean pulmonary artery pressure was 45 to 50. So these people had severe pulmonary hypertension. They just happened to have compensated adequately.
I have a personal reaction to your question, that I feel that once we look at for early detection of pulmonary hypertension, we'll be very much vigilant on the HRCT or CT image. And CT can speak much beyond the size of the arteries and pulmonary arteries and aorta and all. If you look at the left atrium, you can make out very, very well. And if the left atrium is big, and if your echo, if you're not suspecting any shunt in the heart, and there has to be left ventricular diastolic dysfunction, because left ventricular end diastolic pressure must have been raised. So in that way, you can pick up a lot of patients with advanced end diastolic dysfunction, plus patients with heart failure with preserved ejection fractions.
Let's
so
take
that's
the question.
one part of it.
Yeah, let's take the question from audience. He has been standing. Please,
Sir,
please go ahead.
Sir, excuse me. Yeah. Sir, I would like to ask one question.
So can we take the audience question before your question,
Sure.
please? Yes, ma'am.
Yeah. So I just wanted to know if a patient of like group 3 pulmonary artery hypertension, like a patient with a chronic lung disease being evaluated for pulmonary artery hypertension, and the echo shows severely increased pulmonary pressures. So, and we have ruled out the group 2 and that there is no problem with the heart. So with this echo finding in a patient with chronic lung disease, can we conclude with the only echo showing severe pulmonary artery pressures that the patient will have group 2 pulmonary artery hypertension?
So I think that, again, if your tricuspid velocity is above 3.4, so the estimated pulmonary pressure is above 50, then the chances are you're going to find pulmonary hypertension. You can be about 95% sure the pressures will be elevated. It's not a diagnosis, but it's a high probability. If the right ventricle is also dilated, the right atrium is dilated, then, and you get septal flattening, then I think that pretty well bottoms it out. So that tells you somebody's got severe pulmonary hypertension. It does not tell you they've got pulmonary arterial hypertension, because that requires the absence of significant lung disease. So we know that they've got precapillary pulmonary hypertension. We do not know that we can treat it.
Okay. I would also like to add that suppose if you have a patient who has ILD or lung disease with severe pulmonary hypertension, if the left atrium is dilated in the echo, that's a pointer towards class 2 PH as well. Probably there might be an systemic component as well. That is one thing. And if you have a patient who has an FEC by DLCO, that is disproportionately decreased DLCO, then probably there might be a component of class 1 PH also. When in the systemic sclerosis studies, they've shown that FAC by DLCO more than 1.7 could help us in identifying the class 1 pulmonary hypertension. So in a patient with lung disease, probably these are 2 pointers which can point towards the class 2 or the class 1.
So it means like it's still valuable to do a right heart even if you have a severe pulmonary artery hypertension seen on the
So
echo.
if you have a pointers that there is you feel that a PAH is disproportionate to the DLCO, and if you have left atrial enlargement, probably to identify whether it's class 1, class 2 addition, also in addition to the class 3, we might have to do RHC. Dr.
Sir, my question was,
Yes.
when in patients with high index of suspicion of pulmonary hypertension, how frequently we will go for the echo and screening, where the echo is not 100% diagnostic, as sir said, and we are not getting the all positive finding on echoes on the first time screening. So how often we will go on screening in such patients? Anyone in class 2 and class 3 patients, those who have high index of suspicion?
How often should one screen, is the question?
How often we will screen such patients? I mean, how frequently we will go for echo? I mean, first time if it is not normal, so after how many days we should screen it? I mean,
So
how many months or days?
Yeah. So in the scleroderma population where...
Or straight away you will go for RSC?
Yeah, so in scleroderma we will do screening once a year. So we'll do lung function on an annual basis, and if the gas transfer is less than 60%, then we would routinely do an echo, or if they're breathless. For every other population we don't know, but the recommendation from the guidelines is annual for most of these. I would have to say that the echo is really not up to meeting that. So although that's the recommendation, I'm not sure that it's a valid recommendation.
So can I have a question, please?
Yeah, please.
My concern is about the patients of group 1 PAH who has comorbidities. Now, aren't we berefting these patients from the benefit of upfront combination therapy, especially when the patient has simply type 2 diabetes, mellitus, or hypertension?
So the problem we have is evidence. If you go to the trials, you know, comorbidity was very uncommon in the trials. So is there the potential for benefit? Yes, there is. But we have not proven it because they have not been in adequate numbers in the trials. So what we see is the prognosis is much worse with each comorbidity added. So the simple one, diabetes, increase your morbidity or your mortality substantially on therapy. So what we tend to do is to go rapid up titration. So we start with monotherapy, and then a month later we will trial a second agent, but we will then monitor for deterioration, because often it's the second drug is where you begin to realize this is not a simple situation. There is actually left heart disease that you had not expected.
Thank you.
Dr. Harjit.
Cardiopulmonary exercise test will help us. Cardiopulmonary exercise test.
So yeah, cardiopulmonary exercise test is certainly very helpful in patients where you're wondering, do they have pulmonary hypertension or why are they breathless? And if the VCO2 rises very rapidly or the PET CO2 drops at the end of exercise, that tends to point you in that direction. But it's quite an invasive test. It's not easily available. It's not a great screening tool. But I think it's useful for patients that are breathless where you want to understand why are they breathless.
So adding to that point, the cardiopulmonary exercise testing, a 6-minute walk test would be helpful in identifying a desaturation. And then I think Dr. Parthasarathi has done a study on sit-stand test actually, and he has published a paper on that actually. He would probably enlighten us.
Oh yes, I think he is hinting to one which I have tried for early detection of PH. I took up this idea that these patients of PH have got a post-exercise recovery been delayed, especially for saturation. And I evolved a test called two-chair test where I look for desaturation, maximum desaturation post-exercise. The exercise is defined through walking between two chairs, and we find that if the desat max is more than 3%, the pretest probability of having raised pulmonary vascular resistance more than 2 Woods unit is very high. The odds ratio goes beyond 30. And this has been proved with a right heart catheter. But this is done only for the COPD PH patients, not for any other subgroups. So I cannot say what will be the result in class 1 or class 2 PO or class 4 or others, but this can be a very good screening test to appreciate the risk of high pulmonary artery pressure. And that's what I follow. And if my DSAT max goes below 3%, I subject all my COPD patients, irrespective of the lung function, for an echocardiography. And well, this can be also a publication where this kind of algorithm helps. We have to wait for that time.
So Dr. Harjit for the last comment actually, because we have 20 minutes.
Just a quick question. On the spirometry, we have certain ways to identify the quality of the spirometry. We look at the loop, we look at the forced expiratory time, and we know this is a good quality spirometry. Are there any parameters on the echo which will help you believe that the observer or the person doing the echo has done a good job and you should not ask for a repeat echo versus a poor quality echo where I need to go for a better echocardiographer? Are there any quality control measures on the echo which will help us decide this is a poor echo versus a good echo, specifically in context of pulmonary hypertension?
Okay. I think the first problem with echo is patients differ. So getting a good quality echo in somebody with COPD can be very difficult. So just because you've got a poor quality echo doesn't mean you've had a poor quality echocardiographer. But if I want to know whether I can rely on an echo, what I want to see is I want to see a minimum of 3 consecutive full envelopes of tricuspid regurgitation. And if there's not a complete envelope, I will reject it. If they've done pulmonary regurgitation, again, I want a nice clean trace. So it's the quality of the trace. When it comes to the ventricles, I want to be able to see the endocardium. If I can't see the endocardium, then the echo is not helpful. So whether it's unhelpful because of the patient or because of the operator, I don't know.
So thank you very much. The last line from the consultant physician side. Before attributing unexplained dyspnea or unexplained fatigue to aging or to lack of fitness or deconditioning, we need to look for pulmonary hypertension. And at the same time, we need to look for heart failure with preserved ejection fraction. As you all know, the heart failure, preserved ejection fraction attributed 50% of heart failure. So both are equally important for a consultant physician, and we need to look for both at the same time. Thank you very much. And thank you very much, Professor, for a nice talk.
Hello.
Thank you, sir, for this entertaining session. And we are hearing a lot about PH from you. Yesterday it was also an event. And tomorrow morning also we have another talk from Dr. Coughlin, and it is about PH in CTD. So next topic is about open house. It is about obese lungs, cardiometabolic pulmonary. And we are going to talk about pulmonary sequel and GLP-1 receptor antagonist. And none can be better than Dr. Rajesh Rajput. He is an director of endocrinology from Medanta, Gurgaon. For this session, I would like to ask moderator Dr. Naranjan Dishanke to be on the stage. Expert panelists Dr. Ramchand Prasad, Dr. Ajay Kumar Verma, Dr. Fatahuddin, and Dr. Rahul Sharma. Please be on the stage, sir. And our chairperson for this session will be Dr. Rahul Gupta, Dr. Apoor Singh, Dr. Mandeep Singh, Dr. Abhishek Fai, and Dr. Ankur Agarwal. All of us, please be on the stage. Dr. Rajesh Rajput, stage is yours, sir. Please welcome you. Slide change.
Should I start? Okay. So, good afternoon, friends. I am going to discuss a topic where lots of specialties now have a role. And can you have my slides, please? Right. So, I am going to discuss with you a topic which is present, a morbidity which is present probably in everybody's home or everybody's neighborhood. And being a pulmonary conference from pulmonologist perspective. So what we should know about obesity and the field which is going to explode in current few years. This is what I am going to briefly discuss over next 15-20 minutes. then I believe we should spend some time in discussion for this topic because of, so if we see the prevalence of obesity, these are the numbers. I will not read the numbers, but I still believe these are underestimates. And not only from point of view of prevalence, the treatment is also equally disappointing. Now, when you see number of studies, it has been demonstrated more than 3 decades that whenever somebody tries to lose his weight, the first attempt is the most successful attempt. Second attempt is less successful, and third, it becomes least. And even when you lose his body weight, what is a natural patient tries to gain weight. So weight loss following lifestyle intervention is not sustainable. And most of the lifestyle interventions, there are exceptions to the rule. So therefore, we should not debate that somebody has lost that much of weight on lifestyle intervention. Majority of people loses only 5 to 10% of body weight with lifestyle intervention. And it is not loss of body weight, it is also how long they are able to sustain that lost body weight. That is also important. And obesity, bariatric surgery brings about more than 20% loss of body weight. So there is a huge unmet gap between lifestyle intervention and between bariatric surgery. We do not have any drugs. Apart from that, whenever somebody tries to lose his body weight by lifestyle intervention, there is a tug of war which starts inside your body. As soon as somebody starts losing body weight, your metabolism slows down, your hunger hormone, which is ghrelin, goes up, your satiety hormones, which are GLP, GIP, cholecystokinin, and number of them, they goes down. So the result is, despite best possible efforts, simply by doing diet and lifestyle, it is difficult to maintain that sustained weight loss. And why this is happening, we have to understand that the body is developed by God in such a way that over centuries, energy conservation is a natural phenomena of the body. So as soon as you start losing body weight, your compensatory mechanisms comes into action and they limit the ability with lifestyle to lose and sustain your body weights. So therefore, there lies a huge unmet gap in terms of anti-obesity therapy. Newer generation of anti-obesity drugs, which are now available to us, they tends to maximize the degree of weight loss. And now the next generation, which is going to come probably in next 1 year, they are going to cause weight loss even more than bariatric surgery. They are touching up to 30% weight loss. So therefore, judicious use of these drugs are going to overcome the compensatory mechanisms which come into play whenever we try to treat obesity through diet and lifestyle or other measures. Now, out of all the drugs, GLP-1RA is one of the most potent and most studied hormone for treatment of obesity, and it is available with the name of Wegovy, which is written here. What is semaglutide? It's a normal hormone. It has got a 94% homology to human GLP-1. Now, GLP-1 is secreted in all of us, and it has a T-half of around 1 week, which means it can be given once a week. Now, when we talk of obesity, it is not that simple. There are 2 important parts of obesity. One is metabolic obesity or homeostatic control of obesity, which lies in arcuate nucleus of the brain, which means when your body needs energy, you will feel hungry. When your body does not needs energy, you will feel that you are full, there is satiety signal. That is homeostatic regulation of body weight. There is another important system which is present in our mesolimbic system. That is hedonic obesity. We eat because we get pleasure out of eating, and dopamine is important for hair. Now, so you have a wonderful breakfast in the morning. You are feeling full, but when you go out in the lunch area, you will see some wonderful dishes there. You will be tempted, let's take something. Because your brain is getting reward by eating those type of foods. So that is hedonic obesity. Now the hedonic obesity is stronger than your homeostatic obesity. Now GLP-1RA act on both homeostatic control of obesity as well as hedonic control. So therefore, if you see a patient of obesity where craving is a big factor, they says we cannot stop ourselves from eating. Night eating is happening. The craving for all type of foods decreases with use of GLP-1RA. In fact, if we see US database, craving for alcohol, craving for smoking, which is one risk factor for all of you, and in women, craving for shopping, that goes down with use of GLP-1RA. So it tends to reduce, it tends to control your reward system. Now these are step trials which are done. We were associated with good number of step trials. This is a clinical trial development program. I was associated with step 1. Based on step 1, the drug got US FDA approval, DCGI approval, and European approval for treatment of obesity. And there is an entire step program. I am not going to discuss with you in detail, but then we'll briefly tell you what is step program. In this program, this is actually a 68 weeks. All the trials are 68 weeks. Few are placebo controlled. The drug is given starting at a dose and then gradually every 1 month. The dose is up titrated to the maximum tolerated dose of 1.7 or 2.4 milligram. So these are in general step trial clinical program. 2.4 milligram is a maximum dose which is used in step program. Although if some of you are interested in obesity, now we have step up trial where even 7.2 milligram dose is used, and now it is under approval with US FDA. But in entire step program, 2.4 milligram is a maximum dose of GLP-1RA, which is used starting from 0.25. At every 1 month, we increase the dose to 0.5, then 1, 1.7, and 2.4 milligram. And that's how all these SQs are also available in our country by the pharmaceutical company. Now let's see the weight loss. Across step program, more than 20% of the patients achieved more than 20% of the weight loss. Now, before availability of semaglutide, and you know this is approved for treatment of obesity from last more than 7-8 years. But available in our country now only from last 6 months. So across clinical trial, more than 20% weight loss is achieved, which is actually not possible before availability of these types of drugs. And when we see teen obesity, which is a big problem, nowadays we are seeing obesity in our teens, 12 to 18 years of age. Till now, there is no drug available. Only 2 weeks back, DCGI has given approval to semaglutide as the only molecule approved for treatment of teen obesity. And again, across all the body weight categories, more than 20% weight loss is seen even in teen obesity. So a huge unmet area where recently on 5th of May, approval has been given to semaglutide based on step teen trial for treatment of obesity. Now, there are another molecule, tirzepatide, which is available in our country for treatment of obesity. So, 2 molecules are available, semaglutide and tirzepatide. So, some of you must be thinking where to use which molecule. Now, if you see weight loss of more than 10%, both semaglutide and tirzepatide are approved. When we look for pre-diabetes, type 2 diabetes and hypertension as a comorbidities in obesity, both are equally effective. When we look for ASCVD, which means atherosclerotic cardiovascular disease, it is only semaglutide based on select trial where it is approved. Tirzepatide has not shown superiority. When it comes to heart failure with preserved ejection fractions, what you are discussing in previous lecture, semaglutide again is approved for treatment in such type of patients. MASH, a big problem. People come with scan report, ultrasound, fatty liver. For MASH, there are only 2 drugs as of now approved for treatment. These are semaglutide and second is resmetirom, which is thyroid hormone receptor beta agonist. No other drug which are actually written like vitamin E and others, they are approved for MASH. For osteoarthritis, again, it's a category B approval for semaglutide. There is direct improvement in pain scores irrespective of weight loss. And the last point, which is of your interest, obstructive sleep apnea. Now, based on the studies, tirzepatide has an approval by DCGI and US FDA for treatment of OSA. Semaglutide direct randomized controlled trials are not available. Now, obesity, OSA, and airway disease, they are closely linked through mechanical pathway, metabolic dysregulation, and immune activation. And if we see OSA increases or extends beyond your sleep disturbance. When you see the number of disease, we have done our own study at PGIMS Rohtak, number of years back, the increased prevalence of diabetes in those people who are obese, OSA, sleep studies done. So lots of comorbidities increases in people who are suffering from OSA, and remember, 2 out of 3 or virtually everybody who has OSA has obesity. Even those who are appearing normal thin built, if we estimate their visceral adipose tissue, it is possible that even they are having visceral adiposity. So obesity is not just a coexisting condition, it's a major driver for OSA. And these are some of the recent publications regarding OSA. This is this year, 2026, presented at ADA, where they have shown, and this is based on SELECT trial, which is a cardiovascular outcome trial. Mean duration of the trial was 4 years. It has been shown that those people who were given semaglutide, they have significantly low chances of developing OSA as compared to those who were given placebo. And just to show the latest evidence published in April this year, effect of semaglutide on OSA in patients with obesity, this has clearly shown over more than 191,000 that semaglutide use was associated with significant reduction in OSA risk. So therefore, there is a clear evidence that from pulmonologist perspective also, this drug is effective in OSA. These are some Asian data where it has been shown that in Asian and Indian population, drug is more effective as compared to Caucasian counterparts. A big question always comes, what about loss of lean muscle mass? Now, this is a dedicated trial where it has been shown that majority of weight loss comes from loss of fat mass. And when we compare directly with lean muscle mass, the amount of fat loss mass is almost 4 times as compared to the loss of lean muscle mass. Remember, with whatever form of obesity treatment you will undertake, even simple diet exercise, drugs, or bariatric surgery, there is going to be decrease in some degree of lean muscle mass. So therefore, whenever you are treating obesity, you have to increase the protein intake of your patients. You have to ask them to do some resistance exercises. In that way, they can preserve their muscle mass. Lastly, when we see the safety of GLP-1RA, the most common side effects are GI related. And that is why we should tell to our patient to start with the lowest dose, increase the dose every month based on tolerability. Most of the time, these GI side effects are mild to moderate, easily manageable. But in a group of patients, they may be severe enough that you have to either decrease the dose or you have to stop the drug. Rest of the side effects are not of that concern, but we should take a careful history. In those who have suffered from pancreatitis, we should not use this drug. Anybody who is having medullary thyroid carcinoma, we should not use GLP-1RA in that class of patient. What are indications? These are DCGI, US FDA, European medical agencies approved indications. Anybody with BMI more than 30 kg or anybody with BMI more than 27 kg with one or more than one obesity related comorbidities, and one of them is OSA. Apart from that, GLP-1RA including semaglutide is approved for reducing cardiovascular mortality. I have told it is also approved for MASH. So friends, GLP-1RA semaglutide is now available in our country. It is available in all the 4 SQs. I have told you, start with lowest possible dose, that is 0.25 milligram, increase every month, go stepwise and use maximum patient tolerated doses. The maximum permitted dose as of now is 2.4 milligram. To conclude with, obesity is a multifactorial condition with complex pathophysiology. Eating less does not treat obesity, but if you start treating obesity with the newly available drugs, it will result in eating less. Multiple studies have demonstrated the difficulty of maintaining body weight with lifestyle intervention. Despite best efforts, metabolic changes to weight loss promotes weight regain. New generation of anti-obesity medications can maximize this degree of weight loss and helps to overcome compensatory mechanisms. Semaglutide available starting dose of 0.25 milligram up to 2.4 milligram is a GLP-1RA which has demonstrated its clinical benefit in reducing body weight more than 20% in more than 1/3 of the individual. Safety is well established and it is most studied GLP-1RA in this world. Thank you very much.
Very much, Dr. Rajput, for that excellent overview of the use of GLP-1 agonists. And when I put my pulmonologist hat on, and I think usually obesity was actually considered as a cardiometabolic disease. Now it is making inroads into the pulmonology field as well, as you have correctly pointed out, and not only in obesity, causing obesity and obesity hypertension syndrome, but it has been also been shown that patients with asthma, COPD, as well as interstitial lung disease obese patients have poor outcomes, as well as they are having poor quality of life as well. And in our part of the world, especially in Sri Lanka as well as in India, I know that obesity is rampant, maybe affecting about 25% of the population. And, for instance, of the GLP receptors, majority of them are actually situated in the lung. And even though they are having some metabolic activity, their anti-inflammatory activity has also been proven to be of benefit. And some studies have proven that not only the weight loss, but devoid of the weight loss benefit, they have been useful in preventing and reducing some pulmonological sequelae as well. So thank you very much for that overview. And I would like to ask the expert panel, because we are a third, developing country, and sometimes the new drugs might have issues when we start them in a day-to-day practice. So especially before we consider pharmaceutical agents, what are the usual advices that you would suggest to the audience that we might be able to consider in a patient who is obese?
A lot of things needs to be considered when we are talking about starting these molecules to our patients. These molecules has already made so much of buzz in the market that once you recommend your patient to start this molecule, they have some hesitancy, and this hesitancy is there in the non-endocrinologists also. Like, we are also not routinely using these molecules. Most of us are seeing patients who are having sleep apnea, although it has not been recommended so far. But with this, the indication is because most of these patients has metabolic disorders. The only thing that we need to, encourage our patient that, they need to realize this, that obesity is also a disease in them. Until as they realize that obesity is doing all these things, most of the time they are very, very hesitant to start any molecule. Rather, they strongly believe, despite not able to achieve that goal, that we will be able to reduce our weight since we have now been diagnosed with OSA. So I think these are the things you need to counsel again and again to your patients, other than the indication and contraindication that are very clear to us.
Any other?
Before the approval of these drugs for OSA, use of CPAP is believed to be the only treatment for OSA. There are, though I am not a pulmonologist, but we know there are some limitations for CPAP. Patient acceptance become poor. And with CPAP, cardiovascular risk factors and other benefits are still debatable. Now, for the first time, a drug has shown that you actually act at the root cause associated with OSA in large number of patients. Apart from that, you bring about metabolic control, you reduces inflammation, and in long term, you bring about improvement in cardiovascular. So based on this, probably US FDA has given approval for this drug, and I know at least at our place, now people have started, even from pulmonary department, they have started using these types of agent, or at least they are sensitizing the patients that there is a treatment option available, and then they are referring the patient to our department for initiation, because sometime initially patient needs to be told a lot of things about these class of agents. So definitely there is a place of GLP-1RA, but it is expanding, and future will tell where we will go ultimately.
I think we have a question from the floor. Yeah.
We are pulmonologists, you are endocrinologist. My question is that, what is the difference between semaglutide and tirzepatide?
Right.
And second, oral medicine which were available in past, like orlistat, where you will place that drug because of cost constraint is the big issue.
Excellent. Right. So I have shown one slide where I have compared with tirzepatide and semaglutide. Still, I will tell you again, semaglutide is a GLP-1 receptor agonist. Tirzepatide is primarily a GIP agonist, and with molecular mimicry, 1/3 of GLP-1 activity is also included in it. So it becomes a twin cretin. It has both GIP and GLP-1 activity. When we see a pure obese individual, the results of tirzepatide are superior to semaglutide for weight loss. But when we see an obese individual with comorbidities, which I have told you in a slide, cardiovascular disease, MASH, semaglutide has proved beneficial effect, tirzepatide is not approved. For teen obesity, it is semaglutide which is approved, tirzepatide is not approved. But when it comes to OSA, tirzepatide is approved, but semaglutide is not approved because there is no data. But when you see the trials, you have number of trials, number of data available, that even with use of semaglutide, you can see similar type of benefits in patients who are suffering from obesity and OSA. Now moving from that to orlistat, it is one of the most useless drugs for treatment of obesity. The basic fundamental of orlistat is that it increases your lipases inside your intestine. So until and unless your food which you are consuming is predominantly a fat-rich diet, it is of no use. We Indians are predominantly carbohydrate eaters. So that is why orlistat has failed to show any benefit in our population. The maximum amount of weight loss seen with orlistat is only 3 to 5 kgs. On the top of it, it prevents absorption of all fat-soluble vitamins from your gut. So you need to take all types of vitamin supplements. It makes even your stools leaky and oily. So that is why it is no longer preferred as a drug for treatment of obesity.
Thank you very much. I think you have a point.
Sir, I would have one question.
Sir, one question, please. Sir.
So
Okay,
I have,
please.
sir, my question has two parts. First is till how long we have to give semaglutide?
Excellent
to achieve-
question.
And what happens when we stop the semaglutide after reaching our target?
Part of the first question.
Yeah.
So good question. You know, we have to fundamentally understand definition of obesity. What is definition of obesity? It's a chronic, multifactorial, relapsing, remitting, lifelong disorder. So therefore, whatever form of treatment you will start, if you, when you have, say you have reached a plateau or you have reached your desired goal, now you wanted to stop the drug, fine, we can do that. There are strategies for that. But then one has to understand, the patient has to continue with the diet and lifestyle. If patient thinks that going back, stopping the drug, he can eat whatever he want, he will not exercise, he will regain the lost body weight. So we are not going to change the genes. The basic fundamental of obesity is 70% of your weight is determined by your genes. 30% is your environmental behavior, eating pattern, exercise. So we have only control for that 30%. So it's a truth, it's a reality that we have to tell to our patient. You have to continue with diet and lifestyle. There is a new study which have shown that suppose patient has lost more than 20% of body weight or desirable body weight on these drugs. Patient has used these drugs say for 1 year. Now he wanted to stop because of cost or whatever is the reason. There are old generation of anti-obesity oral medications. They can be started and patient can continue to maintain that lost body weight. So there are many strategies, but one must remember that rebound is a reality.
So in your practice, do you recommend semaglutide for how many months or years?
We do not give any such type of guarantee to the patient.
So because patient asks.
हाँ हाँ बिल्कुल बेटा ठीक कह रहे हो सुनो तो सही. Whenever we recommend and we prescribe such type of drugs, understanding that this is a chronic lifelong disorder. Number two, there is a recent publication in Nature where they have studied some 10 to 15% of the patient even does not respond to these drugs because you have genetic polymorphism for GLP receptors in the body. So first of all, we tell to our patient that based on data, there is a possibility that you may lose more than 20% of your body weight in next 6 to 8 months. But whether you are going to lose 25% or whether you are going to lose only 10%, that follow-up will tell you, plus how much honestly you are doing your diet and exercise. Also, we always tell to our patient that whenever we are going to stop this drug, always remember you have to continue with your diet and lifestyle. Otherwise, some degree of rebound is going to happen. It's a reality.
Yeah, I'm sorry.
So
I
there's a
think
side
I
effect-
think I have to give the audience to the panel.
Yeah.
Thank you for asking those two questions. I think we have to give
So actually, there one more question.
अभी करेंगे बाद में. I am here only.
Sir, thank you for your session. I do have a comment to make, and then also, sir, we've also, with obesity, we also talk about the cardio-kidney metabolic syndrome. Where do these new drugs, because right now we're talking about single drug and dual agonists. We will move into a time where we'll have triple agonists like retatrutide, and we'll have more drugs like xanogametide and amylin. Where do these drugs do they fit in patients with comorbidities like CKDs and hepatic issues?
See, in obese individual who have cardiovascular disease, based on select trial, drug is now approved both by USFDA and DCGI. So anybody who is obese, who have sustained a cardiovascular event, you can start this drug or even to prevent future cardiovascular event. There is also a dedicated CKD trial with semaglutide where it has been shown that with use of semaglutide, 3-point combined renal endpoints are reduced by 24%. So therefore, in all these comorbid conditions, we can use this drug, But remember, in those patients who have progressed to ESRD, who are on renal replacement therapies, we do not have currently dedicated RCT trials, although we have small center individual studies.
Okay, thank you. I think the time is up. If the organizers agree, I can just allow one question from the panelists. Yeah.
One last question, sir.
Sir, my question is, if desired weight loss is not achieved, desired weight loss is not achieved, and you say 2.4 milligram is the recommended dose, do you suggest that we should increase the dose? And the second question is,
I cannot get your question. If weight
my
loss
question is like 2.5 milligram is the dose which has been recommended. If desired weight is not achieved, do you recommend to increase the dose?
there is no point. Even if you have gone up to 2.4 milligram and there is no weight loss, we do not expect that up titrating the dose up to 7.2 is going to be beneficial. Remember, again, a take-home message for you. Whenever you are starting any anti-obesity medication, if in 3 months, patient does not loses more than 5% of the baseline body weight, that drug is ineffective for that individual. Please stop using the drug.
Okay, I think in lack of time, and I have been told by the organizers, I think we might have to end the session because we are just out of time. And it has been a very wonderful session. Thank you very much, Dr. Rajput.
Thank you for everyone.
For enlightening us on this topic. And expert panel, thank you very much. And the audience, well done. Thank you.
So thank you to the moderator and the panelist. So the next session is going to be very exciting. This is a new session which we are bring up. So it's a respiratory crossfire, new ILD classification, precision or confusion. Do we have a question? The poll question? Survey? Yeah. So we did the polling and these are the responses. So I would like to invite for the hot seat Dr. Vaishal Seth. And to moderate this session, we have Dr. Sonia Dalal and Dr. Asmita Mehta. So Dr. Sonia to be on that side and Dr. Asmita will be on that side. And we have two teams. So team A, Dr. Pradeep Dabi, Dr. Mansi Gupta, Dr. Devraj Jash, Dr. Subin Ahmed, and Dr. Siva Prakasam Algasan. So the team A will sit on that side. Please be on the stage. Team A. You want team B? Yes. Okay, then please interchange. Then in team B, we have Dr. Navreet Kaur, Dr. Milind Baldi, Dr. Sejal De, Dr. Navdeep Labana, and Dr. Sudhir Kumar Agrawal. So team B on this side. So now I hand over the proceeding to our moderators. Can you show the poll question, the survey? Yeah.
May I please invite our audience poll and referee Dr. Nagarjuna Matru. So, it would go like this, that we have team A, wherein Professor Jenkins is going to talk on precision, and we have Professor Morris Perdella, who is going to probably confuse us. He's going to tell that this is a confusion on the new classification, and we have two teams. The format would be like this, that both of the speakers would finish up their talks, and then we would probably have a crossfire debate amongst the panelists. So, team A would ask to the panelist of team B, and team B would ask to the panelist of team A. Before that, we had this poll question, which is new ILD classification is about. We have around 39% saying less idiopathic, 26% tissue-less, and 34.8% were telling it's more about confusion. So, Professor Morris, most of your work has been done by the people. It's more of the confusion on the poll, which is there. So may I please invite Professor Jenkins.
So that means I can go off the stage then? Or?
I'll just take one sentence that we were taught in the childhood that necessity is mother of invention, right? And when the newer thing comes, it should come for making your life easier, not complex. It is almost 1 year since this new classification came, but the controversy has not become old. And for solving that controversy, we all are here. And over to Professor Jenkins. Thank you.
So, thank you. Well, it's a great pleasure to be asked to argue in favor of something that I do not believe in. So forgive me if I get it wrong. So what am I going to say in support of the new classification? Well, much of the new classification is really good, mainly the things which weren't changed from the previous classification. But I think it is important to recognize that the CT patterns that are used to help us make a diagnosis are not pathognomic for a single diagnosis. And the importance of this is that we have to remember that what we're trying to do is help the patient sitting in front of us. And the most important part of that is taking the history and doing the examination, and then integrating the information that we get from the radiology with that, and to a lesser extent, pathology. But most of it can be done by taking a good clinical history, recognizing that you can get the variety of different CT patterns in different diseases. But the history and examination is critical. And I think if the new classification helps us do that, then it's actually been a force for good. Some of the simple changes, so the change from DIP to AMP, so desquamative interstitial pneumonia to alveolar macrophage pneumonia, that's straightforward. The pathology, when you get it for DIP, is full of macrophages. That seems like a very simple and appropriate change. The detail around PPFE is also helpful. When I was training a long time ago, the pattern that we now call PPFE was observed, but it was just called upper zone fibrosis, and it didn't give us any indication of what might be underlying that. And so now we know that there's pleuroparenchymal fibrosing elastosis. We know what the pathology is. There's a lot of elastin fibers when you look for them, and we know what the natural history is. So I think that's really useful. We've changed acute interstitial pneumonia to diffuse alveolar damage, and the reason for that is that diffuse alveolar damage, again, is a pathological description of what we see when things go rapidly wrong in patients with ILD. Now, acute interstitial pneumonia describes a disease behavior in a certain circumstance, and therefore wasn't reflective of the broad range of conditions that can occur acutely. So we can see this with anti-MDA5 related pneumonia, interstitial lung disease. We can see this with acute exacerbations of idiopathic pulmonary fibrosis. So again, it was about broadening the scope of what we were dealing with. And I think what is useful about the change from HP to BIP is that there is implicit acknowledgement. It's not explicit, but it's implicit that in many cases of fibrotic HP, there is little evidence of ongoing hypersensitivity reactions. Now, this should be important moving forward when we think about how to treat fibrotic HP, because it's implied that inflammation is not playing a role, and certainly my experience is, and I'm sure there are many with many much more experience in the audience, that giving immunosuppression and steroids to patients with chronic progressive fibrotic HP doesn't help the patient. So I think there are some good things about it. And what's really caused the controversy? Now, I think, this is a big document. There's a lot of stuff in the new classification, and it's really only this which has caused the trouble, and that's bronchiole-centric interstitial pneumonia. So just to quickly run through, BIP is a histological and radiological pattern that is suggestive of non-fibrotic and fibrotic HP. The classification, the name BIP in 2025 is very different from the original term proposed in 1969. So you can't look at the old literature to think about BIP. BIP defines the histological and radiological pattern of airway-centered interstitial pneumonia, hence the bronchiola-centric. It's seen primarily in the settings of HP, but can also be observed in CTD-ILD, aspiration, inhalation, and medication exposures. BIP is not a new pattern, but it is a new language. So we saw this before. Actually, the precision hasn't changed. The description is exactly the same. It's just we've given it a new name. And it's proposed that if you have BIP in the right clinical setting, it becomes HP. And this relies on the multidisciplinary team. And it also recognizes that in HP, you can also see UIP and NSIP. I think where it gets a bit confusing is that you can have non-fibrotic BIP, cellular BIP, which is ground glass opacities with mosaic attenuation, which we used to call HP pattern, or fibrotic BIP, which is the same three-density sign, but with traction and evidence of fibrosis. Now, I think what's causing some of the confusion is that it has been reported that CTD-ILD can have a similar pattern. But in the series described in the new classification, it was only 9%. So still 90+% of BIP pattern is going to be HP. So when we think about, does this new classification lead to increased precision? And if we think about what precision means, it has to be exact. It has to be repeatable and consistent. And I think certainly the new classification gives us that. It gives us consistency and it gives us defined definitions. But it's important to remember that precision does not equal accuracy. You can throw the dart 100 times and miss the target. As long as you hit the same place, that is precise. So I don't think precision is necessarily what we should be looking for. We should be looking for accuracy. We want to get the diagnosis right. And does this help? Well, I don't know. I don't know if it makes it better or worse. And this picture is the deck chairs on the Titanic, and it does have that kind of feel. So I think what is not good about the new classification is that it anchors everything in pathology. And this is problematic for two reasons. One is that the only test that we can guarantee we do on every patient who presents to the ILD clinic is the CT scan. Every patient gets a CT scan. In the UK, less than 10% get a biopsy, probably less than 5%. So we are anchoring on a test which 5% of our patients get. It may be higher in India, it sounds like it might be, but it's not. Why are we anchoring on a test which most people don't have? And the vast majority of ILD diagnosis will be made on clinical history and exam. I put it to you that if you are concerned that your BIP radiology pattern is due to CTD, you'd be better off doing a full history and examination and looking for Raynaud's, looking for dysphagia, checking the serology, than biopsying and looking for lymphoid follicles. And I think changing established nomenclature and the associated historical data and evidence of 20 years prior, because it creates uniformity of terminology, which is the classification document's phrase, not mine, is not a good use of people's time, just to make things neat and tidy. And I think we should perhaps have waited for more evidence, waited for more biomarker studies, waited for the omics technologies before changing this classification. So BIP versus HP. Apparently, BIP allows for better characterization of cases that are not HP. Well, I think there are some circular arguments here. If you change the name, of course you can better classify it. And I think this is inferential, not precision. And it also very much depends on how things are defined. It will support further studies related to the provisional clinical entity of idiopathic BIP. Well, of course it will. If you can't study something that didn't exist. You can decide whether you think this is a good thing or a bad thing for precision. It will encourage a more precise classification of HP. Well, I don't think it does, actually. I think we still have the same, the descriptions are the same, we just call it BIP. In the clinical context of HP, it's HP. Again, other people may disagree. And it provides a framework for future research to define the features of BIP. Again, of course it does, because you've created a new disease, people are going to study it. Is that a good use of time? Again, we can argue about the rights and wrongs of that. Importantly, although some cases of previously labeled HP will now be classified as idiopathic BIP, the proposed change in terminology does not alter the diagnostic approaches taken in the recent HP guidelines. This is a critically important statement from the classification. It basically says, although the terminology has changed, diagnosis and management hasn't. I think that's very informative. So I think it does create confusion. I know I'm meant to be arguing against it, but I genuinely cannot argue in favor of something I don't believe in. I just can't do that, and I apologize. Some patients will have a highly specific biopsy findings in support of HP despite absence of etiological exposure. Absolutely, we know that, and that is so fundamentally important. We have to look for potential etiological exposures in this situation. And it may be that we just haven't got the information yet to really say what the diagnosis is. And we know, I was listening to the previous talk on obesity, we know that the genetic drivers of fibrosis are critical here. It doesn't matter what the etiology is. If you're going to get fibrosis, you're going to get fibrosis, whether it's smoking, whether it's pigeons, whether it's mold. And I think there is insufficient evidence at the current time to support adoption of BIP. So I noticed the HP service station on the journey back from Jaipur to Delhi. It was a great trip, thank you. So I welcome HP as the diagnosis. And I think we should anchor our classifications on radiology, not pathology, because it's the only test that we can do. And anything which encourages us to do more biopsies encourages us to take risk with our patients. It's our patients who suffer the consequences of the biopsies. So we should only be doing them if we really need to. So if we really need to make a diagnosis which alters management. I don't see a huge amount of difference between the current treatment guidelines for chronic HP and CTD-ILD. They will get steroids, immunosuppression, and an antifibrotic. And we can make the diagnosis of CTD without doing a biopsy. In fact, it's almost contraindicated in the UK to do a biopsy in someone with CTD. So outside of BIP, I think the new classification is great, but I think BIP is a problem.
Professor Jenkins has made Morris's life very easy, I suppose. All yours, Morris, to create the confusion.
Yeah, thank you very much for the great talk of one of the leading experts in the field. And now I, as a radiologist, I don't have too much to add because you basically gave a great overview over everything, but maybe a little bit from the radiology side. So to put it in my words now, it kind of repeats what you've been saying. Basically, the new classification puts like the imaging pattern over the disease. So these are the examples from the classification here, well, like a few of the examples. And I guess for radiologists, it's easier now. So I basically look, do I see such a pattern? I put it in the report. I'm done, right? Then I don't want to get into too much detail about the BIP pattern because you talked about it so much, at least on this slide. I think what's also new is like the differentiation between the idiopathic and the secondary disease. We also have the updated terminology you mentioned. And then you also have this like combination of patterns here. So you can basically combine everything with like anything with anything, or everything with everything, or whatever. And if you look at it, I think what it basically does is it might make the pattern description from the imaging every patient gets maybe more precise, but the differentials get broader. And this goes into what you were saying about it depends, I think, also on the center. I don't think that in like an expert center, this will probably change a lot of the workflow. But if you will think of like centers who do not see that many cases, they might be tempted to, because of these broader differentials, to then biopsy or do anything in regards to the management of the patients which would not be, or wouldn't have been done without these new guidelines. And then there's also, and I'm not an expert of that, but if you think about the diseases, if you think about the biology, and we heard a little bit about phenotyping yesterday on the ILD workshop, it is, I think, to me a little bit like they want to make a quite complex topic easier at the cost of more diagnostics. And yeah, I'm not sure if to make the pattern more precise actually then ultimately leads to more precise diagnosis, or given what I just was reminded of in the talk, more accurate diagnosis than precise diagnosis. And then maybe just as a little addition to the whole BIP topic. So these four authors, you're aware of it, they withdrew their authorship from the new guidelines, and they wrote an editorial basically which was published just after the guidelines. And these four people, they are all in the HP guideline committee. And for them, it's maybe just to chime in on what you were saying, they felt so uncomfortable about the new guidelines that they decided that they don't want to be associated with it, because they were also on the HP guidelines committee, and rejected the authorship, wrote this editorial about it, and you summarized a lot of things in greater detail than I did here on the slide. But I think one of the points here is we have been talking a lot about more diagnosis, right? But what they also focus on is that when you change the pattern from HP to BIP, you actually might, well, in most cases there's no ongoing exposure in HP, but in cases where there's still ongoing exposure, it might demotivate the physicians to look for the harm here. And that's maybe a little other nuance of what you were saying before. So I think we should now go into the discussion, and I want to look at the moderator. Do you want to take over? Yes. Or?
So the format is Team A would ask questions to Team B, and Team B would answer and ask the question to Team A. You all feel that the new guidelines, you are in favor of the new guidelines, and they all think that it's confusing. So can we start with Team A? Dr. Mansi, would you like to ask a question to our panelists over here? I can't hear you. You will have to.
So I'm saying that we are supporting the guidelines for its precision, and they are against that it provides any precision. So I'm supposed to be asking them a question, and
Yes,
they will
that's
give
correct.
their.
That's correct.
Okay,
Yeah,
sure.
that's correct.
So this new guideline, when they are trying to define the disease more in terms of the morphological diagnosis, giving more importance to the radiology and pathology. But then there are some positive things about the guideline, is that it's what a clinician was already feeling during the treatment regarding the inflammatory and the fibrotic phenotype, which will behave differently in long term clinically in a patient. That part is a little bit more dealt with precision, which was earlier in previous classifications, it was all just about a diagnosis. So as a clinician, I like that aspect of the guideline, and would you like to differ on that?
Interesting part is that when I downloaded these guidelines, I was really amazed, because this is the third guideline. First was in 2002, then 2013, and now 2025. And Ganesh Raghu was there. He was one of the 34 experts, 32 plus 2, 34. And he has himself written in European Respiratory Journal about the word we are using, BIP, and that BIP has replaced hypersensitivity pneumonitis. He was himself amazed, and he was one of the members of that committee. Now, if you read those guidelines, that 48 pages in PDF format, they have themselves mentioned 12 questions. They have asked 12 questions about BIP itself. And one of them, the 11th one is lung biopsy necessary to establish a confident multidisciplinary diagnosis? And more research, and they have mentioned that more research has to be done. Another is, what is the radiological pathological correlation of BIP? And first of all, what is BIP? We are talking of BIP. What is BIP? BIP is inflammation occurring in the center of bronchioles. This is BIP. And it has replaced hypersensitivity pneumonitis. And this is, we are familiar with hypersensitivity pneumonitis, not with BIP. And there is a fight going on between BIP and UIP. This is what it says. And another thing is changes occurring in that there is another word called AMP. Now, in AMP, it has replaced DIP. AMP, that is this the alveolar macrophage pneumonia. And third is idiopathic pulmonary alveolar damage. This has replaced AIP. And what is the reason behind this? Why they have done this? I'm amazed. And
so yeah, I think I can come to the next question. Is, as we are all clinicians here, and if I may just ask you, how is this classification, be it precise or confusing, helping us in treating our patients any better?
We haven't got the answer for my question. I will clarify what exactly I was asking.
What we'll do is, I mean, Mansi will take expert opinion from both the speakers first, and then he can ask the question.
Just let me finish this aspect that precision has come a little bit in terms of prognostication, but yes, everything, it's a consensus statement.
Correct.
So there is no evidence-backed thing and still evolving, but they've tried to stratify the morphological pattern. The disease behavior does not only depend on morphology.
Sure.
There are patient factors and other things, but does it simplify it a bit for the people who are practicing in large scale? Yes, it does.
Sure.
Devraj is
Jenkins,
answering
would you
this
like
question.
to comment on this? And Professor Morris, you too, to her question.
I'm sorry, the sound here is not perfect. So you were talking about the pattern and how it would help the treatment of the patients. Was that the question? Or can you, sorry. Or can you then please repeat your question?
You repeat your
I just asked that the guidelines, do they help in predicting disease behavior in a way, or a progression, or a phenotypic behavior? For a clinician, it is important how disease is going to behave rather than just having a morphological diagnosis. So does it help in any way? Yes, it does. That's my point. Not completely, but partly yes. Since I have to defend this side, so yes.
Your voice is echoing.
Okay.
Can we change the mic because your voice is echoing and we are not able to hear properly? But that's okay, that's fine.
Okay, that's good. It's not just me. I'm very sorry, but I have problems to understand, and it's the same for you. Or can you maybe?
Actually, I'm supposed to be neutral as a chairperson, but I'll put it in a better way. What she wanted to defend from
Sumit, can you do one thing? Can you come over here and ask the question, or your because the thing is it's echoing over here. It's very difficult.
Actually, I'm supposed to be neutral as a chairperson. I just want to help Mansi out. What she meant is, speaking for the classification, as a clinician, this classification has brought out some significant things when it comes to the disease behavior. It was not there in the previous classification, be it 2013 or 2022. So, as a clinician, a fibrotic HP or a fibrotic NSIP, both won't be behaving in the same way in different patients. So this classification, they help us to do the real world MDD, and they specifically look at the longitudinal disease behavior, how the disease progresses. So that's what she wanted to defend for the classification, if I am right.
Okay, thank you. Now I think I got what the question was. But I think, like, my understanding was like the disease behavior was actually taken out of the classification, wasn't it? It's a little hard for me because I'm not treating the patients. Maybe I can look at my panelists, my co-panelists, and ask you, what is your take on that?
What I remember from the classification is the cellular and the fibrotic components of the disease which they are talking about in terms of disease behavior, which has been there since long. I mean, it was maybe not there in the 2013 classification, but it has been there and we have been practicing. I don't see how this classification has changed the way we would manage the patient any differently henceforth, or giving it terms that way as well.
I think what they were trying to do, and so I have to put myself in their shoes, and I know them all very well, so I can kind of, is they like to think algorithmically. And a lot of clinicians like to think algorithmically. So you have a yes-no decision. So clinical history, is it ILD? Yes, no. Radiology, is it BIP? Yes, no. Pathology, is it BIP? Yes, no. Then you integrate it all together and you get your diagnosis. I think the problem is, if you think like that, it works beautifully. But the other half of the world, myself included, don't think about yes-no answers. I think probabilities and scales, and it depends on the patient in front of you. So I think it was a well-intentioned way to organize thought as the key opinion leaders driving this piece think, but failing to recognize that many of us think in a different way.
So we all believe and know how ILD behaves. It's a heterogeneous disease at the end of the day, and there can be no yes-no algorithmic approach. There are so many overlaps, so many patterns, different patients would behave differently, and we are trying to box things here, which is a spectrum. So it won't work. And the other thing, again, which comes, the degree of agreement, if we talk about them amongst different pathologists, radiologists, and clinicians, MDTs as well. The kappa is about 0.5 for different MDTs. And now we are adding more layers to it. We are adding more spectrums, more level of confidences to it. So we are giving more opportunity for that level of disagreement to come. So it is, by design, going to be confusing until it is proven that, yes, consistently this classification is working at putting the boxes right. I don't think we can call it precise.
I think we can take questions from the audience. Before that, I would like to ask the audience, how many of you think, with your raise of hands, this clinical, this new classification has changed your clinical approach? How many of you think, with a raise of hands? Very few. Very few. All right. So
ask the other side also, Sonia.
So I think change is always difficult. Don't you people agree? So to say something which has just come for 1 year and compete it with something which was there for last 10 years, let us give it some time.
I agree with her, and you didn't ask the audience how many find it confusing. There may be people who don't want to answer at all. So some people, 50%, more than 50% wouldn't know exactly the guidelines would work or not.
See, one good thing about this classification is, initially it was all about idiopathic interstitial pneumonias. No, we get there is a whole lot of other UIPs, NSIPs and OPs and DADs and all those things. Nobody was talking about it. One good thing which has happened with this guidelines under the leadership of Chris Ryerson is, we as clinician will have to look at the other interstitial pneumonias as well, not just centering about idiopathic interstitial pneumonias. That is one good thing which has happened. But again, taking a neutral note, speaking for you as well, it's not validated at all. It's about expert opinion. It's about consensus of expert opinion at different confidence levels, where voting has been finalized at 70%. That means a substantial minority of 30% still disagrees. And if I'm correct, correct me if I'm wrong, like even those experts who were in the panel committee, they have deliberately opted their name out of listing as co-authors in the guidelines because of difference of opinion. So on a neutral take, what I would say is, of course, we are looking at other interstitial pneumonias as well, not idiopathic. Then again, this has to be validated, and grading should be done with good scientific literature
Subin, backing. Isn't it not creating a confusion between HP and CTD-ILD the moment you say the pattern is BIP? And we see maximum number of patients of HP and CTD-ILDs in our country.
But how is it confusing you? It's just a morphological pattern which is CT dependent. Diagnosis is not given by this classification.
MDD also, there is a lot of confusion which has been created, Mansi, in the MDD also.
No, ma'am, you're getting it all wrong. Clinical diagnosis is not just the morphological pattern.
See,
clinical diagnosis will depend on the clinical features, the behavior of the disease and the patient
times
is
you don't
coming.
get a clinical feature. Let's talk about IPF
So
then.
no.
Yeah.
The thing is
They
that
have made it more systematic in the sense they look at the they look whether it's interstitial or alveolar filling, or they look at the pattern, and then you go to the diagnosis only after an MDD, which is a good thing.
It's a good thing.
I would beg to stop the verbal duel. So my role is to be a referee for this debate. I'm happy that this has been brought out. So as a referee, I myself am confused after hearing to both the groups. In fact, both the professors have more or less spoken not in complete favor of the new classification. So before we can take any final verdict on whether this is good or bad or neutral, I think one more rise of hands. I would want everyone to raise hands. I will give 3 options. First option, has the new classification been helpful to clinical practice and precise? Yes. How many would raise? Okay, now there are little more hands. Okay. The second option is the new classification has not been precise and led to more confusion in my clinical practice. How many of you say yes? Okay, equal. Okay, the third option, I don't know whether it is precise or confusing, like probably where I am. How many will raise hands? There is some. So I think that is where we are now. So this new classification, I would agree with both the groups. Both the groups have very strong points in either's favor. So this is not an etiological classification, it's a pattern, And whenever a new pattern is introduced, any new thing is always debated till more evidence comes, and then we probably will accept it. So maybe the same debate we should do after 5 years with more data supporting the classification of BAP as a separate entity which needs to be handled differently. We don't know that. So it's an expert consensus that BAP is a new term. So though we may start classifying patients as BAP because we have seen a lot of these so-called BAP non-HP patterns. But I think on a very neutral note, we would probably accept the classification with a pinch of salt, and then we would use both the old ones and the new ones, and then not rely on only one classification to decide what is best for our patient. I think that is how I would put it. Hope everybody will agree, and the moderator also should agree with what I'm telling. So I think we are probably ending this.
BIP is getting a lot of stick, but on a neutral note, it's not the BIP which should be avoided. It's the idiopathic BIP classification which has creeped in.
So we'll
that
not
should
talk
be avoided
about idiopathic and
with more
secondary
evidence.
because that is a huge thing altogether. But the main thing why we're talking about BAP because that is a predominant change which has come out. A lot of other things are terminology changes. Yes, Professor.
I was just going to say, I think in relation to the prior point about the CTD BIP confusion, I think one area where it may help is if you have a patient who you think clinically has got CTD and a CTD-related ILD, in the old classification, their radiology would be described as a fibrotic HP pattern. And that did lead to diagnostic confusion because you had a CT which was providing you with an etiology, i.e. fibrotic HP, but a clinical picture which was looking like CTD ILD. And so marrying that together was tricky. So at least now, it recognizes that you can have a pattern which may be more familiar and more often associated with HP, but can be seen with CTD. So it isn't going to create, so in that respect, in that small percentage of patients, it will add some clarity.
Sir, I would totally agree with you because that has been our experience also. So we had a lot of patients who would fit in with this typical BAP pattern, but they would also have some CTD. Earlier we were calling it HPAF. I think Dr. Dumra is fully agreeing with me, and that in that context probably yes, but people can still argue that this term needs further validation, further prognostication, further treatment validation and so on and so forth. I think we have one question from the audience and we have only 1 minute before we can wind up this session. Yes, Dr. Khurshid.
Yeah. Very nice comparison and discussion. Just one comment. 5-6 years back, we had seen signs like we used to treat patients as. Am I audible?
No, you are audible. Yes, please.
I'm saying few years back, 5-6 years back, patients used to label as IPF. Then we saw secondary UIP like 4-quadrant sign, exuberant honeycombing. When it became, everybody came to know that this is the thing. We came to know it's secondary UIP. Same is the change like here. These changes are better. I recently saw a few patients like DIP, earlier known DIP, now AMP. They were female patients, extremely evaluated. But once you use new classification, you help them easily diagnosing them. I think these changes, new changes are better for a diagnostic workup overall.
So actually he's in favor of the new classification that if we have a terminology called BAP, it will probably help us narrow the differentials to a certain group of diseases. So that's a point in favor of the new classification. I think at this point of time, probably we will agree to it, but again we will end with a very neutral statement that this is a new classification.
Let us wait and see. Yeah.
Time changes, so we don't know whether the next classification will retain this term or change this term.
Correct, correct.
But we will always look at any evidence with a pinch of salt, and we'll look forward for more validating data to it.
Change is difficult, but change is universal.
Yes,
Can we have one editorial comments from every panelist, please? One editorial comments. Yes, sir.
I think this, as Madam rightly pointed out, change is initially unacceptable. We'll wait and see. And the new classification gives us to label almost every patient and fit into the category. So let us see how it works. Pattern, we familiarize with the pattern, and then we'll go ahead with the further classification.
And you must have a good MDD as well. Debraj.
We need to observe over a period of time. Only what Dr. Nagarjuna told, that down the year, 5 years time, probably we will be in a position to say whether the classification has helped us or classification has missed.
Correct. Correct. Mansi?
I think the same thing. Before discarding anything, we should first try and reclassify, like what Dr. Dhar has already done. We are also doing it. Reclassify your patients. Again, with this classification, see the difference for yourself.
Fair enough. Subin?
There are certain good things in the classification, as in it is completely gone away from the pinpoint of idiopathic interstitial pneumonia to all interstitial pneumonias, one thing. But the way they did it, based on confidence levels, consensus levels, without grading, without good backing of scientific literature, that won't go for a guideline thing. So they have to work more on it and come with more graded evidence and scientific data-based evidence rather than expert consensus and confidence levels.
One statement, please. Sir, your comment. Final comments.
What I feel, more research is needed, and that is essential at this stage. And what I told earlier, that 32 experts plus 234, they gave sufficient time, and now only this research will help all of us. And this is not so simple, but let's see. And with this, I think
I think we have a topic for PACS 2030, the next debate in 2030.
Makes sense, yeah. So we'll now have final rebuttal remarks from Professor Jenkins and Professor Morris.
I want to add just
please come.
one point.
Make it, hot
no,
seat.
It's okay. So actually I'm a neutral guy on a hot seat, but I will favor this panel in my practice because it is easy to debate these topics on this forum, but it is very difficult to implicate on ground level. When I started practicing, I was asking my radiologist to make pattern, this is HP, subacute HP or chronic HP. Then I told him, now it is not this classification, now it is non-fibrotic HP and fibrotic HP. Now to tell him again that you stop writing HP, now you focus on BIP. So it is very difficult on ground level to make radiologists understand. So once we have AI in radiology, I think we can implicate whatever pattern we have in classifications. But by the time we have to still continue with the old classification, and like Madam has said, once time will evolve, we can accept this new classification as well.
Closing from Professor Jenkins and Professor Morris. Closing, sir.
So I think a really good thing about the new classification is it has created debate. And I think it does make us realize that we need to learn more and do more. And I would say we do need to do more research to find out what drives progression of these diseases. But let's not spend all our time going back and reclassifying stuff. Let's get new information which really helps us understand the disease for our patients.
Professor Morris.
Yeah, so I just had a thought giving the discussion, and especially what you said, and I just want to share it with you. I was wondering if it's maybe easier if we have like some postgraduates, and we've been talking about the focus on postgraduates, and they have no idea about what was going on 20 years ago or 10 years ago. Will it now be easier for them to get into the ILDs or not? And I just had the thought it might be easier for them to get into it. While most of us probably don't agree, right, with what from our perspective, and this will be also then in 2030 to be found out, and then maybe a question for the poll.
So thank you very much, everyone, to my esteemed panelists, Professor Jenkins and Professor Morris. Thank you all.
Give a big round of applause for all of our panelists, speakers, the moderators. So the next session will be on the complex breathlessness. Why is my echo patient breathless? So to moderate this session, we have Professor Randeep Guleria sir with us. Do we have? So, can I request Dr. Richa to please moderate the session because Professor Guleria is not here. And our expert panelists for this session are Dr. Naved Nazir Shah, Dr. Ashwani Mishra, Dr. K.K. Sharma, Dr. Animesh Arya. Please, sir, join us on the stage. And the chairperson for this session, Dr. Kapil Sharma, Dr. Agam Shah, Dr. Anukul Jain, and Dr. Rahul Gupta from Jammu. So I hand over the proceeding to Dr. Richa.
Good afternoon, everyone. It's my pleasure to call upon Professor Gary Coughlin on the stage, Professor Michelle Chatwin, and Professor Richard Russell. Professor Michelle, she's not there. So this session is on complex breathlessness. Why is my echo patient breathless? I would ask our expert panel speakers, Professor Gary, to come and talk on. Or we can just have the discussion based on the patients, or we can just have. Just the discussion.
So it's primarily a discussion on a patient who's breathless and he comes to a respiratory physician and COPD is perhaps the diagnosis and we go about it and things don't do well. That's the situation. And that's why we wanted so many people to see that. Is it that it is COPD where the patient is going to remain breathless? We should ignore it. Is it there are other options available for us to elevate the treatment? Or is it the time to get the multidisciplinary team and involve other people to find out what is this additional things which we can do to look into that? So I think Richa, you also come here.
we just give a situation? Shall we give a situation?
Yeah, a patient on triple therapy.
So let me ask a question, and it's a very, very like what we see in our clinical practice. We have some 60-year-old gentleman who's an ex-smoker with significant history of smoking, say 25 pack years, have left now. He's been diagnosed to have COPD, was on treatment with LABA/LAMA, had exacerbations in past, and now patient has been put, we have been discussing about triple therapy. Patient is on triple drug therapy, but still complains of breathlessness. So this is what is a situation, and we want to carry forward the discussion. How do we approach this patient, or what we should be doing? What are the different aspects? It is just the COPD, or there are some other aspects also that we should be looking into it. And patient is also doing his pulmonary rehabilitation, say thrice a week, if not daily.
I think this is a very extempore kind of a session that you see patients who are on COPD, they have been given treatment, they are breathless. And today, Professor Richard has already shown us that, you know, the cardiovascular is so important. So what are the thresholds to evaluate from cardiac side, how to evaluate, and how to be sure that we are not missing the cardiac thing? Because this is a very common happening that this patient, you tell them, okay, everything is going on fine, they go to cardiology, they say everything is fine, and he dies. And obviously we know that this is a cardiac death. So like, are there some things which can be indicators to let us be more aggressively looking for cardiac aspects of this patient, and how?
So let's first of all maybe say this is not always easy, and it is difficult because in the diseases we're talking about, where there is end organ damage, whether that's cardiac disease with heart failure due to either ischemic origins or hypertensive origins, there's damage, or valvular disease, there's damage. And obviously in the context of COPD, where there is damage to the lungs with impaired not only obstructive lung function, which is only one aspect of COPD, I'm talking about this tomorrow, but also the emphysematous change with transfer factor abnormality, that also will impact and cause breathlessness. So it's really important to unpack those things as best you possibly can. And also, it's been mentioned about rehabilitation, taking on board the other comorbidities that can go with age, which are frailty, obesity, metabolic syndromes, renal disease, all of those other things which can also impact on the overall well-being and breathlessness of the patient. So it's hard, and being realistic with our patients, as well as having realistic expectations of our patients, is also really important.
Yeah.
But I do think, going back to your point that's been said, it is about, we have to do our jobs, and we have to do the aspect of our disease that we best possibly can. What I don't want to have happen is a ping-pong game between cardiology and respiratory. It's not my problem, it's your problem, it's my problem, it's your problem. That's not helpful. So it's really important to systematically assess and categorize patients, helping each other out with sensible investigations which can help me define the cardiac aspects of the respiratory problem. So I will do lung function. I'll look at the whole lung function, including volumes and transfer factor. If I'm suspicious of asthma, I want to diagnose asthma, because it's different and it leads to different prognosis and different treatments. Right. And then, as people get more advanced with their COPD, I will absolutely be looking at the heart to not only look at the left ventricular function, but also to look at the right heart function particularly as well, because pulmonary hypertension clearly can play a role. And I haven't mentioned imaging, but imaging is also important to give you a full picture if there's tuberculosis damage or bronchiectasis or other things that contribute, which may change what I do. Remember, you have to put a test in the context of the patient, and you also have to have a test which helps you make the next clinical decision. Otherwise, it's actually just a waste of time. And so that's really important. I would not do Jerry's job, but I would certainly begin by doing simple cardiovascular tests, for example, a BNP test. An ECG is a fantastic test for cardiac disease, and of course an echocardiogram. And I use those, as I say, particularly to look at the right heart, perhaps more than the left, because that's more of my area of interest and expertise. So that's what I would do from understanding the breathlessness of the patient, but putting it, as I said, as you did as well, in the context of the patient, from the functionality, the rehabilitation.
Right.
A very famous respiratory physiologist from Canada once said to me, you know what, you can bronchodilate, you can optimize lung function, but unless you get them off the sofa, unless you get them exercising,
Yep.
it's a complete waste of time. And he was absolutely right about that. We have to put it all into the context of the patients as well. So that's the approach I would take.
So let's ask our Indian experts that how do they see this kind of a challenging situation which comes almost like every day in our life? And of course, I think he very rightly said, it's a ping pong basically. They keep running to two OPDs. And in fact, God forbid, if there are two different hospitals, they'll keep going shuttling between two hospitals. So how do you feel this kind of a situation, considering that cardiac involvement is so significant that we really need to be a little more proactive from that perspective? And of course, we can't take Gary's job in any case, but we need to discuss out that, like, how are you taking it in practice?
So in our scenario, what we see first, we have to see that patient is taking the treatment of COPD properly.
No, that's done.
Yeah.
Now you tell me they are doing well, they are already on triple therapy, they are still breathless. How do you look for the cardiac evaluation? Do you go for a cardiac evaluation or you ask them to go to meet the cardiologist?
Definitely, sir, if I am suspecting, if patient is suffering breathlessness due to a cardiac cause, definitely I'll refer to the cardiologist.
No, see, the question is, how do we know it is a cardiac cause? We do not have any idea. So the question is, we start thinking like that, this could be cardiac, because now this is a out of proportion, breathlessness is the word, but may not be very accurate word again. But then at least patient at this time is also a very high risk factor for the cardiac. So that's exactly what I'm asking.
Sir, I totally agree with you. What happens that when a COPD patient comes breathless to us and he's not getting relief, we always think of that there may be technique issues, there may be compliance issues, there may be issues like he may be smoking or anything, but we do not think that the right side of the heart may also be involved. We have to be very proactive from the day first itself for that. Particularly when we ask for echo, suppose I am not doing echo, when I request echo to my colleagues, I will ask him to see the right side of the heart, to see the diastolic dysfunction in more, if there is diastolic dysfunction or not only to see the EF, which they have a very, in our areas, have only to mention, it's echo, EF is normal, nothing, we have to do it.
I think that's exactly the point. You send the patient, they do an echo, and they say that ejection fraction is 55%, your heart is as good as can be, go back.
Yeah. So we have to look at that angle.
Navid.
So we'll look for the right side heart, we will look for the right ventricular systolic pressures, we'll look for any embolism, because there's a good chance of pulmonary COPD patients developing thromboembolic episodes. We'll look for the right ventricular strain pattern to look for the right heart secondary involvement to the lung.
So basic an ECG and an echo are the two things which may be indicating that the pulmonary artery is under stress. So Gary, now here we bring to you that most of the echoes report RSVEP, that's it. So how reliable is that?
So if I can take it from the cardiology point of view, if I can, what I get referred is patients that people feel are too breathless. And certainly the first thing for me is I want to know what their FEV1 is, and I want to know what their gas transfer is. Those are two things I want to know. If the gas transfer is very low, I begin to think it's emphysema or there's some CPFE or there's something else going on, then I might think about, if that's not the explanation, is there pulmonary vascular disease? If the FEV1 is high enough, then I'm going to say, well, that shouldn't really be causing this amount of breathlessness. So the first question I'm always asking is there an adequate lung explanation, which I'm not very good at, but I have some basic rules. And if there isn't an adequate lung explanation, then I'm much more interested in really chasing the heart. The second thing I'd say is that most COPD patients have some cardiac involvement. So whether it's atrial fibrillation, they're at higher risk of thromboembolic disease, so you get CTEF in them, so you need to look for that. HFpEF is very common in this population. Ischemic heart disease, and if they're diabetic, that can cause breathlessness. So you've all sorts of possibilities once you've got a patient that is not able to exercise to the level that their lungs should allow them to exercise.
Yeah, so that brings to Richard this question that HFpEF, where now the new GOLD guidelines recommend to do NT-proBNP, how relevant it is and how much we should use in our daily practice.
It's really important, and it's about the thing Jerry said. It's breathlessness which is out of keeping or in a context, and we have to be very careful with our COPD patients because of their limitations, because of their lung disease. Cardiac disease may be masked. So, for example, ischemic heart disease may be very well hidden until the patient is exercising, but it doesn't happen because they're not able to exercise until it becomes at a critical level and they become a problem. So if something changes, and taking a history each time and understanding is really very important. I tend very much to follow the guidance of the cardiologists I work with, and using the ECG obviously helps. Atrial fibrillation is really important because when someone goes into atrial fibrillation, that will dramatically change cardiac and pulmonary blood flow, which will affect the lungs in a major way. But also, I will use the simple blood test of BNP to actually then utilize how I choose echocardiography and then how I choose referral to my colleagues. We often don't work too closely together in a joint clinic because it's not a useful, because we can screen people out earlier than that, I think. And obviously we rely in the UK very much on primary care colleagues, GPs, who will often screen patients and then go down primarily either a cardiac route or a respiratory route going forwards. But I will certainly follow to a degree what Jerry would say, and actually doing the simple tests and doing the right initial understandings. Now, would I and do I prescribe much cardiac medication? Not much. I will use aspirin. I will use anticoagulants. I will use beta blockers. But for the newer generations of four-pillar therapy, I will tend to send those patients either back to their GPs, who are often very expert at this, or to cardiology colleagues, depending upon the degree of the problem. Because that makes sure they get plugged into the right follow-up systems, having their renal function checked, having a diabetic screen as well, and then moving forwards through those pathways. So it's really important to understand that I will do simple things. I will try and follow cardiology guidelines. We do not need special cardiology guidelines for COPD patients, I don't think. We just need to do what the cardiologists say. And similarly, cardiologists should, in a simple way, follow what we have in our guidelines as well.
Any comment from, like, how frequently you encountered HFpEF in your practice in COPD patients and you ask for a NT-proBNP?
Yes, sir. Like we have discussed, once a patient of COPD who is not responding to the conventional therapy, you have to keep in mind the cardiac cause can be one of the reasons for the breathlessness. And in those patients, we get an ECG done, the echo and pro-BNP level at the routine, and most importantly, D-dimer. That to rule out the thromboembolism. The thromboembolic diseases again are very common. And what in my observation, we have seen that CO patients, D-dimer levels are elevated. Not to a very much high, but they are elevated. So we should keep that in mind.
I think this we have opened another Pandora box. So I will ask Richard to respond to D-dimer because, but before that I will ask that please raise your hands. How many of you in this situation will order an NT-proBNP? Raise your hands. Oh my God. So you can imagine, Richard, it's not an expensive test out here in India, and you can easily get it done with the reports coming out in a couple of hours, actually, not even days. So that's why it is being now frequently used, because we are seeing that most of the times the echo reports normal ejection fraction, and that's the end of it.
And this is a quick question to Jerry. Jerry, in the context of COPD, because I think we have to remember, cardiologists are great at this and great interpretation in context. is the BMP helpful if it is low? Do you ever get false negatives?
Oh, yes.
That's a tough
yes,
one.
certainly. Obesity is the big one. So it can get false negatives there. And the other problem you have is that there are plenty of conditions like, renal impairment, which is very common here, and age, where the BMP can go up and not mean anything. So I think you get false negatives and false positives, so you just have to be a little bit careful.
The point, Deepak, about the D-dimer, again, the context of D-dimer is more important in many ways than the result of the D-dimer. It's so critical to understand that. So number one, let's talk about exacerbations for a moment. If someone comes with an increasing breathlessness in episode, of course a history is important, but also looking at the results of your test initially can be very important. In a case series, more than a case series, several trials in France, they showed that people who did not obviously have an infection, 25% of them had pulmonary emboli. And that's something which I think we sometimes don't treat very aggressively. We assume, and we must not do this, that everyone with a diagnosis of COPD, whenever they come with increased breathlessness, is having an exacerbation of COPD. That is often true, but is not always true. And in the UK, we treat everybody with steroids and antibiotics, which is stupid. When many patients are having exacerbations which are non-infective, which maybe is anaphilic driven, or maybe due to pulmonary embolus, or maybe due to a change in rhythm, atrial fibrillation obviously, or indeed cardiac failure. And so we miss, I think, at exacerbation, some of these subtle moments that can help us not only in the short term treat people better, but then also change the paradigm in our minds to maybe think, oh, this patient's had a change, they should go and see a cardiologist. Many patients have raised troponins. Many patients have raised D-dimers and BNP at the time of exacerbation. And so we must critically appraise that as a moment too. But D-dimer is tricky.
So two biomarkers which can actually quickly look into that acute situations where you can pick up two diseases which have their own treatment, and of course that will make the change in the life of the patient, and that one will be slow and I think slow ongoing, another one may be more acute and catastrophic depending upon patient is seen in the OP, patient is seen in the ER, patient is seen in the ICU. The situation may change, but keeping that in mind that it is worsening can also be there rather than just simple acute worsening or just giving antibiotics and steroids. I think that's what, I think, Richa, you can take to the next level that now the gold is talking about calcifications to be seen in the coronaries on the CT scans. And in India, Richard, there will be, I think, how many percent of our COPD patients have at least one CT scan done? 50%? 50%? 50%. And it also depends upon the center to center. Like at our center, I'll say 90%.
Yeah.
They will get a CT scan done. So if that is there, I think you take forward, Richa, about coronary calcification.
So I think we can discuss about the coronary calcification as well. It is pretty low even at our center. But keeping in mind that largely patients with COPD are elderly, doing a baseline cardiovascular evaluation is something which we should do. And when patient is on appropriate treatment, is not improving, then we should look for the other causes as well, the cardiovascular being the very common. I want to ask you if you want to comment on cardiac calcification, or I want to bring out something more important. How many of us are actually, we make a diagnosis of the patients, we are worried about the lung function spirometries, and we are worried about the treatment. Then we also give pulmonary rehab and vaccination. How many of us are actually talking to the patient and discussing about the nutrition part in COPD? Raise your hands. So I feel the metabolic causes of which diabetes and other things, maybe OSA, and nutrition also plays an important role, and I want to have a discussion with our eminent panelists and the speakers as well about how does nutrition plays a role in the management of a patient who is breathless, COPD, on proper treatment.
So nutritional angles, nutritional aspects of this.
Yes, the nutritional aspect.
So we understand the impact of, let's talk simply about body mass index as the measure, how we measure tests. We understand and know that patients with low body mass index, their prognosis is terrible.
Right.
So if your body mass index is less than 16, going down and they decline, it's a really bad prognostic sign. I also know that my patients who put weight on when they start very skinny do really well.
Yep.
And they go really through rehab and you can feel them getting stronger and better. And that's really important. However, we have a much greater problem with obesity because it's much more a common problem in the UK and of course in many Western countries. And so our goal often is to reduce people's weight rather than increase people's weight in the main. So many of the average, if you look at clinical trials in COPD from the United States, you'll often see average BMIs of 28, 29, maybe 30, which is obviously high. And that's not helpful. And it may be part induced by, obviously, diet being a massive problem, but also the steroids, the oral steroids they may have had, and obviously the lack of mobility or the lack of activity that's going on. So that has to be addressed. I'm very lucky. I work in a big team, looking after a community team where I have physios, occupational therapists, nurses, psychologists, and nutritional experts, all of whom will intervene with what's going on. And I would strongly advise, if you want to, in a comprehensive manner, manage your patients, having the input of a nutritionist and a psychologist together are amazing to make changes. I would also say, and again, I don't know what Jerry thinks about this, that I expect it is good general medical practice, but I would also say that the new weight loss drugs, which are, I'm not going to say freely available in the UK, but are readily available in the UK, are really helping some of our patients, but not alone. They have to be combined with nutritional support and with the psychological support to change their lives. The weight loss drugs help you, give you a kickstart, and then you change your lives going forward to make a new change, along with rehabilitation and all of those other things which really work. So it has to be a whole patient approach, which can then impact on breathlessness, and the patients have to believe it, which is the tough thing psychologically.
So do you feel undernutrition is a major issue in your subpopulation of COPD patients, or they are obese?
We find in our area undernutrition is a major challenge rather than the overnutrition.
And any experience, because we feel that at this point is very, very difficult to improve their BMIs, to improve their health, to improve their muscular component, and all those things are very resistant actually. It is very, very difficult because they are in the vicious cycle of breathlessness, no activity, no good eating, and then finally they get into this kind of, I think we find it very common where it is very difficult to break. And these are the patients who are prone to develop exacerbations again and again and again, which got like so many reasons for that. So do you feel the similar scenario in your practice, all of us are on the same page, or any advice, Richard?
Just to try and change tack on that. So obviously with obesity we get a lot of OSA and nocturnal hypoxemia, which increases our cardiac risk. So we see a lot of that problem, so that's another reason why we want to get it down. But the other thing I see a lot of is people with coronary calcification on the CT that is not reported. So you look at the CT report, it's not mentioned. You look at the CT, it's there. And once I see any coronary calcification, I'm putting that patient on a statin because I know that they've got coronary disease. And it's involving the left main or the proximal LAD, then I'm going to want to know if they've got a substantial ischemic burden in the absence of angina. So it's going to push me in various directions depending on what we see.
And coming back to the, again, forgive me, I think this is really important. Your point about nutrition is important from a cardiac point of view too, because the cachexia which happens, and COPD itself drives cachexia, as does cardiac failure. And so we have to be, again, comprehensive with our approach, as I say, including the nutritional support, high protein diets, as well, if possible, as well as the psychological support needed to start people training and moving forwards. Sadly, the evidence on medication to treat these patients is very poor, whether it's using androgens in the past that have been tried or various other medications that look really good and have really good short-term benefits on exercise tolerance and muscle mass, but actually have had no long-term benefits at all. So this is a very difficult area. The approach from my dietitians and my nutritional experts for patients who have got severe disease, who cannot eat. So the idea of putting a large plate of food in front of them would make them feel ill, is to obviously eat little and often, so that you don't cause too much loading in the abdomen with pressure, which then reduces your ability to actually breathe. So this is really problematic. It's really very difficult indeed, and there is no one clear answer.
Any kind of, we use some therapies to improve their weight or anything out of the box we do in India?
Sir, if we are facing this type of condition, mainly, we have things to improve their weight. Of course, we advise them to have some good fat diet, protein diet. But the situation is gradually changing, sir. We are getting also those group of patients who are very dyspneic, obese, and having complex comorbidities like osteoarthritis.
Separately.
And they are not...
Obesity don't bring in. At the moment, we are talking about people who are lean and thin, who have got a low BMI. We are struggling to get them put on weight. Their appetite is less. You give them protein diets, their appetite further gets worse. And they say that this is better than not having them at all. So do we have any other things to improve that, or it's more of a, I think, nutritionist as well as maybe some psychological advice and things like that, they help, or anything else out of the box?
I think pulmonary rehab forms a very important part. I think if you make the patient exercise and make him mobile, I think that stimulates the nutrition, and that can help us in improving the BMI of the patient.
So that's an excellent point, actually. Put them into pulmonary rehabilitation, exercise, more appetite, eating more, getting out of the vicious cycle is something to break it. But that is also something which is not available easily to all of them. But I think that is, which is very important, you said, because that breaks that vicious cycle. That's the one way of doing about it. Yeah.
We have also used anabolic steroids such as decadurabolin.
So that's exactly what I wanted to ask, that how many of you are using anabolic steroids in this underweight COPD patients who just refuse to eat more and put on the weight? So do we use anabolic steroids? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, out of 250, only like 5%. Very less. So here also it becomes 5% only. Your comment upon using anabolic steroids, they are available in India.
Sure, I've tried them, I've used them, they are available in the UK as well, and have had some short-term benefits, but long-term no changes at all. And I think probably in the population we're looking at, their problem is not a lack of anabolic steroids, it's just they've lost all the muscle, and getting it back is really very difficult. I think it's a poorly responsive population, unfortunately. But I would absolutely agree. The point that was made by a colleague, the key, and I was thinking, who gets better? Of my patients who are very underweight to start with, who is it puts on weight? It's the people who engage with the rehabilitation. It's the people who engage with the normal medication, who improve their lung function to give themselves more room to eat, as well as room to breathe, as well as an ability to do more exercise. And that whole cycle can then be a virtuous cycle rather than a vicious cycle, which is the other side of that. So I think they're the people that really do benefit. So it's about the whole patient, not just about one tablet or one special diet, but about the whole package of exercise. And that begins with getting the patients to believe that they can get better, and getting them to believe that they can almost turn back the clock such that they can want to be like they were 3 years ago, 5 years ago, 10 years ago, for a better life going forward. So that's really the critical thing.
So I think your question has been answered, that it's a short-term benefit, but you may utilize it to turn the round. Actually, then it's not a long-term thing, but initial push which is required to break that cycle might come, and you may try like that. But of course, we know that side effects and everything. Yeah, you want to say something, Rao?
Sir,
there is a subset of patients of COPD where pulmonary rehabilitation helps.
Alone works. Yes.
Apart from that, in patients who are bedridden on oxygen, they cannot move out from the bed. In those patients, rehabilitation becomes very difficult. In those patients, anabolic steroids or some psychological therapy may help, but rehab only help in those patients who can at least walk, who can take some breathing exercises at least.
How many of you are having access to pulmonary rehabilitation department in your working centers? Wow. So very happy to see that in the last 15 years, we have been talking about pulmonary rehabilitation. I remember that we used to do workshops in 2010, 2012, 13, 14. In at least after 10 years or 15 years, this much of change has come that at least 50% of people do have access to pulmonary rehabilitation, which is an excellent number to go by about that. And of course, it completely changes the patient. But yes, very difficult. Many patients just refuse to come because they are not able to come at all. And these are the underweight patients which we discussed. You want to take OSA ahead, Richa? Maybe.
Comorbid conditions, as we were talking about, the metabolic. So in India, it is a little different. We have more of catechic or low BMI patients. But then again, you have a set of patients who are having higher BMI. So how much is how do we take it? Historically, it may be very difficult when we talk to them. They are more worried about the breathlessness. But in a subset of patients, we should screen for sleep apneas or sleep disorders as well.
Sorry. Yes.
Yes.
I think it's very, very simple.
Right.
We are going to miss Sharmila here, actually. We are going to miss her.
OSA is clearly a huge problem, and it is very, very difficult to diagnose clinically. So if a person looks like they may well be the kind of person who would have it, then to me, you automatically have to do the tests.
And I absolutely agree. And using asking, if you don't ask the question, you will not know what the answer is. Yeah. And so you can't just see it. So the tools that were mentioned this morning by Shamila are really useful. Doing an Epworth score takes 1 minute, and it's the easiest thing to do in the world. And it gives you a really clear answer about whether there is daytime sleepiness and impact. And so that's really critical. And we have to remember, as you mentioned, Jerry, you mentioned, this is a very treatable condition. But not just that, the consequences of this condition on the cardiovascular status is enormous, particularly hypertension and then heart failure. Hypertension is the most common comorbid condition with COPD, and in clinical trials you'll often see 40, 50% of patients who are selected for their lung disease have hypertension. And so it's if you have got OSA, trying to control hypertension is almost impossible. And I just make one other point on that. Because these people have been labelled as having COPD, we often undertreat the other conditions. And particularly when it comes to cardiac disease, not cardiologists, but GPs that don't like to use cardiac drugs on COPD patients. And we underuse, for example, beta blockers in COPD patients when they're indicated clearly from a cardiac point of view. So it's almost a double whammy. The double whammy of misdiagnosis or late diagnosis, as well as then with a poor understanding of benefits of treatment.
So we discussed multiple conditions which can make the patient not improve, not just mere the eosinophil count, because I think everybody was thinking about the eosinophil counts, but we are looking at the whole patient. And of course, I think obstructive sleep apnea, you are trying to screen most of the patients, right? That very proactively screening is done. And we have seen number of conditions. Any other thing, Richard, you think that?
I just want to ask this team panel over here. So a patient is there who is, say, compensated or chronic type 2 respiratory failure. I think I'm opening up the Pandora box, but there may be ifs and buts into it. I just wanted to know if the patient is fine, means he is kind of able to do it, but he's chronic type 2 respiratory failure, not acute. When should we consider giving an IV for these patients? Are they the candidates for, improve the survival or survival benefit? I don't know. I mean, I understand if the patient is coming in acute exacerbations or patient is a patient who is having 1 or 2 exacerbations, chronic type 2, then I would suggest an IV. But in a stable patient, is there any role of an IV?
This is a difficult area, and I have a particular personal view on this, which I think is a little controversial in a way. So what are we actually saying when someone has respiratory failure, type 2 respiratory failure? We are saying their physiology is broken. They are broken. And they're extremely, I'm not upset use the word saying they're stable. Well, they're okay for the moment because they're living on a knife edge. And they will very, very quickly tip over into then acute decompensated respiratory failure. And then they are broken and they are dying. The prognosis of people with severe pulmonary hypertension, which will drive pulmonary hypertension, the severe prognosis of pulmonary hypertension in COPD is really poor. The prognosis of people with type 2 respiratory failure is really poor. The prognosis of those people who need long-term oxygen therapy because of hypoxia is really poor. And so, for me, that is saying you need to be thinking about involving our palliative care services, our end-of-life care services, taking a different view about symptom control and symptom benefit rather than fixing a broken physiology. And I think there's obviously going to be parallels with end-stage cardiac failure. So I tend, again, using a multi-speciality involvement, get people involved in that way. Now, who do I refer? Because non-invasive ventilation in the community is done and delivered by regional services. Who do I refer into my colleagues? People who have got type 2 respiratory failure, but who are still functional. Because there is no point in giving non-invasive ventilation to someone who is bed-bound or chair-bound. They have to be able to do something. So they're often a little bit younger. They're often a little bit more emphysema-type people who've done rehabilitation and are very breathless. And those people do quite well. And particularly if they're still working or have other things in their lives they want to do and want to achieve. So there's a mental aspect too. So forgive me, I'm somewhat about holistic symptom management in those people, as well as trying to stabilize the physiology rather than just trying to fix it. Right. Because I cannot fix severely emphysema damaged lungs other than transplantation, and they have to be under 63 to do that. So, but Jerry, would you comment on?
I suppose, yeah, I tend to only see that obviously with end-stage pulmonary hypertension, and as you say, palliation is a huge part of the management then, and makes a big difference. The other place we come across is central sleep apnea because of their cardiac disease, which is unresponsive to CPAP and much more difficult to manage. So I think that obstructive sleep apnea, fair enough. I think when it comes to central sleep apnea, it suggests that you've got a cardiac problem or a central problem, and it's a different ballgame.
I think we traveled a long way. That simple word is breathlessness. Symptom is only one, but there is big umbrella which needs to be very carefully evaluated. And so many points have been already brought in, which actually we know about it. But the problem is when it comes to seeing them in the OP, many times I think some of the things gets
missed out
of out of the box, out of the mind. We don't consider them. But when they are not improving, it should not be just that it is COPD, it will never improve. We should look beyond that. And cardiac, as I think has been very, very rightly highlighted in sessions today, don't forget cardiac actually. Don't forget it, that they have same common factors involving in it. There are many peculiar things like tuberculosis and other things which do happen in India, and there were many points like pulmonary hypertension. I'll stop this, but I will just ask a raise of hand. If the echo reports there is mild to moderate pulmonary hypertension in a patient of your COPD, how many of you give anti-PH drugs? Nobody. Moderate pH, nobody. It should have been on the voting pads. Any last comment? Sometimes we have desperate situations. What are those desperate situations where you do prescribe anti-PH? And especially we know that we only use one. Everybody's passing this question.
Especially for a patient of COPD who is taking treatment properly and the breathlessness is out of the proportion basically. So we are thinking of other causes and the patient is having significant or severe pH on his echo. So that might be a contributing factor and the patient is not improving with optimized COPD therapy, then we can give it a try in few patients. They might benefit with that.
So I think that's how it is. It's basically try, see what happens. Not that there is evidence, not there is anything which we know about it, but definitely we do know that in certain situations it will do more harm than good to the patients.
Can
Yes.
I just quickly comment on that? I think that first things first, don't assess for pulmonary hypertension during an acute exacerbation. The pulmonary pressures will go up, they will come back down. So you can't look at that situation and say this person needs pH therapy. And the second point I would make is that if the evidence, poor as it is, only applies to people with a pulmonary vascular resistance above 5. So if you don't know the PVR, you don't know whether or not to treat.
I think, I'm sorry, I won't be able to allow the questions because we are already running the late. You can ask our faculty outside the room and address your questions. I'm sorry I have to close this session and forward it for the next one now. Thank you very much. Thank you, everyone. Thank you, Richard, and thank you, Gary, for putting great insights into this very difficult situation, which is complex breathlessness. Thank you, everyone.
Thank you, everyone.
Thank you everyone for this enriching session. Moving on, we have a debate. Does cryobiopsy help when there is no access to MDT? And for this, we have two speakers. For yes, we have Professor Francisco Bonella, and for speaking for no, we have Professor Maurice Pradella. Moderated by Dr. Pawan Kumar Singh, and I would like to invite our expert panelist, Dr. Jyoti Bajpai, Dr. Manoj Panigrahi, Dr. Rohit Vadala, Dr. Kishan Shrikant, Dr. Nitin Jain. And this session will be chaired by Dr. Sampath Das, Dr. P.U. Jain, Dr. Sanjay Kumar, and Dr. Ishita Shah. Requesting everyone to kindly take the seats.
So thank you for the invitation to join this interesting debate. I had the challenging task to demonstrate that cryobiopsy helps also, or even where there is no access to multidisciplinary team discussion. So my disclaimers, so I'm not a pathologist, and I'm a big fan of cryobiopsy, but also of MDT. So it was very difficult to me to demonstrate the contrary. So we know that a diagnosis of ILD can be confident when more than 90% of findings are concordant, or can be provisional with high confidence when the findings are 70 to 90% concordant, low confidence when the findings are 50 to 70% concordant, and unclassifiable when there is a high discrepancy in the findings. And the main reasons why ILD remain unclassifiable or unclassified, which is for me the correct term, is because no biopsy has been performed or biopsy is not contributory. And unclassifiable ILD, of course, the rate of unclassifiable ILD is correlated with the experience of the center and generally ranges from 10 to 15% of all ILDs, but we have really cases in the literature, centers in the literature showing that unclassifiable ILD can be also even 30 or 40% of cases if the MDD is not experienced. The diagnostic yield of cryobiopsy in ILD is undisputable. So the diagnostic yield with one site biopsy is 65%, with two different sites rises up to 93 to 95%. And discordant samples can also occur in up to 1/3% of cases. And this study published by Claudia Ravaglia almost 10 years ago with around 500 patients with fibrotic ILD who underwent cryobiopsy demonstrated that the pathological diagnosis, if you biopsy one site or two sites, is very similar to multidisciplinary diagnosis. Please look at the percentages. When you biopsy two sites, you have 92% pathological diagnosis and 93% multidisciplinary diagnosis as diagnostic yield. But Claudia Ravaglia stressed a lot in this study that the high quality of biopsy sample is crucial to have a high performance in terms of pathologic diagnosis. And of course, they also indicated at that time, then there was a white paper some years later in Respiration really stating all these points, which were also taken over in the guidelines, the ERS guidelines on cryobiopsy in 2022. And these are the best samples, so larger than 5 millimeters of diameter and no crush artifact. So this is the ideal situation where we can have then this high diagnostic yield and reliable pathological diagnosis. And these are the European Respiratory Society guidelines on transbronchial lung cryobiopsy, diagnosis of interstitial lung disease, and please look at the numbers. So the diagnostic agreement between cryobiopsy and final MDD in one study by Romagnoli and co-workers with only 21 patients was pretty low, 48%, but Troy and co-workers some years later found a very good percentage of agreement for cryobiopsy plus MDD and surgical lung biopsy plus MDD. It was only the beginning, because if you look at the bottom of the table, there were also studies directly comparing TBLC versus surgical lung biopsy, and the percentage of agreement was around 71%, and Ravaglia also compare directly transbronchial lung cryobiopsy with surgical lung biopsy with an agreement around 83%, which is pretty high. So, summarizing the meta-analysis investigating the diagnostic yield of transbronchial lung cryobiopsy alone show a diagnostic yield of 73%, which is not bad, also without MDD. So my main argument for pro-cryobiopsy is that cryobiopsy findings may be sufficiently decisive to support an ILD diagnosis without a formal multidisciplinary discussion when the tissue shows a high specific abnormalities. And the prerequisite for that is that pathologists must understand the patient's clinical situation and history to read the slide properly. So an exhaustive a priori information is really needed to the pathologist. Which are these highly specific abnormalities allowing a diagnosis without the MDD or MDT? Pulmonary amyloidosis, we show a beautiful example this morning with characteristic amyloid deposits confirmed by Congo red staining and ideally amyloid typing, and pulmonary alveolar proteinosis with alveoli filled with typical PACS-positive material and foamy macrophages, whereas the biopsy has not been recommended by the guidelines as main tool for diagnosis PAP, but only in case of discrepant findings. Pulmonary Langerhans cell lysocytosis, showing characteristic cellular lesion with appropriate immunostaining, CD1A Langerin S100, in the appropriate clinical radiological setting, and also for sarcoidosis, although the presence of well-formed non-necrotizing granulomas do not prove sarcoidosis per se. So we can see here nice examples of pulmonary amyloidosis with the typical amyloid deposits and also the Congo red staining. We have also some new data about transbronchial lung cryobiopsy in the diagnosis of pulmonary alveolar proteinosis. This is the only systematic study, otherwise all the other reports were anecdotal. You see here the diagnostic yield of transbronchial lung biopsy versus transbronchial lung cryobiopsy, which was 100%, and the normal biopsy was 40% only. For PLCH, you see here not only the typical histology, but also the positive immunostaining. But it's, as I mentioned this morning, this is also really a good chance to perform the molecular biology analysis or diagnostic to identify BRAF V600 or MAP kinase mutation. So a thing you cannot do in the BAL of these patients with PLCH. And another study by Venerino Poletti and co-workers, a very elegant study comparing the diagnostic yield of transbronchial lung cryobiopsy in PLCH and Erdheim-Chester disease, which are inflammatory myeloid neoplasm, found a very nice diagnostic yield for the transbronchial lung cryobiopsy in PLCH, 71% versus surgical lung biopsy with a diagnostic yield of 100%. And we see here a transbronchial lung biopsy of sarcoidosis showing nice granulomas, but the magnificent sample from the cryobiopsy showing different granulomas and really giving a picture of the situation. And we have now this study recently published from Germany, from the Freiburger group, comparing transbronchial lung cryobiopsy in the assessment of sarcoidosis and chronic beryllium disease, a retrospective analysis of 321 patients. A very interesting study. Essentially, these patients received both procedures when the findings were discordant at EBUS-TBNA. So they received EBUS-TBNA plus endobronchial biopsy plus transbronchial lung biopsies plus transbronchial lung cryobiopsy. So the combination of the three ones, so of the two ones, EBUS-TBNA plus TBLC reached a diagnostic yield of 88%, improving the diagnostic yields of EBUS alone by 32%, EBUS plus endobronchial biopsy by 14%, and EBUS by transbronchial lung biopsy of 20%. So very nice results corroborating the use of transbronchial biopsy in sarcoidosis, for confirming sarcoidosis when the initial findings were not clear. But now we have a new problem, the new classification of IIPs 2025, and how to deal with the pathological diagnosis in this complex family of interstitial lung disease. But I found this really great paper or diagnosis flowchart published by the Japanese colleagues, a position paper from the Japanese Ministry of Health and the specialized group on diffuse parenchymal lung disorders, a flowchart which was developed to support the pathological diagnosis of transbronchial lung cryobiopsy for suspected ILDs, and also to provide a systemic approach for identifying key diagnostic findings with acknowledging the limitation of small TBLC specimens. And you can see it's a very complex algorithm. So they suggest initially to rule out artifacts, because artifacts caused by the cryoprobe and freezing processes can mimic, for example, acute lung injury and should be carefully evaluated and excluded, but the expert pathologists can do that. A careful observation is essential to detect minimal fibrosis, and elastic fiber staining can be particularly helpful. And we have to be conscious that the TBLC generally does not capture subpleural lesions, making the assessment of subpleural fibrosis one of the key features of the UIP pattern very difficult. But starting from the beginning of the algorithm or the flowchart, you see that there are 4 main groups of pathological findings, which can be very helpful in reaching the final diagnosis. Other diseases, we already touched this group. And then 3 main patterns: acute lung injury, cellular interstitial pneumonia, and chronic fibrosing interstitial pneumonia. In the case of chronic fibrosing interstitial pneumonia, then the pathologist will assess the presence of fibroblastic foci or not, the presence of granuloma or not, and restrict the field of pattern or even diagnosis to very few entities. And if you provide the a priori information to the pathologist, you can avoid the multidisciplinary team to confirm diagnosis. But there are, of course, some patterns which require clinical radiological integration or information. It doesn't matter whether a priori or post-MDT, which are UIP pattern, BIP pattern, NSIP, organizing pneumonia, poorly formed granulomas, diffuse alveolar damage, and acute fibrinous organizing pneumonia or AFOP. So summarizing, the cryobiopsy findings require expert interpretation by a pulmonary pathologist. And pathologists usually complain about insufficient a priori information, which is patient history and clinical condition. The guidelines on transbronchial cryobiopsy summarize the evidence in favor of the pathological diagnosis made by transbronchial lung cryobiopsy, and the Japanese statement 2026 supports its use as a replacement of surgical lung biopsy in undiagnosed ILD, underscoring at the same time the need of high-quality samples. Definite diagnosis based on histology alone is unusual, especially for for idiopathic interstitial pneumonia, but it's also possible. And highly specific histologic findings which allow a final diagnosis without MDT includes adequate and representative tissue, characteristic morphology strongly suggestive of one condition or a very limited differential, confirmation with appropriate ancillary tests like special stains or molecular tests, and exclusion of important mimics. A cryobiopsy finding is considered definitive even in the absence of MDT when it demonstrates an abnormality that by its nature and with supporting tests is overwhelming characteristic of a specific disease and aligns reasonably well with the clinical picture, making an alternative diagnosis highly unlikely. So this is my demonstration of the helpful value of the transbronchial lung cryobiopsy for ILDs. Thank you very much for your attention. The stage is yours.
Thank you very much, Professor Bonella, for giving this insight on cryobiopsy in the absence of MDT. So you have presented very beautifully one side of the coin. For the next side of the coin, I would like to invite Professor Maurice Predella. Does cryobiopsy help when there is no access to MDT? So we will discuss. We will later discuss the panel discussion after your talk.
Yeah, thank you very much, Professor Bonella, for this excellent talk. And now I will try to give my radiologist's perspective on the topic, basically. And as you can see in my subheader, I want to focus a lot more on the entire context. So I guess regarding like biopsy or transbronchial lung cryobiopsy, we probably all agree that it's less invasive than doing a surgical lung biopsy or like wedge resection or something like that. If an expert does it, who has a lot of experience doing it and does it basically every day, the diagnostic yield is high or very high, higher than conventional transbronchial biopsies, and also that it can raise the confidence of what we discuss in the multidisciplinary teams, because typically for the pathologist it's more tissue, as was nicely shown by my colleague, and then when they have more tissue, they typically are more confident with the pathological diagnosis. And the other thing is also regarding if you do a stepwise approach, that's normally a good approach because it reduces the burden for our patients. However, if you take the cryobiopsy and you take away the MDT, how much does it really help? It's less about the biopsy, it's more about what we discuss in the multidisciplinary team. And also, in some cases, in the multidisciplinary team, there is the discussion about whether we need a biopsy or not. I think this is also something we have to take into account. Professor Jenkins, in the 2 talks before, he argued that probably only 5% of his patients get a biopsy. So to keep that in mind. And then the result of the biopsy has to be taken into account regarding all the other findings, the clinical information available, the CT findings, serology, and so on. So before we biopsy, we have to be aware, do we need a biopsy? I think that's probably the first step in the whole process. And then, as briefly mentioned on the slide before, in a lot of cases, we don't need to do a biopsy. Then there are these unclassifiable situations where we want tissue, right? Because tissue may help. And then there's the scenario where we have maybe some sort of tissue, but the tissue is not enough. And even in the last scenario, in the MDT, depending on what our pathologists can get out of the tissue samples available, if it wasn't a cryobiopsy, in a lot of cases, we are kind of like, we don't change the management, and we are okay with, like, for example, trying antifibrotics. I say that as a radiologist being part of the MDT. So the need for, like, to step up, do a cryobiopsy, do a surgical biopsy, it obviously happens, but sometimes we don't need to do it, right? And this points toward that the MDT is really a crucial part of that, because you can decide on what you do before and after a potential biopsy. And so this basically puts everything together, right? So first you have like a sample from the biopsy on which you will see a pattern. However, the discussion then keeps on going, obviously. The differentials are being discussed, and their anamnesis and patient history plays a very important role. And then finally also like the conclusion or the diagnosis that's then made by the entire team, or as a consensus, you can say. And we talk a lot about CT patterns. This is probably the area I'm most comfortable to talk about. But as I was told by pathologists, it's also like a pattern of pathology, and that might be a little risky term if I look at my pathology colleague up over there in the second row. But sometimes, to me as a non-pathologist, is there, for example, I don't know, like a few changes, but not enough. And if you had maybe one cell cluster more, then it might be the diagnosis, but without it, it's not like that. So even histology is not, while it is the gold standard, it has its issues. And that it's independent from the size of the sample. However, when you get a better or larger sample, you can be more confident in general. And we've seen a lot of data from studies by Professor Bonella before. This is just a reminder how good the cryobiopsy is working, how good it is compared to like the single or the surgical lung biopsy. Excuse me. But if you take just the biopsy, the histopathologic agreement is like around 70%, which is good, not great. If you add the MDT to each scenario, the agreement when you combine the cryobiopsy with the MDT, and you look at like high or definite confidence, and the confidence level, so more than 70% basically, the agreement is actually very high. And this was all, I think you're all aware of it, and it basically goes toward the same direction. So while you, in a lot of cases, can replace like a surgical biopsy with a cryobiopsy, the actual factor is not the way of getting the biopsy. Obviously, for patients, it's more comfortable not to undergo surgery in most cases, but the MDT made the big difference. This was what had the way I interpret the studies, this has the big impact on the management of the patients. And to go to the failure points of biopsy, just like in general, it is, so you might be thinking about, and I'm talking like, I also did like CT guided biopsy as part of my training, and it's, I think, a very similar approach. So we are always kind of thinking of like complications. It's obviously a big topic. It affects the patient a lot. So we want to have like beforehand, we want to be sure that we have selected the right patient for the biopsy. Then regarding the pattern, that's more about the pathologists, but it's not like always like 100% correlation, if you will, and so you need more context to interpret even the histopathologic, the gold standard finding. And if you take this out, if you take the MDT out, you might get wrong confidence about what you're seeing, what's in front of you, what the disease the patient has. So this kind of like it goes towards this like precision versus accuracy we've been discussing earlier today. And so may I ask all of you in the audience who works like regularly in an MDT? Can you show up hands, like ILD discussions? Who is part of an MDT at your institution? I see a few hands up there, but not very many. But what we do is, we also do it remotely. So we have, I work in Switzerland, I'm the radiologist, to remind you all again, but we have then, some pulmonologist who's like far away from where we are, gets connected remotely via like a video call. Beforehand, we get all the information, we get the CT study. When there was already a biopsy, our pathologists get the samples sent, and we do an assessment of all that, kind of like we reassess all that. I look at the imaging, the pathologist looks at the available tissue samples, and then we make a decision. Is there maybe a rebiopsy required, maybe a cryobiopsy or something else? And then we discuss the case interdisciplinary as if if the patient was in our hospital, and our colleagues there typically like present the patient history in the video call. I'm not sure if that's also the few people who have risen their hand, if you do that also in your practice, but I think that's actually a very, very comfortable way. And so even like the patients in the periphery who might cannot come to the hospital, or they had already some external workup, they can still benefit from what's available. So I guess cryobiopsy, we all agree on that, is an excellent tool. And the one thing I want to add at this point, you want someone to do it really on a regular basis. I'm not sure if it's a good idea that someone in maybe like a peripheral hospital decides to do like a cryobiopsy a month, right? That's probably, the results will not be very good. And then also, the pattern we see are not automatically the diagnosis, and I guess the MDT, or my experience also, the MDT and the MD discussion, it really brings a lot of information, a lot of knowledge. And however you want the best biopsy available, and I can say at my center we actually do a lot of cryobiopsies. Yeah. With that, I'm very curious what the discussion is going to look like.
Yeah, thank you, Dr. Morris, for giving this insight on MDT versus cryobiopsy. So I think we can start a discussion. So my first question from the panelist, and later on with the Dr. Bonella and Dr. Morris. So what do you think, Dr. Kishan, TBLC compensate for the absence of an ILD and multidisciplinary discussion, or is MDT is essential before deciding on biopsy? What do you think?
For all practical purposes, especially in cases of interstitial lung disease, ILD if you are speaking, MDT I think we should do before you consider the biopsy. Because it is clear from the excellent talks by our international speakers, your biopsy tissue in ILDs will just give you the tissue pattern. It is just giving a how the CT gives one pattern, your histopathology gives one more pattern. It is you, your pathologist and radiologist sit together to decide and keep everything into one box. It doesn't mean your tissue is Brahmastra, where you will get a single answer, a single clinical diagnosis for the patient. So that point should be very, very clear, and it should be go.
Dr. Bonella, anything you want to add in it?
I have to add the third disclaimer, because in Germany the MDT after histology is mandatory for the certification of the centers. So my task was particularly difficult because I had to think against my clinical practice, you know. So obviously the biopsy gives you a pattern, and you have to integrate the pattern in this, all in these informations. But of course, there are situations where you can do it before, so to provide the information to the pathologist, and then integrate at the end the information also without the MDT. But what is happening now in Germany is that we don't do the MDT before or to indicate the cryobiopsy, because especially in experience center, you know, we have a volume of patients which is very high. So if we have to decide all together when to do a cryobiopsy in our patients according to the oldest guidelines we have, it will be really a huge work and almost impossible in a clinical practice. So we run 2 to 3 MDT per week. So we tend now, the specialists, the ILD specialist tends to decide by themselves if the cryobiopsy is indicated, the patients undergo the cryobiopsy, and then we will discuss all the findings together in the MDT. So, yeah.
So you agree that MDT is required, but when the expertise are there, lot
It's
of
mandatory.
experts enter, and then there is a cryobiopsy can be done forward. So Dr. Morris, you want to add something?
Yeah, it makes total sense, and I mean, you work at one of the biggest centers in Germany, and you have probably the most experience, so you don't have to discuss the patient whether there's cryobiopsy or not. But I asked before who does multidisciplinary discussions, and I saw a few hands up. I was surprised that there weren't more hands up. I want to ask the audience, who does cryobiopsies? Can you maybe raise hands? I see also
Only
a few
4
hands.
and 5, I think 5, 6.
Yeah. I just wanted to see if it was more hands, because that would have meant that more people do cryobiopsies than MDT, but it seems not to be the case.
Yeah. So I think cryobiopsy is just a replacement for the surgical lung biopsy, not for the MDT. MDT, whenever you require, you go for MDT. Not the personal, you can do the virtual MDT also before deciding any case for the biopsies. Yeah?
It's also depending on the experience of the pathologist. So we really face this issue, because you have the younger pathologists which are very insecure even in identifying the pattern, right? And then you have the experienced pathologist where I don't want to say you find the diagnosis in the report, but really it gives you, when the pathologist has enough information in the background, it paves the way to go for diagnosis. So I really think that this interesting diagnostic, these very high diagnostic yields found by Venerino, Poletti and co-workers. They were really related to a very ideal situation where the pathologists are experienced, the interventional pulmonologists do fantastic samples in terms of quality, and then of course we have 92% diagnostic yield without MDD and 93% with MDD, because this situation is ideal. So it's like an orchestra playing without the director, right? It's also possible. Orchestra can also play without a director, right?
So any panelists want to ask something?
Hello. I'm not asking. It is just like that we are talking about the biopsy and everything. But if you have a good local team with a very good experienced radiologist, and you can go with a very detailed clinical picture and the detailed everything, that's exposure histories and everything, sometimes the biopsy is not needed even.
Exactly.
And sometimes it happens that, and this is the point where a radiologist is in the close connect with the entire local team, the pulmonologist, the experienced pulmonologist for the ILD itself, and we can have the diagnosis with the confident diagnosis at that level too. Because it's not like we have seen that there are very less people who are doing the cryobiopsy here, so it means that the people are more towards the MDT based with a specific to the radiologist and the experienced pulmonologist with the entire picture.
But you know, we are going exactly in the other direction, in the opposite direction, in direction of hematology. So we need the tissue to classify. Maybe in 5 years we will have tissue markers or even molecular biology markers which informs you about the treatment in the future. So we are going to do more cryobiopsy in the future. It doesn't matter whether the MDT is fantastic or not. We will need the biopsy in the future to classify our ILDs in a totally different way and to decide the targeted treatment. So this is the perspective in 5 to 10 years. So the biopsy will be central, exactly like HRCT has been central all the in the last 2 decades.
Yeah, I can fully agree. I think it's a little bit like I'm also part of the MDT for like lung cancer at my hospital, and there you always need a tissue,
yes,
right?
Of course.
To determine which therapy, which is immunotherapy possible, and so on. So I 100% agree.
It's just a question of time. In 5 years, maybe 7 years, we will have a totally molecular-based classification of ILDs. Now we are running with our morphology. It's nice, but it's not the future, right?
Yes, I think the point is that lack of MDT should not be an indication for doing a transbronchial lung cryobiopsy. And also, if at all indicated for doing transbronchial cryobiopsies, we should basically have 4 right P's. That should be, first is the right patient, where the patient should be fit enough to undergo cryobiopsy. Second P is the pattern on CT, where the radiologist cannot make a confident diagnosis in getting, so probably we need a tissue to diagnose. The third, most important P is the trained pulmonologist who's skilled enough to execute, perform and handle all the complications of transbronchial cryobiopsy. And fourth, of course, we need to have a pathologist who's skilled enough and trained to give us a pattern on cryobiopsy. So I think that summarizes everything.
Actually, my thing is, what you said about the MDT, that's a good point. But considering the resources, we don't have cryobiopsy as easy accessible as it should be. So why not start with an MDT, and you can review the patient with the response or the diagnosis you have made, and then you can review if you need a cryobiopsy on a follow-up with the patient or a follow-up on a scan or any new symptom that the patient has.
So I have a question from Dr. Bonella. If a 60-year-old old man with a smoking history and HR, because we have a very good HRCT pattern now, so definitely UIP panel, would you still like to go for the cryobiopsy without MDD, or you want to, how will you approach this case?
Only if there are discordant findings in the lab or in the clinical history of the patient. So if something is not concordant with a diagnosis of IPF, IPF is an exclusion diagnosis, right? So then you need also the biopsy, right? But if everything is concordant and you have a probable or definite UAP pattern at HRCT in a man 70 or 67 years old, ex-smokers and everything, no lab, no joint pain, no strange systemic symptoms or something like that, then the confidence of the IPF diagnosis is above 70% and then it's done. So IPF is an exclusion diagnosis. So to reach this end point of the MDT confirming the radiological diagnosis, so confirming the diagnosis based on radiology and clinics is so the prerequisite is a number of findings available, including the lab.
Dr. Morris, what do you want to?
Yeah, I had another thought which I want to share, and it goes a little bit towards what you were saying about the MDT and the availability, because like not everything is like great about the MDT, right? I'm a radiologist. Basically, the MDT time, when I know there's MDT on Monday, when I'm back, there will be the MDT, and it will probably take an hour and a half time to discuss the cases. And it's not like there's another colleague who will cover everything in the department till I'm back, right? I have to make time for it, right? And I think that to be like efficient, have an efficient presentation, have all the information available, that is very important about the whole process. And why I say that, it's about like the resources for the MDT, yes, right? And this is definitely a challenging situation. And I guess to streamline which patient you discuss and what's necessary. So like you said, you don't need to discuss whether there's biopsy needed or something. This is definitely very important because people then lose interest and it just everyone looks just, then you're not concentrated anymore. So you really have to streamline your workflow. Yeah. And then the complex cases, I think they are best to be discussed in the MDT, right? And this, I think you cannot really replace.
Yes. So any panelists want to ask something?
So, as you already told that most of the undiagnosed ILD will definitely go for a biopsy. So in country like India, where the acceptance rate of biopsy or going for a cryobiopsy is still a bit of question, because most of the people would say, we will think about it. So do you think that we should not give treatment for them and should wait for a biopsy, or we should start with MDT and should start with a treatment and a biopsy should be in a standby mode till they accept that procedure?
I don't know if I have heard correctly the question, because of course, for unclassifiable ILD, maybe you have to repeat also the multidisciplinary team a couple of times over time to get there. So unclassified or unclassifiable ILD is really a difficult task, because these patients have a worse prognosis compared to the other patients, In the future, maybe if we have a genomic classifier available and you see that this unclassifiable patient have a molecular profile of progression or at risk of progression, maybe you don't have to repeat the MDT and then to try to reclassify this MDT, but this is a future perspective. In 5 to 10 years, maybe we will use the MDT also in another way, to decide a switch of treatment, so more based on treatment than on diagnosis. So the MDT essentially is born as diagnostic tool. This was the first aim of the MDT. Now is switching from pure diagnosis tasks to treatment involving other specialties and so on, and even will be used to refine the treatment over time. So I think this is the perspective of the MDT.
So thank you, Dr. Bonella, and thank you, Dr. Morris. I think the point is very loud and clear. I would like to ask from the audience, you have listened both the talks. So who are the favor of upfront cryobiopsy without MDT? Could you raise your hands? Only 2. Still,
I think
how many
discussion
agree MDT is required before doing cryobapsies? Oh, I think 90%.
Of course, it's
So
wise.
I think you are
it's
absolutely
wise.
right. Future, after 5 or 7 years after that, we need a tissue biopsy to diagnose ILD, it is ILD or not. But still, we are in a very resource-constrained country, and we have a lot of pathologists, radiologists. We are having a good HRCT. So MDT is still required, and India, Dr. Asmita is running a MDT very frequently. I think very good results of MDT, and we are getting a more than 90% confidence in the diagnosis of the ILD. So still, we can, in the era of MDT, then we have to go for the cryobiopsy. But yeah, absolutely, I agree with you also. After 5 years, might be the cryobiopsy is the answer for all the ILDs. So thank you very much, Dr. Bonella and Dr. Morris. All the esteemed panelists are here for amazing discussion. Thank you very much. I think we are on the time.
Thank you so much. Now, moving on to the most awaited session, Lungs on Fire. So, we would like to announce that the expert panelists of this session will all be getting 4 coupons each. And with that, I would like to invite the case presenter for the Lungs on Fire, Dr. Asmita Mehta ma'am. The speakers, the international faculties, Dr. Brajendra Srivastav, Dr. K. Satish, Dr. Ashok Kumar Singh, expert radiologist, Dr. Khushbu Pilania, pathologist, Dr. Charul Dabral, rheumatologist, Dr. Izrarul Haq, and we would also like to invite the expert panelists, Dr. Indu Bubna, Dr. Abhishek Prajapati, Dr. Muhammad Yusuf Dar, and Dr. Akshay Kavadia. This is for the first case. I would also like the chairpersons, Dr. K.B. Gupta and Dr. R. Sunil Kumar, to please join us on the stage. Thank you.
Good evening, and I believe this is my 4th or 5th Lungs on Fire, and this is something which I really enjoy, and thank you PACS Talwar sir for giving me this opportunity. I think if everybody is settled. Yep. So this is, if you people are fond of Netflix or anything, you would have seen Cold Case. So consider this as something like that, which we are going to dig out what exactly went wrong or right. So this is a 76 years old gentleman who has comorbidity of diabetes and hypertension. He was hypothyroid also. He presented to us, look, there is an occupational history which I am giving you, that he was a stone crusher. So he was working as a site where he used to do this particular job. With this background, this gentleman came to us with shortness of breath, dry cough, fatigue, which is going on for last 3 years. For your interest, I have put X-ray and CT scan, which says that the X-ray was taken 3 years ago and CT scan is taken 1 year ago. So the things are happening for 3 years, and now he is coming to us. When he came to us, he has respiratory symptoms for last 2 years. He was seen, evaluated outside. Records of CT scan showed bilateral cavity disease. Bronchoscopy was done not once, not twice, thrice. 3 times before he came to us, but inconclusive, there was no details of treatment either available. CT scan done 1 year ago, that was only films, and the relevant images I have put for your interest, that showed left-sided pleural effusion and a data that thoracoscopy was also done, which came inconclusive. We have 3 bronchoscopy, 1 thoracoscopy, inconclusive. Something which is going on for years, not improving, patient is still symptomatic, came to us. This is the X-ray which was taken at ER in our hospital. When we examined the patient, 92% on room air saturation, other vitals were stable, clubbing present, grade 2. On systemic examination, bilateral crepitations with reduced breath sounds on the left side. I won't go through the details, I'll give you a moment. Please go through other investigations. And meanwhile, if Khushbu can just give some idea about what's going on in chest X-ray and the previous, I would go through the previous slide also.
So when we look at this 3 years... So when we look at this X-ray which was done 3 years back, we are definitely seeing a patch of consolidation in the right lower zone, and I mean rest, there is some haziness in the upper zones also. Left lung otherwise looks okay to me. On the CT we are definitely seeing effusion on the left, and there is a large area of cavitatory consolidation kind of an appearance in the involving the right lower lobe. And there appears to have been significant progression in this current X-ray. There is progression also of the effusion, and we are seeing opacities in the left lung. The right lung opacities have also increased. So there are scattered opacities denoting cavitatory consolidations in both the lung fields.
Yep. As we can see, the investigation did not reveal much. And I will run it 2 or 3 times. We'll come back to you, Khushbu. I don't want your opinion at this moment. And this is the audience poll question, but meanwhile, the panel is open.
I would like to see the first X-ray that was done 2 years back, I think.
Yeah.
Okay, there appears to be a lack of bronchovascular markings on the left side with, yes, and there is also an opacity. Probably, is it the heart? It doesn't look like so. And there is a feature of collapse there, collapse of the left lower lobe.
We will go to the poll question. So meanwhile, that also is happening because we have limited time. So maybe one of the panelists can answer sir's question, and the question is open for audience. Wow.
So basically, yeah, I mean, this is diabetic patient, so immunocompromised. Age, I didn't, what's the age of
72 years.
73, so elderly patient, immunocompromised, cavitary consolidations. I would think about, yeah? Yeah. So basically, cavity consolidations, I would think about TB also, fungal infections, malignancy also it could be. And considering he's a stone crusher, so then we will think about some chronic lung disease.
Sure.
So this is basically elderly male.
Yes.
Total duration about near about 3 years. The immunocompromised state, having cavitating lesion which is progressively increasing, and you have already ruled out TB. So I have 2 differential diagnoses. One is invasive mycosis. Second, it can be vasculitis like Wagner's, which is progressively increasing.
Yes.
So I will work on these 2 differential diagnoses.
Do you all agree?
So I have one, TBs can be, but less likely at this point because multiple times.
What if I say atypical TB or atypical mycobacteria?
Actually, the first X-ray shows a fibrocavitary disease in the right upper lobe, and this left side effusion that time. I feel malignancy is more of a possibility, and fungal can be a possibility, but fungal there are no other settled lesions. So malignancy and fungal after that. TB is unlikely because the long-term fibrocutaneous disease, that's my
Malignancy which did not worsen or kill my patient for 3 years without treatment.
Earlier it was not consolidation, it was just fibrocutaneous disease. Left was effusion that time. In earlier CT, cavity increase in the upper lobe, that could be an old cavity with a fungal infection, like a CCPA. So fungal is a possibility, but again, even a malignancy, like a BAC, bronchial carcinoma, we have to keep in mind. TB looks unlikely at multiple evaluations.
Sure.
The possibility of a primary vasculitis at this stage, considering the histories of 3 years, and the patient, although has a progressive disease, the patient doesn't have any second organ involvement. So it is a primary lung disease without any systemic manifestation. Definitely it is a consideration, vasculitis, but it will be very lower down the
Lung specific vasculitis.
So yes, but still again it is very aggressive disease. What we think about ANCA vasculitis, we think about consolidations and cavitations. We primarily think about ANCA vasculitis, which is a fairly aggressive disease.
So if panelists are done, Khushbu, what will be your impression as a radiologist? If CT, what would you have signed off this CT scan with the diagnosis?
So we are seeing multiple things. One is a cavitatory area in the right superior segment of the right lower lobe, consolidation in right middle lobe, consolidation in the left lower lobe. All of them are showing good air bronchogram. We have a loculated kind of effusion on the left. Surrounding these areas of consolidations, we are seeing significant ground glass attenuation. So that ground glass also tells me that possibly there is some kind of an angio invasion that puts TB slightly out of the diagnosis list. So Dr. Huck has already put vasculitis below. I put TB also lower down in the list. We are left with fungal and malignancy. Both become quite stronger possibility at the age and the kind of other demographics that you've given for the patient for now.
The counts are...
Sorry?
Just that the consolidations are showing a lot of GGO. Usually with the routine tuberculosis, this kind of angio invasion with TB does not happen. So that is one.
Because you are using angio invasion, are you pointing towards mucor?
I am pointing towards any other fungal also. I mean fungal, any
Aspergillus.
invasive fungal, aspergillus, mucor.
So now the audience,
Can
all those who favors the TB can raise their hand, will get the coupon.
Can you please show...
I did not say that TB was negative. I told it was inconclusive. If you see my slides, I said the reports were inconclusive.
Can you please show the mediastinal window?
No, so the reports were what? They were gene expert, they were smears, they were cultures, what were they?
So the reports, as you can understand by the quality of the X-ray and CT scan, we have to go by what patient is telling us and some papers in which it was roughly documented that the cultures and the TB smears were negative.
The smears were negative.
Smears and cultures for TB were negative. It was documented by treating doctor. I did not see any report of microbiologist saying me that TB was negative.
So if we incorporate the finding of Dr. Khushbu with this, so I have the two differential diagnoses again. It could be a mucormycosis, and the second possibility, it is melioidosis.
Melioidosis. Yep.
Yet gene expert of pleural fluid was negative, no?
Pleural fluid gene expert was, I think, not done. Oh yeah, it was negative. Gene expert.
So I think we should go for the pleural biopsy, and then that tissue should be
So
sent for
that
the gene
particular,
expert.
sorry, I have not mentioned here, but it was a thoracoscopy, which came inconclusive. We had seen I have put only representative, but we saw the ICD and everything. So thoracoscopic biopsy was also taken. By the time patient came, 3 years, 3 bronchoscopy, 1 thoracoscopy, inconclusive report, persistent symptoms, persistent opacity.
Just one.
Let us move on. So presently we have got a hung audience who is saying that most probably infection, but malignancy cannot be ruled out. Very low point towards vasculitis or TB in that case. Anyway, we did investigation. Ultrasound chest was done. Left-sided mild pleural effusion. It was documented 500 ml. Don't come back and shout at me when I say something else, but it was documented by a radiologist, approximately 500 ml, with collapse consolidation of basal lung segments. Ultrasound neck was also taken, which was showing few enlarged benign appearing lymph node, level 1 by 0.5 centimeter. There were colloid nodules in thyroid too, but he is a non-case of hypothyroid. Mild fatty liver, prostatomegaly. Nothing. This is the second audience poll, and maybe my panelists also can just think over it, and we will discuss this after audience poll. With the new information which I provided, would you like to change your diagnosis, or you still think this is TB? So what would you recommend next?
So I would think about autoimmune profile because you see pleural effusion. So
sure.
I mean organizing pneumonia with pleural effusion, extrapulmonary involvement, we can think about CTD.
Something which is going on for years can be autoimmune. Do you all agree? Anybody has difference?
Repeated bronchoscopy with targeted sampling for the reason that autoimmune profile might be misleading at times because at times it may be positive but not contributory.
What is your pre-test probability when you are doing bronchoscopy? What are your expectations?
So it is like that you're going to send a culture, TB culture, a gene expert which was not sent, and also an AFB smear for the reason that atypical mycobacteria could be a possibility. You're also going to send for fungal stains.
Sure.
Right, you're going to send for fungal cultures, and then on top of it, taking up a biopsy is always going to help you up for the reason that there are places where there were consolidation and no cavitation. So it is like that taking a biopsy from cavitations might be a little misleading, but there are consolidations also. So a repeated bronchoscopy with targeted sampling would be the first. So
anyone for the pleural aspiration?
Why not thoracoscopy? Why not pleural
a lot
aspiration?
Of prizes to be won.
Yeah.
So pleural aspiration. Good.
Pleural aspiration.
Yeah, pleural aspiration.
Okay, so
Yep.
how many aspirations were done before?
3 times.
Three times done.
Bronchoscopy.
So, no, pleural aspiration.
Pleural aspiration once, thoracoscopy once.
Okay, so the only question is, if the thoracoscopy is negative, what is the chances of it coming out to be positive? A repeat tap.
10%.
Because of the issues related to how reliable is the reporting. So that may be in point. So madam gets a number for that.
One thing negative in this is the CRP is negative.
Yeah, I'll go back to
CRP
that.
is very low. So it goes against the diagnosis of any autoimmune disease or something.
So CRP is, look, we don't know, patient was diabetic also. I won't give
there
that
is a
much.
rheumatologist on board.
Yep.
Can you get an autoimmune disease which is active and CRP is normal?
So the most common thing will, when a CRP normal with the autoimmune disease is SLE. But again, if you have SLE with pleuritis, that is serositis or active arthritis, the CRP can be raised. These are the only two conditions.
In SLE, if I am wrong, correct me. In SLE, if CRP is elevated, you think of infection, right? Mostly.
So that's what he's saying. If it's SLE related, CRP can be normal.
Again,
so
it depends on the level of CRP increase. If it is significantly like more than 5 times increase, it is more of infection. Less than 5 times, active arthritis or serositis.
Sure.
So I will have a little
repeat bronchoscopy is better option. Why? Because maybe they have missed the atypical mycobacteria. Maybe they have not gone for the culture of atypical and they missed the AFP smear.
I agree. Sir,
Yeah. So my approach will be a little bit different because we already did the invasive test and everything is negative. Doing the bronchoscopy, thoracoscopy again is not a good option. What I will do, I will go for the PACS scan, see is there any possibility of malignancy. Then I will select whether the bronchoscopy is the better option and the thoracoscopy is the better option.
Asmita madam, 2 questions. One is ENCA, other thing is what happened to the thyroid nodule?
Thyroid, he was hypothyroid. Radiologist suggested it is colloid goiter.
I think correct. So But still, thyroid, whenever gets abnormal, it is always raising a red flag in lungs on fire.
Sure.
So that's why people are considering that. Why ignore thyroid? I think that is a very important thing.
Sure.
But I think you are very right that in a situation, a PET scan would have definitely been guide to biopsy rather than
Yeah, coming to that, Dr. Sonia. So I was very basic. I did only sputum at this stage. Sputum gram stain, inflammatory cells 10 to 20, gram positive cocci, and very few gram negative bacilli. There is budding yeast cell in sputum with pseudohyphae. Sputum culture, normal flora of respiratory. AP smear negative, expert MTB not detected. Pleural fluid. This is why I tell that it was labeled 500 ml, but when we tried to tap, it was non-tappable.
Okay, so it must be very thick. Yeah. So everything is negative, Asmita.
Yep.
Nasty pleural effusion. Very bad. Giving everything negative. So what comes to the mind when everything comes out to be negative?
Pleural and parenchymal, bilateral consolidation and cavity lesion.
Yes, sir.
And nothing coming out.
Yeah, nothing.
So what do you think? Malignancy.
Repeat.
Autoimmune actually.
Repeat bronchoscopy.
Autoimmune negative, uncast negative.
Madam, can I say?
So, what they are talking about here is that when these patients come to their center, they would like to revisit. And in revisit, they would like to have a tissue again for evaluation. Okay. Biopsy from the wall of the lesion.
Which lesion? Cavity. Upper lobe cavity.
Can you, madam, say one?
Pleural biopsy.
What is the question here? Next, you're showing the question, I think. Yes,
Yep.
What is the question? Now answer.
This is audience poll
Take
and
out
maybe
your
you people
voting
also
pads.
can
Take
think.
out your voting pads. Please, please, please. Vote, 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 vote. Please vote. Vote. Take out your... If somebody doesn't have a voting pad, please raise hands. We will send the voting pads. Must vote.
Did we do the ANA blot?
So I think ANA has been given, so accepted that it is negative, okay?
Wow.
Now, what is it? PET CT. I think the morning's Lungs on Fire gave us an idea that PET scan can do lots of things, right?
Yeah.
So that's why people want PET scan now. And the second is a bronchoscopy, BAL, and a targeted TBLB. I think that's what Loknathan was telling. So he gets at least coupon out there for that. Then
Nobody agreed for oral steroids and ATTR.
And nobody wants even a VATS biopsy.
I think it is a pulmonologist crowd, so understandable.
It's a very good thing actually, because now you have exhausted everything. There's no point in giving ATT to the patient. Everybody wants to reach the diagnosis, and perhaps the diagnosis is obscured at the moment. I think that makes perfect sense that we really want to do something else to get the diagnosis. I think this entire audience needs a loud applause that they have achieved this. Absolutely, that at this point there is no role of giving any drug to this patient.
Yep.
Please reach the diagnosis. Please reach the diagnosis.
Partha Sarthi, sir.
Lungs on Fire are good. They give the message. Okay.
Trans. Needle biopsy.
So you see, now the question is, tissue is an issue.
Yep.
So you have to get the tissue. Where to get the tissue when you have a bilateral disease, and how do you take a call? Whether you want to biopsy bronchus, you want to biopsy pleura, you want to do it to lung. What do you want to do?
So,
and us, everybody wanted PET scan because they now are very, very intelligent and now far advanced, where they want that now one procedure should give you the diagnosis. You can't let this patient go to another, you say after some time, okay, this didn't get, I will try this. Now it is not going to happen because already many procedures have been done on the patient.
So though I am a big fan of PET, but this particular patient, I did not do PET. And we did bronchoscopy. Please have a look. And the next question is going to be tricky because I'm not going to give you the option. I will go back to the
Sonia,
question.
you would have gone for
No, I'll also do a bronchoscopy. And
not change your mind, sorry.
So, okay, bronchoscopy. Will you do biopsy? If yes, where will you do biopsy from? I am showing upper lobe, middle lobe, left upper lobe, left lower lobe. You had seen the CT scan. You want me to go back to CT? I can go back to that also.
So they're looking at this. Is like why the choice is only one? Is there a problem in taking multiple biopsies from various areas which are looking abnormal?
What about the HIV status?
So you spoke about transbronchial biopsy, no?
Yes.
Yeah, she's talking about it.
No, because there is nothing endobronchial.
Correct. Yes. Yes.
Okay, left lower lobe.
I think the radiologist has to tell us which looks more active, dirty, and likely to give the diagnosis. I think this is very good to ask your radiologist that which is the right place to get into rather than making our own decision. So let's see what Khushbu tells us.
So to me also left lower lobe looks like a more active place where more disease is happening and more actively.
It's more consolidated.
More
So if you
consolidation,
do a
more
TBLV,
problems.
you'll get a good tissue. Definitely you'll get a good. Everybody agrees left lower lobe? Right upper lobe. He wants to go into the right upper lobe. So people, half of them left lower lobe. How many left lower lobe? All.
Okay, once again, who all want to go for right upper lobe? My God. Sure.
Oh, we have Morris. Morris, we are here. Please, come here. If you are a radiologist and I ask you that I am into real bad trouble, I don't have a diagnosis, and this is the kind of CT scan, where will you advise the parents?
So based off what I see on CT scan, and since there are so many great interventional pulmonologists in the room, why not do multiple biopsies? Do them in like the lower left lobe and the upper right lobe. I mean, this is an option, right? To do it at multiple sites. But from the CT scan, what I'm looking at is if there's something else going on.
Like?
Yeah, if there's maybe some infection, because in the left lower lobe, the consolidation, I'm not so sure. Probably in the right upper lobe, I would be a little more confident because there's also not the effusion. It might be that in the left lower lobe there's something else going on. But I think both would be fine. I wouldn't strongly argue for the right upper lobe, but I think the right upper lobe.
I think entire hall is correct. He says you can take it from there, you can take it from there. Both are good enough. So I think what point he is making is, Asmita, that since it is cavitated, he is very likely that biopsy might yield something there because it's an ongoing process.
So I would answer that. This is for you, sir. So if there is a cavity which is caused by a bacteria or TB or infection, even BAL will come positive. I don't think you need to biopsy for proving it. Second, if it was a malignancy which is causing a cavity, which malignancy?
I think that's a good question, Morris. Just a minute, please. Morris, tell me one thing. If we don't have infection in the mind and malignancy in mind, in that situation, your advice will be still right upper lobe, or it will go to the left lower lobe, which is totally consolidated, and the right upper lobe, which is cavitated. Which one you will advise? I can understand that there may be two diseases at two different places.
Yes.
But
yeah, good question.
We don't have answer.
Then I think it's probably 50-50.
Correct. So there is no correct answer. Everybody is correct. He's already agreed. Everybody is correct. So let's see. I think it's correct because we do not know. There are two diseases or one disease. We have no idea. Correct.
I would just like to make one point.
Madam.
So one side from top to or bottom take biopsies.
One side. Because we can't do both
I think
sides.
this would have been best case
Madam,
for a
also,
PET scan. And it should have been a PET guided biopsy. That would have been, but I think at that point of time, PET was never considered. So that's fine actually.
Madam, can I have?
So Khushbu has some point to tell. Khushbu, can you please repeat what you just said to me?
Madhukar, give him one more coupon.
So if we look at the CT scan which was done,
Give him one more coupon.
One second, Khushbu has some points, sir.
Yes, Khushbu.
if we just look at this CT scan which was done around an year back,
Correct.
and we see the evolution of these cavitations, we see that they have developed into thin-walled cavity and they've evolved into a chronic process, especially the right upper lobe. So I think this disease is kind of going chronic. Better to target either the right middle lobe if we are opting right, or else the left lower lobe.
Okay. So I think what she's making point is very clear that, you know, if you want to do, somebody said on the right side, do both, upper and lower. So that makes sense because one might be a chronic inflammation, another may be something which is coming up on new. So we had enough discussion. Asmita.
Yeah.
What did you do?
The only thing is technicality. Just look at the segments, and if you are doing a transbronchial lung biopsy from right upper lobe, apical segment, there is no segment existing. There is only a very, very narrow window of passing the probe. So will you still do? Anyway, I
if
go
you have
for
to do
right upper
this-
lobe.
Okay.
I went for right upper lobe.
So if you would have got a radial EBUS, I'm pretty sure you would have used it that to guide you that. But she has already done it and brought a beautiful tissue. Where is our pathologist?
I think we will give Madam last
can-
chance, sir.
sir,
There is
can
one
we have a
audience poll. There is one audience poll. Madam cannot.
There is an audience
Yeah.
poll? Okay, what is the audience poll? No, do the audience poll now.
Yeah, ma'am, afterwards.
Yes. What is it?
A.
So vote it now. Everybody please vote it. We don't know who's voted what.
Malignancy.
Oh.
So it is A.
Oh. Why you said A? It is A and B equally getting numbers. Only thing is tuberculosis is not there.
So can
Who is this D? I don't know. Everybody should get one. Everyone should get one. Everyone gets one. Please run around,
So
run around.
I guess the entire hall is for us.
No, not the entire hall. Only those who have raised hands. Please. They are courageous enough to say that they don't know. So they must get it. Must get it. Deepak. Must get it.
Sir, can we have
Pathology.
Sir, can we have before pathology comment?
We can go back to that pathology. Now actually the cat is out of bag. No point. Already there you are seeing their... You are seeing IHC already on this.
So lymphoma, malignancy.
Now after that it is okay.
I think our pathologist is
Yes,
ready.
Ramanathan.
Our pathologist is ready, sir.
Yes, ma'am. Please.
Okay, so these are all IHC slides. Unfortunately, I think we do not have the histopathology. But this is also informative because it is showing CD20 positive, which is a pan-B marker. So it's a B-cell lymphoma. And with it, there is some positivity for CD138, which is a plasma cell marker, and lambda
B-cell
positivity,
lymphoma.
which is again a plasma cell marker, and BCL2 positive. The KI was how much? So the KI is less than 10%. So obviously we are dealing with a low-grade B-cell lymphoma, most likely a maltoma lung.
So who had said lymphoma? Who said lymphoma?
Oh my God.
No prize. Too many people have judged in the last segment. This was the last question. You should have guessed it early. If nothing is happening, it has to come as a malignancy, and bilateral lymphoma would be the one. And she has got maltoma. That's great. Actually.
So
And now she's getting the PET.
Yeah. We did this way only. PET was done only after biopsy.
See, hidden.
Where actually the biopsy was done? On which lung? Which
Right
lung the biopsy?
upper lobe.
Right upper lobe. She's marked that.
Right upper lobe.
So she does get PET scans done, but she wanted to sequence it the other way around. Otherwise, I think people would have taken and asked for, if given this, I would have definitely gone for a CT guided biopsy. Definitely, by all means, CT guided biopsy, because it's totally solid. And from the left side, I think I can ask Maurice. Maurice, if you are seeing this PET scan, what will be your advice?
I mean, it looks more active, like the activity is higher in the lower lobe. So you would probably go for the lower lobe then, but you would still probably think if it's the same thing going on, right? Because
It would have come.
it could be also two different etiologies, but.
The only thing is, if you
So
do
one thing
only
has
CT
happened.
guided, sir, you won't get cultures.
So one thing is that
I would say.
Morris has also agreed that, the FTG avidity will tell you that this is an active tissue. You are not going to come back and say that, sorry, I didn't get good tissue and it doesn't show any diagnosis. I think that's one thing very important. Second is, he says, if you get it from one side, it's not necessary the disease on the same side is same. So you need to keep in mind that whatever you are getting on one side, if it's explained by on the other side also, it's fine. Otherwise, sit on it and try to do, or keep looking for it, right? I know you have said everything. You have a lot of coupons have been given to you. Please, Loknathan. Yes, give him a applause.
Big round of applause.
Okay, that's fine.
That's fine.
Done. Agreed.
I think my panelists also should be given some chance to say, sir.
Yes, I think let's go to the panelist only.
If we all say first malignancy was highlighted clinically because patient was not sick. Autoimmune as such consolidation will not be so stable patient. Second again, fungal again should be symptomatic. So it was a
So you are saying autoimmune also possibility?
No, I am saying it's a slow growing process. It was clinically asymptomatic. Malignancy was a more, I thought it's a BSc. It came a lymphoma.
BSc.
Yes, actually give him coupon because he had right from the beginning shouting lymphoma only. For all of them are going to get, wow, great, very nice.
Okay, so the answer for left side pathology was also same or not? Patient was low grade lymphoma, maltoma, as madam rightly said. Bone marrow biopsy was taken, which was showing monotonous infiltration of neoplastic
I think let
cells.
her tell that. That's not our forte. That's a pathologist forte.
So the bone marrow biopsy is showing infiltration by small lymphocytic cells with, like hyperchromatic nuclei, and there is some cleaving. These are basically centrocytic-like cells, and which are showing positivity for PAN-B markers CD19 and 20 and BCL2, and they were negative for T-cell markers CD3, 5 and 23. NKI was very low, less than 10%, so it's a low-grade B-cell lymphoma, maltoma, involving the marrow also. Primary lung maltoma involving the marrow.
Okay. Quick one, because we are already running short of time and we have one more lungs on fire cases, which is equally exciting. So that's why everything was negative.
Yes, that's a good point.
I think all of you, if go back home today and think about it, that when you are stuck and you are not able to reach the diagnosis, PET will guide you as to from where to take the biopsy rather than looking for malignancy always. Because we think PET scan means diagnose malignancy, do PET scan. But this is not the way, because many cases you are under stress to get the best tissue, the first tissue and a diagnostic tissue, which actually PET is able to do much better than any of the CT scans. Right.
Did you had a chance to get the AFB culture later on?
Yes, it was negative. Everything was negative. No two diseases.
Everything. That's why we went for bronch.
Thank you very much. Wrap up, Asmita.
So I would like to end my presentation with saying, think beyond infection. Pulmonary malt lymphoma is uncommon, but it can be when you have got persistent cavitation. Do not stop at non-diagnostic bronchoscopy. Even though you have to do it 4th time, please go ahead. Adequate tissue, adequate site selection. IHC is the key. Once diagnosed, it has a very good prognosis, just like this patient. Thank you so much.
So tissue is the diagnosis. We must obtain a tissue and not keep guessing. And you are very right in getting on to that. Thank you, Asmita, for this wonderful case.
Thank you,
and
sir.
we move on to this 4th case of lungs on fire, and I think we have lots of coupons and prizes still available. So in this case, if you haven't got before, you please get it now. And if you have already got it, then let others have it.
I think thank you all the moderators, panelists,
Absolutely, yeah.
chairs, everybody, Khushbu and madam. Thank you.
Thank you
So
to our
one
expert
side is
panelist
open,
and
we have kept all
chairperson. I request the expert panelist and chairperson for the second case to kindly join us. Dr. Suresh Sagadevan, Dr. Akansha Chawla, Dr. Anil Kumar Singh. These are the expert panelists for the second case. And the chairpersons for the second case, Dr. Tajamul Hussain Shah and Dr. Gaurav Chabra. Sir,
And any more to come? Everybody has come. Okay. Who's doing the case?
So I would like to invite Dr. S.K. Madhukar
Wow.
to present the second case. Thank you.
God bless.
Thank you so much, Dr. Dhruv.
I promise you tomorrow 2 more very, very complex lungs on fire cases will be there in the pre-lunch session. Don't miss that. Oh, it's really fiery.
Can we have the sound, please?
Okay, let's...
Yeah. So it's my absolute pleasure, privilege, and honor to be here in this PACS with all of you. And I really congratulate my panelists. Believe in me, it's a very tough job for them. And before I start the session, here comes the first question for the audience. Tell me the name of movie from which this music is taken from.
This is a trivia question. Where is Kanishk Kumar? This is a trivia question. He has put this music.
Someone said Agnipath. 0 prizes for you. Who says Odyssey? Perfect. And I'm really very happy to see all of you taking some good interest in some good movie. Yeah, 1 coupon for each one of you.
So, guys, are you ready? Let me start the show. Here is the story.
Because I didn't know the answer of this.
So, this is about 70 years female, non-smoker, homemaker, who is diagnosed with ILD in 2024, 2 years back, and started on nintedanib, previously tried pirfenidone, couldn't tolerate it, has to be stopped. She came with the complaints of intermittent fever, with night sweats and dry cough for 2 months, swelling in the left supraclavicular region over last few days, which is mildly painful. Weight loss, approximately 20 kgs in the last 6 months, with extreme fatigueness. History of breast carcinoma, post-operative case, received radiotherapy 2 years ago, known diabetic, hypertension, and hypothyroid on regular treatment. So I'll just pause here for a minute so that all of you can go through the case. So, all right, should I move ahead? Yep. So the question is, what do you recommend next? Well, you have
Answer on the voting
you have
pads,
the voting
please.
pad.
Please take voting pads. Voting pads. These are voting
Atypical
pads.
infection profile, FNA cervical lymph node biopsy, CT head and neck. So, to my esteemed panelists, do you have any different view from the majority of the audiences? Any one of you? Do you think...
Madhukar, you must have leaked this case. I can see 61.9% asking for FNA.
So any different of the opinion from the panelists, please? All okay in the unison? Fine.
So this is the follow-up case of CA breast and received chemotherapy and radiotherapy, immunocompromise, having the lymph node. Doing the FNAC will not be a good option. I will go the biopsy of that because 30% patient of malignancy can have granulomatosis lesion on FNAC, that will confuse you. The background of malignancy, I will prefer to go for excision biopsy.
So absolutely. Let me tell you, this case had undergone initial investigations before the patient came to us. And it's not different from the mass thinking. The way we think, the 61% of us believe that FNAC should be done. And this is what exactly was done in this case. So,
no, I think they're jumbled up. Just there is FNA.
So the FNA lymph nodes, and I have the best mind in the business. Dr. Charul, ma'am, please.
So this was the FNAC of the cervical lymph node, and it is showing the reactive population of lymphoid cells with some presence of immunoblasts are there. There are no granulomas or necrosis per se in the FNA, but some histocytic collections could be appreciated, and I think gene expert was negative in this, so we had suggested a reactive lymphadenitis.
So a reactive lymphadenitis on FNA lymph nodes.
I think Dr. A.K. Singh had already said FNA is not going to be of any use. It's waste of time. But sometimes patient is very happy to get an FNA done first, and if they don't get anything on the FNA, then they can be mentally prepared for the biopsy, which is a little bigger procedure. I can understand that that happens in practice almost every day. The moment you tell them it has to be taken out, they will just disappear. So FNA was thought of that if some hint comes on it, you might go ahead, but it came out as a reactive lymphadenitis.
So the patient was treated with ATT outside for 4 weeks, but the patient's fever didn't subside. The patient subsequently developed severe abdominal pain and multiple episodes of vomiting, required admission for 5 days. The question is, what do you recommend next? So the voting line is open now. Are you going to repeat the FNA, excision biopsy, true cut, lymph node biopsy, CT head and neck?
I'm very curious to know if there are oh God, good, 0% A, and excision biopsy versus true cut lymph node biopsy. I think that is the major issue.
So true dilemma between these two. I would like to have the opinion of the expert and the panelist. Excision biopsy versus true cut lymph node biopsy.
I think CT chest and neck before biopsy to see the
true cut biopsy.
No, CT scan chest and neck first.
You want to have CT head and neck?
Yes.
Any specific reason
you want
for that?
to see how many more nodes are there, what is the characteristics of the nodes. You want to give a contrast and then see that, right? Perfectly right. Anybody can justify a true cut biopsy here?
So true cut biopsy is a non-surgical procedure that can be done by ultrasound.
Correct.
With equal diagnostic aid, whether you go for the surgical or you go for true cut biopsy, because we can do the ISC and all receptor study on this. So I will prefer to go for true cut biopsy rather than the surgical biopsy.
So absolutely, as been all of us are telling, we went ahead with the true cut lymph node biopsy.
Correct.
It was, and this is here.
But I can ask, I think, Banola, Professor Banola, that in your situation, you would have asked for a CT guided true cut biopsy or take out that gold. Absolutely. So, see, that's the difference in the Medicare system. If they advise, he has to get it done. But here, if you advise, there is always a possibility of second, third, fourth, fifth opinions, and then do whatever he feels is best, or he or she. So that's the reason precisely, they must have been under pressure, because this is not done at our center. So they must have been under pressure to undergo the true cut biopsy.
So Dr. Charul, please.
Charul, for the sake of shortage of time now, you just stand there actually, continuously cover all the pathology.
So this is a true cut lymph node biopsy, and as you can appreciate, it is showing extensive necrosis, and there are collection of these histocytic cells. So it is a necrotizing histocytic lymphadenitis, and few large cells were seen. But this is the limitation of a true cut biopsy, that we just got to the point that it is a necrotizing histocytic lymphadenitis.
So necrotizing lymphadenitis.
Necrotizing giant cells? Necrotizing giant cells, Dr. Charu?
No, necrotizing histocytic lymphadenitis. There are no giant cells in this.
What to do?
ABC
What to do?
AFB staining and fungal staining then on this or not?
AFB stain was negative.
Fungal
GMS
stain?
and PACS
we go for
fungal stains
IHC?
were negative.
IHC on this tissue will yield anything?
There was so much necrosis that IHC would have been non-contributory. So we.
Any other comment?
So excision would have been better, of course.
Better, of course.
But then now imaging is the option left. Now we cannot like send
So
more.
now this is little
investigation.
disheartening because the second biopsy is non-conclusive actually.
So,
if your comment is not good, Lognathan, I will take back all the coupons which you have collected. What is that? It's not done at our center at all.
fine. So
I'll take 2 coupons back.
So
because this is an old story.
that consideration is taken now into.
And now every time you say PET scan, it won't get you the coupons. Yes, somebody at the back had raised the hand. Wanted to say something from the back? No? Okay.
So with the background of necrotizing histiocytes, we thought of having CT chest done for the patients.
I think the important question will be if you are given a report of a biopsy of a lymph node, which is a true cut, good tissue, as a necrotizing granulomatous lesion, how many of you will start AT2 to this patient? Raise your hands, 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 raise your hands. Good. At least 50% of people in India would do this. And another 50% might be hesitant that, but 50% will jump to this diagnosis that this is necrotizing lymph node.
Sir, everybody will give it. It is just lungs on fire, so we are waiting for more.
Give him 4 coupons. Truth has come out. 4 coupons.
But in the era of
So-
evidence, we need microbiological evidence to start getting.
So let's see the CT scan.
So it's
You see
there.
the CT scan.
So please see the CT scan.
So again we have Morris with us. Morris, history of CA breast. Breast has been removed and radiotherapy has been given and this kind of an ILD picture is being seen. Any comments from your side?
So we definitely have fibrosis. There was a single cyst, but I think that's not important. But so there's some fibrosis going on in the lung,
Repeat the
definitely.
CTs.
Maybe you can play it again.
Yeah, play it again.
I'm looking also at the soft tissue there, looking at, like, there are a lot of lymph nodes, little calcified lymph nodes, and then there's the reticulation at the, like, pleura as well, but it's not just subpleural, there's also bronchiectasis, like more like bronchilocentric fibrosis, right? And this lymphadenopathy with like partially calcified lymph nodes, so differential sarcoidosis 1 differential, I guess, in this case.
So, Dr. Khushbu, what is coming out with us is it BIP with the mediastinal lymphadenopathy?
Yes, I agree with
BIP?
Dr. Morris.
So, bronchocentric interstitial lung
yes.
disease? Yep.
So he doesn't agree with the BIP very much at the moment. Is that right?
I described it, but I avoided the acronym because of didn't want to like stir the discussion again.
Okay. So any clue to etiology of this interstitial lung disease, considering?
It's a bronchocentric.
I think you leave that part, please. Let's leave that. We go
So,
to it.
Dr.
What
Khushbu-
is the etiology of this interstitial lung disease, if we can know about? She's an elderly lady. And post radiotherapy, post surgery, it has been found.
Ma'am, can you have a look on the
Yes.
again? Lung window. Lung window.
Lymphangitis carcinomatosis. Somebody has said no pleural effusion, no lymphangitic shadows.
It's very symmetrical.
It doesn't look like as-
it's a differential, I agree, but I think it's a lower.
Okay. Lots of hands, no, you are not allowed now. Enough. Others have to be given actually a chance. Post radiation, people are saying post radiation. Can you have a bilateral interstitial lung disease when you get a unilateral CA breast and irradiated?
Yes, Dr. Pratibha.
I think that's a very good question.
No, just surgery and
was
radiotherapy.
Only given surgery followed by radiotherapy and given nintedanib.
Yes.
So that's one of the question, that if you have a calcified lymph node and this kind of thing, and patient is relatively doing okay for the last 2 years on nintedanib, can it be sarcoid also? Is that lungs look like sarcoid? I think that would be the question.
Yeah, definitely. That would probably be that's the first thing I said, right? But
she wants to see liver spleen. Okay, I think we can go ahead in shortage of time.
So the question is, with so many...
Sir, I want to say something. In history, there was weakness, and we don't know which kind of weakness she is having in 20 kg weight loss. And for this juncture, because he shown that I believe in autoimmune profile.
Yeah. Okay, so yes, 20 kg weight loss was there.
So this patient is already having malignancy and there is a lymph node which is not fitting into any diagnosis. We see the CT scan, there is fibrotic ILD plus multiple mediastinal lymphadenopathy. My diagnosis will be post-malignancy sarcoid-like reaction. That is involving mediastinum as well as ILD.
SLR.
So the question is...
like reaction.
So many things coming up.
Possibility.
So one more opinion that I would like to give is that patient already has breast carcinoma. This is an ILD. She has weakness. So myositis associated ILD also has associated malignancies.
Very good. That's why I think autoimmune profile has come out there. We have voted on that?
Yeah. So what should I skip the opinion? Yeah. Okay. So we did the autoimmune profile test. Entire autoimmune profile negative.
So this was the bone marrow biopsy. It was showing only mild megaloblastoid changes with some degenerative changes. There was no lymphoma infiltration or any atypical cells in the marrow.
So you can ask me why bone marrow was done. It was primarily PUO investigation. Bone marrow was done. It was also done outside. It was not done at us.
And I believe there was a lot of immunoblast there. So it makes a sense to
Does immunoblast makes any?
Immunoblasts can be there in reactive lymph nodes also, or they can be there in immunoblastic lymphomas as well.
So,
bone marrow, as sir rightly says, was done for PUO, basically to find the cause of PUO. But there was nothing to suggest any granulomas or any histoplasmosis or any other infectious etiology.
Thank you. So the question is, now we had this.
This question is easy, I think.
The autoimmune profile is negative. Myocyte is done, negative. Entire autoimmune profile negative. So now what would you do?
What?
So let's have a poll on this, yeah.
So everybody is asking for PET scan? No numbers for that. No coupons for that. Any other choice?
87%.
Everybody wants a PET scan. And it was
I cannot deny them. I have this.
Go ahead, Madhukar.
Yes, I think it's...
PET scan, yes, you need to show them. Oh. What happened? It didn't run?
Time's up.
Okay, so I think now the cat is out of the bag.
Okay.
So PET scan was done. There was intense uptake, what you can see, and that was complete excision biopsy done from there.
So this was a very interesting lymph node excision biopsy. It gave us a lot of information. So this was the excision.
Ma'am, आप बता देंगी diagnosis तो? Is there a prize question on the diagnosis here?
There are pride questions
I
ahead.
think, sir, I will not tell the diagnosis.
Okay.
I'll just describe it and then it's open for the house. So I'll just show, this is the lymph node excision biopsy. At the top it is showing extensive karyoretic debris with extensive necrosis, and the important point is there were no neutrophils. There were lymphoplasmacytic infiltrate with a lot of necrosis and karyoretic debris, apoptotic bodies. And here you could see some large cells were there, and there were some plasmacytoid cells, and the large cells can be demonstrated better here. So there were large cells with prominent nuclei were appreciated. So apart from a necrotizing lymphadenitis, now we have some large cells also in the excision biopsy in the background of extensive necrosis.
So before I move ahead, any diagnosis that is coming to your mind?
Kikuchi.
Oh my
Okay.
God. What's your name?
Lognathan?
And how did you come to this diagnosis?
She's going to fire you.
No, I just want to understand.
Painful lymph node also is one of the clue actually.
What about the large cells? These large cells which you are seeing, how do you explain it in Kikuchi? Okay.
Painful lymph
So
node.
some of the learning points that we all should take this from here.
For this
So-
I will come.
So anyways, my differential was...
For this I will also come.
Yeah, so my differential was Kikuchi, lupus lymphadenitis or any lymphoma
You
which we
also
are
get-
dealing with.
Give him Yes. Who got it here? You also got it? Indu, there's a guy out there. Okay.
This
So
case
if-
has been leaked, I guess.
Yeah, no, not at all. Not at all.
There is some controversy. Anyways,
Not-
we did
Because
the...
these slides had to be reviewed multiple places to get to the diagnosis of Kikuchi disease.
Kikuchi.
But I
And-
think very good questions will come later.
Yeah, so you can see it is showing 19, 20, which is PAN B, and even 3, 4, which was slightly positive. So, yeah.
Go
and-
next.
Next. So CD30 was very focally positive, but it was showing membranous staining, which you see in immunoblast, and 15 and EBV were negative. So obviously we are not dealing with the
So
Hodgkin's
this is a
lymphoma.
prized question.
अभी तो ये हो गया ना,
No,
diagnosis
no.
दे दिया.
The point is the patient has CD30 positive, but the patient has CD15 negative. So what is not the diagnosis?
Sorry, TB. That will not get even single mark.
So
yes.
if we are talking about CD30 and CD15, CD30,
He has
CD15.
ruled out this prior to
Isko-
reaching the diagnosis of Kikuchi disease. So what's that disease?
Sorry? Okay. So Dr. Charul, please, just the answer.
Yeah, basically 15 is negative, 30 is showing only membranous positivity, which is seen in immunoblast. These, you should not confuse it with Hodgkin's lymphoma. Basically.
So if the CD30 is positive, immunoblast, CD15 negative, rules.
CD30 in Hodgkin's has a very characteristic presentation. If you show the
Okay.
next slide. So,
Oh, we have missed this question also. Forget it now. Let's go
So-
to the next.
CD68 was also positive, which was showing histocytic cells, and CD8 was positive.
So we really have to give the prize for this. Which disease very closely mimics the diagnosis?
Those who picked up Kikuchi disease, they can answer this question. Which disease mimics like Kikuchi disease?
Yeah, what is the differential of Kikuchi
There are
disease?
3-4 people who came up with.
Sorry.
So what is the first differential of
So a
Kikuchi
patient,
disease?
you have Kikuchi's disease, CD68 is
Let
positive.
her ask, Madhukar. She's not going to leave this.
So, what is-
IgG4. So we have the prize for this. Let's.
So when you're seeing a necrotizing lymphadenitis and you have made Kikuchi, what is the first differential for Kikuchi? Yes, very good. Lupus lymphadenitis.
He gets the prize. SLE.
And
SLE.
lymphomas also, you have to keep lymphomas also
SLE.
in the
That,
differential.
but we are not talking about lymphomas. Are
We have
going on
already
discussion
ruled
for
out
a very
that.
long time. The answer, the master is always right. Sorry, this answer was SLE.
So
But sorry, he gets
now
it.
we have this final prized question.
Yes, this is for everybody.
Identify the cell.
Mega prize.
Can anyone recognize
No,
what
I
is
have a
this?
question.
Yeah,
because
sure.
Generally, Kikuchi disease is in younger people. Under
Yeah,
30 years
absolutely.
old, the
Yes,
patient
yes.
is 70 years old, is out of...
So what
came
was
out
the
to-
driver here? We couldn't understand
We
that.
would go to the last slide and we'll have this
Yeah,
discussion.
okay. He has
with
something
Richard.
again hidden.
Yep.
Okay.
So
Which disease closely mimics? Has anybody answered? Any prize for
No.
that? Acha, that's gone.
Okay.
Next.
SLE. SLE.
Acha,
Lupus.
that's gone. Next is that.
So next is
Ha,
identify the cell.
Sorry?
No.
Alveolar macrophage. We won't show you that. Very sure. Anything else? Sorry? Immunoblast you said? Okay, we showed you immunoblast before. Why would we show you again? Sorry? Langan cells? No. Histiocytes? No, she won't allow histiocyte word. But it is close to that. But not the one. You have not reached there. Nobody.
Should we give the clue?
Give the clue.
Clue is that this is CD30 staining.
CD36 positivity.
30.
Sorry, CD30 positivity.
You remembered CD30 positive, CD15 negative?
Sorry?
CD30.
Huh?
Very
Reed
good.
Sternberg cell, correct. Reed Sternberg cell, Krishan Kant, mega prize. Where are the postgraduates? Where are they sleeping? Why are they not getting the prize? You can't recognize Reed Sternberg cell?
So now comes to the question that was really
One
pertinent.
more prize, wow.
That pertinent question that Dr. Brunella asked, So a 72 years female, Kikuchi's disease, why would this patient have this disease at this age? And let's see the CT scan. The HRCT, we forgot the HRCT completely. So I'm putting it again, this CT, HRCT being put here. So this is the crux of the discussion, What about this ILD with the Kikuchi's?
Any connection? Any connection? Any connection?
So before take this discussion, Dr. Khushbu, would you please explain the findings that we have?
So definitely we are looking at a fibrosing interstitial lung disease. The disease has a diffuse axial distribution, top to bottom, entire lungs are involved. The pattern goes, it very closely mimics, I think that discussion was there, it looks like a BIP pattern, if I have to give a pattern name to it.
So do you believe it's a bronchocentric lesion with lymphadenopathy?
Yes.
And it has
So
progressed?
sarcoid has been already brought in as a possibility.
So we have the inspiratory, expiratory scan.
There are air trapping, there are areas of air trapping in the
Yes.
expiratory scans.
So there is involvement of small airway, bronchocentric ILD with lymphadenopathy. Kikuchi is in the mind that there is progression, 72 years female. Any idea? And the prize and answer to, and the prize for the right answer will be given by the Supreme Boss, Dr. Deepak Talwar. So Kikuchi's can have ILD manifestations rarely. What is atypical here, which is not found in a Kikuchi's, is the involvement of small airway on the CT. So it could not be the Kikuchi's ILD. What else it could be?
What? Huh? Lupus. Otherwise... Okay, go ahead.
So your thought on this, and then
No,
we'll
I
finish
think
it.
just finish it.
So
now, yeah.
are we going to give the prize for this?
What is that? Okay, he's talking about immunotherapy. Immunotherapy. Not received any immunotherapy.
Not received any immune
Not
checkpoint
received any
inhibitors,
immunotherapy,
nothing.
yeah. I think let's close this.
Yep. So the key learning is, it's a histocytic necrotizing lymphadenitis. It is a rare benign self-limiting disorder. Primarily causes fever and painful cervical lymphadenopathy. Mimics highly aggressive disease like lymphoma and SLE. And most critical challenge here, to avoid the misdiagnosis, whether it's tuberculosis or lymphoma or Rosai-Hoffman. Misdiagnosis has to be avoided. Thank you so much, everyone. Thank you so much, my panelists.
Thank you, everyone.
And thank you so much, experts. Thank you so much, sir.
Thank you, everyone. These were two very interesting cases with learning points. Moving on, we have the next session, MRI in pulmonary sarcoidosis, the new paradigm with 0.55 Tesla, what's trending. And for this, we would like to invite the speaker, Professor Morris Pradella. For moderation, we would like to invite Professor Manoranjan Dash, our radiologist expert, Dr. Khushbu Pilania, Expert panelists Dr. Ashish Tandon, Dr. Sweta Purohit, Dr. Amit Dave, Dr. Brijesh Prajapat. And this will be chaired by Dr. Sunali Kumar, Dr. Sanjay Sareen, Dr. V.N. Tyagi, and Dr. Rajiv Kekar.
When to use MRI, what information it will give, can it help us? And we have today the speaker who's the author of the article on the 0.5 MRI Tesla MRI in lung disease. I think sarcoidosis is the paper. So I think best to hear from him. Manoranjan, take over.
Good evening. Hello. Very good evening. Thanks to the organizer for giving this opportunity. Welcome all faculties, chairpersons, speakers, Professor Pradella. I hope, as you know, sarcoidosis, should we follow with serial CT thorax or should we go for MRI? Then why the MRI stands since last 2 decades? Why again the paradigm shift of 0.55 Tesla? I think to justify this talk, I invite Professor Pradella to speak on this paradigm shift of low field MRI in lung disease, particularly in sarcoidosis. Welcome, sir.
Thank you so much for the kind introduction. And I must tell you that I'm not going to talk about sarcoid only. I want to share with you a little bit our journey with like lung MRI, low field lung MRI. I have no personal disclosures, but my department gets support from Siemens Healthineers. So what I want to talk about first, a little bit about the background, introduce you all to the system. I'm not sure how aware you are of lung MRI, low field MRI. And then I want to kind of like show or take you on a journey towards why you do MRI, why would you want to do MRI of the lungs. And I will basically focus on 3 things. I will focus on anatomy, morphology, I will focus on functional imaging, and then new imaging techniques, new tissue contrast techniques. And in between, I will throw in the results of our sarcoid study. However, the sarcoid study we started multiple years ago, and we couldn't apply everything in this cohort. But first, lung MRI. Basically, it's a very bad idea because typically for MRI, you want a lot of water protons, but the lung has less tissue. There's so much air around the tissue, so you have a low signal. And because of these air-tissue interfaces, it creates artifacts. Like basically, you get a lower signal compared to like parenchymal organs, for example. If you look at like PubMed, still there are people doing lung MRI, right? But if you think probably this graph would be the same for anything you search on PubMed over like the last decades. So then is maybe a low field MRI the solution? Because of the lower magnetic field of the device, you have actually less artifacts and you also have then more time to get the signal, the low signal, measure the low signal in the lung. So in the meantime, there was a little bit of a reclassification. So a few years ago, anything below 1 Tesla was considered low field. Now there's a range of like mid-field scanners. It's 0.1 to 1 Tesla. And in the lung, it's less artifacts. However, the scanning time gets a little longer. And that's the system we have at my hospital. It looks probably like more like a CT. It has the 0.55 Tesla as mentioned. And one interesting thing is the bore is pretty wide. It's 80 centimeters. Typically, MRIs are like 60 centimeter bore wide or 70 centimeter. So this is more comfortable for the patients. We published another article where we looked at like the cardiac cine imaging, and we asked our healthy volunteers and the patients how they liked it. And basically, green means, I have to add, they got the 0.55 MRI and a 1.5 Tesla MRI. And green means the comfort was the same, and blue means the comfort or like each parameter was perceived as better for the patients. So both the healthy volunteers as well as the patients, they preferred actually the exam in the low field MRI. And another interesting thing is that there's less infrastructure requirements. So you see there's like no quench pipe. So when there's, for example, electricity shutdown, the scanner is not losing all the helium. It has basically, compared to a normal MRI, which has hundreds of liters of helium, it only has like 700 milliliters of helium, which makes all these things possible. But in general, ask yourselves, how and why do you image the lung? So we do a lot of CT in pulmonary disease. There's a little bit of SPECT for like functional imaging and also ultrasound. But ultrasound is CT is like the major thing, right? Because what do we want to see? We want to see anatomy. We want to see the lung. We want to look for these subtle reticular changes. And then lung function, a little bit in expiratory scan, right, to see if there's like some small airway disease, but that's just like a little side part. And then we also have the radiation exposure. If we think differently, and if we think about why do we do MRI, in MRI what we want to do about anatomy, we want soft tissue contrast. I've shown you an example of the brain. Brain MRI is like amazing. I don't read brain MRIs myself, but you get a very good soft tissue contrast. Also for like images in the MSK section of the joints, that's state of the art, right? You can also look at vessels in the brain, vasculitis and things like that. So anatomy is one part, but you also want to know about the function. This is an example of a cardiac MRI. The patient had a LAD infarction. You see a thinning of the septum of the apex post-infarction, reduced left ventricular function. That's also state of the art, right? Also then, besides the heart, functional imaging, for example, is done to look for like chronic inflammatory bowel disease or in pregnancy to evaluate the location of the placenta, for example. And then MRI is really about tissue characterization. If you think about the abdomen, this is an example of a sequence with which you can quantify the steatosis in the liver, and in the extent you can do that, like assess that on MRI, you cannot do it on CT, basically, or in any other disease. Also, in MSK settings, you can look for edema and things like that, right? Now, I want to go back and I want to go to the lung. So this is one of the patients of our sarcoid study. It's a sequence which was developed at my hospital. And so the patient had pulmonary involvement, as all had in the study, and especially in the upper lobes on both sides, you see some kind of like consolidation-like changes because of the fibrosis. So this sequence runs like approximately 6 minutes. The resolution is 1.3 millimeter isovoxel. So it's not as good as CT, right? With CT you can get a much higher resolution, but I think it should show you that you can actually image anatomy as well in anatomy of the lung, morphology of the lung. And I don't want to go into too much detail because these are my two colleagues from MRI physics I work with a lot. They came up with the sequence, and what this spiral animation there, this is the way the image acquisition is done in this MRI sequence. It's a very fast way of getting a lot of signal, a lot of imaging information, and we don't need any contrast for this scan, and the patient is actually, there's no requirement to hold the breath or anything. The patient can breathe however she or he likes, and all the reconstruction of the imaging is part of the post-processing. So this, to us, is a very comfortable way for the patient to get the scan done. Now I want to transition a little bit and talk about our sarcoidosis study. You're all aware about what sarcoidosis is. It's a multi-system disease. It can ultimately also involve the lung, but that's not the typical organ. Typically, it's the mediastinal lymphadenopathy. and it's often asymptomatic. Chest CT is the gold standard. And since we had the new system back a few years ago, we thought of what we could do, and we first thought, let's look at like sarcoid patients with like known lung involvement. And what we wanted to do was to compare it to CT, and also we want to investigate the lung function in these patients. So it was a prospective study. All patients underwent CT and MRI. We used the sequence. That's the same patient I've shown you before. Free breathings, about 6 minutes acquisition time for this sequence. And we compared it to like a 1 millimeter isovoxel resolution lung kernel CT. And then two colleagues of mine, we all read the scan. We first read the CT, which was the ground truth. Then we did a blinding period of 7 days. So ideally, we forgot what we saw. It was much longer, for me, for example, than 7 days. And then we looked at the MRI of the patients. And what we were focusing on were the changes you in general could see in like pulmonary disease. So consolidation, traction bronchiectasis, whether we saw nodules, ground glass reticulation, and we did the common tests like the kappa, Fleiss kappa for the agreement, and also accuracy, sensitivity, and specificity analysis. And we learned a lot about the sequence. So this is still like kind of an early image, but it shows what we were reading best. I would say now the images look better when we would like scan a patient today. But you can see here this consolidation, a little bit of the nodular appearance. It's better to be seen on the CT, but it's approximately the same position on the MRI. One thing I want to mention is the MRI is actually in expiratory phase compared to the CT. This has to do because you get more signal of expiration time when you think about the breathing cycle. So we could also do inspiratory scan, but then we had to run the sequence longer. So this is why this is a little difference between CT and MR here as well. And that's the same case now in coronal orientation. But I think you can see it's not so easy to read. It's a very different imaging. The contrast is different. It's harder, right? And so we had in total 15 patients. The mean age was 50 years, and about half of them were females. And if you look at what each reader, when, for example, I looked at MRI, CT and MRI, there was quite some variation going on. So for example, for consolidation, the accuracy was pretty good, sensitivity was good, specificity not so good. But then look at traction bronchiectasis, sensitivity dropped a lot. However, specificity was high. But overall, that was probably like a moderate result, not so overwhelming. And then we also investigated the inter-reader agreement for both studies, and if you look at the CT side, that was a little humble moment for all of us because our agreement was really bad, right? On the MRI side, it was in some cases less than random, but I guess first, what I learned in my research career is data. You have to take it like it is, right? And I think if I do the study start the study today again, I would really focus about the readers sitting together, get like a consensus going. And we didn't really do that in the past, and especially for the MRI, I think that was the reason why the results were so bad. Why the CT results were so bad? Yeah, I don't know. I cannot really tell you. I was a little shocked. So far about the anatomy in the sarcoid study, I want to show you another case of anatomy I just had last week. And I probably try to pause the video here for a moment because I think it showed kind of nicely what can be done. If you look at like the basal part of the lung, you can probably see that there's like some cystic changes, right? And it's not just cystic changes, especially look here, right lower lobe, but on the other side, this is actually, it looks like honeycombing, doesn't it? But also more interestingly, if you look here at the APCs on both sides, you see some like consolidation going on. I will show you the CT of this case here next to it. I think on CT we are all probably more comfortable to diagnose here the UIP pattern, right, with these with this honeycombing at the bottom, and also this consolidation at the top. I'll probably stop here so you can better appreciate the changes here, even in the lung window. You can better appreciate the changes also in the lung window. So it looks like PPFE at the APCs and UIP at the bottom. And I just wanted to show you that now we get quite nice images, as this case was just from the other week, right? So this is about anatomy, and I think now the next I want to talk about functional imaging. So this is another case. This is a case who was sent to us because there was a suspicion of a one-sided paresis of the diaphragm. We did the sequence we have seen before, right? And there's no obvious elevation of the diaphragm on one side, right? It looks pretty symmetrical, right? But then what we did, and the sequence is very similar to the hard sinus sequences, and you see it's quite fast the way I present it here, but I wanted to show that you see it's also symmetrical movement of the diaphragm. Like if you had a paresis, you would expect one side to not move at all or be severely different. So there was no sign of paresis, right? So this is actually like nice. You can evaluate how the lung changes, right? But it doesn't stop there. So my colleagues have for like more than 15 years also worked on like functional lung imaging. And if you look at this video here on the side, it's the same video, just slower than the others, but it's the same sequence basically. And you see this like blue dot there in the top right lobe, right? And if you in like this voxel, if you can now analyze the signal intensity in this voxel there, and if you look at the graph on the right, this gives you the signal over time in this one voxel. And you see there are like two things going on. We have a very fast oscillation, that's actually due to the blood flow. And you can, if I start the video again, if you look at the vasculature, you see like the big vessels, they get brighter and darker. I think that's quite obvious. But this is actually also going on in the lung. But we can't really see it with our eyes, but you can quantify it with MRI. And then also you see this like slow oscillation. That's the changes due to the compression of the tissue between in and expiration. So what I am telling you basically is that there is some information about the ventilation and the perfusion of the lung in this imaging, which is obviously free breathing, but it's also, there's no intravenous contrast agent involved. So if I go to the next slide, and my colleagues, they really worked immensely, they're MRI physicists, they worked immensely on extracting that data. So if you think on the top left, you see the ventilation over time. So what you do like a co-registration, you remove the movement because of the in and expiration to get to a steady state, and then you automatically segment the lung, and then you get this like a spectral profile. And you see the respiratory frequency is here, there's also the cardiac frequency. And based off that, you can, it's a technique called matrix pencil decomposition. You can then extract all this information, you can create these maps you see here at the bottom for like the ventilation, for the perfusion, and much more. So how does it work? And if you think of the entire lung, you have these coronal acquisition, you have like multiple slices. It takes about a minute per slice, and depending on the size of the patient, you would do 6 to 10 slices typically. And at our side, it works all automatic. So we acquire these images, they are sent to this special server from my colleagues, and they do all this post-processing automatically. So the motion correction, the lung and lung lobe segmentation, the matrix pencil analysis to quantify everything. And the computational part it took about 20 minutes, now it's even faster. And in the end, I get these results. On the left, this is like the imaging I get in our PACS. And on the top, you see the ventilation, the perfusion map. You see also the anatomy map, how the lobes were automatically segmented. And on the bottom, it shows you what is considered to be defects in the lung. In blue, ventilation defects, in red, perfusion defects, and then an overlay map to identify areas with reduced ventilation and reduced perfusion. These are in pink on the bottom right. And I also get this report as a PDF, which gives me the defects per lobe, actually, not just per for the entire lung. And we are still investigating it, but defects more than 15% are abnormal, more than 20% are like 15% likely abnormal, 20% they are definitely abnormal. And the thing is, due to the imaging technique, there's always some inhomogeneity in the lung, so up to 15% is in the range of let's put it, these inhomogeneities, right? And we, as I said at the beginning, we also investigated that in our sarcoidosis study, and we had our 15 sarcoid patients, and we had a control group consisting of 30 healthy people, and we not just looked at the ventilation itself. You, for example, can see here on the top right, you see the anatomical changes here. And then, for example, here in the right upper lobe, you see there's like reduced perfusion there, and there's also in part a corresponding ventilation, reduced ventilation. And at the bottom, we basically, orange and red areas mean there's like decreased or severely decreased ventilation and perfusion in the center. And we took it in total and we compared the healthy volunteers to the sarcoid patient, and we could see that this shows you the percentage of defects. So for the healthy volunteers, it was around 50, and that is normal, but for the sarcoid patient, it was significantly more ventilation defects, significantly more perfusion defects. And when you look at like the combination of both, the matching ventilation and perfusion defects, that were the differences were even bigger. So far, that's about the sarcoid study, but now I think probably the most interesting part of the talk is going to start. And it's about the tissue characterization. And I brought to all of you this image. It's from JACC, like the leading journal in cardiovascular imaging. And it gives you an idea what you do in cardiac MRI. You see here on the left, you see like it's been around for like 2 decades, T1, T2 weighted images, and then the LGE, right? And then it's basically then the quantitative technique starts. So the mapping, for example, with which you can see fibrosis in the heart, you can see edema in the heart, and it helps you also regarding amyloid involvement of the heart. And if we look at like the lung, there are basically 2 things we are investigating at the moment. And one thing is called magnetization transfer. It's a kind of like contrast technique without any IV contrast, which there has been a lot of research, especially in the brain, and then also T1, T2 mapping, very similar to the heart. And first, the magnetization transfer. This is a rather complex slide from the MRI physicists. But what's going on is basically you measure the amount of protons which are bound, of water which is bound to protons compared to free water. You require 2 images, like a normal images and a MT weighted image on the right, and then you can basically calculate a map and calculate all of this. And why could this be of interest? There was one article about applying this to the lung. And this article, as you can see, is more than 30 years ago. It was from a group from the US. They also had like what we would now call a midfield scanner, 0.1 Tesla. And they investigated some healthy volunteers, but they also investigated some patients with interstitial lung disease, for example. And so they acquired one image per patient, basically. You see here, this is like an empty image, like the non-empty image and the empty image. And what they found out was the empty was a lot longer in these patients with interstitial lung disease, with, or as it was called, chronic parenchymal lung disease. And what does it look like at our place? So the acquisition time for that is about like 10 minutes. It gives a very different contrast, something you kind of have to get used to, right? But if you look at it, it's a little probably hard to grasp. But we can cover the entire chest, right? And then we can also apply lung segmentation. When we do that, you can get, like in a healthy volunteer, for example, you get this kind of like a bell-shaped curve, and it tells you that the mean MT is about 27. That's like on a scale from 0 to 100. That's like a percentage. And we did a scan, like quite a few volunteers, took about 9 minutes per participant, and we got quite stable results around this 27. And then we had a known patient with fibrosing hypersensitivity pneumonitis. You see the CT there at the top. You see there's fibrosis going on top right, bottom left lung, for example. The morphologic image there is, I think you can also like see that there's fibrosis going on. And then at the bottom, you see the empty image. And I think it's quite hard to just qualitatively look at the lung and see if there's a difference. But what you can see at the bottom here, in the center, the gray curve, that's the healthy volunteers. And in this patient, you see a shift of the empty values towards the right. So they were a lot higher. So they were around 40%. The patient got a BAL, and there was like acute inflammation in regards to the hypersensitivity pneumonitis. So for us, it was a little tricky. Is it the elevation caused by the acute inflammation we saw in BAL, or is that because of underlying disease? And the patient came back a few months later after cortisone therapy, and it was still 40%. So we were like, okay, after cortisone therapy, it's very unlikely that it's still acute inflammation, but the patient didn't have BAL there. And then the patient came back another time, 1 year actually later, and we still had a value of around 40. So our current hypothesis is that actually the MTR values in the lung are higher in fibrosis. And I don't have that really on the slides, but what's interesting is even lung parenchyma which does not look fibrotic on CT, has really elevated volumes. And as you know, for example, from IPF, when it's fast progressing, it's first just at the bottom, and then like a few months later, you see a lot of fibrosis going on. And we think that we might be able to image already affected lung which has not been transformed into like this fibrosis we are known from CT images. And another aspect of the MT is here, that's a young patient. If you look at the CT, like a patient with asthma, on the CT looks quite normal. There's nothing really obvious on the inspiratory CT. Also on our morphologic MRI sequence, there's nothing going on. But then if you look at our MT, it's around 20%. So normally it should be, especially in this young patient, it should be around 27, 28. So is this maybe also a sign in asthma? Can we maybe see is that an expression of small airway disease? The lung function test in that patient was quite normal, as there was no obstruction. But as we all know, it's possible that it's like not yet obstructive. So this is about MTR, the one contrast, and the last minutes I would like to talk about mapping. So this T1, T2 MRI contrast It's established for the, I mentioned the heart before, but it's also for the liver. And for the lung, the data currently is limited. We also do coronal coverage of the lung. It's faster, it takes about 3 minutes. Again, free breathing, no contrast needed. And you see here a case at the bottom. It has already been automatically segmented, and you get these values. And that's another patient with a fibrosing HP. And we don't really have normal reference values from our side, but a group from Bethesda in the US, led by Adrian Campbell-Washburn, they have published some normal values here, and you see, like on their system, which is similar to ours, they got T1 times about 970, T2 times around 61, and in our case, actually, the T1 time was a lot lower. It was only 817. The T2 time of the entire lung, again, was also elevated. So is this also a way to image fibrosis in the lung beyond the morphologic assessment we typically do on CT? This is our current hypothesis. So our vision basically is to establish a lung MRI program on our midfield system, free breathing, no contrast, and we want to do all these assessments. We want to do anatomy, but we want to focus more on function and tissue characterization, and we try to do it in less than 30 minutes. The post-processing will then give us lobe-based results, and we are also working on an software to analyze that. So with that, I'd like to conclude. So I want to say that low midfield pulmonary MRI offers new options, mainly for research, but if you think about anatomy, you have to be careful, because if you want anatomy or morphology, CT is just superior, it's fast, and this we won't beat it. But if you want to know more, if you want to explore lung function, if you want to explore lung tissue characterization, MRI might offer things CT cannot offer in this extent. And ultimately, potential new imaging biomarkers. That's basically what we're working on. I'm very glad to say that we have received funding to investigate cohorts of workers with dilicosis. We'll probably start in the beginning of next year to get participants into the hospital to do it, and ultimately we want to do a lung MRI program. And with that, I thank you very much for giving me the opportunity to talk about lung MRI and also to be part here of PACS. It's been an incredible experience for me. So to you, to the organizers and the faculty, thank you so much.
Thank you, sir. Sir, I am coming to, please. So, Professor Padala, thank you for excellent deliberation. Actually, please, sir. One of the best articles I have seen, it is published in recently European Respiratory Journal, Radiology Journal 2026, regarding low field 0.5 Tesla MRI. Do you think it replaces CT in near future, sir? What's your verse? Or it will complement CT in sarcod follow-up?
I think to replace it, no, it won't replace CT, right? But if you want the morphology, and we're all used to morphology, anatomy assessment for fibrosis. CT is so fast, there's no way to replace it, right? But if you want to know more, if you maybe, I think actually in ILD, you might only see the tip of the iceberg on CT. And if you think about, I had a discussion outside before, if there's some mild fibrosis on CT, what do you do? Do you do biopsy or something? It might be that on MRI you will see changes. You will see actually there is fibrosis.
Yeah.
And then this might change the treatment. And then you would say, okay, this is fibrosis, and we start based on the MRI, not on the CT. I think that is where the room is for the MRI.
Sir, you told in your article that it is very much sensitive for your consolidation, for GGOs, for lymph nodes. But for a sarcod patient, if there is a reticulation or the peripheral nodules, do you think still go for a MRI along with CT, or we will directly switch off to only the CT follow-up?
Yeah, like our clinical practice has not changed because of the study. We still do CT, and one thing which we found out in the study is calcifications are difficult on MRI because they don't get any signal. So if you have lymphadenopathy without calcification, you see it very well on MRI, but if you have calcified nodules, it might be completely dark. On our anatomical sequence, you can still see them, but since the CT is so fast and everything, we just do CT.
Thank you, sir. Now just a question to our subject expert, Khushbu madam. Madam, why did this 0.5 Tesla MRI is preferred over the 1.5 Tesla to 3 Tesla MRI? Because what we are usually using this only. But to you, ma'am.
So I wanted to put ahead that question to Dr. Morris, that how early are you looking at this data being extrapolated on a 1.5 or a 3 Tesla? Because those machines are more easily available. 0.5 is just coming up and it may not have as much utility to other...
Yeah, that's a very important and very good question. So in Switzerland, we currently have 2.55 MRIs in the entire country, right? And I guess the picture will not be very different here in India. So we are actually working on transferring those sequences to the 1.5 systems as well. 3 Tesla will be very difficult. I don't see it happening on 3 Tesla because of the technical limitations of like higher...
The magnetization transfer is an issue.
No, it's just because there's so much more artifact going on in the lung, and then you cannot get the signal of the lung protons out anymore. We have done some extensive work on like shielding techniques on MRI. So we are the goal to have this lung MRI program ultimately on 0.55, but also on 1.5. But this is still very much under development, unfortunately. Yeah.
Thank you, sir. With the pursuit of time, I think wind up. Before that, I will take one line from the expert panelists. Sir, what is your take on note regarding your MRI preference over CT on sarcoid follow-up?
Can you please repeat the question?
Sure. What is the practical advantage of MRI over sarcoid in a serial follow-up sarcoidosis patient? Because sarcoidosis patient, they detected in the 3rd or 5th decade and they are doing serial follow-up. Just final comments, sir, from you.
Actually, sarcoidosis patients we see in a younger age, between 20 to 40 years. And to monitor these patients' activity needs a lot of radiation.
Yeah.
So a 0.55 Tesla MRI would do much good to the patient in the long run. And secondly, in a sarcoidosis patient, when we look at the lesions on a CT, it is difficult to find out whether they are active or not. Whereas in a MRI, we can take a judgment whether to treat them or not.
Thank you. Thanks a lot, Professor Pratila, for your excellent talk. Thanks, expert panelists, my chairperson, and subject expert Khushbu Pilene, madam. Thank you, organizer Deepak Talwar, sir, for giving this opportunity. Oh, one audience question, sir. One audience question, please.
Oh, this is
working.
So, hello, Dr. Morris, I am here. So, it was a wonderful deliberation on the MRI aspect. It was comprehensive and exhaustive lecture. So, of course, we know that MRI takes a longer time, around 30 to 60 minutes if you do a proper MRI of the cardiac. So, some patients are there who cannot lie down that much. So, is there any way we can obtain these MRIs in a limited time? One of this is thing. Then, where do you see this? Of course, first you can go ahead with this.
Yeah, so there are basically 2 ideas. The one idea is that we apply dormicum, like midazolam, as a nasal application for patients who cannot lie for a long time or might be claustrophobic or something. But actually in the 0.55, while they say at the beginning they are uncomfortable, when they lie in there, it's a lot better, right? And when you're talking about, I'm not sure if we were also talking about pain. I mean, you have to do pain control, then otherwise, while the sequences are free breathing, the image quality still depends a little bit. If there's very fast or not regular breathing, it can get worse from the image quality. So you want to have the patient comfortable in the scanner.
Sir, with due apology, sir, should we wind up? We will discuss in that chair, sir. Because I think another few sessions are there. Sir, thank you. Yeah.
Thank you very much.
Thank you, sir. Thank you, madam. Thank you.
much. Moving on to the next session, the topic is approach to GGOs, role of interventional pulmonologist. To moderate this session, I would like to invite Dr. Lokesh Gutta, expert panelist Dr. Vishal Seth, Dr. Rakesh Godra, Dr. Sandhya Nair, Dr. Narendra B. Raval, and this will be chaired by Dr. Anaya Parakshkar, Dr. Sri Kirti, Dr. Gauri Nath, Dr. Gopal Krishna. And I would like to invite our speaker, Dr. Elena Mitrofan, to speak on this topic. Thank you so much.
Hello, everybody. Thank you for this opportunity to speak in front of you today. So, the ground glass opacities are among the most subtle. Oh, sorry, I started. So can I start? So as I say previously, the ground glass opacities are among the most subtle and in the same time the most demanding findings in thoracic imaging. They may represent transient inflammation, pre-invasive disease, or invasive adenocarcinoma. The difficulty is not simply reaching the lesion. The real challenge is deciding which lesion need tools, need tissue, need selecting the safest and most informative route, confirming that our instrument is truly inside the target, and obtaining a specimen that can answer the clinical question. In the next 20 minutes, I will focus on persistent focal ground glass opacity in subsolid nodules and on the specific value of the interventional pulmonologist can add to their management. Let us begin by defining exactly what a ground glass opacity is and what is not. Just a moment. A ground glass opacity is an area of increased pulmonary attenuation in which the underlying bronchial and vascular margin remain visible. This is an imaging descriptor and not a final diagnostic. The same appearance may result from partial alveolar filling, interstitial thickening, hemorrhage, inflammation, fibrosis, or neoplastic growth. Therefore, the first diagnostic intervention is classification. Is the opacity focal or diffuse? It is pure ground glass or part solid? It is new, it is transient, or persistent? This distinction immediately changes both the differential diagnostic and procedural strategy. For the presentation, I will concentrate mainly on the persistent focal lesions because that is where the decision between surveillance, biopsy, and resection become particularly important. That first distinction, diffuse versus first distinction, diffuse versus focal disease lead to two very different procedural questions. When ground glass opacity is diffuse, the clinical question is usually what pulmonary process is occurring. In that setting, bronchoalveolar lavage may identify infection, hemorrhage, or an exposure-related process, and transbronchial forceps biopsy or cryobiopsy may be considered in selected interstitial lung diseases. The endpoint is often a multidisciplinary diagnosis. A focal or subsolid lesion is different. Here is the central question is whether the lesion is persistent and biological significant. We must estimate the risk of invasive disease and decide whether observation, tissue acquisition, or surgical treatment is the most appropriate. So although the radiological terms is the same, The procedural logic is entirely different. Today, our focus is the persistent focal ground glass opacity and the subsolid pulmonary nodule. Once the lesion is focal and persistent, the CT phenotype becomes our first biological signal. The sequence illustrates the CT features that should drive our risk assessment. First, persistent must be confirmed because many inflammatory ground glass opacity resolve after treatment with antibiotic. Second, rising density is a form of growth, even when the maximum diameter changes very little. Third, the solid component must be measured separately because its appearance or enlargement is associated with a higher probability of invasive disease. Finally, morphology matters. A bronchus sign, bubolucensis, vascular convergence, pleural retraction, and speculation can also influence suspicion or procedural planning. Thin section CT and careful longitudinal comparison are therefore mandatory. For subsolid lesions, size stability alone can be falsely reassuring. A new or enlarging solid component should be interpreted as a change in biology, not simply like a change in appearance. The reason that matters becomes clearer when we connect the CT phenotype with the underlying histology. On the left, we see the radiological transition from a pure ground glass to a part solid lesion. On the right, we see the pathology illustrate the continuum from predominantly lipidic growth along preserved alveolar structure toward an invasive focus. The relationship is not perfectly one-to-one, but it's clinically useful. A pure ground glass opacity often corresponds to pre-invasive of minimal invasive disease, whereas a growing solid component increases concern for stromal invasion. This is why the consolidation to tumor relationship and the evolution of the solid component are so important. The radiological sign phenotype help us estimate biology, but it does not replace histology when histology will alter treatment. Our task is to identify the moment when tissue adds meaningful information. This brings us the more important question, not whether we can biopsy, but whether we should. The key decision is whether tissue will change management. A low-risk phenotype may be managed with structural CT surveillance. An indeterminate lesion is where biopsy can have the greatest value because the result may determine whether the patient continues surveillance, undergoes surgery, or receives another form of treatment. In a highly suspicious lesion in a fit and operable patient, resection may provide both diagnostic and both definitive therapy. Biopsy should be avoided when a negative result would not reduce the probability of malignancy enough to change the next step. Technical feasibility alone is not an indication. The procedure earns its place when it resolves a genuine clinical fork and produces information that changes what we do for the patient. So, in practical terms, when does ground glass opacity biopsy truly earn its place? There are 4 common situations in which tissue is particularly useful. First, when benign or inflammatory disease remain plausible and would avoid unnecessary surgery. Second, when histology could influence the extent of surgical resection. Third, when the patient is not a surgical candidate and the pathological diagnostic is required before ablation, radiotherapy, or systemic treatment. And fourth, when adequate tissue is needed for molecular analysis before treatment. The procedural plan should therefore begin with the required output. Do we need cytology only, preserved architecture, biomarkers, or simultaneous mediastinal staging? Once we know what information is needed, we can select the route and sampling tools that are most likely to provide it. The next decision is choosing the route around both the patient and the geometry of the target. These three approaches should not be viewed as competitors. Bronchoscopy is attractive when the airway path is present, when the lesion is deep central, when pneumothorax risk is important, or when mediastinal staging can be completed during the same session. CT-guided transthoracic biopsy offers direct access, especially for pleural-based lesion, but carries a higher pneumothorax burden in some patients. Surgery may be the correct decision when the pretest probably is high. The patient is operable and tissue is unlikely to redirect management. The optimal strategy is therefore multidisciplinary and patient-specific, and we should consider lesion size, bronchus sign, pleural distance, emphysema, comorbidity, the required specimen, and what will happen after a positive or negative or non-diagnostic result. If bronchoscopy is selected, we must understand why ground glass opacity remains technically difficult. Ground glass opacity biopsy can fail at 3 different levels. First, navigation errors. The virtual path may not correspond to the real airway. Second, CT to body divergence, anesthesia, respiratory motion, atelectasia, and bronchoscope-induced airway distortion may shift the lesion away from the planned location. Third, sampling error. Even when the tool reaches the lesion, the specimen may be too small or too hypocellular to establish a diagnostic. This is why navigation alone is not enough. Navigation is hypothetic. Radial EBUS, cone-beam CT, augmented fluoroscopy, or another form of three-dimensional imaging provides confirmation. The procedural endpoint should be by verified tooling lesion, followed by acquisition of tissue that is adequate for histology or biomarkers. Modern interventional bronchoscopy addresses these failures by combining complementary technologies. A modern workflow begins with a thin section CT and careful airway mapping. Navigation may then be performed using electromagnetic or robotic technology. However, the critical step is confirmation. A radial EBUS can demonstrate the relationship between the probe and the lesion, while cone-beam CT or augmented fluoroscopy can show the actual three-dimensional position of the biopsy tool and allow correction of divergence. Sampling then uses a combination of needle, forceps, brush, and in selected cases cryobiopsy. If malignancy is suspected and staging is indicated, we can do EBUS in the same session. The greatest improvement may therefore come not from another navigation platform, but from integrating navigation, real-time confirmation, adequate sampling, and staging in the one coherent workflow. Once the target is confirmed, the choice of sampling instrument becomes decisive. Each sampling tool answers a different part of the tissue problem. Needle aspiration provides cytological material and can be useful for eccentric targets, but it may offer limited architecture in a low cellularity lesion. Forceps biopsy is familiar and control, and multiple bites from slightly different trajectories can increase tissue acquisition. Cryobiopsy provide a larger, architecture-rich specimen and sample tissue circumferentially around the probe, which is particularly attractive when the probe is adjacent to rather than centered with the lesion. However, the benefit comes with an additional safety requirement. Before cryobiopsy, the operator must confirm a vessel-free position, secure airway control, prepare for bleeding, and standardize specimen handling. The correct strategy is usually multimodal rather than dependent on one instrument. When we discuss diagnostic performance, however, we must be careful with the old yield. Published series report encouraging diagnostic yields for robotic bronchoscopy and cone-beam CT, guided cryobiopsy in ground glass opacity, and subsolid nodules. However, this percentage cannot be compared as if they came from identical population. Studies differ in lesion size, the proportion of pure versus par-solid nodules, prevalence of malignity, presence of bronchus sign, technology used, sampling tools, follow-up duration, and importantly, the definition of diagnostic yield. A non-specific benign result should not automatically be counted as diagnostic unless clinical and radiological follow-up confirm. A major program should therefore report not only yield, but also sensitivity for malignancy, molecular adequacy, complication, and the final truth established by surgeon or longitudinal follow-up. This is why program quality must be measured beyond one headline percentage. A high-performing program should measure targeting success, pathology, quality, safety, and clinical outcome. Targeting metrics include whether tooling lesion was confirmed and how often divergence required correction. Pathology metrics should distinguish a definitive diagnosis from non-specific inflammation or normal lung, and should include molecular adequacy from when relevant. Safety reporting should include pneumothorax, chest tube drainage, and bleeding that require intervention. Finally, we should track false negative surveillance. These measures identify where improvement is needed: patient selection, navigation, confirmation, sampling, pathology processing, or follow-up. A non-diagnostic result is not beginning until the clinical and radiological sign story support the conclusion. The natural history of subsolid lesions explain why follow-up and interpretation must remain disciplined. Many subsolid nodules evolve more slowly than conventional solid lung cancer that justify prolonged surveillance in carefully selected patients, but indolent behavior should not be confused with harmless behavior. The first step is to determine whether the lesion is transient or persistent. The development of growth of a solid component is particularly important because it suggests increasingly invasive potential. Therefore, longitudinal assessments should include diameter, volume, when available, density, and the solid component. Short-term stability cannot always exclude malignancy. The trigger for action may be compositional change rather than dramatic size growth. Another potential source of false reassurance is a negative PET-CT examination. So, pure ground glass lesion is a small, and the small part solid lesion may show minimal or absent FDG uptake because of their small size, low cellular density, and predominant lipidic growth pattern. Therefore, a negative PET scan does not reliably exclude malignancy in a suspicious ground glass opacity. PET-CT become more informative when a substantial solid component is present and when invasive disease is likely, particular for staging. The CT trajectory remains essential. and if a lesion is persistent, become denser or developing a solid component, low FDG uptake should not override that evolution. PET-CT is one element of risk assessment, not a rule that out-test for lipidic spectrum adenocarcinoma, for example. Before taking the bronchoscope into the room, the entire procedure should be designed backward from the desired result. So, pre-procedure planning should begin with the endpoint. Do we need histology only, preserved architecture, molecular testing, or simultaneous staging? Next, we analyze the airway path, the bronchus sign, the airway generation, lesion size, pleural distance, like I told you before. Sometimes we have ground glass with nodule, mediastinal nodule, and we ask before, because we have this tool in our face, we can do it with ABAS, a diagnostic, for example. But sometimes the ground glass, we must know, the ground glass, pure ground glass, malignancy ground glass, don't spread in lung nodules. Sometimes there are very, very little to have a beginning lesion, cancerous lesion, and the nodule in mediastinum. So it can be another lung cancer, another pathology, or it can be inflammatory, or can be infectious, I don't know. But sometimes we can discern between this choice. One of the most important traits to that plan appears only after anesthesia begins, because anesthesia can change our first planning. The pre-procedure CT is usually obtained during full inspiration and in a awake patient. During general anesthesia, lung volume decrease. Dependent atelectasia develop, and the relationship between the airway and the lesion may change. The bronchoscope itself can also distort peripheral airway. This is CT to body divergence. A perfect virtual pathway may therefore lead to the wrong physical location. Ventilatory strategy is part of the biopsy technique. Appropriate PEEP, recruitment maneuvers, when safe, avoidance of unnecessary delay, and rapid three-dimensional confirmation can preserve accuracy. If intraprocedural imaging shows that the lesion has moved, the pathway must be corrected before sampling. We should never confuse successful navigation with successful targeting. Finally, we need a clear strategy for what happens when the pathology is negative or non-diagnostic. This is how we can have a changement in the imaging inside of an interventional room. A negative or non-diagnostic post-biopsy is not the end of the pathway. It triggers a second decision based on a radiological, pathological concordance. If the lesion has a low-risk phenotype, the target was confidently reached, the specimens were adequate, and pathology offer a plausible benign explanation, structural CT follow-up may be appropriate. If the result is discordant with suspicious imaging, if truly lesion was not confirmed, or if the sample contained only normal lung or non-specific inflammation, malignancy has not been excluded. The next step may be a repeat bronchoscopy with improved confirmation, CT-guided biopsy, or surgical resection. The word benign on a report is not sufficient by itself. Benignity is a conclusion reached by integration, pathology, imaging, procedural quality, and follow-up. I would like to close by summarizing where the interventional pulmonologist adds the greatest value. The interventional pulmonologist's role is larger than performing a biopsy. First, we selected the right patient and intervene only when tissue change management. Second, we confirm the target in 3 dimensions because navigation alone does not prove truly lesion. Third, we match the sampling strategy to the information required, cytology, architecture, biomarkers, all three. Therefore, we integrate the diagnosis, mediastinal staging, location, and the next treatment decision into one patient-centered pathway. The goal is not to chase every opacity or to use every available device. The goal is to resolve the right uncertainty to the right route with verified tool, position, and actionable tissue. Thank you very much for the attention, and if you have questions, I will answer from my experience.
Thank you, Professor Elena. That's a wonderful lecture on ground glass opacities, because GGO is such a vague, non-specific terminology which can fit into every diagnosis in the pulmonology. It can fit into infection, it can fit into inflammation, it can fit into malignancy like adenocarcinoma in situ. So, like you mentioned, in the interest of time, we will not take more questions. We are running late about 1.5 hours, so we'll take only 2-3 questions from the panelists. So once we know the diagnosis, we always go behind the history and clinical history where the patient fits into, whether it is malignancy or infection, inflammation, you know it first. So Dr. Rakesh, so I will ask you one question. So once you see ground glass opacity, and unlike it's an asymptomatic patient, he came to health check. So as a routine checkup, he underwent CT scan as well. There you found GGO of 20 mm, around 2 centimeters. You don't have any infection at that moment. So how would you approach that nodule? So basically, I ruled out all the possibilities, infection and inflammation.
So thank you, Lokesh. So as Alina explained that you very rightly that first when we look in a patient that is completely asymptomatic and we see a GGO, we need to confirm it first of all, is it a real GGO or not? It's very important because the CT has been taken in a proper, because in a full inspirations and probably where the locations, we need to be very clear about that. If it is in a basal part, we need to again look for that, whether it's a dependent density or kind of, we need to confirm it with your prone scans, if it is really, and also we need to ask for any kind of previous scans are there or not. Second thing, when we look into, when we are confirmed about these CT radiology protocols that it is a clear GGO, now the character is very important, because for the GGOs, hardly all these things matters, whether the patient is smoker or non-smoker, whether the age and all, because in every patient, whether it could be a young, it could be a concern for the GGOs, whether I need to go for, before going for a tissue diagnosis, I need to look into that. Is there any previous scan? What is the kind of incremental size increase or not? Second thing, what is the nature? Whether it's a pure GGO or it's a part solid nodule. That is because very important, as shown, that the character of that sub-solid nodules that raise the concern, and how much percentage and the volume or the diameter of the solid component is there, that raise the part of that how much it is a suspicion of the malignancies.
Thank you, Dr. Rakesh. Like you mentioned, we need to know the character of the nodule, whether it is subsolid or pure GGO,
right,
and also background history. So now we know that in our practice, at least in my practice, I always see leptic pattern adenocarcinoma. It progressed to stage 4 disease. So then I usually get treated by pneumonia, non-resolving pneumonia. But there are few cases where you find these incidental GGOs, and when you have high suspicion of malignancy, yes, I want to do a biopsy. That's when, how do you approach? In the current scenario, we have either you have to go for CT surveillance for 3 months, whether if it resolves, nothing to do. Then oral CT-guided biopsy versus the technology. Right now we don't have robotic in India. We have only cone beam CT and augmented fluoro. So which one you choose?
So it's very practical. First of all, that because it depends upon the nature of the GGO and the patient's preferences, and if it's possibility of, because 20 mm or the 2 centimeter size is not normal, because there we can, because we need to, if the patient we have a suspicion of possibility of biopsy, then looking at available resources, because as the cone beam CT and it is not regularly available at every center. So definitely if that is a bronchus sign is positive and the navigation path is clear, I would first definitely prefer with the radial EBUS with the cryobiopsies, because it can give us a decent your diagnostic yield. But if it is a negative, then it's a kind of the problem, because whether I need to repeat biopsy with the cone beam CT or directly send the patient for the surgical resections, provided that there is no any lymph nodes and any kind of other things where I need to go for a repeat procedure. Anything you want to say?
Yeah, Professor Elena, your take on that, because like you mentioned, with a small GGO, there can be body divergence and also basal atelectasis, like you have mentioned in the last slides, where you can miss the slide. So in that case, CT guided biopsy also would be ideal choice.
If you speak about large GGO, yes.
Yeah, GGO of 20 mm, less than 20 mm.
If we have the reason, that's why I talk about multidisciplinary team and speak with the thoracic surgeon. Sometimes it's better not to make navigation and tunnel lesion with cone beam CT and take a decision, a right decision to eliminate this ground glass opacity with an intervention, or in surgical intervention, and we resolve also the problem diagnostic and also the treatment sometimes. But this depends of the opacity. This depends of the variability in size of the opacity, how it changes with the time. Yes, of course, it's prudent to be careful and to wait a little bit, but not too much, because sometimes can change. The change will be very fast. So it's better to be prudent, but in the same time, like I said in the last slide, it's not better to confound our behavioral, to be prudent with lazy
so
behavior.
4 weeks. So in this like 20 mm, then you will wait for the 4 weeks, or it's a kind of 3 months? You will wait for.
If it is a ground glass opacity with single, for example, and we don't have any affection antecedent before this, the first thing that I do it, maybe to have a bronchoscopy or aspiration, lavage bronchoalveolar, and inflammation test. And if it is something like infection, to treat with antibiotic. After that, repeat it to the CT.
Because Dr. Lokesh, because for the focal GGO single in asymptomatic patients, probably antibiotic or lavage will not help too much.
Yeah.
I believe. So anybody?
Yeah. So in the interest of time, we would like one more question. So Dr. Narendra, Dr. Narendra sir. So like Professor Elena mentioned, yes, we need to look at the history, treat infection first. If at all, if you think of inflammation, treat that inflammation first, and do CT surveillance CT surveillance in 3 months. Then we're talking about next step. Yes, you decided it is not infection. You want to do a biopsy, and you're going in for biopsy. In that time, if you want to and also when you think of lebetic pad adenocarcinoma, we send a lot of molecular analysis. So do you mix up cryobiopsy when you're doing for cone beam CT along with cryobiopsy, because tissue is very important there?
Basically, we have to understand that GGO is an enzyme, it's not disease.
Yeah.
Just like the ILD, there are the 100 causes, more than the 100 causes of the GGO. So we have to find out the exact cause, and we have to treat, depend upon the which biopsy and the cryobiopsy, depend upon the time and the place to decide the intensive pulmonologist. They are the best judges.
Thank you, sir. So in the interest of time, we'll close the session. So to summarize, yes, GGO, it can be, every diagnosis is possible in pulmonology. So SSC or clinical history first, and evaluate in 3 months' time. So if you really want to go for biopsy, then choose your options wisely, because even if you're doing cone beam CT guided biopsy, the body divergence and atelectasis might prevent your result can go very low. So think twice how you do a biopsy, whether CT guided biopsy or percutaneous or cone beam CT, as robotic is also not available. With all the best possible techniques, we only go up to 70 to 85%. Thank you all.
Thank you. Thank you.
Thank you all the panelists for coming.
Thank you, everyone. Now we'll be taking a short 15 minutes break because we have to do the setup for the Boston University quiz, which Dr. Kanish, Dr. Preeti Vidyasagar will be conducting along with me. Thank you so much and see you after 15 to 20 minutes. Thank you. We'll be having the inauguration ceremony and the dinner after the quiz. So do join us for that. Thank you so much.
This is the case of a 24-year-old woman who presents with episodes of shortness of a 35-year-old, a middle-aged, a 32-year-old, this is the case a 35
सब उठा दे यार। फिर क्यों नहीं आ रही? आया यहीं छोड़ रहा हूँ इसको ऐसे ही। कंप्रेसर ठोक देना इसमें या कुछ। चलो ये देखो, कोई चलेगा तो आएगा तो नहीं है। आगे चलो, आगे चलो। क्लोज काट के सिर्फ हाई छोड़ दो, ये ना हाई ये कोई चले तो। टेंशन नहीं लेते सर। एक मिनट रुक जाओ, एक मिनट रुक जाओ। तीसरा नंबर दबा, तीसरा। है एक मिनट जाओ। वायर हटा दे। ये यहीं पर ही देखा, माइक थोड़ा और क्लोज नहीं हो सकता? आवाज कहाँ से आ रही है? नहीं अभी क्लोज करूँगा, काम कर रही हूँ। कहाँ से आ रही है? मतलब कैसे आ रही है? अंदर इसके इक्विपमेंट। प्लास्टिक बल्ब उठा लियो। हेलो, आप कैसे? बल्ब उठा ले। क्या जरूरत पड़ गई भाई आपकी? बल्ब उठा ले, बल्ब। हाँ बल्ब, बल्ब। खाली बैठे क्या एक महीने? मतलब इक्का दुक्का एक काम पहले दो दिन तीन काम दो काम बल्ब क्या हो? खाली वाला चेक करके वायर डाल दो। हाँ एक चलो भाई, बड़ा बड़ा चल चलो से टेंशन नहीं लेते जैसे देखा जाए ना सारी तरह देखा भाई। चार बोर वाली केवल लेकर आया हूँ काम तार डालने पड़ा एक साथ। तो और हल्की लेते ना, ये कौन सा डीसी करंट जा रहा होगा इसमें? ये कितने एम्पेयर का होगा ये? एक बल्ब जल रहा है। आवाज कहाँ से आ रही है? इसमें से? स्पीकर का है? अंदर है। हम लोग को ये माइक रखना पड़ेगा यहाँ पे। तो म्यूट वहाँ से करें? ऑन नहीं है ना माइक? हाँ ऑन है, माइक ऑन है। दबाओ भाई, बजाओ बजाओ ना, बजाओ बजाओ। वन से करो, वन से। आवाज आ रही है ना? यहाँ पे माइक छोड़ रहा हूँ यहाँ पे, ठीक है? ठीक है, ठीक, कोई दिक्कत नहीं। सर सुनो सुनो, एक चीज़ और आपको ध्यान रखना है। क्या रखना है बताओ? बोलना नहीं है आपको ज़्यादा, यहाँ पे किसी को आगे चलिए या किसी को बोलो ना भाई साइलेंट रहना है यहाँ पे, मोबाइल साइलेंट कर लो करना है तो मैं इसको उठा दूँगा, इसको उठा के ऐसे बस दबा नहीं कोई सब दबाओ चलने दो हेलो हेलो
Right. All postgraduates, your friends, your colleagues who are not yet into the hall, message them, call them, WhatsApp them, come to support you. Call everybody inside, give message fast and now. We are going to start, we are just ready to go ahead. Can we pass the message outside, Deepak? How the message will go? There are a lot of people standing outside. They must come to know of it. Process बताइए देना ये सब मैं तो सिर्फ लोगों को बुला लेता हूँ
हेलो हेलो
Hello. Hello, hello. All set? None? Are they connected? Huh? We have a couple of minutes more because we are connecting with the Boston University in US, which will be taking care of the 3 rounds.
Hello, hello. So it's not just to support your friends. We also have a round where the questions will actually be directed to the audience. So you'll be getting prizes. So we need active participation from the audience. Please call whoever is remaining. All the postgraduates are requested to be here today.
We're waiting for them.
She's saying something. So good evening everyone, and I welcome you all to this Boston PACS mega quiz. So there were MCQ quiz which was conducted throughout the country in various medical colleges, and these 20 people were actually selected for this grand round. We have 5 rounds, and that will actually decide the winner from the best of the best. So I welcome you all, and first of all I would like the teams to actually take their places. In team A, we have Abhijit Singh Sengar, Keshav Lamba, Anuvad Modgil, Sanjeev Verma and Kundam Kumar. This is team A. Can team A please come? Can we have a round of applause? These are all winners.
So, Dr. Dhruv, Team A is from which zone? People want to know. You guys are from which zone of our country?
Mike. North zone.
So Team A is North zone. So I'm expecting all the faculties from North side to support Team A.
And all the postgraduates also.
A big round of applause for North side.
Now moving on, Team B, I would like to invite Nikhil Madhani, Om Prakash Vijay Kumar Giri, Shivani Chauhan, Gaurav Bansal and Govind CS. Kindly come to the stage.
So Team B has 4 people, 5.
So I think Team A, someone backed out last minute. 2 people backed out, oh God.
So they are at disadvantage, nothing can be done right now.
So they need more support from the audience.
If you allow, then they can add on 2 people if you want. All the doubtful questions will be, we can add one? One of the postgraduate student can raise your hand.
If there is any volunteer, you
Wildcard entry.
might want to try your luck.
Yeah, we went to Vadodara and the number 1 over there in the ILT quiz is sitting over here, I think. Yeah, please join and represent Team A. This is called pure luck. The wild card entry, maybe he can chase the game now. So now Team B, put up the mic and address the audience. Where do you belong from? Which zone of the country? Who is the leader? If I would have been standing there, I would have put up the mic and ladies first.
From West Zone.
West Zone.
So West Zone, give us a cheer. Now, Team C, we'd like to invite Abrar Vallabhai, Akila Shankar, Jaya Surya H, Ilam Parithi and Hari Krishna R.
So the third team is here on the stage. It's too crowded, I think.
How many people? 5 people. Where
5.
are you from?
No absentees.
South Zone. Yeah.
A big round of applause for South Zone people.
South Zone.
I request all of you to just text your friends to join this quiz because this is going to be very interesting.
Moving on, now we have Team D, Umesh Mohan, Crosswind Revant, Dharani EP and Abharna Ji. Come on. So 4 people. Okay.
So you are
Acceptable
short
strength.
of one person, right?
1 person backed out. So I think
they
Team
have
A
4.
also has 4 people.
They have 4.
And Team A now has 4.
Should we ask to volunteer? No.
No.
4, 4?
No.
5, 5.
So which zone
what
are you from?
What part you represent?
Which zone?
East Zone.
East Zone, give us a cheer. A big round of applause for East Zone. So we'll be having 5 rounds. 3 rounds have been made by Boston University, and I'll be telling you the rules when we start each round. Each round has different rules. And 2 rounds in the end are PACS round, which are prepared by us. So this is going to be interesting. Let's see.
So before we move ahead, I request Dr. Preeti Vidyasagar, one of our quiz masters and judge maybe in the later rounds. I request her to please be on the stage, a very famous personality, Dr. Preeti Vidyasagar. Big round of applause for her. So Dr. Dhruv, how do we proceed further?
So starting with the round 1, can we please have my presentation?
We can, yeah, it's too crowded. Can we have the team to just separate this dice so that we can know that which team people are together? We can have 3-4 people over here, please, for the quick shifting of this desk. You can also do one ahead and one back, maybe. Slightly ahead and slightly back.
Change it.
Yeah. एक आगे लीजिए इसको. Yeah, you can take this side.
So meanwhile, I'll tell you the rules for round 1. So we have 6 questions. All is buzzer oriented. So whoever presses the buzzer first gets the chance. And if they are not able to answer, the question goes to the audience. And whoever answers correctly, I think, PACS coupons?
Yes.
Yeah.
Absolutely. I'm sure many people are having an eye on the big prizes in the souvenir counter. Of course, you can get the coupon, trade it, and there is a time tomorrow as well. Save your coupons and then trade it tomorrow to get the bigger prizes from the souvenir corner, the PACS souvenirs. First round with the buzzer round, and audience will be hoping, I think, that they shouldn't answer, so they get the opportunity to get the coupons, I think. Okay, can we have, yeah. Now you can take your places, slightly behind the, yeah. I think now we have some demarcation.
Can I have the slide changer, please?
Remember, first round, buzzer round. Yeah, we have the questions on the screen.
So, should we start?
First, before we start, Dr. Dhruv will be explaining about the marks, the rules, how to proceed further in the quiz. Please, Dr. Dhruv.
So, we'll be asking 6 questions. Whoever presses the buzzer first will get the chance. If he is unable to answer,
please listen to this carefully. Like this.
The question will go to the audience if you are unable to answer. For correct answer, we have plus 100. For incorrect answer, minus 25. So, even if you don't answer and press the buzzer, it will be minus 25. So, you only press the buzzer if you're sure.
Think before pressing it, okay?
Should we start with the first question? Are we ready?
A big round of applause. Come on, guys. Let's see who wins this Boston quiz. Team A.
So, here goes. No, it's for the buzzer.
Oh, buzzer. Yeah.
Everybody has only for Team A.
Fair chance.
I'm reminding you, it's buzzer round. So, everyone hands on your buzzer.
I request Dr. Preeti to be here and see whatever you decide, who has pressed the buzzer first, we'll ask the team that question.
If there is any discrepancy. She can sit, I think there.
You can go there. Near that podium, I think that will be the area that will be very visible to you. So we will take your final opinion. Yeah, we can do that. I'll bring the chair. I'll bring the chair. Yeah. All eyes. But how can you? She will have to see who is pressing the buzzer first. Yeah.
She will be able to see from here, I think. Okay. Team, please, 3-4 people from your side. Make it same level horizontally. Semicircle. 2 here and 2 here. Yeah. Yeah, you can take it slightly ahead. Let's take it here. That one has to come here. Or is this fine, sir? Yeah. Slightly left, more left. Uh-huh. So I request all of you to check your buzzers first. Yeah. So at one time only one buzzer will make sound. Yeah, because that he presses the buzzer first. So the one who presses the buzzer first, the light will glow in that. So others buzzer won't work. So it's very easy for you. Everybody has checked it?
All settled?
All done now.
All settled? Ready? So here we go. This is the first question. A 60-year-old man with a 55 pack year smoking history was diagnosed with asthma COPD overlap syndrome. He was...
But Dr. Dhruv is audible, so he will be telling you like
I'm
slowly.
telling you that.
Yeah.
It's okay. I can repeat if you want. A 60-year-old man with a 55 pack year smoking history was diagnosed with asthma COPD overlap syndrome. He was started on a combination of LABA and LAMA, but continued to experience persistent exertional dyspnea, worsening in night and in early morning. After 1 year and 6 months of treatment, a combination of ICS LABA-LAMA was prescribed. However, 1 year later, the patient's pulmonary function test demonstrated moderate airway obstruction, elevated inflammatory markers. There's peripheral eosinophil count, which is 499, FeNO level of 88, and serum IG level of 766. ABG examination in ambient air revealed a pH of 7.424, PaCO2 of 37.8 mmHg, and PaO2 of 78.7 mmHg. Furthermore, the patient's asthma control test was also low, it was 15, whereas his COPD assessment test score was high, 17. So what should be the next step in managing this patient? A, continue current ICS LABA-LAMA therapy without further change. B, add long-term oral corticosteroids as maintenance therapy. C, initiate biological therapy. Or D, initiate NIV. So
we
backhand team, which team has pressed the buzzer first?
So we have already one team who has pressed the buzzer. I think it's Team D representing East Zone, right? Yeah. So what's the answer?
Option C.
You are saying?
Option C.
Option C, initiate biological therapy. That's the right answer. Can we have an applause? 100 points for Team D.
So East Zone has taken the lead. The first question is right. They get 100 marks for that. A great start for Team D.
So second question. A 63-year-old woman with obesity, hypertension, 20 pack year smoking history, presents with exertional breathlessness. She has no chronic sputum production and no exacerbation, Post-bronchodilator spirometry shows FEV1 by FVC of 0.78, FEV1 68% predicted, FVC 69% predicted. HRCT shows no emphysema, bronchiectasis or ILD. Echo has been done, it shows grade 1 diastolic dysfunction. So this is the question. What is the most appropriate diagnosis of this patient? A, moderate COPD, B, PRISM, C, asthma plus COPD, or D, severe asthma?
My God, what a quick response from team A. What's your answer?
Answer B.
He says answer B, preserved ratio and impaired spirometry condition. Dr. Dhruv.
That's the right answer. 100 points for team A.
Team A is now neck to neck with team D. And you represent zone? North zone.
So zone north, make a noise.
North people supporting north. Please make us. Yeah.
So 2 questions have gone. 2 teams have 100 points and 2 teams are on 0. So team B and C, be more attentive. You have to be fast.
But remember, if you just press the buzzer and make a wrong guess, then minus marks are also there. So be steady and be confident before doing anything.
So moving on. 3rd question. A 67-year-old woman presents with 3 days of worsening dyspnea, increased frequency of coughing, green purulent high volume sputum. Patient has a 100 pack year history of smoking. She had intermittent Tmax of 37.7 degrees Celsius for the past 3 days and poor appetite. Her vitals were a respiratory rate of 21 per minute, heart rate of 87, and she was saturating 93% on room air. The patient is currently prescribed a LAMA therapy. So the question is, what is the most appropriate treatment of this patient? A, add inhaled corticosteroid, B, empiric antibiotics and corticosteroid systemic, C, NIV, or D, reassurance.
We have team D pressing the buzzer first.
Option B.
ये नहीं बचेगा क्योंकि उन्होंने पहले बजा दिया. So those the team who will be pressing the buzzer first, the light will be glowing over there, not anywhere else. So इसलिए वो नहीं बचेगा. Team D.
Option B, empiric antibiotics and systemic corticosteroid.
So he has chosen option B, empiric antibiotics and systemic corticosteroid. Dr.
That's
Dhruv.
the right answer. 100 points for team D. Team D is now winning with 200 points.
So we have team D leading with 200 points and team A just behind them with 100 points. Team B and C has yet to start the scoring numbers on their charts.
So team B and team C, you need to open your accounts. Come on. So next question. A 76-year-old man with a history of diabetes and COPD is on ICS LABA-LAMA over the past year. He has had 2 episodes of radiologically confirmed pneumonia but no COPD exacerbation. His blood eosinophil count is 80. What treatment modification is correct for this patient? Increase the dose of ICS, withdraw ICS, initiate prophylactic azithromycin, or D, administer pneumococcal vaccine.
That was too quick. That was too quick. Let's see. They have pressed the button out of desperation, or let's see what happens. Team C.
Option B, withdraw ICS.
So he has chosen option B, withdraw ICS. Dr.
That's
Dhruv.
the correct answer, 100 points.
Good start for teams.
Okay, so now we have, I think, can we ask that question as a buzzer again for plus 25 points? Okay, madam will give the prize.
Madam will be giving 1 lakh rupees right now. Then only we'll be accepting this question. So let's give us just a fun question. This will not be having any marks. Please, ma'am, what's your question? Take the mic and you can ask anything which you want. Team C.
Which clinical trial was there which showed that the steroids can induce pneumonias in COPD? Name of the clinical trial.
I think ma'am has saved her 1 lakh rupees now. That's a good way. So she will be answering that question for all the audience. Ma'am, please.
The wisdom trial.
Wisdom trial.
That's correct.
Now moving
Next
ahead.
question. A 75-year-old woman is brought to the emergency department with severe shortness of breath and has worsened over the past 2 days. She also developed confusion and reduced urine output with hematuria. On arrival, she appears drowsy and cyanosed with bluish discoloration of the lips and extremities. Her SpO2 is 60% despite 15-liter oxygen via non-rebreather mask. And the ABG shows a pH of 6.94, PaCO2 of 145, PaO2 of 143, and a lactate level of 2.9. So this is the question. What is the most correct interpretation of this patient's condition? Severe type 1 failure, acute respiratory alkalosis, severe type 2 failure, or metabolic acidosis with respiratory compensation?
So we have team B pressing the buzzer. How guys, you're so quick, man? I was not even,
I think they just tried their luck. They didn't see the question, they just put the buzzer.
Yeah.
Am I right?
Are you taking the risk, guys? Because there is a negative marking for that. Let's see what they answer.
Option C.
So they have
Correct
chosen
answer.
option C.
Plus 100 for team B finally. So your strategy worked.
Yeah, I think the risk versus reward benefit, I think there is a reward this time.
Moving on, question 6. A 70-year-old man presents with sudden onset dyspnea and right-sided chest pain. He reports of one episode of hemopsis. He has no increase in sputum volume or purulence. His respiratory rate is 28 breaths per minute. Heart rate of, we have not asked the question. इतना भी जल्दी नहीं दबाना है भाई.
Wait. Who has pressed the button? I just want to know why you guys press. Like desperation, there's a lots of round which is going to happen. Maybe, let's see. Let them press the buzzer, let's see. But after the options are displayed, then only you have to press the buzzer. Now we'll consider this for this time. Go ahead.
So the respiratory rate is 28 breaths per minute, heart rate is 118, SpO2 is 89 on room air, and temperature is normal. Chest examination shows mild wheeze, no crackles. Chest X-ray shows hyperinflation without any consolidation on pneumothorax. Right calf is swollen and tender. So the question is, which of the following is the most appropriate next step? A, treat as a COPD exacerbation with oral prednisolone. B, start azithromycin. C, CT angiography of the chest. And D, increase inhaled corticosteroid dose.
Option C, CT angiography of chest.
You see, he has chosen option C, CT angiography of chest. Dr.
Correct answer, 100 points for team B.
My God, this time you guys got lucky, I think, huh? So it's an injustice to everyone. Let the question be complete. Let us go on that screen, then only press the buzzer.
There's a bad news, team B. You figured out the thing with the buzzer, but the buzzer round has ended. This was the last question for buzzer.
You don't know the question, so that means, everybody will be pressing the first before we start the question. So nobody will be doing that. If you do that again, there will be minus 50 negative markings for, I'm telling you to all the team.
So now the questions will be decided by your luck. It will be by chits. You all will be picking up one chit, one volunteer will pick up from your team, and that will decide which question you get out of 4 questions. That is what we will do.
So basically what we thought, me and Dhruv, that let's have a luck factor also, because people can say that, of course, I got the hard question, they got the easy question, it's biased. So let the luck decide what type of questions do you get, okay? So that will be decided based on the chits. I think we have that with us. So we'll start with which team? Maybe A? Next time we'll be doing with other. Who is lucky amongst you? He's a lucky guy. Ladies first. Now you get what's left for you. Maybe that's the best thing. The easiest question.
So which
see.
one did you get? Please announce your things one by one. Yeah. 4. Team B.
They got 4.
Please announce.
3, 2, 1. See, I told you. Team D got 1 and you got 4, right? So Dr. Dhruv.
Let me say the rules, because the Boston University wants us to read the rules every time. So this round will consist of 4 AV questions, which will be directed at each team. Question allocation will be through chits. We have already done that. the question will not be allowed to pass to other teams. So if they can't answer, then obviously it will be passed to the audience. Correct answer, 100 points. Wrong answer, -25. So who was the one who got question number